Chapter 53. Hazardous Materials Incidents. Introduction. One of the inevitable consequences of living in an industrialized world is the proliferation of hazardous materials. The products of our civilization require the manufacture, transport, storage, use, and disposal of thousands of potentially toxic substances. Approximately 10,000 hazardous materials releases occur in Canada each year. 10% of these are related to transportation incidents. This chapter will take a broad look at the special considerations involved in responding to incidents that may involve hazardous materials. It is not intended to be a comprehensive coverage of hazardous materials. The general rule for paramedics responding to industrial, highway, and many other types of incidents is to maintain a high index of suspicion and to stay away from the hazardous materials incident. Laws and regulations. Training requirements and standards are put forth by the 2018 edition of NFPA 472. Standard for Competence of Responders to Hazardous Materials or Weapons of Mass Destruction Incidents published by the National Fire Protection Association. All paramedics should receive training to the basic awareness level, and those more involved, working on medical monitoring or decontamination of the team, will need to be trained to the operations or technician level. With awareness level training, you may be the first to discover a hazardous materials release. Topics covered in the course include recognizing hazardous materials, isolating the area, and calling for appropriate assistance. The operations level, emergency medical services or level 1 responder, of training will allow you to perform defensive actions against hazardous materials. You can perform patient pre-hospital care activities in the cold zone, the command and support center, at an incident for patients who no longer present a significant risk of secondary contamination. The technician level, emergency medical services or level 2 responder, of training will allow you to perform patient pre-hospital care activities in the warm zone at a hazardous materials incident, working with patients who may still present a significant risk of secondary contamination. At this level, you should be able to use specialized equipment, care for patients during the rescue, and manage the incident, and all personnel at the scene. Federal, provincial, and local rules govern the use, storage, and transportation of hazardous materials. These regulations and standards are designed to improve the public's ability to know, and to help protect workers and emergency responders as they try to protect the public. You should become familiar with the laws of the provinces and localities in which you serve. Paramedics and hazardous materials incidents. Paramedics must use their street smarts to identify potential hazardous materials scenes, and determine how to handle the scene if they are the first responders. You should know how and when to access specific toxicologic information, reference sources, poison control center, medical control, and/or a hazardous materials team. You should understand how a hazardous materials scene is organized from a command and control perspective, including how you fit into the command structure and operational plan. You also need to be familiar with the different types of personal protective equipment used at a hazardous materials scene, how the hazardous materials team or other responders will decontaminate patients, and how to assess and treat exposures. In addition, you may be called on to support hazardous materials teams through on-scene medical monitoring and/or provide treatment in the event responders are exposed. Hazardous materials incidents may include the following: a highway or railroad incident in which a substance is leaking from a cargo tank or railroad tank car. A leak, fire, or other emergency at an industrial plant, refinery, or other fixed facility where chemicals or explosives are produced, used, or stored. A leak or rupture of an underground natural gas pipe. Incidents in an agricultural setting in which insecticides may be in use or accidentally released. Buildup of methane or other byproduct of waste decomposition in sewers, sewage processing plants, or landfills. An incident with criminal intent in which a suspected hazardous materials agent is intentionally released. A clandestine laboratory involved in the manufacture or processing of illicit drugs. Often, the presence of hazardous materials is easily recognized from warning signs such as victim or patient signs and symptoms, placards, labels, or other clues found at the scene. Placards or labels may be found in the following locations: on buildings or in areas where hazardous materials are produced, used, or stored. On trucks and railroad cars that transport certain types or amounts of a hazardous material. On drums or other storage vessels that contain a hazardous waste or hazardous material. When you first arrive at a call and recognize a hazardous materials incident, your most important job will be to identify the hazardous materials. Unfortunately, identifying materials can be difficult. Sometimes, transporters do not label containers or vessels appropriately, and the labeling of packages and transport vehicles can be misleading. In most cases, the package or tank must contain a certain amount of a hazardous material before a placard is required. A truck carrying 100 kilograms of hazardous material number 1, hazardous material number 2, and hazardous material number sign may not be required by law to display any labels or placards, because the quantities are so small, there is no law governing these materials. The truck may show only "Please drive carefully" on its flip placard. Although a collision involving this truck might not seem serious, the wise paramedic will keep a high index of suspicion when approaching the scene of any truck or train tanker collision. Maintain that high index of suspicion as you follow up on your first assessment of the scene. Some substances are not hazardous until mixed with another substance. The hazardous material number 1 and the hazardous material number 3 in the truck collision may become highly toxic if they combine. As a paramedic with a high index of suspicion, you need to remember that there may be no regulations against carrying such substances together on one truck or railroad car, or adjacent tank cars. The driver of a commercial truck, and the conductor of a train, however, must carry papers that identify what is being transported in their care. If you can, without sacrificing your own safety or pre-hospital care, look for these papers. These papers may be your first clue that you are in a hazardous materials incident. You can often identify leaks or spills of hazardous materials by the following: a visible cloud or unusual-looking smoke or vapor resulting from the escaping substance. A leak or spill from a tank, container, truck, or railroad car with or without hazardous material placards or labels. An unusual, strong, noxious, acrid odor in the area. Manufacturers may add substances that produce a strong noxious odor to indicate the presence of normally odorless toxic gases or fluids during a leak or spill. However, there are a number of dangerous substances that are odorless and can be detected only by air monitoring instruments, for example, carbon monoxide. To that end, never rely solely on your sense of smell to identify the presence of a hazardous material. If you smell it, you are exposed. Remember, a large number of people, including you, could be exposed before the presence of a hazardous materials incident is identified. If you approach a scene where more than one person has collapsed or is unconscious or in respiratory distress, you should suspect the presence of a hazardous materials agent. If you do not follow the proper safety measures when faced with a hazardous materials incident, you and many others could end up needlessly injured or dead. The safety of you and your team, the other responders, and the public must be your most important concern. Dead heroes cannot save lives. There will be times when the ambulance is the first vehicle to arrive at the scene. If, as you approach, any signs suggest that a hazardous materials incident has occurred, you should stop at a safe distance, upwind and uphill from the scene. After rapidly sizing up the scene, isolate the hazardous area to the best of your ability, deny entry to the affected area, and call for additional resources. Provide as much information as possible when calling for additional resources, including your exact location, atmospheric conditions, if appropriate, the size and shape of containers or cargo tankers, the exact name of the substance, if known, the chemical ID number or symbols if visible, the number of victims, including signs and symptoms, if observed, the type and number of additional resources requested, the location of safe staging areas for incoming resources, and the location of incident command post. Do not re-enter the scene, and do not leave the area until you have been cleared by the hazardous materials team, or you may contribute to the situation by spreading hazardous materials. Hazardous materials assessment. If the dispatch center says there could be a hazardous material involved in the call you are going on, assume that you have a hazardous materials incident. If you are responding to an incident that involves a commercial vehicle or a non-commercial vehicle, and a train, maintain your high index of suspicion. Tractor trailers, tanker trucks, alternative fuel vehicles, and pesticide control vehicles should be high on your list. Be suspicious if you are called to industrial facilities, warehouses, tank farms, pipeline facilities, manufacturing operations, water treatment facilities, and chemical plants. Agricultural operations and supply stores use many different chemicals that, in spite of the benign nature of the business, demand utmost care and alertness. Consider the possibility of terrorist incidents in places such as large offices, government buildings, and shopping centers. Remember, hazardous materials may be solids, liquids, or gases. When you approach any scene, be alert for evidence of spilled liquids or powders, vapor clouds, or odors. If a dispatcher reports that there are many people who seem to be ill or people with symptoms that raise your index of suspicion about exposure to a toxic material, you should stop far away from the scene and think through your approach, assessing the risks of the scene. Use binoculars to get a clearer picture of what is going on. The standard rule of thumb for hazardous materials scene assessment says that if the entire scene cannot be covered by your thumb held out at arm's length, you are too close. You should use every piece of technology at your disposal to get information about what has happened, who is involved, how many patients there are, what their injuries or symptoms are, and, if possible, what hazardous materials may be involved. Identification of hazardous materials. One of the most valuable pieces of information at a hazardous materials scene is the identification of the specific material involved. This information will be of tremendous value to the responding hazardous materials team. Particularly if there are a number of casualties, this knowledge is critical to prepare for the possible health effects on patients, and to alert the emergency medical services teams that will be dispatched to help you. Take no risks, but when applicable, try to read the marking and placards required at hazardous materials storage sites, and on vehicles. If you are at a permanent manufacturing or storage facility, you should ask anyone you can for the safety data sheets for in-depth information about the hazardous materials. What you do at this point, even though you might rather be using your patient skills, could save lives later. Hazardous materials placarding system. Different systems of placards are used at fixed facilities and on transportation vehicles, and it is important for you to recognize them. The most common is the 4-digit numbers that are part of the United Nations or North American Hazardous Materials Coding System for identification of hazardous materials. These numbers identify the specific material being transported and correspond with information in the Transport Canada's Emergency Response Guidebook. You can download a free copy of the Emergency Response Guidebook by visiting the CNUTAC website, http://www.tc.gc.ca/ing/canutech/menu.htm. The most recent edition of the Emergency Response Guidebook should be carried on every emergency response vehicle. The Emergency Response Guidebook provides information on specific properties and hazards of substances, what is shown on placards, and recommended isolation distances. Figure 53-2 shows examples of hazardous materials placards and hazardous materials warning labels. In addition to the numbers, symbols are used to help identify different classes of hazardous materials. Other good sources of information for identifying hazardous materials in transport include the bill of lading, or freight bill, which should be carried by the truck driver in the cab, and the waybill or consist, which is carried by the conductor of a train. The dispatch center may assist in collecting further information from organizations such as CNUTAC, which operates a 24-hour telephone line. Call collect at 613-996-6666 or star 666 from the mobile phone, and has an extensive database to assist emergency responders. To be of assistance, CNUTAC needs to know the product involved, the shipper, and the transporter. CNUTAC has a website listing many educational events and activities for all hazardous materials responders, including paramedics. There are a variety of online and downloadable tools available to paramedics and hazardous materials response teams to help identify hazardous materials and their effects. The Wireless Information System for Emergency Responders, WISER, from the United States National Library of Medicine, an agency for toxic substances and disease registry, United States Centers for Disease Control and Prevention, contain detailed information on the necessary personal protective equipment, toxicology, symptoms, and treatment of thousands of hazardous materials. Paramedics should become familiar with the specific tools used by their emergency medical services agency before they are needed on a hazardous materials incident. Initial isolation and protection distance. Until the hazardous materials technical team arrives to determine the hazard zone, you should be aware of the safety perimeters that are necessary for hazardous materials that are toxic, poisonous, and those that pose danger of fire or explosion. In general, the safe distance is a lot further away than most people would believe. Remember the rule of thumb described earlier. Also, the Emergency Response Guidebook can help determine appropriate safe distances for isolation of the incident. However, if you are able to read placards with the naked eye, you may already be too close and should consider moving farther away. In general, you should stay uphill and upwind from any hazardous materials seen. To help determine wind direction, a piece of narrow roller bandage approximately 1 meter long can be tied to the top of your antenna. Be sure to check the wind direction periodically, and relocate if a change in wind direction dictates. Once on the scene, hazardous materials teams have many sophisticated tools to help identify hazardous materials, and to establish safe scene perimeters. Hazardous materials teams use air monitoring equipment to help determine explosive limits, oxygen levels, and the concentration of hydrogen sulfide and carbon monoxide. They will also be able to determine the pH of spills and may have the capability to perform specific agent testing using colorimetric devices. They may also use tools such as computer-aided management of emergency operations to help predict downwind concentrations of hazardous materials based on the input of environmental factors into a computer model. Classification of hazardous materials. The National Fire Protection Association 704 Hazardous Materials Classification ranks hazardous materials according to health hazard or toxicity levels, fire hazard, chemical reactive hazard, and special hazards, such as radiation or acids, for permanent facilities that store hazardous materials. Levels of personal protection gear are rated according to the toxicity of the material. Before you enter any potential hazardous materials area, you must know the type and degree of health, fire, and reactive hazard protection needed to operate safely near these substances. Much of this specialized personal protective equipment is not carried on the ambulance on a daily basis and needs to be acquired through a hazardous materials team. Figure 53-3 shows hazardous materials classifications from the National Fire Protection Association. Toxicity level. Toxicity levels are measures of the health risk that a substance poses to someone who comes into contact with it. There are 5 toxicity levels: 0, 1, 2, 3, and 4. The higher the number, the greater the toxicity. Most ambulances are unlikely to have the specialized protective gear that would be required for dealing with any hazardous materials over level 0. Level 0 includes materials that would cause little, if any, health hazard if you came into contact with them. This is the only level that does not require special personal protective equipment. Level 1 includes materials that would cause irritation on contact but only mild residual injury, even without treatment. Level 2 includes materials that could cause temporary damage or residual injury unless prompt medical treatment is provided. Both levels 1 and 2 are considered slightly hazardous, but require the use of a self-contained breathing apparatus if you are going to come into contact with them. You would need training in using the self-contained breathing apparatus in a hazardous materials incident. Level 3 includes materials that are extremely hazardous to health. Contact with these materials requires full protective gear so that none of your skin surface is exposed. Level 4 includes materials that are so hazardous that minimal contact will cause death. For Level 4 substances, you need specialized gear that is designed for protection against that particular hazard. Table 53-1 further describes the 4 hazard classes. Hazardous materials scene management. Establishing safety zones. If you discover that an ordinary ambulance call is really a hazardous materials incident, you must take the following steps. Protect yourself first. Isolate the incident as much as possible to avoid the risk of further harm to other people, laypeople, emergency medical services staff, firefighters, and law enforcement responders. No one should risk his or her life or health at a hazardous materials incident. The Emergency Response Guidebook, which you should carry in your vehicle, can help determine initial isolation distances. Notify your dispatcher and any other emergency medical services, fire, or law enforcement responders that a hazardous materials incident is in progress. Inform incoming responders of what you observe about wind direction, terrain features, and a safe response route. Keep in mind the rule of thumb: if you cannot cover the scene with your thumb held at arm's length, you are too close to the hazardous material. As the hazardous materials incident progresses, hazardous materials specialists will establish the hot, warm, and cold zones. The hot zone is the contamination zone where only properly trained rescuers wearing appropriate personal protective equipment are allowed. The warm zone surrounds the hot zone. Typically, the decontamination corridor is located in the warm zone. This zone should only be entered by trained hazardous materials specialists wearing appropriate personal protective equipment. The cold zone provides a further buffer from the hazards present in the hot and warm zones. Paramedics normally perform triage and patient treatment in the cold zone. Personal safety. You should be familiar with the personal protective equipment used at hazardous materials scenes even if you are not trained to use it. Hazardous materials technicians call this personal protective equipment level A through level D, and the equipment is used depending on what and how much of the hazardous material is at the site. Most paramedic ambulances do not carry this equipment. Level A provides the greatest respiratory and skin protection from exposure to hazardous substances because it is fully encapsulating. These garments fully cover the body, and the self-contained breathing apparatus or other supplied air system worn by the responder. The suits are rigorously tested by the manufacturers to determine resistance to many chemicals. Because they are considered gas-tight and completely cover the wearer, you may be asked to monitor or evaluate the technicians for heat stress. Additionally, you should familiarize yourself with the procedures for getting into and out of these types of garments in the event a responder has an in-suit emergency, and you are called on to provide patient care. Level B is called for when the responder needs a high level of respiratory protection, but the released substance does not pose a lethal threat via skin absorption. It is not fully encapsulating like Level A, and it is worn with self-contained breathing apparatus, or supplied air on the outside of the suit. Level B protection is often worn by the hazardous materials responders who are performing decontamination. Level C is designed to protect against a known substance. The equipment provides minimal splash protection, and is worn with an air purifying respirator or powered air purifying respirator that must have filters specifically chosen to provide protection against the known agent. Receivers of exposed patients in the emergency department and law enforcement officers providing perimeter protection at a scene would be good candidates for wearing Level C protection. Level D is typically not worn in hazardous materials incidents by anyone other than support personnel working in the cold zone. This level of protection is worn when there is little or no threat posed by the released substance, and the responder is wearing no respiratory protection other than perhaps a dust mask. The hazardous materials team should determine the appropriate personal protective equipment needed for a specific hazardous material. After identifying any hazardous material, the hazardous materials team will consult a permeability chart to determine breakthrough time for the fabrics the level of suits are made of. The hazardous materials team will also determine which type of gloves and boots will be worn. The team might decide that a double or triple glove system is necessary for the incident. The dangers that hazardous materials present to the human body depend on the ability of the hazardous materials to interfere with the body's processes. The bodily harm caused by a hazardous material is affected by the route of exposure, the dose and concentration, how long the toxin was in contact with the body, and whether it exhibits acute or delayed toxicity. If a patient has a chronic pre-existing condition, like a respiratory ailment, then a minor anhydrous ammonia exposure could prove to be more dangerous than would be expected. Primary and secondary contamination. There are two basic types of contamination, primary and secondary. Primary contamination is the direct exposure of a patient to a hazardous material. Secondary contamination takes place when a hazardous material is transferred to a person from another person or from contaminated objects. Routes of exposure. The physical properties of hazardous materials, and the physical surroundings at the hazardous materials incident can expose your patient in different ways. Air temperature, the concentration of the hazardous materials, and the amount of time that a patient is exposed will help you determine what your primary concern in treating your patient should be. If a material is not volatile and does not give off vapor but touches your patient's skin, it is called a dermal exposure. Many hazardous materials can be taken into other body systems through the skin. Skin conditions like abrasions may accelerate the absorption. Dermal exposure, also known as topical exposure, may result in only a local effect, such as reddening of the skin, localized pain, or the formation of blisters. However, if the hazardous material is absorbed through the skin, a systemic effect may occur. Hazardous materials, when absorbed through the skin, can have a significant adverse effect on the neurologic, renal, or hepatic systems. These toxic effects may be seen immediately in the pre-hospital environment or may be delayed for hours or even years, eventually presenting in the form of cancer. When the reaction shows up hours or days after your initial treatment, your careful documentation becomes invaluable to patients. Your records should include a description of the scene, anything the hazardous materials team told you about the substance, how your patient looked initially, the treatments rendered, and the positive or negative changes since initial contact. Regardless of the route or type of exposure, the dose effect principle applies. The greater the length of time or the greater the concentration of the material, the greater the effect probably will be on the human body. For example, people who have a substance briefly splashed on their skin will be exposed to a much lower dose of toxin than if they were lying in a puddle of that same substance for 30 minutes. The cycle of poison action includes absorption into the body, delivery to target organs, and binding to the organs. The cycle continues with biotransformation and elimination of the toxin through the gastrointestinal, renal, or respiratory systems. These concepts should be considered as decontamination decisions are made with the hazardous materials team. In addition, you should be aware that a synergistic effect may occur when two hazardous materials interact, producing a much greater impact than either substance alone. If your extrication patient is lying in a puddle of gasoline, his or her level of consciousness will be compounded if also exposed to carbon monoxide. Respiratory exposure can be efficient, rapid, and lethal. Many hazardous gases, the gases formed when some liquids spill, or even dust-like powders can harm the respiratory membranes or be absorbed into the body by passing through the bronchial tree or alveoli directly into the bloodstream. When hazardous materials are injected into the body or are absorbed through an open wound, this is known as parenteral exposure. Parenteral exposure could occur at a vehicle collision if your patient has an open wound that is exposed to a toxin leaking from a container. Gastrointestinal exposure occurs when your patient swallows a hazardous material like an organophosphate pesticide. You'll need all your patient communication skills when assessing such a patient, because often the ingestion is deliberate. Chemical terms. When you are working at the scene of a hazardous materials event, you can often assess the scope of the problem by considering the physical properties of the toxin in relation to environmental factors. For example, if the liquid leaking from a tank has a high boiling point, and the air temperature is low, then you will have less concern that the vapors of the liquid will be a respiratory hazard. If vapors rise as the liquid turns to gas, it is important to know that as the air temperature becomes hotter, the vapor pressure of a hazardous material will also increase, as should your concern for more toxin being released to affect you and your patients. Vapor density is another concept for figuring out where a gas or vapor might go. Vapor density compares the hazardous material gas to air. Air has a vapor density of 1. If the gas is heavier than air, the gas will sink into little valleys and ditches. Gases such as propane, butane, and carbon dioxide are heavier than air. But if the vapor rises and dissipates as it travels with the wind, then the vapor density is less than that of the air. Gases like anhydrous ammonia, acetylene, methane, and hydrogen are lighter than air. This is why you are taught to approach a scene from upwind and uphill. Of course, the situation changes dramatically if a fire is involved. If a hazardous material reaches a temperature at which its vapors can be ignited by a spark, then it has reached its flash point. If it gets warmer than the flash point, the vapors will burst into sustained burning. It has reached its ignition temperature. If the percentage concentration of the hazardous material as it mixes with air reaches its lower explosive limit, also known as lower flammable limit, then it can burn in the air or explode. If the concentration of the hazardous material gets too high or too rich, there will not be enough oxygen to support the combustion in air, and the mixture has exceeded its upper explosive limit. Hazardous materials teams can, in many cases, cool down the heat or dissipate the concentration of vapors by pouring on streams of cool water. However, before any water is applied, the hazardous materials team will make critical decisions about whether or not the material may be water reactive or water soluble. If they are going to use water, they will also determine the hazardous material's specific gravity, whether the hazardous material will sink or float in water. Toxicology terms. Chemistry experts and medical providers should communicate with each other using agreed-upon terms to describe the health hazards any incident might present. You'll be a better provider and incident historian if you can master these terms. Safe and unsafe concentrations of various substances are often expressed in parts per billion or parts per million. The threshold limit value is the maximum concentration of a toxin that someone can be exposed to for a 40-hour work week. If you look up a chemical in a reference text and find that it has a very low ppb number for its threshold limit value, this means it is more dangerous than if it had a high threshold limit value. The threshold limit value short-term exposure limit is the concentration that a person can be exposed to for a limited number of brief time periods, for example, 4 15-minute exposures per day. The threshold limit value ceiling level is the concentration that a person should never be exposed to. A permissible exposure limit is the maximum concentration of a chemical that a person may be exposed to. In Canada, occupational exposure limits are set by provincial or territorial regulations. Sometimes you will hear the experts refer to the lethal dose, which is the amount of the substance sure to cause death. You might hear the hazardous materials responders refer to immediately dangerous to life and health, which means that the atmospheric concentration of any toxic, corrosive, or asphyxiant substance will pose an immediate threat to life, irreversible or delayed adverse effects, or serious interference for a team member's attempt to escape from the dangerous atmosphere. Decontamination and treatment. Treating hazardous materials patients can be a difficult and emotionally challenging experience. Remember, your safety comes first. If you are first on the scene, you cannot immediately begin pre-hospital care. Even when a patient is visible and in need of rescue, you must not rush in. Staying safe is a tough decision that requires discipline and emotional coolness. You must work as part of the team to prevent more casualties. Use the incident command system, which permits only properly trained and equipped hazardous materials personnel to enter the hot zone. Wait until your patients have been decontaminated. Then you can apply your knowledge and skills to actually treat the patient safely in a hands-on fashion. Because hazardous materials can cause harmful effects, protecting the environment should be one of your considerations. If your patient's injuries are treated and not life-threatening, environmental issues should be a major consideration. You should take steps to prevent runoff during decontamination. If your patient is suffering, environmental considerations are still important, but a lower priority than patient pre-hospital care. Decontamination. Decontamination methods will depend on the type of hazardous materials involved, the stability of the scene, and the number, condition, and location of patients. Decontamination is undertaken to reduce the dose of hazardous materials in contact with the patient and decrease the risk of secondary contamination to others, including rescuers and hospital personnel. Protection of the environment during decontamination is important. Plans should be made for containment of runoff. When lives are at stake, however, containing runoff is secondary. There are 4 types of decontamination methods: dilution, absorption, neutralization, and disposal. Dilution is the most common method, and the easiest to perform in the pre-hospital environment. Dilution typically relies on the use of copious amounts of water to flush the contaminant from the skin or eyes. This action decreases the dose effect of the hazardous material on the patient. Sometimes a simple soap, such as tincture of green soap, is used in the decontamination process. Other decontamination agents are rarely used. Vegetable or mineral oil is sometimes used if the contaminant is a water-reactive substance. Be cautious when you are using brushes. Abrasion of a patient's skin increases the potential for hazardous materials absorption. Pay special attention when your patient has been exposed to a solvent. Solvents are especially difficult to remove from the skin with water only. The patient may still have a solvent odor for quite some time after decontamination has been performed. Be aware of this during transport, or you may fall victim yourself to the off-gassing of solvents. Absorption is accomplished with large pads that the hazardous materials team carry to soak up liquid and remove it from the patient. Towels can also be used in the same way. Neutralization involves the use of a chemical to change the hazardous material into less harmful substances. Neutralization on the skin is almost never used by hazardous materials teams because of the dangers of uncontrolled exothermic reactions. When acids are used on bases, or vice versa, heat is generated as a byproduct of the reaction. Such reactions could be detrimental to the patient, making neutralization an action that is almost always contraindicated. Disposal is not so much of a decontamination strategy as it is a result of the process. Emergency medical services responders should be mindful of removing as much of the patient's clothing as possible, in some cases, all of it, to reduce the amount of contamination that contacts the body. Simply removing the clothing of a person exposed to chemicals can reduce the level of contamination by as much as 80% to 90%. Emergency decontamination in fast-breaking situations. In some of the most difficult situations, you may be faced with the need to make an immediate decision about whether to treat patients despite the fact that they are contaminated. In this case, you may be responsible for deciding whether to proceed with rapid emergency decontamination. In all cases, you must ensure you have the appropriate protection to protect yourself against the threat, and stay clear of the product. Do not make physical contact with it. In such situations, you must still don appropriate personal protective equipment. Even if no respirator is available, you should take maximum barrier precautions. Put on turnouts or a splash-resistant, Tyvek, jumpsuit, eye protection, mask, such as a high-efficiency particular air mask, and at least 2 layers of gloves. In addition, booties should be worn over footwear if possible. In general, nitrile gloves offer superior protection against many hazardous materials. Leather materials should be removed because these often absorb hazardous materials. Once you are protected as much as possible, you should instruct patients to disrobe and remove as much of the hazardous materials from their bodies as they can. If you can, give the patients plastic bags in which they can place their personal belongings and clothing. If the hazardous material is a powder, then it should be brushed away first. If the hazardous material is water reactive, then no water should be used during decontamination. Most often, however, water is considered to be the universal decontamination solution. In any emergency decontamination method, you need to minimize the risk to yourself. This type of decontamination is also referred to as the two-step approach to decontamination. Unmanned hose streams can be set up by the fire department to douse patients with large amounts of water. An example of such a setup is the creation of an emergency decontamination corridor made by parking 2 fire engines parallel to each other and approximately 3 to 6 meters apart. Nozzles can be attached to the side discharge ports of the engines and set to create a fine particle fog stream decontamination shower. Patients should disrobe on one end and enter the shower in single file. From a remote location, patients could be advised how to decontaminate and directed to pay special attention to the areas of the body that are difficult to rinse, such as the axillae, between fingers and toes, around the groin, the scalp, and between the buttocks. Soap and soft brushes should be made available. At the other end of the shower corridor, towels, blankets, and temporary garments should be available. Hypothermia may be a concern for some patient populations, such as young children and older adults, after decontamination. It is at the end of this corridor that you would make initial contact with the patients and begin the triage process. Ideally, the runoff water from decontamination should be contained. At a minimum, the runoff should not be allowed to become a source of secondary contamination. Technical decontamination. Technical decontamination is the process used by the responders to clean personal protective equipment, tools, and equipment. It is a thorough cleaning process, and the process and setup may differ from jurisdiction to jurisdiction. You'll hear the hazardous materials team refer to an 8-step process, which is only carried out by trained personnel. 1. Responders exit the hot zone and approach the decontamination corridor. 2. Contaminated tools and equipment should be left behind at the hot zone end of the decontamination corridor. 3. Hazardous materials personnel are showered and washed using water, brushes, soap, or other appropriate decontamination agents to remove all surface contaminants. This is done with the assistance of other hazardous materials personnel, the decontamination team, who should not wear more than one step lower personal protective equipment than the entry team. Because technical decontamination is not aimed at life safety, it is done in a manner that will contain the runoff. Often this is accomplished inside a small wading pool or other disposable basin. 4. Paramedics should stay alert for signs of an ongoing primary or potential secondary contamination problem. 5. The team members move into an area of the decontamination corridor where they are helped out of their personal protective equipment by another member of the decontamination team. Contaminated protective clothing and equipment are placed into a bag or receptacle for later decontamination or disposal. 6. Respirators and/or self-contained breathing apparatus masks and undergloves are removed last and placed in plastic bags or in other forms of containment. 7. Ideally, the responders should proceed to a location where they can take a personal shower to further reduce the potential for contamination. This is not always possible, but is the best course of action when possible. 8. Entry team personnel undergo medical monitoring. Treatment of patients exposed to hazardous materials. In general, the treatment of hazardous materials patients is straightforward. You can use many of the concepts learned in the chapters on burns and toxicology. However, there are some special considerations for hazardous materials patients. One of these is that invasive procedures should be minimized if possible. If you know from the hazardous materials team that your patient is contaminated, the process of tracheal intubation may expose the patient to airway contamination. Placement of an intravenous or intraosseous line may allow contamination to bypass the skin barrier. You'll need to weigh the risks of invasive procedures against their benefits. You should be familiar with references and how to access technical expertise when deciding how to treat patients during a hazardous materials incident. Some assistance may be obtained from the Emergency Response Guidebook and CANUTEC. In addition, you may consult with Poison Centers, the Agency for Toxic Substances and Disease Registry, and your local direct medical control. The hazardous materials team may have comprehensive reference textbooks that can guide you in treatment decisions, and also be of assistance to emergency department physicians. Never forget that you are the eyes and ears of the physician in the pre-hospital environment. Share the knowledge you have gained from the hazardous materials team for your patient's sake. Corrosives. Acids and bases. Corrosives are chemicals that include both acids and bases. Some examples are toilet bowl cleaner, lye, and hydrochloric acid. Acids have a low pH, from 0 to 7, while bases have a high pH, 7 to 14. Substances with either high or low pH can cause severe burns to the skin, eyes, and mucous membranes. Signs and symptoms include skin irritation, reddening or other discoloration, and blistering. Exposure of the mucous membranes to fumes can also cause burns, including severe life-threatening airway and lung burns. Decontamination of materials with a high pH will require considerably more time to flush from the skin. High pH materials react with skin to form a soap-like resistance to being flushed from the skin as compared to low pH acids. Once the patient is decontaminated, treatment is generally supportive, ensure a patent airway, oxygenate the patient, treat for pain if indicated, and treat burns appropriately. Some emergency medical services agencies carry calcium chloride or calcium gluconate, which can be used when directed by medical control to treat the pain and hypocalcemia that is caused by hydrofluoric acid, even when no burn is apparent. Consider transport to a burn center if necessary. Patients showing signs of pulmonary edema secondary to an inhalation exposure may need to be treated for this with diuretics. However, you should always consult medical control to determine the proper course of action when you are treating patients with chemical exposures. Hydrocarbon solvents. Solvents may be liquids, solids, or gases. Common solvents include paint thinner and nail polish remover. Solvents are substances that are capable of dissolving other substances. Many of these solvents give off potent vapors that can be inhaled and can also be absorbed through the skin. Respiratory exposure in particular can cause immediate pulmonary symptoms such as pulmonary edema. Prolonged dermal exposure can cause symptoms as well, including cardiac dysrhythmias and seizures. Pulmonary irritants. Many gases react with the moisture of mucous membranes to cause irritation ranging from minor to severe or choking. Examples of such gases are chlorine gas and ammonia. The first thing to do for your patients is to make sure they, and you as well, are away from the contamination, and in fresh air. Removal of clothing may help dissipate trapped gases. Pulmonary edema should be treated according to protocols. Pesticides. Exposure to organophosphate and carbamate pesticides can produce severe signs and symptoms. These hazardous materials interfere with the enzyme acetylcholinesterase, which promotes uptake of the neurotransmitter acetylcholine. Runaway nerve stimulation produces a syndrome that is known by the mnemonic sludge, salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis. Also look for excess pulmonary secretions. As always, you should protect yourself from secondary contamination, including that from emesis when the exposure has been gastrointestinal. Treatment of pesticide poisoning includes aggressive decontamination, protection of the airway with intubation and frequent suctioning when necessary, high-flow oxygen, and the use of atropine to block the overstimulation of muscarinic receptors of the parasympathetic nervous system. The use of pralidoxime is recommended for organophosphate exposures, but not for carbamates. Chemical asphyxiants. Any gas that displaces oxygen from the atmosphere is termed an asphyxiant. Colorless, odorless gases, for example carbon monoxide and hydrogen sulfide, that are confined to an area may represent a deadly trap when would-be rescuers rush in to help a collapsed victim. Substances known as chemical asphyxiants interfere with the use of oxygen at the cellular level. Cyanide is a common example of such an agent. Hydrogen cyanide is used in many industrial processes. The 1984 release of methyl isocyanate in Bhopal, India, was a major hazardous materials incident that caused thousands of fatalities. Cyanide poisoning can also occur during exposure to the byproduct of combustion at structure fires, which is the most common exposure scenario for hydrogen cyanide. 2 commercially available kits are available for treatment of cyanide poisoning. One treatment kit consists of hydroxycobalamin, which binds to cyanide and forms a non-toxic byproduct. When using hydroxycobalamin, the receiving hospital must be made aware as it has an intense red color that renders many blood tests unreliable. Alternatively, cyanide exposure, for patients whose exposure was not due to smoke inhalation, can be treated with amyl nitrate ampoules that the patient should inhale for 15 seconds of every minute. This step is followed by the intravenous administration of 300 mg of sodium nitrite, followed by 12.5 grams of sodium thiosulfate. Because of potential toxicity of the amyl nitrate and sodium nitrite, it is no longer a first-line treatment for cyanide poisoning. Another common exposure that results in a chemical asphyxiation is carbon monoxide. This gas ties up hemoglobin to the extent that oxygen in the blood becomes inaccessible to the cells. Treatment includes removal of the patient from the source and administration of 100% supplemental oxygen, no matter what the apparent oxygen saturation reading shows. Severe carbon monoxide poisoning is sometimes considered for hyperbaric oxygen therapy. This can affect transport destination, and typically requires a protocol or a discussion with direct medical control. Transportation considerations. The ideal transportation scenario at a hazardous materials incident would be to have a team of paramedics who were not involved with decontamination or cold zone patient treatment standing by to transport patients to the hospital emergency department. However, if the incident is a large one, the cold zone paramedics may well need to both treat and transport patients. You should remember that patients received after decontamination should not be assumed to be completely decontaminated. Accordingly, you should take certain precautions to prepare yourself and your equipment for assuming pre-hospital care of the patient from the hazardous materials team, and for getting the patient to the hospital. First, you should wear the appropriate personal protective equipment. The hazardous materials team may be able to supply some of the personal protective equipment if you do not have access to a splash protective garment, for example. In addition, you should be given a complete report on what hazardous materials have been involved, the patient's source of exposure, and what has been done to decontaminate and treat the patient. In no event should you transport a patient if decontamination has not been sufficient. An example of insufficient decontamination would be when hazardous material on the patient continues to produce toxic gases, such as after a smoke exposure or a liquid splash exposure. Before receiving and transporting a patient exposed to hazardous materials, you can do several things in preparation. One principle is to reduce the amount of supplies and equipment that the patient will come in contact with. You could remove the mattress from the stretcher, because the patient will probably be carried on a backboard. Removing the mattress will make decontamination easier later. In general, use as much disposable equipment as possible. Supplies and equipment inside the ambulance should be removed and set aside in a clean, safe place for later retrieval. It is impractical and time-consuming to line the inside of the ambulance with plastic. Instead, plan to isolate the patient by wrapping him or her in a sheet or other available covering to reduce the potential for secondary contamination. A double wrap procedure is preferable. In this procedure, the patient is first wrapped in a cloth or plastic sheet, preferably one that helps protect the patient from hypothermia. Then the patient is placed on a backboard, and the backboard placed on the stretcher. You should know which hospitals in your area have facilities for receiving patients with possible hazardous materials contamination. Give the hospital plenty of notice prior to the transport so that they can assemble the appropriately trained personnel and prepare equipment. Often hospitals will have a separate or dedicated treatment and decontamination room for these situations. There have been instances in which patients who were not adequately decontaminated caused secondary contamination inside hospitals. Receiving hospitals may sometimes stop paramedics from bringing patients into their facility until they can complete their own decontamination and assessment. Medical monitoring and rehabilitation. You may be asked to assist with medical monitoring of the hazardous materials team. Wearing personal protective equipment often causes heat stress and, of course, the toxins the team is working with can cause serious health effects. Factors that influence hazardous materials team members' health include level of physical fitness, activity, level of personal protective equipment, and environment factors such as temperature. Medical monitoring should include documentation of the incident factors, including the hazardous materials involved, the toxic effects, what personal protective equipment was worn, its resistance to permeability with the hazardous materials, and what type of decontamination was used. You should have a plan for treatment, transport, and potential availability of antidotes in the event that a hazardous materials team member needs medical assistance. You might be asked to assess hazardous materials team members before they suit up for entry into the hot zone, and then again after they come out. Your assessment should include complete vital signs, temperature, and body weight. Team members should be encouraged to hydrate with water or a sports drink prior to entering the hot zone. Working inside a level suit is like being inside a sauna, with no way to lose heat through evaporation, conduction, convection, or radiation. A useful fact that can help you with your assessment is that some hazardous materials teams keep a file of their members' baseline medical status. Be sure to ask for this information. Before being allowed to re-enter the hot zone, the hazardous materials team should be evaluated by the paramedic in the rehabilitation area, located in the cold zone, for hydration status, vital signs, and any potential symptoms of exposure to the toxic agent the incident involves. Team members should take off their protective clothing and be given a chance to rest. Reassess vital signs and perform a neurologic assessment, for example, orientation to time, place, and events, as well as an assessment of fine motor skills. Team members with elevated temperatures should be monitored closely for possible heat stroke. The loss of body weight is a direct correlation to the loss of fluids and the risk of dehydration and hypovolemia. Members should be encouraged to rehydrate by drinking water or other appropriate fluids. If there are abnormalities in vital signs or if team members have signs or symptoms, they should not be allowed to return to work until their physical status returns to normal. An example of a hazardous materials team rehabilitation log that can assist paramedics in the hazardous materials rehabilitation sector is shown in Figure 53-8. Chapter 47. Patients with Special Needs. Introduction. Throughout the ages, humans have learned to adapt to the challenges they encounter. In the pre-hospital environment, you'll encounter patients who face a variety of special challenges. Some conditions or anomalies are congenital, for example, spina bifida. Others have developed during the patient's lifetime, for example, panic disorders, or occurred as the result of a sudden event, for example, the transection of the spinal cord during a diving accident. Whatever the source of the challenge, these patients will require you to adapt your assessment and management to accommodate their needs. Although you can still use the standard assessment plan with these patients, sometimes you may find it necessary to adapt to best meet a patient's unique needs. Can the patient see you? Can the patient hear you? Can the patient normally move all extremities? You'll need to formulate a plan to care for these patients in a short amount of time. Be willing to incorporate the patient, family members, or caregivers as essential teammates. Learn to solve problems as part of a group, and remember your ultimate goal: to give the patient the best care possible, in the most efficient way, and still accommodate for his or her individual needs. Your confidence and caring attitude will promote trust between you, your patient, and the other members of your team. Physical challenges. Humans use all 5 senses to gather information, but we often take that sensory feedback for granted. Imagine what it would be like to go bowling while blindfolded. You hear the pins dropping, but did you knock down a couple of pins, get a strike, or just leave a 7 to 10 split? Imagine how frustrating it might be to see that you need to tie your shoe but to be unable to do so because an injury resulted in the loss of motor function in your hand. Hearing impairments. Hearing challenges are classified into 2 types, conductive and sensorineural deafness. Conductive deafness is a usually curable temporary condition caused by an injury to the eardrum, an infection, or simply a buildup of earwax in the external auditory canal. Sensorineural deafness, which is permanent, may be caused by a lesion or damage to the inner ear, or damage to the 8th cranial nerve. This type of hearing impairment may be congenital or secondary to a birth injury, but it may also have occurred over time from disease, medication complications, viral infections, or tumors. People may also have hearing loss due to aging, called presbycusis, or from prolonged exposure to loud noise. Hearing impairment may range from a slight hearing loss to total deafness. Some patients may have difficulty with pitch, volume, and distinguishing speech. Some have learned to speak even though they have never heard speech. Others may have heard speech and learned to talk, but have since had a loss of some or all of their hearing, leading them to speak too loudly. Parkinson's disease or other disease processes may cause the patient to slur words, speak very slowly, or speak in a monotone voice. Interaction with a patient with hearing loss. Clues that a person could be hearing impaired include the presence of hearing aids, poor pronunciation of words, or failure to respond to your presence or verbal questions. While communicating, face the patient so that he or she can see your mouth. Do not exaggerate your lip movements or look away. Position yourself approximately 50 centimeters directly in front of the patient. Most people who are hearing impaired have learned to use body language, such as hand gestures and lip reading. Because patients with a hearing impairment typically have more difficulty hearing higher frequency sounds, if the patient seems to have difficulty hearing you, do not just speak louder, try lowering the pitch of your voice. Ask the patient, "How would you like to communicate with me?" American Sign Language may be the patient's preferred method of communication. An interpreter, family member, or friend may prove to be a valuable teammate. If an interpreter is not readily available, call the receiving facility early on to request one. Ideally, an interpreter will arrive before you begin your assessment. Other patients may prefer written communication or communication of concepts or procedures with gestures or pictures. Simply asking a team member to retrieve the patient's hearing aid or auditory electronic enhancement device may help a great deal. Here are some helpful hints for working with patients with hearing impairments. Speak slowly and distinctly into a less impaired ear, or position yourself on that side. Change speakers. Given that 80% of hearing loss is related to the inability to hear high-pitched sounds, look for a team member with a low-pitched voice if you think this may be the issue. Provide paper and pencil so that you may write your questions, and the patient may write his or her responses. Only one person should ask interview questions, to avoid confusing the patient. Be sure to speak directly in front of the patient or toward the good ear, if there is a difference. Try the reverse stethoscope technique. Put the earpieces of your stethoscope in the patient's ear, and speak softly into the diaphragm of the stethoscope. This will amplify your voice. Hearing aids. A hearing aid is essentially a device that makes sound louder. Hearing aids cannot restore hearing to normal, but they do improve hearing and listening ability. Several types of hearing aids are available. In the canal and completely in the canal. These hearing aids are contained in a tiny case that fits partly or completely into the ear canal. In the ear. All parts are contained in a shell that fits in the outer part of the ear. Behind the ear. All parts are contained in a plastic case that rests behind the ear. Conventional body type. This older style is generally used by people with profound hearing loss. To insert a hearing aid, follow the natural shape of the ear. The device needs to fit snugly without being forced. If you hear a whistling sound, the hearing aid may not be in far enough to create a seal or the volume may be too loud. Try repositioning the hearing aid, or remove it and turn down the volume. If you cannot insert the hearing aid after 2 tries, put it in the box, take it with you, and document the transport and transfer of the hearing aid to hospital personnel. Never try to clean hearing aids, and never get them wet. If a patient's hearing aid is not working, try troubleshooting the problem. First, make sure the hearing aid is turned on. Try a fresh battery, and check the tubing to make sure it is not twisted or bent. Check the switch to make sure it is set on M, microphone, not T, telephone. For a body aid, try a spare cord because the old one may be broken or shorted. Finally, check the ear mold to make sure it is not plugged with wax. Speech impairments. For most people, the spoken word is the primary mechanism for communicating thoughts and ideas. For some, speech may be delayed by psychological or psychosocial factors. For others, it may be altered by injury, illness, or hearing impairment. Articulation disorders. Articulation disorders cause the majority of speech difficulties. Dysarthria, the inability to make speech sounds correctly, results from a lack of muscle control and coordination of the larynx, tongue, mouth, and lips. Speech can be slurred, indistinct, slow, or nasal. Commonly, articulation disorders result from damage to nerve pathways passing from the brain to muscles in the larynx, mouth, or lips, delayed development from hearing problems, or slow maturation of the nervous system due to brain damage or motor disability. Articulation disorders affect both children and adults. Language disorders. Stroke, traumatic head or brain injury, brain tumor, delayed development, hearing loss, lack of stimulation, or emotional disturbance may cause damage to the language center of the brain, and lead to aphasia. Aphasia is the loss of ability to communicate in speech, writing, or signs. It can range from being very mild to making communication with the patient almost impossible. Aphasia may primarily affect a single aspect of language use, such as the ability to recall the names of objects, to put words into sentences, or to read. When communicating with a patient with aphasia, remember to talk to the patient as an adult, not as a child. Use focused questions rather than open-ended questions, and minimize background noise. Fluency disorders. In fluency disorders, the person's speech pattern is broken, interrupted, or repetitious. An example of this type of disorder is stuttering. Stuttering may be noticed only when the person attempts certain words or sounds, and it may become worse when the individual is under stress. Stuttering is normal for young children, and will disappear gradually over time. The specific causes of stuttering are unknown. When interacting with a person who has a fluency disorder, patience is the key. Impatience with or interruption of a patient who stutters may frustrate the patient more and cause the stuttering to get worse, making assessment and history-taking difficult. Voice production disorders. Voice production disorders refer to the way the voice sounds, These may be slightly easier to understand than other speech impairments. Signs of these disorders include hoarseness, harshness, inappropriate pitch, or abnormal nasal resonance. Causes include the closure of vocal cords, hormonal or psychiatric disturbance, or severe hearing loss. Hypernasality may be a complication of a cleft palate, a deformity in which the two sides of the palate fail to fuse in the midline during in utero development, or it may accompany enlarged adenoids. Inflammation of the larynx may produce laryngitis. Laryngitis is a common occurrence in cases involving overuse of the voice, throat infections, heavy smoking, smoke inhalation, allergic reaction, or exposure to fumes. The cause of the laryngitis may provide clues about the patient's reason for calling for your services, and the severity of the situation. Chronic laryngitis may point to long-term exposure to laryngeal irritants, which may cause polyps to develop in the larynx. Occurring more commonly in men, progressive hoarseness is usually the chief complaint in such cases. Long-term exposure to toxins such as chemicals, smoking, or weakened vocal cords from continuous strain are other risk factors. The most ominous cause of chronic laryngitis is carcinoma of the larynx. A laryngectomy, either partial or total removal of the larynx, may be performed to treat the cancer. In the case of a total laryngectomy, the patient would have aphonia, which is the inability to produce normal speech sounds. The patient would receive a stoma, and might communicate by burping sounds or by using an electronic or mechanical device. Interaction with the patient with a speech impairment. When establishing communication, ask the patient how he or she would be most comfortable communicating with you. Allow an appropriate amount of time for a response, and listen carefully to establish an understanding, or enlist someone who knows the patient to interpret. For instance, small children often have speech difficulties that spontaneously resolve, but may be difficult for a stranger to understand. If the patient prefers to speak, your ability to understand the patient will likely be affected. When working with the patient with the voice production disorder, offer a pencil and paper or listen carefully if the patient prefers to speak. Repeat what the patient said to allow for correction or further clarification. Avoid speaking for the patient or finishing sentences for him or her. Above all, be patient. Visual impairments. Visual impairments may result from a multitude of causes: congenital defect, disease, injury, infection, for example, cytomegalovirus, or degeneration of the eyeball, optic nerve, or nerve pathway, for example, with aging. The degree of blindness may range from partial to total. Some patients lose peripheral or central vision, while others can only distinguish light from dark or discern general shapes. Visual impairments may be difficult to recognize. During your scene assessment, look for signs that indicate the person is visually impaired, such as the presence of eyeglasses, a white cane, or a service dog. Make yourself known when you enter the room, and introduce yourself and others in the room, or have them introduce themselves so that the patient can identify their placement and voice. In addition, retrieve any visual aids to make the interaction more comfortable for your patient. A person with a visual impairment may feel vulnerable, especially during the chaos of a crash scene. He or she may have learned to use other senses such as hearing, touch, and smell to compensate for the loss of sight, and the sounds and smells of the crash may be disorienting. Remember to tell the patient what is happening, identify noises, and describe the situation and surroundings, especially if you must move the patient. To ambulate safely, the patient may use a cane or walker. Even if the individual will be carried out on your stretcher, do not forget to take the patient's cane, walker, or eyeglasses. Unless the patient is critical, a service dog can remain in the room, and will provide reassurance for the patient, and prevent delays in transport. In some provinces, service animals are allowed in the ambulance with the patient. However, if you need to arrange for the care or accompaniment of the dog, a friend or animal control officer can be helpful in this situation. An ambulatory patient may be led by a light touch on the arm or elbow. You may also allow the patient to rest his or her hand on your shoulder, as this may enhance the patient's sense of balance and security while moving. You may also ask the patient which method he or she prefers to use while traveling to the ambulance. Patients should be gently guided, but never pushed. Obstacles need to be communicated in advance. Statements such as "you're approaching the stairs," and instructions about how many stairs to expect, will allow the patient to anticipate and navigate the obstacle safely. They will also appreciate your consideration and concern. Paralysis. Paralysis is the inability to voluntarily move one or more body parts. It may be caused by a head trauma, cerebrovascular accident, stroke, spinal cord injury, malignancy, neuromuscular diseases, trauma, or birth defects, among other things. Paralysis does not always entail a loss of sensation. In some cases, the patient will have normal sensation or hyperesthesia, increased sensitivity, that may cause the patient to interpret touch as pain in the affected area. Paralysis of one side of the face may cause subsequent communication challenges as well. Patients who are paralyzed may have diaphragmatic involvement requiring the use of a ventilator. They may also rely on specialized equipment such as halo traction, Foley catheters, tracheotomies, colostomies, or feeding tubes. Each spinal cord procedure requires its own equipment and may have its own complications. See Chapter 48. Dysphagia, caused by a partial paralysis of the esophagus, is the inability to swallow. Patients with dysphagia may choke or aspirate food and drink very easily, leading to the need for emergency airway interventions. If patients have a loss of some or all of the sensation in the affected limbs, they cannot tell you when you are hurting them. Always take great care when lifting or moving a patient who is paralyzed. Because paralyzed limbs lack muscle tone, provide intravenous access and medication administration on the non-affected side whenever possible. Check intravenous sites frequently for infiltration, especially after medication administration. Bariatric patients. Obesity is the result of an imbalance between food eaten and calories used. The solution to the obesity problem may sound relatively simple: re-establish the balance and cure the problem. Unfortunately, obesity can be a much more complex situation. Causes of obesity are not fully understood and, in many cases, are unknown. Often, this problem may be attributed to low basal metabolic rate or genetic predisposition, but there are other causes. Bariatrics is the branch of medicine that studies and treats patients who are obese. The term obese is used when someone is 20% to 30% over his or her ideal weight. In severe or morbid obesity, the person is 20 to 40 kilograms over the ideal weight. Obesity afflicts approximately 1/4 of all Canadians. These individuals may be ridiculed publicly and sometimes are victims of discrimination. Mobility and the patient's general quality of life are often negatively affected by their oversized status, and the extra weight can cause myriad health problems. Interaction with the patient who is obese. Patients who are obese may be embarrassed by their condition or fearful of ridicule as a result of past experiences. Some of those negative interactions may have occurred at the hands of an insensitive healthcare professional. As with any patient, work hard to put these individuals at ease early. Establish the patient's chief complaint, and then communicate your plan to help. Many of these patients have a complex and extensive past medical history, so mastering the art of conducting a patient interview will serve you well in your interactions with these individuals. If transport is necessary, plan early for extra help and do not be afraid to call for more help. Many service providers have specialized equipment for these patients that make movement safer for all involved. These devices ensure the safety and comfort of the patient, while also taking into consideration the logistics and safety of providers that need to move the patient. These devices can include inflatable mats and larger polypropylene sheets. Stretchers are also now designed with increased load capacity and adjustable side supports to accommodate these patients. Pneumatic stretchers also assist in the safe movement of these patients. Patients who are obese may overcome mobility difficulties by pulling, rocking, or rolling into a position. This constant strain on their body's structures may leave them with chronic joint injuries or osteoarthritis. Be conscious of these accommodations, and sensitive to be able to assist when asked. Some patients have a condition called obesity hypoventilation syndrome, also known as Pickwickian syndrome. Patients with Pickwickian syndrome are usually extremely obese. They experience hypoxemia, deficient oxygenation of the blood, hypercapnia, excess carbon dioxide in the blood, and polycythemia. overabundance or overproduction of red blood cells. Physical findings may include headache, apnea, especially during sleep, sleepiness, red face, muscle twitching, and signs of right-side heart failure. Some of these symptoms may necessitate emergency intervention in the pre-hospital environment. Weight reduction is the ultimate remedy for Pickwickian syndrome. Some patients may be on a carefully monitored diet, and others may benefit from surgical intervention, such as gastric bypass surgery. Surgery carries a high risk of complications, however, and not all patients are suitable candidates. When you are moving a patient who is obese, follow these helpful tips. Treat the patient with dignity and respect. Ask your patient how best to move him or her before attempting to do so. Avoid trying to lift the patient by only one limb, which would risk injury to overtaxed joints. Coordinate and communicate all moves to all team members prior to starting. Ensure the most appropriate device is used for safety of all. If the move becomes uncontrolled at any point, stop, reposition, and resume. Look for pinch or pressure points from equipment, as they could cause a deep venous thrombosis. Very large patients may have difficulty breathing if you lay them flat. Keep this possibility in mind when you position these individuals. Many manufacturers now make specialized equipment for patients who are obese, and most areas have specially equipped bariatric ambulances for such patients. Become familiar with the resources available in your area. Plan egress routes to accommodate for a large patient, equipment, and the lifting crew members. Remember, do no harm. Notify the receiving facility early to allow special arrangements to be made prior to your arrival to accommodate the patient's needs. Mental challenges. Mental or emotional impairment. Mental illness is a generic term for a variety of illnesses that result in emotional, cognitive, or behavioral dysfunction. Mental illness can occur in persons with mental or emotional disability just as it can arise in people without a disability. The care of patients with specific mental illness is discussed in depth in Chapter 40. In the broader sense, a person's mental status can influence his or her physical well-being, and vice versa. Emotionally or intellectually disabled individuals may be difficult to assess due to the body's normal stress response, which may alter their respiratory rate, heart rate, or perception of physical illness. Gathering a detailed history will be useful in the assessment and development of a treatment plan for these patients. Calmly ascertain the chief complaint, and treat the patient accordingly, with care and understanding. One of the key components of effective communication, with any type of patient, is to be a good listener. Always listen carefully to your patient, not just the words spoken, but also heeding the patient's tone, facial expressions, and body language. Watch for signs of aggression, clenched fists, or aggressive or agitated movements or speech. They may be your only warning of an impending dangerous confrontation. Implementing active listening skills by repeating what you heard will reassure the patient that you understand and are there to help. Although these patients may present an assessment challenge, they are still patients, and are prone to the same illnesses and disease processes as anyone else. Consequently, treatment and transport of such patients should focus on the chief complaint, and supportive care. When treating patients with emotional or intellectual disabilities, take care in establishing communication with the patient and/or the caregiver. Establish a baseline for the patient's emotional or mental ability so that you will be able to identify any changes. Speak in a calm voice, even if the patient does not have the ability to understand, and explain what you are going to do before doing it. Developmental disabilities. The current terminology in Canada is persons with disabilities, with emphasis on the person rather than the disability, be it intellectual, behavioral, developmental, or emotional. A developmental disability is a permanent condition that means a person develops more slowly and differently than others do. Individuals with a developmental disability may have difficulty learning and processing information with abstract ideas, and changing to meet the needs of normal daily life. It may be caused by genetic factors, congenital infections, complications at birth, malnutrition, or environmental factors. Prenatal drug or alcohol use may also cause disability, as in fetal alcohol syndrome. Postnatal causes may include traumatic brain injury or poisoning, for example, with lead or other toxins. Although IQ testing can identify the extent of the person's ability to learn and reason, just speaking to the patient and family members will give you a good idea of how well the patient can understand and interact with you. A person with a slight impairment may appear slow to understand or have a limited vocabulary. Such an individual will often act immature in comparison to developmentally normal peers. Because the individual may also have difficulty adjusting to change or a break in routine, an emergency call that generates a room full of strangers can be overwhelming. The patient may become more difficult to interact with as his or her anxiety level increases. A severely disabled person may not have the ability to care for himself or herself, communicate, understand, or respond to the surroundings. Treatment of these patients should be based on the chief complaint, unless the illness is related to the mental disability. Patients with developmental disabilities are prone to the same disease processes as any other patients, including diabetes, heart disease, and respiratory difficulties. Transport should be accomplished without causing any more stress than necessary. In most cases, supportive care is all that is needed. Down syndrome. Down syndrome is characterized by a genetic chromosomal defect that can occur during fetal development, resulting in a developmental disability, including mild to severe intellectual impairment. The normal human somatic cell contains 23 chromosomes. Down syndrome, which is also known as trisomy 21, occurs when chromosome 21 fails to separate, so that the ovum contains 24 chromosomes. When the ovum is fertilized by a normal sperm with 23 chromosomes, a triplication, trisomy, of chromosome 21 occurs. Increased maternal age, more than 35 years old, and a family history of Down syndrome are known risk factors for this condition. A variety of abnormalities are associated with Down syndrome: a round head with a flat occiput, an enlarged, protruding tongue, slanted, wide-set eyes, and folded skin on either side of the nose, covering the inner corners of the eye, short, broad hands, a small face and features, congenital heart defects, thyroid problems, and hearing and vision problems. Patients do not usually have all of these symptoms, but will have a combination of them to such a degree that the diagnosis is rapidly made at birth. Patients with Down syndrome are at increased risk for medical complications, including those that affect the cardiovascular, sensory, endocrine, musculoskeletal, dental, gastrointestinal, neurologic, and hematologic systems. As many as 40% may have congenital heart disease, for example, endocardial cushion defects, or ventricular or atrial septal defects. Emergency treatment should therefore include airway management, supplemental oxygen, and intravenous access. In patients with heart failure, administer diuretics with judicious fluid resuscitation only if necessary. Because people with Down syndrome often have large tongues and small oral and nasal cavities, intubation of these patients may be difficult. These individuals may also have malocclusions and other dental anomalies, for example, abnormal contact of the upper and lower teeth. The enlarged tongue and dental anomalies can lead to speech abnormalities as well. In an emergency situation, if airway management is necessary, bag mask ventilation and intubation can be challenging. In the case of airway obstruction, a simple jaw thrust maneuver may be all that is needed to clear the airway. In an unconscious patient, either the jaw thrust maneuver or a nasopharyngeal airway may be necessary. Many people with Down syndrome have epilepsy. Most of the seizures are of the tonic-clonic type. Management is the same as with other patients with seizures. Autism and autism spectrum disorders. Autism and autism spectrum disorders are conditions involving developmental delay that are being diagnosed with increased frequency. These complex disorders of brain development are characterized by difficulties in social interaction, repetitive behaviors, and verbal and nonverbal communications. Increased rates of diagnosis may be due to better awareness and screening or an actual increase in the occurrence of autism in the population. Patients demonstrate a wide variety of symptoms that often relate to communication, social interaction, sensory processing, the ability to purposefully shift attention, and the ability to play. A large number of people with autism will either be completely nonverbal throughout their lifetime or become nonverbal during periods of stress. Developmental regression in absence of another cause in young children should raise concerns for the possibility of autism. Cognitive function can vary significantly among people with autism. Some people with autism may have impaired cognitive function, meeting the criteria for intellectual disability. Other people with autism may demonstrate highly sophisticated skills with mathematics, puzzles, memory, or art. Some patients will achieve a large degree of independence while others will continue to rely on others for basic needs throughout their lives. When you are treating patients with autism, you should be extremely mindful of your actions when you are attempting to communicate and initiate physical contact. Commotion and excess stimuli may cause a patient with autism to have bizarre or aggressive behaviors. Any physical contact should be preceded by a careful explanation, and go from distal to proximal on the patient. Any questions should be repeated to the patient in a variety of ways to determine whether there is a consistent response. Patients with autism may exhibit minimal reactions to significantly painful injuries or may experience great discomfort with minor physical contact or injuries. You should be prepared for many possible challenges while providing care to patients with autism. Including the caregivers in assessment, treatment, and transport will often be extremely helpful. Interaction with patients with developmental disabilities. When caring for a patient with any developmental disability, specifically intellectual or behavioral, obtain a complete history, treat the presenting illness, and provide supportive care. It is normal to feel somewhat uncomfortable when initiating contact with this kind of patient, especially if you have encountered such situations infrequently. Simply treating the patient as you would anyone else is the best plan. Approach the patient in a calm and friendly manner, watching him or her for signs of increased anxiety or fear. Remember, you are a stranger, and are approaching with a group of people. The patient may not understand your uniform or realize that you and your crew are there to help. It may be helpful to have the members of your team hold back slightly until you can establish a rapport with the patient. You can then introduce the team members, and explain what they are going to do. This method will slowly bring forward the other paramedics, instead of mobbing the patient all at once. You might interact with the patient as follows. Hello, Mr. Pemberton. I'm a paramedic, and my name is Jerry. Shake Mr. Pemberton's hand if he will allow it. We're here to help you. Your sister called us. She says you're not feeling well today, and we're here to help you feel better. My friend Tim is going to take your blood pressure. Do you remember having that done before? Allow Mr. Pemberton to see and touch the blood pressure cuff as Tim moves forward. Move slowly but deliberately, explaining beforehand what you are going to do, just as you would with any other patient. Watch carefully for signs of fear or reluctance from the patient. Do your best to soothe the patient's anxiety and/or discomfort as you work through your assessment and treatment. By initially establishing trust and communication, you'll have much better luck successfully executing your treatment plan, even if you eventually need to do something painful such as starting an intravenous line. Pathologic challenges. Pathologic challenges require special consideration when you formulate your treatment plan. Pathologies you may encounter during your career may include arthritis, cancer, cerebral palsy, cystic fibrosis, multiple sclerosis, muscular dystrophy, poliomyelitis, previous head injury, spina bifida, and myasthenia gravis. Many of these patients will be well versed in the progression, treatment, and unique nuances of their current health status. Cancer. Simply stated, cancer is the uncontrolled overgrowth of normal tissue cells. If this growth is left unchecked, these cells have the ability to spread, destroy body systems, and kill. More than 200 different kinds of cancer are believed to exist. The type of cancer is determined by where it originates. Cancer is discussed in greater detail in chapters 6 and 48. Numerous types of treatment regimens are available for cancer: surgery, medications, radiation, and chemotherapy, to name a few. Cancer treatment may follow a single pathway or be orchestrated into a complex combination of therapies and medications. Surgical removal has long been one of the primary methods of controlling or terminating cancer's progression. It is often used in tandem with other therapies. Cerebral palsy. Cerebral palsy is a non-progressive, bilateral neuromuscular disorder in which voluntary muscles are poorly controlled. It results from developmental brain insults in utero, for example, cerebral hypoxia, maternal infection, or kernicterus, brain trauma at birth or in early childhood, or postpartum infections, for example, encephalitis or meningitis. Patients often have spastic movements of their limbs and display poor posture, which impairs their ability to move in a controlled manner. Symptoms of cerebral palsy can range from mild to severe. As children grow, these symptoms may either become exaggerated or stay the same. Related complications include visual impairments, hearing and language difficulties, seizures, and developmental disability. Some children with severe cases of cerebral palsy are able to learn to walk with assistive devices, whereas others need support even to sit and cannot stand, walk, or speak. If the patient is able to speak, grimacing and uncontrolled movement may make speech difficult and hard to understand. To cope with ordinary tasks, many patients use computerized household controls and speaking aids. Mechanized wheelchairs may be controlled with a joystick or mouth control. Specially shaped chairs and pillows may be custom-built to facilitate the patient's comfort and ease movement. Toys may also be adapted to allow for learning and play. In addition, computers may be specially configured to aid the patient with speech simulation and provide the ability to perform household tasks, such as temperature control and lighting. Thanks to these technologies, many patients with cerebral palsy lead near normal lives and live independently. When caring for a patient with cerebral palsy, note the following. Do not assume that patients with cerebral palsy are always intellectually disabled. Although 75% of patients have some intellectual disability, many people with cerebral palsy have no intellectual disability or only slight intellectual disability. Patients' limbs are often underdeveloped and are prone to injury, for example, from a fall from a wheelchair. Patients who have the ability to walk may have an ataxic or unsteady gait, and are prone to falls. If the patient has a specially made pillow or chair, pediatric patients, the patient may prefer to use it during transport. Remember to pad the patient to ensure his or her comfort, and never force a patient's extremities into any position. Whenever possible, take walkers or wheelchairs along during transport. Approximately 25% of patients with cerebral palsy also have seizures. Be prepared to care for a seizure if one occurs, and keep suctioning available. Cystic fibrosis. Cystic fibrosis, also known as mucoviscidosis, is a chronic dysfunction of the endocrine system that targets multiple body systems, but primarily the respiratory and digestive systems. It is estimated that 1 in every 3,600 children born in Canada has cystic fibrosis. Although it is found in all races and ethnic groups, it most commonly occurs in Caucasian individuals of Northern European descent. The disease is usually fatal, with most children not living past their teens. With aggressive management and careful monitoring, some patients may live well into their 30s. Cystic fibrosis is caused by a defective recessive gene, which makes it difficult for chloride to move through cells. This causes unusually high sodium loss, resulting in salty skin and abnormally thick mucus secretions. The secretions in the lungs cause breathing difficulties and provide an ideal growing medium for bacteria, leaving the patient highly susceptible to infection. Ultimately, the lung damage from the condition leads to lung disease, which is the primary cause of death in affected individuals. Respiratory difficulties associated with cystic fibrosis include tachypnea, productive cough, shortness of breath, barrel chest, clubbed fingers, and cyanosis. The thick mucus may also collect in the intestines. Malnutrition and poor growth rate are common, as are intestinal blockages. Physicians strive to reduce the progression of the disease with physical therapy, exercise, vitamin supplements, and medications. Some patients may also benefit from a lung transplant. Care of these patients should primarily focus on treating the individual's chief complaint. Keep a keen eye out for respiratory insufficiency, signs of a respiratory infection, intestinal blockage, or cardiac dysrhythmias, as a result of the electrolyte imbalance. Suctioning, high-flow supplemental oxygen, and breathing therapies may also be required during transport. Multiple sclerosis. Multiple sclerosis is a chronic disease of the central nervous system characterized by destruction of the myelin and nerve axons within the brain and spinal cord. It has no known cause, but is an autoimmune disorder. In some cases, It is genetically inherited. This disease strikes women in their 20s to 40s at a rate 2 to 3 times more often than men. Canadians have one of the highest rates of multiple sclerosis in the world. Every day, 3 new cases of multiple sclerosis are diagnosed. It is the most common neurologic disease affecting adults in Canada. Myelin is a fatty covering that shields the axons. Axons are responsible for electrical conduction from neurons to muscles, leading to muscle response and communication from the body to the brain. Multiple sclerosis causes areas of myelin in random places to become inflamed, detach from the axon, and ultimately self-destruct. The area of destruction becomes scarred over, hence the name multiple, many, sclerosis, to harden. 2 types of multiple sclerosis are distinguished: relapsing or remitting and progressive. The relapsing or remitting form affects 90% of patients, presenting with bouts of worsening symptoms. Signs and symptoms of multiple sclerosis can be divided into those associated with the brain, and those associated with the spinal cord, and include numbness or tingling in parts of the body, unexplained weakness, dizziness, fatigue, double or blurry vision, and vision impairment. Periods of relapse leave the patient feeling marked improvement, with stiffness and weakness lingering for some. The other 10% of patients have the progressive form, in which symptoms get progressively worse with no periods of improvement or relief. 1/2 of all people who have the relapsing or remitting form of the disease will develop the progressive form within 15 years if they remain untreated. There is no cure for multiple sclerosis, although many treatments can significantly reduce the frequency of attacks and lessen symptoms when they occur. As with other illnesses, your treatment may be limited to supportive care. You may also be called to the patient's side due to tertiary complications of multiple sclerosis, such as a fall. Because of the disease process, the patient may lack feeling, so the physical examination may be difficult. A detailed medical history will help elucidate the diagnosis. As with patients with paralysis, you must take special care when lifting and moving patients with multiple sclerosis. When these individuals are in crisis, they may not be able to walk even with their assistive devices. Muscular dystrophy. Muscular dystrophy is an inherited muscular disease that causes progressive degeneration of the muscle fibers. In many cases, the destroyed fibers are replaced by fat or connective tissue. The result is a gradual weakening of muscles, slowing of motor development, and loss of muscle contractility. More than 30 types of muscular dystrophy have been identified. Some begin in early childhood and progress rapidly. Others do not surface until the late teens into the 40s and progress much more slowly. Duchenne muscular dystrophy, the most common type, affects 10 out of every 100,000 male births. Muscular dystrophy may not be apparent in infancy, but rather appears as the child grows, presenting as muscle weakness during childhood or early adulthood. Parents or physicians may notice a delay in the normal developmental landmarks such as sitting, walking, or climbing stairs. The wasting of skeletal muscles ultimately leads to increasing disability and deformity. Kyphoscoliosis, an outward hump of the upper spine accompanied by curvature of the lower spine, may compromise pulmonary function. Cardiac involvement may also be present in as many as 95% of patients. Unfortunately, only 25% of those affected live to age 21 years, with pulmonary or cardiac complications usually being the cause of death. Poliomyelitis. Poliomyelitis, polio, is a highly contagious viral infection. First identified in 1789, it was once a worldwide plague, with its incidence growing to epidemic proportions from late spring through fall. Canada was declared polio-free in 1994. The last major Canadian epidemic of wild polio virus occurred in 1959, with 1,887 paralytic cases reported. Following the release of the Salk and Sabin polio vaccines in 1955, the number of cases of polio declined rapidly, and the only polio cases now seen in Canada are polio-infected visitors from other countries or vaccine-associated paralytic polio, which is caused by contact between an unvaccinated individual and a person who has recently been inoculated with the live vaccine. Although live vaccines have not been used in Canada since 1996, they are still administered in many other parts of the world. Thanks to worldwide vaccination programs promoted by the World Health Organization, the goal is to eradicate polio worldwide. However, sporadic outbreaks of polio still occur in countries where immunization programs have lapsed, where civil unrest prevents immunization programs from taking place, or where migration brings new polio cases from areas where polio is still present. Humans are the only known hosts for the poliomyelitis virus. This pathogen enters the body by direct contact through the mouth, replicating in the pharynx, gastrointestinal system, and local lymphatic system. The virus then enters the bloodstream and spreads to the central nervous system. The spinal cord and brain are affected, which may cause paralysis or death. In 80% to 90% of cases, usually involving young children, the illness is mild, presenting with malaise, sore throat, headache, vomiting, and slight fever. The initial symptoms are followed by a period of apparent wellness. Symptoms of major illness, fever, severe headache, stiff neck and back, deep muscle pain, or paralysis, then appear after a few days. In non-paralytic forms of polio, recovery is complete. In paralytic forms, muscle function may gradually and completely return. However, any weakness or paralysis lasting longer than 12 months after the infection is a sign of permanent damage and disability. Patients with paralysis will need special attention in order to safely lift, move, and position them. They may also need special equipment, such as ventilatory assistance via a tracheal tube or tracheotomy if they experience respiratory paralysis. They also may have an indwelling catheter in place if the lower extremities are paralyzed. Spina bifida. Spina bifida is the most common permanently disabling birth defect. In Canada, approximately 120 children are born with spina bifida each year. In this disorder, during the first month of pregnancy, the fetus's spinal column does not close properly or completely and vertebrae do not develop, leaving a portion of the spinal cord exposed. Faithfully taking the B vitamin folic acid prior to becoming pregnant reduces the risk of spinal defects. Other maternal risk factors for spina bifida include previous neural tube defect. Pregnancy increases risk by 20%, diabetes, medically diagnosed obesity, some anti-seizure medications, exposure to increased temperature in early pregnancy, that is, hot baths or hot tubs, infection resulting in fever, Caucasian or Hispanic ethnicity, and lower socioeconomic status. Symptoms of spina bifida may include partial or full paralysis, usually of the lower extremities, bladder or bowel control difficulties, learning disabilities, and latex allergy. In addition, as many as 70% to 90% of individuals with the most severe form of spina bifida also have hydrocephalus. In hydrocephalus, an increase in the amount of cerebrospinal fluid results in increased pressure on the brain. A shunt is inserted to relieve this pressure on the brain by draining excess cerebrospinal fluid. The shunt will stay in place throughout the patient's lifetime. Patients with spina bifida will likely benefit from the same considerations that you offer when treating a patient with paralysis or difficulty moving. When you are caring for these patients, ask how best to move them if possible. Remember to rule out a fall or other event that may have caused an injury. Check carefully for injuries, as patients may not be able to feel them, or the pain of an infiltrated intravenous line, for that matter. Also, be aware that these patients may have urinary catheters or other aids in place. Patients with head injuries. Traumatic brain injury is a potentially devastating condition associated with many serious short and long-term complications. You may encounter patients immediately after they experience the injury. Care of these patients in emergency situations is discussed in depth in Chapter 24, Head and Face Injuries. Once the acute crisis has resolved, many of these patients continue to experience serious or life-altering long-term complications. Patients with a previous head injury may face a complex array of challenges related to their injury. In such cases, gathering a complete medical history from the patient, family, and friends will assist you in the formation of a treatment plan. Treatment will primarily be supportive care. Your interaction with the patient will need to be tailored to his or her specific abilities. Take the time to speak with the patient and the family to establish what is normal for the patient, for example, whether the patient has cognitive, sensory, communication, motor, behavioral, or psychological deficits. When you are caring for a patient with a previous head injury, talk to him or her in a calm and soothing tone, and watch the patient closely for signs of anxiety or aggression. In some cases, the patient may need to be specially positioned or restrained to ensure the safety of both you and the patient. Do not expect such an individual to walk to the ambulance or stretcher. As always, treat the patient with respect, use his or her name, explain procedures, and reassure the patient throughout your care. Myasthenia gravis. Myasthenia gravis is a rare autoimmune disorder characterized by chronic fatigability and weakness of muscles, especially in the face and throat. It is the result of a defect in the conduction of nerve impulses at the nerve junction, caused by a lack of acetylcholine. In myasthenia gravis, antibodies keep acetylcholine from reaching the muscles by blocking or damaging the receptor sites. This interruption in communication results in sudden bouts of muscle weakness, usually during activity, although the condition improves with rest. Although it affects all ethnic groups and sexes, myasthenia gravis is most commonly found in women younger than age 40, typically between 20 and 30 years, and men older than age 60. The first symptoms usually present as weakness in eye or eyelid movement. Myasthenia gravis may also affect facial muscle control, changing the person's facial expression. In many cases, the disease is noticed initially as a sudden difficulty swallowing or chewing, or as slurred speech. Other symptoms may include blurry vision, weakness or difficulty moving the neck, shortness of breath, and weakness or difficulty moving limbs. Myasthenia gravis may be difficult to diagnose because these symptoms can be attributed to many illnesses and disease processes. A crisis may occur if the patient's respiratory muscles are damaged by infection, stress, side effects of medications, or even menstruation. These muscles could become so weak that the patient experiences an acute onset of respiratory failure. In such a case, you need to intervene immediately with airway management, ventilatory support, and possibly intubation. End-of-life care. Unfortunately, some illnesses cannot be cured. As healthcare providers, you and your team will often be called on to assist a patient who is in the end stages of a terminal illness. Signs of impending death include decreased intake of food and drink, decreased orientation, irregular breathing patterns, and bradycardia or tachycardia. If you recognize these signs, reassure the family that you will help their loved one in a most respectful and dignified manner. Although the goal of end-of-life care is to provide patients with the meaningful, dignified, and comfortable death, there's a surprising lack of data describing what patients and their families believe constitutes a good death. While some patients with terminal illness choose to have the most aggressive care possible, others have a goal of comfort rather than cure or prolongation of life. In general, seriously ill patients identify pain and symptom management, preparation for death, and achieving a sense of completion as important factors in a good death. If you are called to a scene in which death is imminent, the actions you take will have a lasting impact on the family. This is a time when compassion, understanding, and sensitivity are most needed. Some scenes may be chaotic. The family may be having a difficult time coping with the situation, and they may act out with anger and hostility. Treat everyone with compassion and understanding. The other members of your team may be able to separate individuals and speak with them individually to diffuse intense emotions and restore order to the situation. Terminally ill patients usually need only supportive care. Therapy is often aimed at making the patient as comfortable as possible. The patient may have a displaced urinary catheter, need assistance in returning to bed, or need intervention in a pain crisis. Some patients may also be receiving care from hospice or a home health nurse. You may have been called because of a delay in the arrival of the regular care provider or for transport to take care of an immediate need in a clinical setting. Because terminally ill patients may use a complex array of pain medications, transdermal patches, or self-administered pain management devices, you may need to consult medical direction for guidance in their care. If the patient has a valid do not resuscitate order, cardiopulmonary resuscitation is not indicated or appropriate if the patient's heart stops and/or he or she stops breathing. If you have any question regarding the validity of a do not resuscitate order or the level of interventions the patient wants, you should start resuscitation while contacting direct medical control for further instructions. When no resuscitative measures are attempted, aggressive comfort measures are required. These include oxygen administration, salbutamol-based breathing treatments, and narcotics for pain and respiratory distress, as per local protocol. Place the patient in a comfortable position. Although the decision for a do not resuscitate order had already been made, family members may not understand what to do, and they may not be ready to face the death of a loved one. In such a case, take a thorough history and compassionately discuss the patient's wishes. Ask to review the do not resuscitate order and keep it with the patient during transport. Ascertain the family's wishes about having the patient remain in the home versus transport to the hospital. During transport, contact direct medical control and advise the receiving hospital of the situation. If a family member requests to accompany the patient, he or she should be allowed to do so. If the family wishes the patient to remain at home, this request should be honored provided it is in accordance with your local or regional protocol. Protocols for handling the death of a patient vary, so you must learn your local or regional regulations. Your protocol will identify whether the coroner needs to be called to report the death and, if so, who is responsible for contacting the coroner. Also determine whether a pronouncement of death is required and, if so, who makes it. Patients with communicable diseases. Some patients may have communicable diseases, which explains why appropriate personal protective equipment and routine precautions need to be followed with every patient, every time. Gloves and eye protection should be considered basic attire. Gowns, masks, and other protective measures should be deployed if the situation warrants. Safety for yourself, your crew, and your patient is paramount. At the same time, you should treat patients with communicable diseases with the same compassion you would give to any other patient. Clues that a patient has a communicable disease include rashes, coughing, ill appearance, health or travel history, and medications. Offer patients with immunocompromised conditions a mask prior to their arrival at a hospital to safeguard them from further exposure to illness. Masking a patient early during your assessment may be the quickest and easiest method of preventing disease transmission. See chapters 2 and 39 for more details. Financial challenges. Many patients, particularly the elderly, may be concerned about the financial aspect of the ambulance ride to the hospital. Remember, they have experienced the times before the institution of universal health care in Canada. I can't go to the hospital. I don't have the money. These statements are heard from many patients who do not understand the concept of universal health care. Many of these individuals do not have private health insurance that covers ambulance services. By engaging in careful, compassionate communication with your patient, you should try to determine the source of his or her anxiety. Share with the patient your concerns about his or her current health.
Chapter 46. Abuse. Introduction. Maltreatment, neglect, and assault of children, women, and older people are, unfortunately, all too common. Because these issues are frequently encountered reasons for calls to EMS, it is important for you to recognize the signs and symptoms. You must know not only how to recognize and differentiate among maltreatment, neglect, and assault, but also how to protect yourself from injury while maintaining optimal pre-hospital care for the patient. Victims who survive maltreatment or neglect often have permanent disabilities, both mental and physical. They may themselves become abusive or neglectful caregivers, perpetuating the cycle of mistreatment. Prevention and early detection are key to limiting maltreatment and permitting survivors to heal. Although prevention strategies have improved in recent years, you may be on the front lines for getting help to victims of maltreatment. Child maltreatment. Child maltreatment includes any improper or excessive action that injures or otherwise harms a child or infant or puts a child or infant at serious risk of harm, including physical abuse, sexual abuse, neglect, and emotional abuse. In the last major national report released, 2008, there were an estimated 235,842 investigations related to child maltreatment. 36% of those cases were confirmed cases of maltreatment, or approximately 85,000 children. Child neglect occurs when a child's physical, mental, or emotional condition is harmed or endangered because the caregiver fails to supply basic necessities or engages in inadequate or dangerous child rearing practices. Neglect includes failure to provide adequate food, clothing, or shelter, the caregiver's misuse of drugs or alcohol, failure to provide support or affection necessary to the child's psychological and social development, or child abandonment. Children who are neglected are often dirty or too thin or appear developmentally delayed because of a lack of stimulation. As a paramedic, you will often be called to scenes because of a reported injury to a child. Many maltreated children have permanent or life-threatening injuries, and some die. If suspected child maltreatment is not reported, the child is likely to be victimized repeatedly. Therefore, you must be aware of the signs of child abuse and neglect and cognizant of your responsibility to report suspected maltreatment to law enforcement or child protection agencies. When in doubt as to whether it is an abuse or neglect situation, it is always better to err on the side of caution to protect the victim. It is known now through the scientific literature that permanently withdrawing a child from his or her family environment is a last resort option, and to assure his or her safety. The motivation to report a child maltreatment situation should be driven by a willingness to protect the child from further harm, and not to have a parent put in jail, even if your emotions may cloud the situation. A child's parent, if he or she is the offender, may seem to be the worst person for a child. The attachment bond between a child and a parent is very hard to recreate, so working on the relationship through better socializing and support of the parent is better than placement for many children. Profile of an at-risk child. Child abuse and neglect occurs in all communities, and among all socioeconomic strata. Younger children are at higher risk for fatal abuse and neglect than are older children. Approximately 85% of abused or neglected children who die are younger than 6 years, more than 40% are younger than 1 year. Although no geographic, ethnic, or economic setting is free of child maltreatment or neglect, children from low-income or single-parent families have more reported occurrences of abuse and neglect than children from higher-income families. Table 46-3 lists other factors that put a child at risk of maltreatment. When assessing a potential child maltreatment case, be attuned to suspicious behavioral traits. A child who does not become agitated when a parent leaves the room or who does not look to a parent for reassurance may be maltreated. Children who are maltreated may also cry excessively or not at all, may be wary of physical contact, or may appear apprehensive. People who maltreat children. Child maltreatment can be done by any person who has care, custody, or control of the child, including parents, step-parents, foster parents, babysitters, and relatives. Parents who maltreat their children frequently receive little enjoyment from parenting, and are more isolated from the community than those parents who do not maltreat their children. They have unrealistic expectations of their child, and try to control the child through negative and authoritarian means. Parents who maltreat their children are often afraid of, or emotionally unable to ask for help from, sources of support in their community. Most were themselves maltreated or neglected as children. Many view themselves as victims in life generally or in the parent-child relationship in particular. They feel that they have lost control of their children, and their own lives. When their children behave in a manner that parents perceive as disrespectful, they lash out in an effort to establish control. Caregivers may prefer to discipline using other means but are pushed to violence by stress. Characteristics shared by caregivers of maltreated children include drug use, poor self-concept, immaturity, lack of parenting knowledge, and lack of interpersonal skills. Table 46-4 lists additional red flag caregiver behaviors. Assessment and management of child maltreatment. One of the most important indicators of possible maltreatment is repeated calls to the same home or family for a child injury or medical problem. Nevertheless, the best indicator by far is the physical examination of the child, conducted with a keen ear for inconsistencies in the history. The physical examination must take into consideration the mental and emotional age of the child. Examining the child from toe to head may work best on toddlers and preschoolers, whereas an infant may be best examined in a parent's arms. Pre-adolescents and teenagers have modesty and body awareness concerns, which should be respected. If possible, do the examination with another colleague. This approach will verify your findings and help prevent false accusations of impropriety. Also, make certain that you are very objective on your documentation. Do not include opinions or draw non-medical conclusions, list only the objective information, and stick to the facts. When assessing for possible child maltreatment, you may find the child abuse mnemonic helpful. C. Consistency of the injury with the child's developmental age. H. History inconsistent with injury. I. Inappropriate parental concerns. L. Lack of supervision. D. Delay in seeking care. A. Affect. B. Bruises of varying ages. U. Unusual injury patterns. S. Suspicious circumstances. E. Environmental clues. Soft tissue injuries are the most common findings in the physical examination of an abused child. Multiple bruises in various stages of healing are another red flag. Be alert for bruises on areas of the body where they would not be expected, such as the buttocks, back, face, and upper legs. Bites and burns may also be noted. Stocking or glove burns and donut burns occur when a child is immersed in hot water. Fractures can result from fall, twisting, or jerking injuries. Multiple fractures or fractures in various stages of healing are indicators of maltreatment, as are self-healing fractures. Head injuries are the deadliest for children. Even if not fatal, they can easily produce permanent disability. Look for scalp wounds, signs and symptoms of hematoma, and concussion. Although abdominal injuries are rare in child maltreatment cases, they are usually serious. Remember, small children have thin and underdeveloped abdominal muscles. Note the color and rigidity of the abdomen and tenderness to palpation. Injuries to the abdomen may result in injuries to the intestines or rupture of the liver. Sometimes, normal physical findings may suggest an inflicted injury. Other benign skin findings can also suggest maltreatment, although the lesions are actually produced by cultural rituals intended to treat illness. Some medical or folk remedies may be foreign to you or inconsistent with your training. For example, cupping and coin rubbing are alarming to most paramedics, but a reasonable explanation of the practice, which is common in some Asian cultures, should allay your suspicions. It is important to observe the scene, including the household dynamics, as you provide pre-hospital care for the patient. Be aware that more than one victim may be encountered. It is important to keep the scene as safe and calm as possible while still providing life support for any critical and moderately distressed patients. In a case involving child abuse or neglect, the patient care report, with objective observations, will be very important to the police and child protective services. In most provinces and territories, the paramedic is a mandated reporter in child abuse or neglect cases. Most provinces and territories have also established toll-free numbers for reporting suspected child abuse or neglect. Do not assume that someone else has already called or that the emergency department will call. It is better to have more than one person call the hotline for the same case than to see the case fall through the cracks. Most communities also have parenting classes available through county social services. Elder maltreatment. The incidence of older patient maltreatment and neglect is growing. The aging of the population, and the strains placed on caregivers, and the nursing home systems contribute to this problem. You must use sound judgment, and learn to develop good observational skills. Because geriatric patients present much differently than children, and younger adults, you must be especially attuned to the possibility of maltreatment in this population. Consider the following scenario. You respond to a call for man down. On arrival, you find an 86-year-old man lying on his side in the living room, bleeding from the mouth and nose. He appears confused, and you cannot understand what he is trying to say. His 56-year-old daughter states that her father tripped and fell. His vital signs are as follows: pulse, 68 beats per minute, respirations, 14 breaths per minute, and blood pressure, 100/68 millimeters of mercury. The patient's skin is warm and wet. You see a walker device in the kitchen, approximately 8 meters away. The daughter states that the patient does not really need it, stating, "He just uses it to get sympathy." The daughter is very upset that the police have just pulled up. Your partner tells you that she has been to this home several times before for falls, that the patient has Alzheimer's disease, and that the daughter seems to lose patience with him, sometimes refusing to cooperate with the paramedics. The daughter then states, "Would you people hurry up and get him out of here? He's getting blood all over the rug." In this scenario, the older patient clearly needs assistance, but his caregiver also seems to be overwhelmed. This situation is not unusual. Because people are living longer than ever before, their children, often baby boomers, must assume responsibility for their care. The stress on these caregivers is real. Physical, emotional, and financial burdens can wear them down. Your crews should be familiar with local resources to assist caregivers and patients. This assistance can be as simple as a visiting nurse or a handy van agency to take the patient to his or her doctor's appointments. As with child maltreatment, elder maltreatment involves a direct action causing harm to the victim. Maltreatment of older patients includes sexual abuse, psychological or emotional abuse, neglect, and abandonment. Neglect can be active or passive. Active neglect refers to the deliberate withholding of companionship, medicine, food, exercise, or assistance with mobility. Passive neglect occurs when an older person is ignored, left alone, isolated, or forgotten. Abandonment is the desertion of an older person by a person who has physical custody of the older person or by a person who has assumed responsibility for providing care. Table 46-5 lists the characteristics of older maltreated patients. In domestic maltreatment cases, the perpetrators are quite often the children of the maltreated person. Factors contributing to elder maltreatment. Although paramedics are concerned with treating and managing the results of abuse and neglect, an understanding of why these problems occur can be beneficial in the pre-hospital setting. In some cases, the violence may be a learned response. Children who were maltreated may ultimately be in a position to maltreat their older parents. The stress of caring for an older person may push some caregivers into abuse or neglect. Factors such as a diminishing social network, frailty, and medical illness also put older people at risk for maltreatment. Older people are at an increased risk for maltreatment in nursing facilities that have a history of providing inadequate care, are understaffed, and provide poor training for their employees. Signs of elder maltreatment. The signs and symptoms of elder abuse and neglect can be subtle and, in the emergency setting, can often be overlooked. Evaluate each situation involving an older person with a critical eye toward potential abuse and neglect. Be on the lookout for a fearful patient with unexplained bruises or sores that have not been tended to. Of course, the patient may naturally be fearful of the whole emergency situation, and there may well be a reasonable explanation for the marks on the body. Be alert for a situation in which you find an unkempt, dirty patient while the caregiver is clean. Generally speaking, a solicitous caregiver will keep the patient and the patient's surroundings tidy. Watch for a patient who allows the caregiver to answer all of your questions, while appearing mentally competent to do so. This person may look to the caregiver for approval when you ask the patient a direct question. If a patient tells you that items are being taken or money confiscated, such a complaint may be an indication of paranoia or a symptom of dementia, but it could very well be true. Do not investigate these claims, simply document them thoroughly. Be wary if a patient states that he or she is not allowed to socialize with peers, and is kept in isolation. Generally, maltreated older people do not seek help. This reluctance may be due to fear of being institutionalized, fear of getting the person performing the maltreatment into trouble, polypharmacy, confusion, or brain disorders such as Alzheimer's disease. In such cases, the physical examination, history, and observation of scene surroundings and patient interaction with caregivers are of paramount concern. The physical examination and history should address the following issues. Is the patient capable of answering your questions in an appropriate way? Is the patient fearful? Does the patient look clean? Are the pill bottles marked appropriately and consistent with purchase dates and use? Does the patient have bruises or sores? Is the patient's current history consistent with the report given by the caregiver? Objectively record your observations on the patient care report, avoiding drawing conclusions and giving opinions. Adult Protective Services could use these observations as an indicator of whether assistance is required. As far as the scene goes, ask these questions. Is the home tidy and are the surroundings orderly? Is there food in the refrigerator? What is the heating or cooling situation, and is it appropriate to the weather? Does the patient use a walking or wheelchair device? For patients who reside in nursing homes, signs of maltreatment include undocumented decubitus ulcers, tied-off catheters, and dangerous use of restraints. Some nursing home residents who are victims of maltreatment may not have a way to report the maltreatment, may not know how to report the maltreatment, may not be physically able to report it, or may fear retaliation for reporting it. Others may be victims of maltreatment by visiting family members. Although the aging of the population has placed increased demands on the system, institutional caregivers have a legal obligation to meet accepted standards of care. Most communities have health departments that provide care, and even transportation for older citizens. If the patient is institutionalized and maltreatment or neglect is suspected, you may notify the regulatory commission responsible for overseeing the facility. You should thoroughly familiarize yourself with all local assistance, and keep an up-to-date directory with 24-hour phone numbers. Domestic maltreatment. Violence within the family has a long history. In ancient Rome, for example, husbands had the legal right to administer physical punishment to their wives within their own homes, and in public. Today, paramedics are frequently called for assault and battery in the home. The statistics on intimate partner maltreatment are sobering. Millions of women are maltreated by an intimate partner each year. Calls of this nature will challenge your skills. Scene safety is a paramount concern, and preservation of evidence is a necessity. Consider the following scenario. You are called for a woman bleeding. When you arrive, a man opens the door and tells you that his wife fell down the stairs. You find a 42-year-old woman crying and bleeding from her mouth. She has obvious contusions and abrasions on her face. Vital signs are a pulse of 124 beats per minute, respirations of 28 breaths per minute, and blood pressure of 132/84 millimeters of mercury. The patient is alert and oriented to person, place, and day. Her skin is warm and dry. Her husband tries to answer all of the questions you pose to her. The stairwell is carpeted and has only 7 risers, but there is no blood on the stairs. 2 children, ages 6 and 12 years, are crying in an adjacent bedroom. The father tells them to stay in the bedroom. Police have not been dispatched to this call yet. Is there significance to the husband dominating the patient interview? Should the crying children raise any red flags? The children's concern, and the husband's control of the scene could be perfectly normal behavior. You must look at all the pieces of the puzzle. Document what you have observed, not what you think. As a paramedic, you must be able to recognize the scope of domestic maltreatment and understand its various forms. Physical, hitting, kicking, pushing, shoving, choking, beating. Emotional, making negative comments, calling names, playing mind games. Economic, trying to keep a person from getting a job, and gaining his or her own financial independence. Sexual, making a person perform sexual activities against his or her will. Even though the awareness of domestic maltreatment has been raised in recent years, dealing with these cases in the pre-hospital environment presents a challenge to you as a paramedic. Battered patients may not give accurate details about their injuries, and they may avoid seeking help. Indeed, victims typically report their maltreatment only as a last resort, for many reasons, for example, shame, embarrassment, financial considerations, and low self-esteem. Moreover, many victims do not want the person responsible for the maltreatment to be charged or removed from the home, nor do they want to leave for a shelter. Often they believe the behavior will change, as is often promised by the abuser. Sometimes the victim believes that he or she is the reason for the maltreatment and somehow deserved it. Finally, some victims may fear even greater maltreatment should they disclose the truth about their injuries. Profile of a maltreated spouse. Physical injuries from maltreatment include broken bones, cuts, head injuries, bruises, burns, scars from old injuries, and internal injuries. A maltreated spouse may have feelings of anxiety, distress, or hopelessness and may show signs of depression, make suicide attempts, or engage in substance abuse. Although in the overwhelming majority of cases the victim is a woman, men also are maltreated. Men who are battered may be too humiliated to report the incident as it happened but still feel the same emotions as women: guilt, loss of control, and shame. Because society tends to be less empathetic toward maltreated men, and because fewer resources exist for them, the situation can be that much more difficult. Same-sex relationships can be as fraught with peril as heterosexual unions. A common misconception is that participants in same-sex relationships are on an equal playing field, so that the maltreatment cannot be as serious as that found in heterosexual relationships. In reality, concerns about coming out may prevent these victims from seeking help. You must be aware of and sensitive to their concerns. Battered patients may appear fearful, apprehensive, or nonverbal. They may avoid eye contact, and their answers may be incorrect or inconsistent. Be alert for verbal clues such as "it was my fault, I really shouldn't push him," or "he's a good person, it's just that when he drinks." In many provinces and territories, there are guidelines and policies that direct the police to lay a charge, as defined in the criminal code, when they suspect that an assault has occurred. People who maltreat their partners. Research confirms that domestic abusers are a diverse population. Approximately one-half show no psychological deficits or difficulties, whereas others may be overly sensitive, obsessive, paranoid, or threatening. They often abuse alcohol or drugs, and may have access to weapons, or they may exhibit none of these characteristics. Table 46-7 lists other characteristics of abusers. People who maltreat their partners or spouses may use intimidation and threats to maintain their control over the person. They may throw objects in a rage or threaten regarding what he or she will do if the spouse leaves or reports the abusive behavior. A spouse who maltreats his or her partner may also use isolation as a means to dominate the partner, not allowing the spouse to visit friends or talk openly with others, and may feel that he or she is providing discipline or is justified in these actions. Many times, the spouse who maltreats his or her partner is immediately remorseful and promises never to let the problem happen again. Historically, this is rarely true. The maltreatment usually continues and becomes even more violent. Never forget that domestic violence calls can be dangerous. You may be dealing with a potentially violent person, and emotions on the scene will be highly charged. If the person appears to be hostile or violent, remove all unnecessary people, such as family, friends, and bystanders, from the scene. It is imperative that you put your safety, and the safety of your partner first. If there is any doubt about scene safety, call for law enforcement assistance. See Chapter 54. Assessment and management of domestic maltreatment. Identifying a battered patient can be difficult because the victim may be protective of the attacker, frightened, or honestly unable to recall details. Patients may avoid eye contact or be otherwise evasive about their injuries. Listen for verbal clues regarding the incident, such as "we've been having some problems." On approach to the patient, use direct questioning to ascertain the physical harm. Try to empathize and reassure the patient. This caring attitude alone may instill confidence. Be as objective and non-judgmental as possible. Listen attentively, and be supportive. Give the patient a sense of control as much as possible. You may be the last or only chance a victim has to escape this situation, so encourage the patient to consider where he or she can go or whom he or she can call for help. In cases involving domestic maltreatment, the patient care report is more than just documentation of the transfer of care. It is a permanent record of treatment and disposition. More important, from a legal viewpoint, it represents hard evidence for the prosecution and the defense. Your statements and assessments must be objective, non-judgmental, exact, when quoting a statement from the scene, and as neat as possible. If you make an error, and want to change it, draw a line through the error, and initial the crossed-out statement. Usually, before testifying in court, you are allowed to review your patient care report, but remember that your testimony may come many years, and many patients later. Intimate partner maltreatment is not simply a family issue, it is a crime to assault another person, regardless of the relationship. The presence of law enforcement personnel is always helpful in these cases. If the patient refuses to be transported, ask if it is safe to leave information on services and resources, such as victim witness assistance programs or domestic maltreatment shelters that the patient may reference later. Learn what services are available in your area. Sexual assault. Sexual assault is another difficult call that EMS receives. Even more, your beliefs and values may be challenged when realizing what happened to your patient. Consider the following facts, which will help you adopt the necessary attitudes and behaviors that are helpful to victims of sexual assault. Any degree of sexual assault or rape are crimes of power, force, and violence. Although most victims are women, men and children can also be victims of sexual assault. The legal definition of these crimes differs from jurisdiction to jurisdiction, but essentially sexual assault refers to unwanted sexual contact and rape means penile penetration of the genitalia without the victim's consent. They can be classified as simple assault or aggravated assault. When the victim is underage, it is called statutory rape. Rape is an indictable offense, and you have a responsibility to preserve the crime scene in addition to treating the patient. These offenders are often known by the victim, hence the terms acquaintance assault or date rape. Consider the following scenario. You are sent to an assist police call. On arrival at the scene, you find a 20-year-old woman covered in a blanket and bleeding from several abrasions on her face. The police officer pulls you aside and states that the patient may have been assaulted in the alleyway on her way home from night class. Vital signs include a pulse of 134 beats per minute, respirations of 32 breaths per minute and irregular, and blood pressure of 122/80 millimeters of mercury. The patient is alert and oriented to person, place, and day. Her skin is warm and wet. She is very quiet, appears confused, and tells you she does not remember what happened. She wants to go home and shower. The victim of sexual assault is often found in a state of denial or disbelief. Likewise, the desire to shower or douche is common. The patient should be encouraged to go to the hospital, where evidence can be collected, and where access to professional services is more readily available. In general, be alert for signs that drugs were used to facilitate the sexual assault, such as weakness, nausea, disorientation, or memory loss in the victim. In some cases, patients may have multiple system trauma, and may require treatment for shock. Proper care of a victim of sexual assault will be discussed next. Treatment and documentation. You should know about the specific protocols for sexually assaulted victims, and assist the police, and any medical or social services personnel on the scene. Underage patients will need a parent, a guardian, or a legal representative present for the procedures. From arrival on scene to possible judicial system involvement, trust building, respect, and empathy are the keys to proper pre-hospital care. Most important, your concern in caring for a victim of a sexual assault should be to foster empowerment of the victim. Empowering means to let a person take action for himself or herself, regaining control of his or her body, thoughts, and life. It can be done through offering choices to the patient when accomplishing your assessment, and letting him or her have control over simple tasks, like installing the pulse oximetry themselves. Any kind of assault or abuse victim should be treated this same way. Specific treatment and documentation. In promoting proper care and documentation of a possible crime of sexual nature, you must consider the victim's psychological and physical state but also help preserve evidence, while addressing those different matters. A victim of sexual assault may be hysterical, embarrassed, and/or frightened, or he or she may be silent and appear emotionally contained. Denial and disbelief are common. Any reaction at this point is normal. Observe routine precautions. Take the patient's history, and perform a limited physical examination. Preserve the patient's dignity by shielding the patient from onlookers. Further help the patient regain a sense of control by posing open-ended questions, and allowing him or her to make simple decisions. There is no need to have the victim report to you the details of the assault. You may ask for the time passed since the event. You may ask for what took place since the event. Some victims may wish to block out details of the events. Refrain from seeking details that are not immediately necessary to provide emergent care, and leave the detailed inquiries and questions to teams specially trained to investigate such assaults. If you do not observe life-threatening signs and symptoms on arrival, avoid any aggressive treatment approach. As soon as possible, advise the patient not to bathe, douche, urinate, or defecate, if possible, if genital or anal penetration has occurred. If oral penetration has occurred, advise the patient not to eat, drink, brush the teeth, or use mouthwash until he or she can see medical personnel at the hospital, and decide on having a sexual assault evidence collection kit done. Medication should be taken only if prescribed, and if truly necessary. Leave evidence as untouched as possible, such as bringing the patient's unwashed clothes, and take care to establish a chain of custody as required. The police should be notified as per protocol. Treat all other injuries according to appropriate procedures and protocols for your EMS system. The patient may refuse assistance or transport, often because he or she wants to maintain privacy and avoid public exposure. Adult patients have the right to decline care. In these cases, you should follow your system's refusal of treatment policy or procedure for sexual assault victims without being judgmental or condescending to the patient. Your compassion is your best tool to win the patient's confidence, and encourage him or her to get further help. Because you may need to appear in court as many as 2 or 3 years later, you should document the patient's history, assessment, treatment, and response to treatment in detail. Record only the objective facts. Subjective statements made by those on the scene or the patient should be in quotation marks on the patient care report. Thoroughly document all patient statements pertaining to the crime, as well as statements, names, addresses, and contact information of any witness. Like a battered partner, a victim of sexual assault must be treated by EMS and protected by police. Conscientious health care providers will make a huge difference in the recovery of the patient through their professional conduct. Many provinces and territories offer rape crisis teams or sexual assault treatment centers to assist patients. Your EMS system should keep an up-to-date directory of all sexual assault hotlines and assistance available, with 24-hour telephone numbers. Child victims. In most cases of child sexual maltreatment, the person who maltreated the child is an adult who knows the child, and may be living under the same roof. Children of any age, and either gender can be victims of sexual maltreatment. Although most victims of rape are older than 10 years, younger children may also be victims. Child sexual maltreatment usually does not occur as a single incident. It does not always involve violence and physical force, and it commonly leaves no visible signs. The power of authority or the parent-child bond may be used to victimize the child instead of force or violence. The child may be manipulated into thinking that the acts are acceptable and normal behavior. The child may also be made to feel deeply ashamed and powerless or even be kept silent by threats. The insidious nature of this maltreatment makes it difficult to detect unless the child discloses the information to a confidant or a pre-hospital professional. Your assessment of a child who has been sexually maltreated should be limited to determining the type of dressing any injuries require. Sometimes, a sexually abused child is also beaten. In such cases, you should treat bruises and fractures as well. Do not examine the genitalia of a young child unless you see evidence of bleeding or an injury to this region that must be treated. In some cases, the child may present with behavioral or physical problems, such as hostility or restlessness.
Chapter 45. Geriatrics. Introduction. Geriatrics is the assessment and treatment of disease and/or injury in someone 65 years or older. In 2016, 15.6% of Canadians were seniors and, by 2030, that percentage will jump to 22%, largely driven by aging baby boomers, people born between 1946 and 1964. Furthermore, the elderly population is growing older. The most rapidly growing segment of the Canadian population is people 85 years and older. By 2036, the average life expectancy at birth for women will increase to 86.2 years and 82.9 years for men. Older people constitute an ever-increasing proportion of patients in the healthcare system, particularly the emergency care sector. People 65 years of age and older account for 1/3 of all hospitalizations, and more than 1/2 of all hospital stays. People are receiving more of their care out of hospital, and with insurance issues, this trend will continue in the future. This population also has more contact with physicians than those younger than 65 years. The old age dependency ratio is used to determine the number of older people in a society as compared with the number of potential workers who are theoretically capable of providing resources to sustain the whole population. The ratio is the number of older people, 65 years and older, for every 100 adults, potential caregivers, between the ages of 18 and 64 years. In 1990, there were 20 older people for every 100 working-age people. By 2025, however, it is projected that there will be 32 older people for every 100 working-age people. In other words, the supply of people capable of providing resources for the older population is not keeping pace with the growth of the older population. The need for caregivers will certainly increase, and society may have difficulty keeping up with the demand for services as the population continues to age. As the older population grows, paramedics will be required to offer services that are cost-effective and efficient. Most of your geriatric patients will not reside in nursing homes. Although nursing home admissions are increasing, owing to the larger number of older people in Canada, a counter-trend is for older people to maintain independent lives. Many older adults continue to live at home with support from a spouse or family member, and a visiting nurse. Others live in a more dependent care environment such as a senior center facility. Still others may reside in an assisted living facility or a total care nursing home. Determining how and where older adults will spend their retirement years is a difficult and complex process involving numerous social and economic issues, such as the person's marital status, financial resources, religious beliefs, ethnicity, gender, and general health. Because such decisions may place a burden on grown children and other family members, their wishes must be considered by healthcare providers when making care decisions. Older adults and their families may seek advice from medical social workers, professional care managers, discharge planners at healthcare facilities, and many private and public resources. The range of services available includes meal delivery, personal care, housekeeping, adult daycare, transportation, caregiver support, respite care, and emergency response systems, including paramedic services and lifelines. Psychosocial factors may influence successful aging. For example, at retirement, a person may no longer feel useful or productive in society, and may experience diminished self-esteem. Age also brings bereavement, sadness over the loss of friends and loved ones. Notably, the likelihood of death increases during the year following the death of one's spouse. As friends and family die, older adults tend to experience increasing loneliness and isolation, factors shown to have negative effects on health. Finally, the health problems of older people are quantitatively and qualitatively different from the problems of younger people. Consequently, one cannot simply transfer the principles of caring for and interacting with the younger population without modification to the older adult population. The special problems of older people require special approaches. Anatomy and physiology. Human growth and development peak in the late 20s and early 30s, at which point the aging process sets in. Aging is a linear process, that is, the rate at which a person loses functions does not increase with age. A 35-year-old is aging just as fast as an 85-year-old person, but the older person exhibits the cumulative results of a longer process. Organ and tissue aging may be accelerated by a variety of factors, including genetic qualities, pre-existing diseases, diet, exposure to toxins, activity levels, and psychosocial characteristics. It is difficult to make general statements about the rate of aging for all people, as this process can vary dramatically from one person to another. Most of us can report seeing 60-year-olds who look frail and 80-year-olds who are healthy enough to run marathons. The aging process is inevitably accompanied by changes in physiologic function, such as a decline in the function of the liver and kidneys. All tissues in the body undergo aging, albeit not at the same rate. The decrease in the functional capacity of various organ systems is normal but can affect the way in which a patient responds to illness. The aging process, and its associated changes, can also affect the way healthcare professionals respond to a patient's illness. It is important to differentiate between normal physiologic changes of aging and acute changes that indicate pathologic processes. For example, a healthcare provider who is unaware of the normal changes of aging may mistake these changes for signs of illness and be tempted to provide treatment when none is necessary. At the other end of the spectrum, a healthcare provider may attribute genuine disease symptoms to just getting old and fail to provide proper treatment. Changes in the cardiovascular system. A variety of changes occur in the cardiovascular system as a person grows older, with their net effect being to decrease the efficiency of this system. Specifically, the heart hypertrophies, enlarges, with age, probably in response to the chronically increased afterload imposed by stiffened blood vessels. Over time, cardiac output declines, mostly as a result of a decreasing stroke volume. Arteriosclerosis contributes to systolic hypertension in many older patients, which places an extra burden on the heart. This phenomenon may be a consequence of disease states such as diabetes, atherosclerosis, and renal compromise, and it is associated with an increased risk of cardiovascular disease, dementia, and death. Compliance of vascular walls depends on the production of collagen and elastin, proteins that are the primary components of muscle and connective tissue. An increase in blood pressure, normal hypertension seen in aging, leads to overproduction of abnormal collagen and decreased quantities of elastin, both of which contribute to vascular stiffening. The result is a widening pulse pressure, decreased coronary artery perfusion, and changes in cardiac ejection efficiency. Many geriatric patients also exhibit an S4 heart sound. In addition, the electrical conduction system of the heart undergoes changes over time. For example, the sinoatrial node, atrioventricular node, in the bundle of has become fibrotic and the number of pacemaker cells in the sinoatrial node decreases with age. In many cases, the changes in the conduction system lead to bradycardia, which can contribute to the decline in cardiac output. Some changes in cardiovascular performance are probably not a direct consequence of aging, but rather reflect the deconditioning effect of a sedentary lifestyle. Whether because of other disabilities, such as arthritis, or for social, financial, or psychological reasons, many people tend to decrease their physical activity as they grow older. The bodybuilder slogan, "Use it or lose it," applies just as much to the cardiac muscle as to the biceps. Changes in the respiratory system. A person's respiratory capacity also undergoes significant reductions with age, largely due to decreases in the elasticity of the lungs and in the size and strength of the respiratory muscles. In addition, calcification of costochondral cartilage tends to make the chest wall stiffer. As a result of these changes, the vital capacity, the amount of air that can be exhaled following a maximal inhalation, decreases, and the residual volume, the amount of air left in the lungs at the end of a maximal exhalation, increases. Thus, although the total amount of air in the lungs does not change with age, the proportion of that air usefully used in gas exchange progressively declines. Airflow, which depends largely on airway size and resistance, also deteriorates somewhat with age. Respiratory rates increase to approximately 16 to 25 breaths per minute, with breathing also becoming shallower. Meanwhile, Changes in the distribution of blood flow within the lungs result in declining PaO2, partial pressure of oxygen. At age 30 years, the PaO2 of a healthy person breathing ambient air is usually approximately 90 millimeters of mercury. At 80 years, the PaO2 under the same conditions is approximately 75 millimeters of mercury. PaO2 estimated as 100 minus age divided by 3. Furthermore, the respiratory drive becomes dulled as a person ages because of decreased sensitivity to changes in arterial blood gases or decreased central nervous system response to such changes. Musculoskeletal changes, such as kyphosis, outward curvature of the thoracic spine, may also affect pulmonary function by limiting lung volume and maximal inspiratory pressure. The thoracic cage becomes increasingly stiff, owing to calcification of the costal cartilage. Chest expansion is also limited by decreased pulmonary muscle strength and mass. The decreased mass and strength require an older person to exert a greater amount of energy to perform ventilations. The respiratory system is physically limited by these changes in its ability to modify either the respiratory rate or tidal volume as a compensatory mechanism. In addition, the lungs' defense mechanisms become less effective as a natural consequence of aging. In the later stages of chronic obstructive pulmonary disease, some patients will develop an enlarged chest anterior-posterior diameter referred to as a barrel chest. This change is due to chronic overinflation of the lungs so that the rib cage remains partially expanded all the time. This condition makes lung sounds sound diminished or distant. The cough and gag reflexes decrease with age, increasing the risk of aspiration. Furthermore, the ciliary mechanisms that normally help remove bronchial secretions are markedly slowed. Retention of these secretions and mucus produces a breeding ground for bacteria, putting geriatric patients at increased risk of respiratory infection. Changes in the nervous system. Aging produces changes in the nervous system that are reflected in the neurologic examination. Changes in thinking, cognitive, speed, memory, and postural stability are the most common normal findings in older people. Studies have documented age-associated declines in mental function, especially slower central processing of sensory stimuli and language, and longer retrieval times for short and long-term memory. Collectively, these changes affect performance on the mental status portion of the neurologic examination, with common findings including slow responses to questioning or requests to repeat a question. The brain weight may shrink 10% to 20% by age 80 years. The functional significance of this change is not clear, however. The human brain has an enormous reserve capacity, and having a smaller and lighter brain does not interfere with the mental capabilities of productive older adults. The performance of most of the sense organs declines with increasing age. The senses of taste and smell become diminished as a person ages. Visual changes may begin as early as 40 years of age, such that as many as 50% of patients older than 65 years have vision problems. Causes of visual impairment in older adults may include diabetes, age-related macular degeneration, and retinal detachment, which may also be associated with diabetes. The two most common causes of visual disturbances in older adults are cataracts and glaucoma. Cataracts is a result of hardening of the lenses over time. The lenses eventually become opaque, which prevents light and images from being transmitted to the rear of the eye. Patients with cataract may report blurred vision, double vision, spots, or ghost images. Surgical repair may be required to improve vision. By contrast, glaucoma is caused by an increase in intraocular pressure severe enough to damage the optic nerve, potentially resulting in permanent loss of peripheral and central vision. Treatment of glaucoma consists of oral medications and eye drops. Decreases in visual acuity are common in older people, even without disease processes such as cataracts. Night vision becomes impaired, as does the ability to adjust to rapid changes in lighting conditions, depth perception, and perception of color. Changes in a patient's vision can affect independence, the ability to read, and the ability to drive a vehicle. The possibility of hearing loss increases with age. A common cause of hearing impairment in geriatric patients is presbycusis, a progressive hearing loss, particularly in the high frequencies, along with a lessened ability to discriminate between a particular sound and background noise. Patients who lose the ability to interpret most speech experience a decreased ability to communicate, which may lead to isolation and depression. Another hearing-related impairment noted in the older adult population is Meniere's disease, prevalence, 1 person in 1,000. The onset of symptoms usually occurs in early middle age, with symptoms presenting in cycles that last several months at a time. The typical symptoms include vertigo, a sudden loss of normal balance or equilibrium, hearing loss, tinnitus, and pressure in the ear. For many older people, physiologic changes make it difficult to produce speech that is loud enough, clear, and well-spaced. Weakness, paralysis, poor hearing, or brain damage can damage the delicate functions that make these abilities possible. As we get older, changes in the vestibular system cause problems with balance and spatial orientation. Sense of body position, proprioception, also becomes impaired with age. As these mechanisms fail with age, people become less steady on their feet, and the tendency to fall increases markedly. Changes in the digestive system. The process of digestion begins in the mouth, which is also where age-related changes in the digestive system may first be noted. A decrease in the number of taste buds and changes in olfactory receptors may diminish an older person's senses of taste and smell, which may in turn interfere with the enjoyment of food. The consequent decrease in appetite may lead to malnutrition. Other age-related changes in the mouth include a reduction in the volume of saliva, with the resulting dryness of the mouth. Dental loss is not a normal result of the aging process, but rather the result of disease of the teeth and gums. Nevertheless, dental loss is widespread in the older adult population, and contributes to nutritional and digestive problems. Like oral secretions, gastric secretions are reduced as a person ages, although enough acid is still present to produce ulcers under certain conditions. Changes in gastric motility also occur, which may lead to slower gastric emptying, a factor of some importance when you are assessing the risk of aspiration, and a factor contributing to uncomfortable, but not life-threatening, heartburn and acid reflux. The functions of the small and large bowel change little as a consequence of aging, although the incidence of certain diseases involving the bowel, such as diverticulosis, increases as a person grows older. In the liver, there are changes in hepatic enzyme systems, with some systems declining in activity and others increasing. Notably, the activity of the enzyme systems concerned with the detoxification of medications declines as a person ages. The decrease in hepatic function can complicate medication absorption, resulting in medication toxicity. When patients are prescribed numerous medications, the risk for hepatic damage or medication toxicity increases. Changes in the renal system. The kidneys are responsible for maintaining the body's fluid and electrolyte balance and have important roles in maintaining the body's long-term acid-base balance and eliminating medications from the body. In a young adult, the kidneys weigh 250 to 270 grams. In a healthy 70-year-old, they weigh 180 to 200 grams. This decline in weight results from the loss of functioning nephron units, which translates into a smaller effective filtering surface. Although the kidneys of an older adult may be capable of dealing with day-to-day demands of a person's body, they may not be able to meet unusual challenges, such as those imposed by illness. For that reason, acute illness in geriatric patients is often accompanied by derangements in fluid and electrolyte balance. Aging kidneys, for example, respond sluggishly to sodium deficiency. A geriatric patient may lose a large amount of sodium before the kidneys halt urinary sodium excretion, a problem that is exacerbated by the markedly decreased thirst mechanism in older people. The net result may be a rapid development of severe dehydration. Conversely, older adults are at considerable risk of overhydration if they are exposed to large sodium loads, such as from intravenous saline solutions or heavily salted foods. Because of its lower glomerular filtration rate, the aging kidney is less able to excrete a large sodium load, making the patient vulnerable to acute volume overload. The same factors that reduce an older person's ability to handle sodium also affect the body's ability to handle potassium. Thus, geriatric patients are susceptible to hyperkalemia that can reach serious, even lethal, levels if the patient becomes acidotic or if the potassium load is increased from any source. Bowel and bladder continence require anatomically correct gastrointestinal and genitourinary tracts, functioning and intact sphincters, and properly working cognitive and physical functions. Although urinary incontinence, involuntary loss of urine, can have significant social and emotional impacts, relatively few people admit to this problem, and even fewer seek treatment for it. Incontinence is not a normal part of aging, and can lead to skin irritation, skin breakdown, and urinary tract infections. As people age, the capacity of the bladder decreases. As a consequence, an older person may find it difficult to postpone voiding or may have involuntary bladder contractions. Two major types of incontinence are distinguished: stress and urge. Stress incontinence occurs during activities such as coughing, laughing, sneezing, lifting, and exercise. Urge incontinence is triggered by hot or cold fluids, running water, and sometimes the simple thought of going to the bathroom. Treatment of incontinence consists of medications, physical therapy, and, possibly, surgery. The opposite of incontinence is urinary retention or difficulty urinating. Patients may have difficulty voiding or absence of voiding as a result of many medical causes. In men, benign enlargement of the prostate can place pressure on the urethra, making voiding difficult and frequent. Bladder and urinary tract infections can also cause inflammation that results in retention of urine. The pain associated with urination during such infections may lead patients to intentionally avoid urination. In severe or prolonged cases of urinary retention, patients may have acute or chronic renal failure. Changes in the integumentary system. Wrinkling and loss of resiliency of the skin are the most visible signs of aging. Wrinkling occurs because the skin becomes thinner, drier, less elastic, and more fragile. As subcutaneous fat becomes thinner, bruising becomes more common because subcutaneous fat normally cushions blood vessels from mild blunt forces. The levels of both elastin, the substance that makes the skin pliable, and collagen, the substance that makes the skin strong, decrease with age. Thinner skin tears much more easily, and the loss of elasticity allows for more bleeding before hemostasis occurs. As a person ages, the sebaceous glands produce less oil, and the skin becomes drier. Sweat gland activity also decreases, hindering the ability to sweat and to regulate heat. Hair follicles produce thinner hair or may stop producing hair. Follicles produce less melanin, the pigment that gives hair color, making the hair color change to gray or white. The blood vessels that supply the skin also are affected by atherosclerosis, and provide less oxygenated blood at the cellular level. As a consequence of the skin's lower metabolism, epidermal cells develop more slowly and do not replace outgoing cells as quickly as with younger skin. Geriatric patients, therefore, are at higher risk for secondary infection after the skin breaks, such as with skin tears, pressure ulcers, and skin tumors, as well as viral and fungal skin infections of the skin. Homeostatic and other changes. Homeostasis is the process by which the body maintains a constant internal environment. Many homeostatic mechanisms work on a feedback principle, much like the thermostat in a house, that is, a change in the internal environment feeds back to the control system to induce a corrective response. For example, when the body temperature starts to rise, temperature sensors are activated, which in turn activate compensatory responses. Cutaneous blood vessels dilate, and excess heat is transferred from the body to the environment. Similarly, when a concentration of glucose in the blood rises, the pancreas is stimulated to secrete insulin, which leads to uptake of glucose by cells and reduction of the blood's glucose level back toward normal. With aging, there is a progressive loss of these homeostatic capabilities. For that reason, a specific illness or injury in older adults is more likely to result in generalized deterioration. For example, the thirst mechanism, which ordinarily protects a person from dehydration, becomes depressed in older adults. Likewise, temperature-regulating mechanisms tend to become disordered, which when combined with integumentary changes makes older adults much more vulnerable to environmental stresses such as heat exhaustion and accidental hypothermia after relatively minor exposures. A defect in temperature regulation may also account for the absence of a febrile response to illness in some older adults. Infections that would ordinarily produce high fever, such as pneumococcal pneumonia, may produce only a low grade or no fever in older adults. The regulatory system that manages the blood glucose level similarly becomes impaired with increasing age, such that an elevated blood glucose level occurs quite commonly in older patients. Ordinarily, moderate hyperglycemia does no harm, but overly aggressive treatment of this problem may produce damaging hypoglycemia. Changes in the musculoskeletal system. Aging brings a widespread decrease in bone mass in men and women, but especially among postmenopausal women. Bones become more brittle and tend to break more easily. Tendons and ligaments begin to lose elasticity, synovial fluid in the joints thickens, and the amount of cartilage that ordinarily cushions the joints decreases. Narrowing of the intervertebral discs and compression fractures of the vertebrae contribute to a decrease in height as a person ages, along with changes in posture. Joints lose their flexibility, and may be further immobilized by arthritic changes. Muscle mass decreases throughout the body, with an accompanying decrease in muscle strength. From your perspective, the changes in the musculoskeletal system most often translate into fractures incurred as the result of falls. Pathophysiology. Cardiovascular system. Diseases of the heart remain the leading cause of death among older adults in Canada, and coronary artery disease is the #1 culprit. Heart attack, or myocardial infarction, is the major cause of morbidity and mortality in people older than 65 years, and its potential for mortality increases significantly after a person reaches 70 years. Although chest pain is a common presentation for acute myocardial infarction in older patients, it may be decreased in intensity or atypical. In fact, pain may even be absent, with a patient instead reporting dyspnea, syncope, weakness, confusion, nausea, vomiting, or fatigue. People 65 years and older are a high-risk group for heart failure. In fact, this problem is the most common reason for hospitalization in the geriatric population. Heart failure is on the rise in this cohort for two paradoxical reasons: better care of the diseases that might otherwise result in failure, such as coronary artery disease and hypertension, which enables patients to live long enough to develop heart failure, and more effective management of heart failure once it develops. Risk factors include sex, ethnicity, family history and genetics, long-term alcohol abuse, and multiple medical conditions. As with myocardial infarction, prevention is aimed at lifestyle changes, cessation of tobacco use, eating a healthy diet, good control of blood glucose in patients with diabetes, exercise, weight control, and control of hypertension. Rhythm disturbances, dysrhythmias, of the heart occur when the electrical system controlling the heartbeat experiences an interruption or malfunction. These irregularities cause heartbeats that are too fast, too slow, irregular, or absent. Many people experience an occasional or harmless dysrhythmia that they may describe as a skipping, fluttering, or fast heartbeat. Dysrhythmias in older people are generally a result of age-related changes in the heart, existing cardiac disease, adverse medication effects, or a combination of these factors. Cardiac dysrhythmias are classified by the part of the heart from which they originate. Unlike tachydysrhythmias or bradydysrhythmias, which speed up or slow down the heart, premature beats signify no change in speed but rather alter the regularity of the heartbeat. In contrast, atrial fibrillation, coming from the atria, which is the most common dysrhythmia among older people, increases the risk of stroke and heart failure. The fibrillating atria allow for stasis of the blood, thereby encouraging clot formation, and increasing the chances that a clot fragment might travel to the brain and cause a stroke. Most of the blood in the atria enters the ventricles when the valves open, with approximately 20% being kicked in by contraction of the atria. The aging heart may function adequately when preload provided by the atria ends up in the ventricles. However, when that 20% remains in the atria, new signs or symptoms of heart failure may develop or stable heart failure may decompensate. Bradycardias are also more common in older people. The aging conduction system may produce dysrhythmias such as sick sinus syndrome and atrioventricular blocks. Coronary artery disease may produce high-degree blocks, whereas medications such as beta blockers or calcium channel blockers can cause excessive slowing of the heart rate. The incidence of aneurysm increases with age. An aneurysm is a weakness in any artery that produces a balloon defect, weakening the arterial wall. This weakness may be congenital, present at birth, or acquired. In the latter case, hypertension, atherosclerotic disease, and obesity are contributing factors to development of such a defect. For example, blood pressure greater than 160/95 millimeters of mercury doubles the mortality risk in men, and can lead to kidney loss and blindness by damaging the blood vessels that supply the kidney and eyes. Life-threatening aneurysms can develop in the brain, chest, or abdomen. A new headache or a change in chronic headache patterns, for example, may signal early cerebral bleeding from an aneurysm. All too often, however, the first manifestation is a sudden and devastating stroke. Preventive measures, proper diet, exercise, smoking cessation, and cholesterol control aim to control the risk factors associated with hypertension and atherosclerotic diseases. Aortic disruption occurs when the inside wall of the artery becomes torn and allows blood to collect between the arterial wall layers. It may occur with trauma or sustained hypertension. Disruption weakens the arterial wall, making it susceptible to rupture. A thoracic aortic disruption, for example, can produce chest pain that is difficult to differentiate from cardiac ischemia. Therefore, it is helpful to take blood pressure readings and to palpate a heart rate in both arms in all patients with chest pain. A systolic blood pressure difference of 15 millimeters of mercury or higher suggests a thoracic aortic disruption. More than one-half of all older people are hypertensive. The majority have isolated systolic hypertension resulting from a loss of arterial elasticity. Controlling systolic and diastolic hypertension in older people helps prevent both strokes and myocardial infarctions. Unfortunately, hypertensive emergencies require a controlled decline in blood pressure that often cannot be achieved in the pre-hospital environment. Stroke is a significant cause of death and disability in older people. More than 80% of all stroke deaths occur in people older than 65 years, and stroke is the leading cause of long-term disability at any age. Strokes, which are mainly caused by atherosclerosis, are responsible for 14,000 deaths, 7%, annually in Canada, making stroke the third leading cause of death. The risk of stroke doubles each decade after 55 years of age, mirroring the increase in risk factors such as hypertension and atrial fibrillation. Hypertension is the primary risk factor for stroke, but age, family history, smoking, diabetes, high cholesterol, and heart disease also contribute to its incidence. Normal changes of aging, such as loss of vascular elasticity, also place the older patient at an increased risk of hemorrhagic stroke. Prevention is aimed at reduction of risk factors, improving diet and exercise, and lowering cholesterol. Transient ischemic attacks, also called mini-strokes, entail a temporary disturbance of blood supply to the brain that results in a sudden, temporary decrease in brain function. The symptoms are the same as those for a stroke but last less than 24 hours, and most will last less than 60 minutes. They are warning signs of a future stroke. Respiratory system. Although tobacco use seems to be decreasing among older people, chronic lower respiratory disease, influenza, and pneumonia remain in the top 5 causes of geriatric deaths. In fact, one of the most common causes of death in older patients is infection with pneumococcus bacteria. Pneumonia involves an inflammation of the lung, secondary to infection by bacteria, viruses, or other organisms. Although it can affect people at any age, this disease has its biggest impact on the very young and on older adults, typically during the colder seasons, winter and early spring. People considered at risk include older people, people with underlying health problems such as chronic obstructive pulmonary disease, diabetes mellitus, and vascular diseases, and any person with a depressed immune system because of acquired immunodeficiency syndrome, cancer therapy, or organ transplantation. Treatment is primarily supportive, consisting of placing the patient in a position of comfort that allows for the best possible ventilation, plus giving fluids, oxygen therapy via a nasal cannula or mask to relieve dyspnea, and analgesics to reduce fever. These patients may benefit from application of continuous positive airway pressure. Preventive measures include a pneumococcus vaccine given once, with booster doses after 3 to 5 years, although this will not prevent infection from other bacterial species, along with smoking cessation and respiratory exercises during bed confinement. The receiving facility will determine whether antibiotics are necessary. Chronic obstructive pulmonary disease is the name given to a set of diseases, including chronic asthma, chronic bronchitis, and emphysema, all of which are characterized by the presence of bronchial obstruction and airway inflammation. Distinguishing these diseases can be difficult, so the problem may not be diagnosed or treated correctly. The effects of chronic obstructive pulmonary disease reflect the age-related loss of elastic tissue in the lungs, and a decreased ability to defend against infection. These factors may increase the baseline disability of chronic obstructive pulmonary disease, and set up older patients for an increased risk of acute exacerbation, often caused by infection. Patients with chronic obstructive pulmonary disease may experience dyspnea on exertion, and when the disease is in its later stages, even minor physical activities such as position changes and walking may become difficult for the patient. Thus, along with shortness of breath, presenting symptoms in an acute chronic obstructive pulmonary disease exacerbation may include fatigue and a decreased activity level. Preventative measures for chronic obstructive pulmonary disease include smoking cessation, avoidance of certain environmental pollutants, and immunization for influenza and pneumococcal pneumonia. In a patient of any age, treatment goals for chronic obstructive pulmonary disease are to reduce the symptoms and complications. Long-term oxygen therapy has proven helpful in patients with hypoxemia. In addition, pulmonary rehabilitation may improve functional status and the quality of life for some patients. Patients with chronic obstructive pulmonary disease frequently use inhaled beta-adrenergic agents and inhaled or oral corticosteroids. Approximately 1 in 20 older people has a history of asthma or is affected by it. Onset can occur in old age with presenting symptoms of shortness of breath, especially with effort, chronic or nocturnal cough, and wheezing. A pulmonary embolus occurs when a blood vessel supplying the lung becomes blocked by a clot. Just as is true with the heart, any obstruction in blood flow to the lung can result in irreversible damage or infarction. An embolus is often released from a vein in a lower extremity, the pelvis, or the abdomen, but could also result from a heart dysrhythmia such as atrial fibrillation. The risk of pulmonary embolus increases with age because of increasing immobility and increased vascular stasis in the lower extremities. Bed confinement during illness or after surgery will further decrease blood flow in the legs and feet, increasing the chance of deep vein thrombosis and pulmonary embolism. Finally, geriatric patients have an increased incidence of diseases associated with a higher risk of pulmonary embolus, such as cancer, heart attack, cardiac dysrhythmias, and clotting disorders. Prevention of thromboembolism is based on the patient's risk level, high, moderate, or low. Surgical patients are in the highest risk category for potential emboli, and prophylaxis is generally recommended in such cases, including warfarin, Coumadin, and/or heparin and compression stockings. Nervous system. Normal age-related cognitive changes have two major features. 1. They are relatively isolated, that is, they are not associated with multiple abnormal neurologic findings that suggest specific disease states, and 2. The onset and progression of these findings are in time with the person's aging process, that is, the findings are not sudden or extreme, and they do not extend to other abnormalities. Delirium, also known as acute brain syndrome or acute confusional state, is a symptom, not a disease. This temporary state is generally a reflection of an underlying disturbance to a person's well-being, usually a treatable physical or mental illness, and is usually reversible. In older adults, delirium often replaces or confounds the typical presentation caused by an acute medical problem, an adverse medication effect, or drug or alcohol withdrawal. Causes of delirium may include medications, poisons, electrolyte imbalances, nutritional deficiencies, respiratory, cardiovascular, or nervous system disorders, hyperglycemia or hypoglycemia, environmental emergencies, trauma, and infections such as urinary tract infections and pneumonia. The onset of confusion or disorientation is abrupt, occurring during hours to days, and generally resolves with treatment of the underlying problem. The confusion and disorientation fluctuate with time, and hallucinations may lead to bizarre, uncharacteristic, or confusing behavior. The patient experiences a rapid alteration between mental states, such as lethargy and agitation, serious attention disruption, disorganized thinking, and changes in perception and sensation. Unlike delirium, dementia produces irreversible brain failure. Disorders that cause dementia include conditions that impair vascular and neurologic structures within the brain, such as infections, strokes, head injuries, poor nutrition, and medications. The two most common degenerative types of dementia in older people are Alzheimer's disease and multi-infarct or vascular dementia, both of which cause structural damage to the brain. An estimated 6% to 10% of older adults will eventually have dementia, although this percentage increases with advancing age. Dementia is typically diagnosed when two or more cognitive and psychomotor functions are impaired, including language, memory, visual perception, emotional behavior and/or personality, and cognitive skills. Risk factors that may predispose a patient to dementia include low level of education, female gender, and African ethnicity. Although most cases of dementia cannot be prevented, some experts suggest that low-fat diets and exercise may help ward off vascular dementia. Experts have not identified a single cause for Alzheimer's disease, but most believe it is not a normal part of the aging process. Although age is a significant risk factor for this disease, age is not the sole cause of its development. This progressive disease cannot be cured or reversed by any known treatment or intervention. Symptoms are subtle at onset. Over time, patients lose their ability to think, reason clearly, solve problems, and concentrate. They may forget the identities of close family members, including their spouses and children, and their own past experiences. In the later stages of Alzheimer's disease, patients cannot take care of themselves and may lose the ability to speak. People with severe Alzheimer's disease become completely debilitated and totally dependent on others. Patients with Parkinson's disease, another age-related neurologic disorder, have two or more of the following symptoms: resting tremor of an extremity, slowness of movement, bradykinesia, rigidity or stiffness of the extremities or trunk, and poor balance. Parkinson's disease is caused by degeneration of the substantia nigra, an area of the brain that controls voluntary movement by producing the neurotransmitter dopamine. Cells use dopamine to transmit impulses, so a loss of dopamine results in the loss of muscle function. Parkinson's disease can affect one or both sides of the body, and produces a wide range of functional loss. The incidence of seizures, including status epilepticus, is also increased in the geriatric population, partly because of the increase in risk factors such as stroke, dementia, primary or metastatic brain tumors, and acute metabolic disorders, such as hyperglycemia, hyponatremia, and alcohol withdrawal. Pre-hospital treatment for seizures is the same for younger and older patients. Gastrointestinal system. Constipation is a frequent and significant problem in older people. Although it can cause acute abdominal pain, it should not be the initial condition suspected when a patient experiences such discomfort. Instead, causes with high mortality, such as bleeding from an acute abdominal aneurysm or dead bowel from mesenteric ischemia, should be investigated first. Many older adults have diverticulosis, small outward pouches in the colon wall, and are at risk for diverticulitis and/or perforation. Appendicitis can be difficult to diagnose in older people, which probably accounts for the high perforation rate, 50%, seen with this condition. The incidence of peptic ulcer disease is also increased among the older population, likely because of their relatively high use of nonsteroidal anti-inflammatory medications for pain management. Large bowel obstructions in older people are likely to be caused by cancer, impacted stool, or sigmoid volvulus. In addition, small bowel obstructions secondary to gallstones increases significantly with age. With one or more episodes of cholecystitis, inflammation of the gallbladder adheres to the small bowel and, over time, creates an opening or fistula. The stone or stones drop into the bowel and produce the obstruction. The large and small intestines are also at risk for obstruction from adhesions due to previous surgery or infection, or when a segment of bowel is forced into a fascial defect, hernia, in the abdominal wall. Older patients are more likely than younger ones to have stomach or duodenal ulcers, peptic ulcer disease. The main risk factors for development of peptic ulcers are regular use of nonsteroidal anti-inflammatory medications and infection with Helicobacter pylori, an ulcer-associated bacteria of the stomach, both of which are more common in older patients. Other medications have also been implicated in ulcer formation. The main symptom of peptic ulcer disease is dyspepsia, gnawing, burning pain in the upper abdomen, which usually improves immediately after eating but returns several hours later. Other causes of dyspepsia include acid reflux, gastritis, and gastric cancer. Endocrine system. Diabetes arises when the body cannot oxidize complex carbohydrates, sugars, due to impaired pancreatic activity, namely, production of insulin. Insulin moves carbohydrates out of the bloodstream, through the cellular walls, and into the cells to be metabolized. With diabetes, more glucose is present in the blood than the body can handle. Geriatric patients with diabetes are at increased risk for hypoglycemia for several reasons: confusion about medication doses or usage, inadequate or irregular dietary intake, inability to recognize the warning signs due to cognitive problems, and/or blunted warning signs. Delirium may be the only indication of hypoglycemia in a geriatric patient. Over 2.25 million Canadians are estimated to have diabetes. 10% of these are older than 65 years, and primarily have type 2 diabetes mellitus, non-insulin-dependent diabetes. The most common risk factor for this disease is having more than one chronic disease, and many older people with diabetes also have hypertension, heart disease, and stroke. Other risk factors for diabetes include a family history of diabetes, genetics, age, diet, obesity, and a sedentary lifestyle. Symptoms of an elevated blood glucose level, that is, hyperglycemia, include fatigue, poor wound healing, blurred vision, and frequent infections. Other symptoms of diabetes include the 3 Ps, polyuria, polydipsia, and polyphagia. Prevention of type 2 diabetes mellitus is aimed at changes in lifestyle that include dietary restrictions, exercise, and controlling obesity. Older people with diabetes and consistently high blood glucose levels are more susceptible to hyperglycemic hyperosmolar syndrome, also called hyperosmolar noncatotic coma, than diabetic ketoacidosis. The most frequent cause for hyperglycemic hyperosmolar syndrome or hyperosmolar noncatotic coma is infection, but other potential risk factors include hypothermia, hyperthermia, cardiac disease, pancreatitis, and stroke. Presentation is likely to be hyperglycemia. Blood glucose level is generally greater than 33 millimoles per liter, and acute confusion with dehydration, although signs of dehydration may be altered in older adults. Pre-hospital treatment remains the same as for younger patients, albeit with a cautious approach to fluid resuscitation. Thyroid abnormalities also increase with aging. Many older patients remain asymptomatic, and the disease is diagnosed only when a routine blood test reveals a thyroid problem. Adult hypothyroidism is manifested by a general slowing of the body's metabolic processes due to the reduction or absence of thyroid hormone. In patients with hypothyroidism, the signs and symptoms may match those seen with normal aging: cold intolerance, constipation, dry skin, weakness, and weight gain. Prior thyroidectomy is also more common in geriatric patients, who typically take synthetic thyroid hormones to compensate for the body's inability to produce them. For acute onset hyperthyroidism, the presentation can be blunted. Although tachycardia is generally present, older patients may experience less tremor, anxiety, or hyperactive reflexes compared to younger patients. Atrial fibrillation is more likely to be induced by an overactive thyroid gland in a geriatric patient. A smaller percentage of older patients with hyperthyroidism present with symptoms opposite those expected: weakness, lethargy, and depression. Care in the pre-hospital setting is supportive. Musculoskeletal system. Changes in physical abilities can affect older adults' confidence in their mobility. The muscle system atrophies and weakens with age. Muscle fibers become smaller and fewer in number, motor neurons decline in number, and strength declines. The ligaments and cartilage of the joints lose their elasticity. Cartilage also goes through degenerative changes with aging, contributing to arthritis. The stooped posture of older people reflects atrophy of the supporting structures of the body. Many older patients will show some degree of kyphosis, outward curvature of the thoracic spine. Lost height in older adults generally results from compression in the spinal column, first in the discs, and then from the process of osteoporosis in the vertebral bodies. Osteoporosis is characterized by a decrease in bone mass leading to reduction in bone strength and greater susceptibility to fracture. The extent of bone loss that a person experiences is influenced by numerous factors, including genetics, smoking, level of activity, diet, hormonal factors, and body weight and structure. The most rapid bone loss occurs in women during the years following menopause, and many postmenopausal women use hormone replacement therapy as a means to reduce the bone loss. Calcium and vitamin D supplementation is another treatment for the condition, as are medications that improve bone density. These include alendronate, fosamax, edidronate, didrocal, risdronate, dactonal, and zoeldronic acid, aclasta. Older people should remain active and perform low-impact exercises to maintain bone and muscle strength. Osteoarthritis is a progressive disease of the joints that destroys cartilage, promotes the formation of bone spurs in joints, and leads to joint stiffness. This type of arthritis is thought to result from wear and tear and, in some cases, from repetitive trauma to the joints. Typically, osteoarthritis affects several joints of the body, most commonly those in the hands, knees, hips, and spine. Patients report pain and stiffness that gets worse with exertion. The end result is often substantial disability and disfigurement. Patients are typically treated with anti-inflammatory medications and physical therapy to improve the range of motion. Rheumatoid arthritis is a long-term autoimmune disorder that is characterized by inflammation of the joints and the surrounding tissues. Symptoms are usually bilateral and most commonly affect the hands, feet, wrists, ankles, and knees. Patients may note pain and stiffness at the joints, with smaller joints in the fingers and toes usually being affected long before larger joints, such as the elbows, shoulders, knees, or hips. You may observe deformities that are part of the patient's state as well as a poor range of motion. Care for rheumatoid arthritis is strictly supportive in the pre-hospital setting. If rheumatoid arthritis causes chest pain associated with pleurisy, this symptom should be treated according to pain management protocols. Toxicology. As the number of uses for medications increases, the likelihood of adverse medication reactions and interactions increases in tandem. Older adults are particularly susceptible to adverse reactions, even when they take medications at doses that would be safe in younger people. This increased incidence of adverse medication reactions among older people seems to reflect age-related changes in medication metabolism because of diminished hepatic function, in medication elimination because of diminished renal function, in body composition, including increased body fat and decreased body water, altering the distribution of medications through the various body compartments, and in the responsiveness to medications that affect the central nervous system. A change in any one of these processes can lead to toxic effects in older people. Other body changes may affect medication use by geriatric patients in a more general way. As vision declines with age, reading small print becomes more difficult. Night vision becomes less acute, so reading labels in dim light can lead to errors. Short-term memory loss may lead to forgetfulness about whether medications have been taken. An inability to distinguish flavors may cause patients to take multiple doses of medications before they detect problems. The geriatric population consumes more than 20% of all prescribed and over-the-counter medications sold in Canada. Older people in community dwellings take an average of 3 to 5 medications per day. Nursing home patients take an average of 6 to 7 routinely scheduled medications daily and 2 to 3 additional medications on an as-needed basis. This kind of polypharmacy, the use of multiple medications, may be therapeutic when multiple medications are used to manage different medical problems, but it may prove harmful when these medications interact. Geriatric patients are particularly susceptible to having multiple chronic diseases, which may lead to a vicious cycle. The presence of multiple disease states leads to the use of multiple medications, which increases the likelihood of adverse reactions, which in turn leads to treatment with more medications. A person's risk of ending up in the hospital because of an adverse reaction to a medication increases with the number of medications taken. Ultimately, The best dosage of a medication for an older patient is the lowest dosage that will achieve a therapeutic effect. Medication non-compliance in older patients is also associated with negative effects on health. Many patients, not just older patients, do not follow instructions or advice on the use of their medications. Because older adults take more medications than the rest of the population, non-compliance issues are more likely to arise with these patients. Non-compliance issues include failure to fill a prescription. For example, the patient does not have the money to pay for the medication or does not see the benefit of it. Improper administration of medication. For example, the patient decreases the dosage to make the prescription last longer. Discontinuation of medication. For example, the patient feels better and decides not to take the medication, and taking inappropriate medications. For example, the patient had medication left over from a previous prescription or shares the medicine with family or friends. Geriatric patients are predisposed to medicine-related reactions owing to the previously mentioned age-related physiologic changes that occur in body systems and body composition. For example, an increase in the proportion of adipose tissue can prolong the half-life of a medication in the body. In particular, medications that affect the central nervous system are the most common source of adverse or unexpected reactions, with barbiturates and benzodiazepines being the medications most often associated with toxic effects. For this reason, when caring for older patients, you should consider reducing the dosage of medications that affect the central nervous system. For example, consider administering 25 micrograms instead of 50 micrograms of fentanyl for pain relief. A reduction in the nervous system response, especially the decrease in parasympathetic activity typically seen with the aging process, increases the risk that adverse anticholinergic effects will occur. Reduced beta-adrenergic receptor sensitivity, which is responsible for bronchodilation, makes most bronchodilator medications less effective in older patients. The use of diuretics and antihypertensive medications can cause hypotension and orthostatic changes due to reduced cardiac output and a decrease in total body water. Finally, decreased glucose tolerance may cause medications such as diuretics and corticosteroids to have hyperglycemic effects in older adults. Drug and alcohol abuse. Alcohol is the preferred substance of abuse among older people, in whom its use is on the rise. A much smaller but increasing segment of the geriatric population uses illicit drugs. Most users are men, and more than one-half carry their addiction into old age. Approximately one-third develop an abuse problem after reaching 65 years, often in response to a life-changing event such as the loss of a spouse, declining health, or low self-esteem. The prevalence of alcohol and drug misuse among older people is also attributable to the multiple medications prescribed for them and their heightened vulnerability to abuse owing to the effects of aging. Their decreased body mass and total body water means that alcohol consumption leads to higher concentrations of blood alcohol in older adults compared to consumption of the same amount of alcohol by younger adults. At the same time, the combination of digestive, renal, and hepatic system changes leads to slower elimination of alcohol from the older adult's body. As the geriatric population continues to grow and experiences even more chronic disabilities, the likelihood of substance abuse-related problems in this group will increase. Recognizing substance abuse in older people can be difficult. If they have engaged in this behavior for a long time, it may be well hidden from, or even accepted by, family and friends. Because substance abuse can complicate your initial assessment and treatment, it is important to ask about this issue. Psychiatric conditions. Depression is not part of normal aging, but rather a medical disease that occurs in 5% to 10% of the population older than 65 years. It is treatable with medication and therapy. However, if depression is unrecognized or untreated, it is associated with a higher suicide rate in the geriatric population than in any other age group. Depression in geriatric patients can mimic the effects of many other medical problems, such as dementia. Risk factors for depression in older people include a history of depression, chronic disease, and loss of function, independence, or significant others. This condition may be difficult to recognize in older people because many do not want to report feeling sad, worthless, or unwanted. Disturbingly, the majority of elder suicides occur in people who have recently been diagnosed with depression. In addition, the majority of suicide victims have seen their primary care physician within the month before the event. Unlike younger people, geriatric patients typically do not make suicidal gestures or attempt to get help. Instead, the rate of completed suicide is disproportionately high in the geriatric population. Many geriatric patients see no other way out when they have a terminal illness or debilitating cardiac or neurologic condition, such as severe heart disease or stroke. At highest risk are white men 85 years and older, who use firearms as their suicide method of choice. Injury in older adults. Environmental injury. Internal temperature regulation is slowed in older people, and continues to slow with increasing age. The body's ability to recognize fluctuations in temperature becomes delayed owing to a slowed endocrine system. Heat gain or loss in response to environmental changes is delayed by atherosclerotic vessels, slowed circulation, and decreased sweat production in the skin. In addition, thermoregulation can be adversely affected by chronic disease, medications, and alcohol use, all of which are more frequent in older adults. Not surprisingly, about 1/2 of all deaths from hypothermia occur in older adults, and most indoor hypothermia deaths involve geriatric patients. Although living where harsh winters occur is a risk factor, hypothermia can develop at temperatures above freezing when an older person is exposed for a prolonged period. The death rates from hypothermia are more than doubled in older adults compared with younger people. People older than 85 years are at highest risk. Providers should be aware of environmental emergencies during extreme heat and cold, particularly in lower socioeconomic areas where homes may not have sufficient heat or air conditioning. Managing such events may require public awareness and pre-planning. You may have to keep the ambulance's patient compartment at a temperature that is higher than normal, and perhaps uncomfortable for you, to adequately maintain the geriatric patient's temperature. Trauma in older adults. Trauma is one of the top 10 causes of death among the geriatric population. In Canada, from 2017 to 2018, more than 137,500 seniors aged 65 years and older were hospitalized for injuries, which accounted for more than 1/2 the injury-related hospitalizations. Most of these injuries were caused by falls, which is the #1 cause for a senior being seen in an emergency department or being hospitalized. Several factors place an older person at higher risk of trauma than a younger person: slower reflexes, visual and hearing deficits, equilibrium disorders, and an overall reduction in agility. In particular, changes in the body's homeostatic compensatory mechanisms combined with the effects of aging on body systems, and any pre-existing conditions usually add up to less than favorable outcomes in trauma situations. Compensation in trauma is successful when increased pulse rate, increased respirations, and adequate vasoconstriction make up for trauma-related blood loss. Reduced cardiac reserve, decreased respiratory function, impaired renal activity, and ineffective vasoconstriction, by contrast, may lead to unsuccessful recovery from traumatic situations. Furthermore, an older adult is more likely to sustain serious injury in case of trauma because stiffened blood vessels and fragile tissues tear more readily, and brittle, demineralized bone is more vulnerable to fracture. Most geriatric trauma cases involve falls or motor vehicle collisions. Although most falls do not produce serious injury, they do result in increased mortality in geriatric patients, a trend that is directly related to the patient's age, pre-existing disease processes, and complications related to the trauma. Falls are associated with a higher incidence of anxiety and depression, a loss of confidence, and post-fall syndrome. In post-fall syndrome, geriatric patients develop a lack of confidence and anxiety about potential falls. Falls among older adults are evenly divided between those resulting from extrinsic, external, causes, such as tripping on a loose rug or slipping on ice, and those resulting from intrinsic, internal, causes, such as a dizzy spell or a syncopal attack. The risk of falls increases in people with pre-existing gait abnormalities, such as from neurologic or musculoskeletal impairment, and cognitive impairment. Older patients with osteoporosis have lower density bones, so even a sudden, awkward turn may fracture a bone. When you are treating a patient who has fallen, you need to obtain a careful history. Although the patient often may attribute the fall to an accidental cause, "I must have tripped over the rug," Meticulous questioning often reveals a period of dizziness or palpitations just before the fall, suggesting a different cause. Home safety assessments by paramedics, during a routine visit or as part of an outreach program, may reduce fall incidents. After falls, motor vehicle collisions are the second leading cause of accidental death among older adults. An older patient is far more likely than a younger patient to be fatally injured in a motor vehicle crash. Impaired vision, errors in judgment, and underlying medical conditions contribute to the higher risk. Impairments in vision and hearing, along with diminished agility, also contribute to pedestrian deaths involving older adults. Types of injuries commonly seen in geriatric people. Changes associated with normal aging and with diseases of aging make older adults particularly vulnerable to certain types of injuries. In particular, head trauma or injury is a serious problem. The increased fragility of cerebral blood vessels, enlargement of the subdural space, and a decrease in the supportive tissue of the meninges all contribute to make an older adult more vulnerable than a younger person to intracranial bleeding, particularly subdural hematoma. In many cases, the hematoma develops slowly, over days or weeks. By the time the patient becomes symptomatic, the person or his or her caregivers may not remember the initial incident, or the family or caregivers may feel guilty about their own negligence in the incident. As a result, it may be difficult to obtain an accurate history of the initial trauma. The most important early symptom of a subdural hematoma is headache that may be worse at night. Sometimes the headache occurs on the same side of the head as the blood clot. With increasing intracranial pressure, the state of consciousness becomes depressed and the patient becomes increasingly drowsy. Older adults are also more vulnerable than their younger counterparts to cervical spinal cord injury and cord compression, even after apparently minor trauma. Degenerative changes in the cervical spine, cervical spondylosis, cause arthritic spurs and narrowing of the vertebral canal. The nerve roots exiting from the cervical spine gradually become compressed, and pressure on the spinal cord increases. Any injury to the cervical spine, therefore, is much more likely to injure the already compromised spinal cord. Even a sudden movement of the neck may result in spinal cord injury. Injuries to the chest in older adults are much more likely to produce rib fracture and flail chest, owing to the brittleness of the ribs, and overall stiffening of the chest wall as the costochondral cartilage becomes calcified. Abdominal trauma often produces liver injury, perhaps because the liver is less protected by abdominal musculature. Orthopedic injuries are a common result of falls in geriatric patients, with hip fractures the most common acute orthopedic injury, followed, in severity and frequency, by fractures of the femur, pelvis, tibia, and upper extremities. Hip fracture may also occur without trauma, simply because of vigorous contracture of the hip musculature. The most important risk factor for hip fracture is osteoporosis. Approximately 1/2 of older women, and 1 of 8 older men will have an osteoporosis-related fracture, hip or other. An estimated 1.4 million Canadians have osteoporosis. 1 in 4 women and 1 in 8 men older than 50 years are affected. Treatment of osteoporosis costs the Canadian healthcare system approximately $2.3 billion per year, representing approximately 1.3% of Canada's healthcare expenditures. Burns are a significant risk of morbidity and mortality in older adults because of physiologic and pathophysiologic changes related to aging. The risk of mortality increases when the patient has 1 or more pre-existing medical conditions, defense mechanisms to protect against infection are weakened, and fluid replacement is complicated by renal compromise. In the assessment of a burn patient, you need to monitor the patient's hydration status by assessing current vital signs, mucous membranes, and urine output, which is typically 50 to 60 milliliters per hour or 0.5 to 1 milliliter per kilogram per hour. Assessment of geriatric patients. Although illness is common among older adults, it is not an inevitable part of aging. All complaints made by older adults cannot be ascribed simply to getting old. Aging is a continuous process, and a normal development sequence that affects people in multiple ways. The normal wear and tear concept and genetic makeup are 2 theories that have been suggested to explain the biologic effects of aging. Along the same lines, there is a widespread misconception that older adults tend to be hypochondriacs, with many imaginary or minor complaints. In reality, hypochondria is far less common among older patients than among younger patients. Indeed, older patients tend not to complain, even when they have legitimate symptoms. When an older adult calls for an ambulance, he or she usually has a real problem. Knowing what is and what is not part of the aging process constitutes the first challenge in assessing geriatric patients. A second challenge is that signs and symptoms of disease may present differently in this population than in younger patients as a consequence of the aging process. A myocardial infarction may present without chest pain, fever may be minimal in pneumonia, and uncontrolled diabetes may present as hyperglycemic hyperosmolar syndrome or hyperosmolar non-ketotic coma rather than as ketoacidosis. A variety of acute illnesses, from heart failure to an acute abdomen, may present simply as delirium. Another challenge relates to the fact that the older the patient, the more likely there are to be multiple problems, medical, psychological, and social. Debilitating health conditions often found in this population include hypertension, arthritic symptoms, heart disease, cancer, diabetes, stroke, and chronic obstructive pulmonary disease. The co-occurrence of multiple pathologic conditions has several consequences for patients and healthcare providers alike. The symptoms of one disease or disability may alter or hide the symptoms of another condition. The patient with severe leg pain from arthritis, for example, may not pay much attention to new pain caused by thrombophlebitis. In addition, when several organ systems are in borderline condition, a disturbance in function in only one of the systems may have repercussions throughout the body, leading to failure of multiple organs in a domino-like manner. The presence of multiple underlying illnesses also makes it much more difficult for health professionals to sort out which problem is causing which symptom. Furthermore, chronic comorbidities may make it much more difficult to treat the patient's acute problem. For example, the medication a patient needs for a cardiac problem may be contraindicated because of a renal or hepatic problem or, at the least, may require major modification in the dosage. The GEMS Diamond. There are many acronyms in the pre-hospital setting to help you remember steps in your assessment and treatment processes. The GEMS Diamond was created to help paramedics recall key themes when caring for geriatric patients. It was designed to assist the pre-hospital professional in the assessment and treatment of geriatric patients. G of the GEMS Diamond is to recognize that the patient is a geriatric patient. Your thought process needs to be geared to the possible problems of an aging patient. When responding to an emergency involving an older patient, you should consider that older patients are different from younger patients and may present atypically. E of the GEMS Diamond stands for an environmental assessment. Assessment of the environment can help give clues to the patient's condition or the cause of the emergency. Is the home too hot or cold? Is the home well kept and secure? Are there hazardous conditions? Preventive care is also very important for a geriatric patient, who may not carefully study the environment or may not realize where risks exist. M of the GEMS Diamond stands for medical assessment. Older patients tend to have a variety of medical problems, and may be taking numerous prescription, over-the-counter, and herbal medications. Obtaining a thorough history is very important in older patients. S stands for social assessment. Older people may have less of a social network, because of the death of a spouse, family members, or friends. Older people may also need assistance with activities of daily living, such as dressing and eating. Numerous social agencies are readily available to help geriatric patients, and these agencies can share with you and your patients a listing of the services they provide. The GEMS Diamond provides a concise way for you to remember the important issues for older patients. Using this concept will help you make appropriate referrals, and as a result, you'll help older patients maintain their quality of life. Scene assessment and initial assessment. As you move from scene assessment to the initial assessment of a patient, gather information that may prove relevant to the case. Look for potential clues from the patient's general living conditions, availability of social and family support, activity level, medications, overall appearance with respect to nutrition, general health, cleanliness, and personal hygiene, and attitude and mental well-being. You also need to be aware of the numerous factors that affect the assessment process in geriatric patients, sensory alterations, verbal communication skills, and mental and physical capabilities. You need to be able to accommodate and comprehend these conditions. Patient history. Explain everything you plan to do, especially if the patient seems confused. Part of your task in the assessment is to determine whether this confused state is normal, a new manifestation of a pre-existing medical problem, or a result of the patient's lack of understanding. A comprehensive patient history includes many elements: the patient's chief complaint, present illness or injury, pertinent medical history, and current healthcare status and needs. Keep in mind that pertinent past medical history would include current cardiovascular health, such as palpitations or flutters, exercise tolerance, diet history, medications, smoking and drinking habits, sleep patterns, and other intrinsic and extrinsic factors. Communication. The ability to elicit a thorough patient history reflects education and experience. Good communication skills will help you gather the information you need during your assessment. Without good communication skills, you could frighten, alienate, insult, anger, or even harm your patients. Your first words should focus on gaining the patient's trust. Introduce yourself. Use respect when addressing the patient. Use his or her name, if you know it, and do not use terms such as honey or dear or grandpa when addressing an older patient unless the patient asks to be called by that phrase. Communication is not just talking, it involves active listening. When you are asking questions of older patients, wait for their answers. Active listening also involves paying attention to the patient's tone, especially if it conveys fear or confusion. Nonverbal communication is just as important as verbal communication. Eye contact, hand gestures, body position, facial expressions, and touch communicate a message. When you are speaking with patients, position yourself so that you are face-to-face with them and make sure there is plenty of light. Have patients put in hearing aids or wear glasses to facilitate better communication, and be sure to take these aids with the patients to the hospital so other healthcare providers can communicate with these patients using the devices. Chief complaint. Obtaining the chief complaint would seem to be a straightforward procedure, but it may not be simple with some geriatric patients. Older patients tend not to report significant symptoms for several reasons. Many share the misconception that illness and assorted aches and pains are simply part of aging. Others may not mention even legitimate symptoms to avoid being identified as old and a hypochondriac. Some older patients fear that mentioning a symptom will lead to a diagnosis or treatment that will jeopardize their independence. If I mention those pains in my stomach, the person may reason, they'll put me in the hospital, and I may never come out of that place again. Geriatric patients may underreport serious symptoms, and the symptoms they do report may sound trivial. Furthermore, geriatric patients are likely to have several chief complaints, each of which may have a different source. When a patient's chief complaint seems trivial, it may be necessary to go through a standard list of screening questions to confirm that you are not missing important pieces of information. In such a review of systems, the questions are designed to evaluate the functions of the body's major organ systems. In the pre-hospital setting, there is not sufficient time to conduct a complete review of systems, but a few well-chosen questions can provide a great deal of information about the function of the patient's more important systems. Cardiovascular. Have you had any pain or discomfort in your chest? When? Have you had any pain in your left arm or jaw? Have you noticed any fluttering in your chest or fast heartbeats? Respiratory. Do you ever get short of breath? When? Have you had a cough lately? Is it painful and, if productive, what color? What position have you been sleeping in? Recall that patients with heart failure may find themselves sleeping in an upright position in bed, with pillows behind their back, or in a reclining chair. Neurologic. Can you explain the reason for calling 911? Have you had any dizzy spells? Have you fainted? Have you had any trouble speaking? Have you had headaches recently? Have you noticed any unusual weakness or odd sensations in your arms or legs? Gastrointestinal. Have there been any changes in your appetite lately? Have you gained or lost any weight? Have there been any changes in your bowel movements? Have you had any nausea or vomiting? Genitourinary. Do you have any pain or difficulty urinating? Have you noticed any change in the color of your urine? Have you noticed any changes in the frequency of urination? If any of these screening questions yields a positive answer, follow up with further questions. For example, if the patient states that he has been coughing lately, find out whether the patient is bringing up sputum and, if so, what the sputum looks like. For example, is there blood in the sputum? Once you have elicited what you believe to be the chief complaint, go through the usual process of assembling the history of the present illness. This history may be complicated if other chronic problems are affecting the acute problem. To sort out which symptoms relate to the current chief complaint, and which are chronic difficulties, try asking questions such as how does this problem differ from what it was like last week, or what happened today to make you decide to get help. Obtaining a history from a geriatric patient requires patience. You must be prepared to listen, often for an extended period. But your listening will be rewarded, not only by helping you discover the patient's problem, but also by allowing you to provide part of the solution to the problem. Listening is a demonstration of caring, and your caring can mean a great deal to a lonely or frightened older person. Other medical history. Just as it is not practical to go through a comprehensive review of systems in the pre-hospital setting, it is not usually feasible to obtain a complete medical history in the pre-hospital setting. Nevertheless, you should obtain a sample history to inquire about recent hospitalizations and allergies. Most important, you should obtain the most detailed history possible of the patient's medications because medications account for a significant percentage of medical problems in older adults. A medication history should include all medications, not just prescription medications, because many people do not think to mention common over-the-counter preparations such as aspirin, antacid tablets, and herbal medicines. Ask the patient to list the medications by name, and determine the dosing and frequency for each one. Also, inquire about medications that are prescribed but not taken, for example, because of cost issues or side effects, and medications that may have been provided by other sources, for example, a spouse's medication. Obtain the patient's permission to take medications to the hospital, and then collect them all, prescription and non-prescription medications. If the patient cannot tell you where the medicines are stored, check the bathroom medicine cabinet, the bedside table, the kitchen table and counters, and the refrigerator. Physical examination. During the physical examination of an older adult patient, you may have to adjust your usual examination methods. Because a geriatric patient may tire more easily and may not be cooperative, keep manipulation of the patient to a minimum. In addition, older people are more susceptible to hypothermia, so be sure to keep the patient warm and maintain body temperature. Inspection and palpation can be hampered by multiple layers of clothing, so remove only the clothing that is necessary to perform an accurate examination. Be sure to cover the patient when you are finished. Begin by observing the patient's general appearance, including dress and grooming. In some cases, inattention to appearance may be one of the first signs of depression or a serious medical condition. Evaluate the level of consciousness as you would for any patient. In a critically ill or injured patient, use the AFPU scale: alert, voice, pain, unresponsive. If you have more time, try to perform a more detailed assessment of the patient's cognitive function. Is the patient fully alert? Is he or she oriented to place and time? Does the patient's affect seem appropriate to the situation? Are there obvious disorders in thinking, such as delusions, false beliefs? Attempt to confirm the patient's level of consciousness with a family member and/or caregiver that the patient's presentation is normal for that patient. Note the patient's position and degree of distress. Check the color, moisture, and temperature of the skin, bearing in mind that the loss of elasticity in the skin of geriatric patients may produce apparent signs of dehydration, such as tenting, when hydration is normal. If you are examining the patient in his or her home, take a good look at the patient's surroundings, as well as at the patient. Try to assess the patient's self-care capability. Is everything neat and well maintained? Or is the home a mess, with dishes piled in the sink, and rubbish accumulating? Is there food in the refrigerator? Are there burn marks on the patient's clothes or furniture? Do you see evidence of alcohol consumption, such as empty bottles? Are there signs of violence, such as broken glassware, that might provide clues to elder maltreatment? Are the patient's quarters adequately heated or cooled? Is the patient living alone? Does the patient have pets? If so, you should make arrangements for someone, such as a neighbor, to assume their care until the patient returns. Record these observations on the patient care report to enable social service personnel to make appropriate arrangements for follow-up care. Measure the patient's vital signs carefully. Postural changes in blood pressure vary among older adults, but changes increase with increasing frailty and heighten the person's risk for falls. Marked postural changes in blood pressure and pulse rate may indicate hypovolemia or overmedication. As you obtain the vital signs, bear in mind that blood pressure tends to be higher in older adults. Thus, an older patient who has a blood pressure in the normal adult range could actually be hypotensive. If possible, determine the patient's baseline blood pressure. When you are obtaining a patient's blood pressure, be aware of the possibility of significant hypertension and orthostatic changes. Consider obtaining vital signs in both arms, and checking pulses proximally and distally in all extremities. This process will allow you to gather information and observe for signs of dependent edema, dehydration, and the patient's circulatory status without raising his or her anxiety level. Pay close attention to the respiratory rate. Tachypnea can be a very sensitive indicator of acute illness in older people, especially pulmonary infection, even when patients show few, if any, other signs. When you are assessing the patient's respirations, listen to lung sounds in all fields, noting adventitious sounds that might aid in development of a treatment plan. You can also use the stethoscope to listen for carotid bruits, note jugular vein distension. Detailed physical examination. When you are examining the mouth, make a note of any upper or lower dentures. In the chest examination, keep in mind that older adults may have pulmonary crackles without apparent pathology, so do not immediately consider starting continuous positive airway pressure at the first crackle you hear in the chest. Similarly, edema in the legs may be the result of chronic venous insufficiency, and not right-side heart failure. Assessment and management of medical complaints in older adults. Cardiovascular complaints. Pre-hospital treatment for chest pain remains essentially unchanged in geriatric patients, albeit with extra cautions being warranted because of the increased potential for adverse medication effects in this population. As in all pre-hospital emergencies, you must prioritize management of the patient's airway, breathing, and circulatory status. Nitroglycerine and morphine may produce more hypotension or respiratory compromise in older patients than in younger patients, or may cause geriatric patients to react adversely owing to their other long-term medications. Aspirin may increase bleeding in patients who are already taking anticoagulants. The presentation of heart failure in an older person can be masked by symptoms and signs symbolic of old age, and shared by a number of chronic diseases, for example, dyspnea on exertion, easy fatigability, especially with left-side heart failure, confusion, crackles on lung examination, orthopnea, dry cough progressing to productive cough, and dependent peripheral edema in right-side heart failure. Acute exacerbations of heart failure are often related to poor diet, for example, high salt content leading to increased blood pressure, and increased afterload, which increases left-side heart failure, medication noncompliance, onset of dysrhythmia such as atrial fibrillation, or acute myocardial ischemia. Pre-hospital treatment is unchanged from that of younger patients, although greater consideration is given to becoming familiar with the patient's medications and their implications for your proposed treatment. End-tidal carbon dioxide should be evaluated immediately and monitored throughout the transport to observe for trends. Additional treatments by paramedics should include close monitoring of fluids and avoidance of excessive fluid overload, consideration of the use of continuous positive airway pressure, and potential use of diltiazem, cardizem, in patients with atrial fibrillation or atrial flutter. Non-perfusing rhythms receive the same treatment as given to younger adults. Survival depends on the pre-arrest health of the patient, and the usual factors: early recognition, prompt and effective cardiopulmonary resuscitation, and early defibrillation. Thoracic aortic aneurysms generally remain asymptomatic until they become large or rupture. Early symptoms may be related to compression by the aneurysm, such as difficulty swallowing or hoarseness from laryngeal nerve pressure. Abdominal aortic aneurysms present typically with abdominal pain or possibly only with back pain. Asymptomatic thoracic and abdominal aortic aneurysms that do not exceed a certain size and are not expanding are generally treated without surgery, but are reassessed on a regular schedule. In an older patient with back pain, examine the chest and abdomen carefully. The treatment of abdominal emergencies is surgical, so early recognition, assessment, stabilization, and rapid transport to an appropriate medical facility are essential. The usual treatments for systolic hypertension usually prove safe and effective in geriatric patients. In case of rapid onset of symptomatic systolic hypertension, treatment aims to reduce the systolic pressure with antihypertensive therapy, which can minimize cardiovascular and cerebrovascular morbidity and mortality. Respiratory complaints. Older patients with pneumonia often do not have the classic presentation of chills, fever, and productive cough, particularly if they take non-steroidal anti-inflammatory medications regularly for joint pain or another comorbidity. Instead, these symptoms are often supplanted by acute confusion, delirium, normal temperature, and a minimal to absent cough. Pre-hospital treatment is primarily supportive, consisting of placing the patient in a position of comfort that allows for the best possible ventilation, plus giving fluids, oxygen therapy via a nasal cannula or mask to relieve dyspnea, and analgesics to reduce fever. The receiving facility will determine whether antibiotics are necessary. Asthma clinical practice guidelines are the same for younger and older patients. On rare occasions, inhaled or intramuscular epinephrine may be indicated for a life-threatening asthma exacerbation. In a patient of any age, treatment goals for chronic obstructive pulmonary disease are to reduce the symptoms and complications. Along with shortness of breath, presenting symptoms may include fatigue and a decreased activity level. Treatment consists of immediate assessment and correction of respiratory difficulties with the application of supplemental oxygen. Patients with chronic obstructive pulmonary disease frequently use inhaled beta-adrenergic agents and inhaled or oral corticosteroids. Many pulmonary emboli are silent or present with tachypnea alone, that is, the classic triad of dyspnea, chest pain, and hemoptysis is often altered or absent. If you suspect a pulmonary embolus, check for swelling, erythema, and warmth or tenderness of the lower leg. All of these are signs of a deep vein thrombosis. If deep vein thrombosis might be present, handle the leg gently and monitor the patient for respiratory changes. Pre-hospital treatment is largely supportive after ensuring that airway and ventilation are adequate. Lysing the thrombus and use of anticoagulation therapies may be considered after a risk assessment is performed, with these measures being followed by rapid transport. Gastrointestinal complaints. Many causes are possible for gastric complaints. Constipation and its accompanying abdominal pain, for example, are some of the more common complaints of geriatric patients. In your assessment of a gastric emergency, ask the patient about food and fluid intake, history of abdominal complaints, current bowel and bladder habits, and medications and supplements before proceeding with a physical examination. Symptoms are often vague and manifest only as diffuse abdominal pain with no particular point of origin. Abdominal and gastric complaints often require surgical treatment, so early recognition and rapid transport for definitive hospital care are the best practice. Upper gastrointestinal hemorrhage occurs in conjunction with bleeding from the esophagus, stomach, or duodenum. When severe, this condition is a true medical emergency that must be recognized and assessed quickly. Not only are older people more susceptible to upper gastrointestinal bleeding, they are also in need of urgent surgery, and at a greater risk of complications and death from this cause. It is not possible to determine the cause of upper gastrointestinal bleeding without an endoscopic examination, inspection of the inside of a hollow organ or body cavity, of the esophagus, stomach, and duodenum. However, obtaining a thorough history can provide clues to the cause. Regular use of nonsteroidal anti-inflammatory medications or alcohol may result in bleeding from irritation of the lining of the stomach or from ulcers, a hollowing out or disintegration of tissue in the stomach or duodenum. Forceful vomiting can cause tears in the esophagus that may bleed. Cirrhosis of the liver from long-term alcohol use or chronic infectious hepatitis may cause enlargement of the veins, varices, in the esophagus. These varices can subsequently rupture and result in massive bleeding. Stomach cancer or esophageal cancer can also produce upper gastrointestinal bleeding. Recent weight loss or difficulty swallowing would raise the suspicion of cancer as the source of bleeding. On arrival at the scene, even more important than knowing the cause of bleeding is being able to assess its severity. Slower bleeding is characterized by emesis with coffee grounds appearance. With minor bleeding, the pulse rate and systolic blood pressure are normal. Brisk bleeding presents with hematemesis, vomiting red blood, or melena, black, tar-like stools. Note that melena, not pain, is the most common presenting symptom of upper gastrointestinal bleeding. Pre-hospital treatment is supportive, including adequate pain control. Treat for shock. Severe upper gastrointestinal bleeding requires immediate transportation to the nearest emergency department. Lower gastrointestinal hemorrhage primarily describes bleeding from the colon and rectum and should never simply be attributed to hemorrhoids. Colon polyps and colon cancer are also possible causes, among others. Minor lower gastrointestinal bleeding is characterized by small amounts of red blood covering formed brown stools or scant amounts of red blood noticed on the toilet paper. Severe lower gastrointestinal bleeding is characterized by passing significant amounts of red blood or maroon-colored stools. Assessment should begin with identifying risk factors such as a history of previous lower gastrointestinal bleeding, symptoms or signs suggestive of colon cancer, recent constipation or diarrhea, and use of medications such as blood thinners. Treat the patient for shock. As with severe upper gastrointestinal bleeding, severe lower gastrointestinal bleeding also requires immediate transportation to the nearest emergency department. Neurologic and endocrine complaints. Effective pre-hospital acute stroke care includes early recognition, discovery of conditions that mimic stroke such as hypoglycemia or hypoxia, and timely transport to the most appropriate facility. Use a stroke assessment tool as appropriate, taking the patient's history into account when assessing the components of the scale. An older person with severe arthritis may not move as well on one side, or damage from a previous stroke may make his or her speech difficult to assess. Always ask family or caregivers for information that may help you identify deviations from the patient's normal pattern of behavior or activity. Assess for new weakness, fatigue, syncope, and near syncope, and for changes in these symptoms, and in mood and sleep patterns. Signs and symptoms of dementia take months to years to become apparent and may include short-term memory loss or shortened attention span, jargon aphasia, talking nonsense, hallucinations, confusion, disorientation, difficulty in learning and retaining new information, and personality changes such as social withdrawal or inappropriate behavior. Dementia is not synonymous with delirium, however, and a patient with dementia can also have delirium. In delirium, assess for recent changes in the patient's level of consciousness or orientation. Specifically, look for an acute onset of anxiety, an inability to think logically or maintain attention, and an inability to focus. Also assess for changes in vital signs, temperature, indicating infection, glucose level, and medications, all frequent causes of delirium. Use the mnemonic deliriums to identify other causes of delirium. D. Drugs or toxins, including intoxication or withdrawal. E. Emotional, psychiatric, or electrolyte imbalance. LOPAO2, carbon monoxide poisoning, chronic obstructive pulmonary disease, heart failure, acute myocardial infarction, pneumonia. I. Infection, pneumonia, urinary tract infection, sepsis. R. Retention of stool or urine. I. Ictal state, seizures. U. Undernutrition, including vitamin deficiencies, or underhydration. M. Metabolism, thyroid or endocrine, electrolytes, kidneys. S. Subdural hematoma. Altered mental status is a symptom, not a disease. As a consequence, the assessment and subsequent management of its numerous causes is complicated. Always consider head injury, medical or traumatic, heart rhythm disturbances, dementia, medications, fluid balance changes, such as blood loss, respiratory disorders, such as hypoxia, endocrine changes, such as blood glucose level fluctuations, hyperthermia or hypothermia, and infection. Most important, paramedics need to consider neurologic causes, such as Alzheimer's disease and Parkinson's disease, and endocrine changes, such as diabetes. In Alzheimer's disease, symptoms may present as confusion, lack of familiarity with surroundings, changes in personality or judgment, and extreme difficulty with daily activities, such as feeding, bathing, and bowel and bladder control. Parkinson's disease may present as dyskinesia, involuntary movements or tremors affecting one or both sides of the body, dementia, depression, autonomic dysfunction, bladder and gastrointestinal problems, and postural instability, loss of reflexes or inability to right oneself. Many endocrine changes may have occurred earlier in life, and been diagnosed before intervention by paramedics became necessary. Geriatric patients may have diseases such as Graves' disease, hyperthyroidism, Addison disease, hypoadrenalism, Cushing syndrome, hyperadrenalism, osteoporosis, or diabetes. In the assessment of geriatric patients with diagnosed diabetes, look for signs of dehydration or hyperglycemia, and the 3 Ps, polyuria, polydipsia, and polyphagia. New-onset diabetes in geriatric patients is often a mild progression that produces no symptoms. Toxicologic complaints. The most common therapeutic error in cases of reported poison exposure is inadvertently took or given medication twice or double dosing. In essence, medications are poisons with beneficial side effects. This definition emphasizes the need for obtaining a careful history, and collecting and transporting all medications with the patient. As mentioned earlier, many older adults take a variety of medications. Patients may be taking medications prescribed by more than one physician, each dispensing prescriptions without knowledge of the other's orders. Patients may also take over-the-counter medications or medications prescribed for a family member or friend. Another factor contributing to the toxic effects of medications in older adults is aging-related alterations in pharmacokinetics, that is, the absorption, distribution, metabolism, and excretion of medication. Pharmacokinetics may also be influenced by diet, smoking, alcohol consumption, and use of other drugs. Medications such as digoxin that depend on the liver and kidneys for metabolism and excretion are particularly likely to accumulate to toxic levels in older patients. With most medications, we know little about the optimal dosage for older adults because nearly all clinical trials to establish the safe dosages of medications are performed in young populations. For the most part, however, dosages for geriatric patients need to be reduced compared with those for younger patients. Start low, go slow. Although almost any medication can produce toxic effects in an older person, certain medications and classes of medications are implicated more often than others. Table 45-4 lists the dirty dozen. Typically, toxic effects present with psychiatric symptoms, such as hallucinations, paranoia, delusions, agitation, and psychosis, and cognitive impairment, such as delirium, confusion, disorientation, amnesia, stupor, and coma. Sepsis. Infections in older people can be severe and dangerous. Sepsis occurs when the patient develops an infection, which may be caused by bacteria, fungi, or viruses, and microorganisms or their toxic product enter the bloodstream. This disease state is a serious problem that every paramedic should know how to recognize and treat. Think of sepsis whenever you see a hot, flushed patient who is also tachycardic and tachypneic. Other signs of sepsis include an oral temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, a respiratory rate of more than 20 breaths per minute or PaCO2 less than 32 millimeters of mercury, and pulse rate of greater than 90 beats per minute. Skin complaints. Herpes zoster, shingles, is caused by the reactivation of varicella virus on nerve roots. This condition is more common in the older population, especially if they had chickenpox during the early years of life. Most people with herpes zoster are in good health, but people with cancer or immunosuppression are at higher risk of reactivation of varicella. This condition affects any nerve in the body, but the thoracic nerves and the ophthalmic division of the trigeminal nerve are the most common targets. The disease usually starts with pain in the affected area. Subsequently, a cluster of tiny blisters, vesicles, erupts on reddened skin in the same area. The rash is typically unilateral, it rarely crosses the midline. One of the most common complications of herpes zoster is pain, or postherpetic neuralgia. During the acute phase of the infection, the person may have severe pain and require narcotic pain relievers. Antiviral medications such as acyclovir and valacyclovir can be used, preferably within 48 hours of the activation of the disease. These medications decrease healing time, new lesion formation, and pain. Cellulitis is an acute inflammation in the skin caused by a bacterial infection. This condition usually affects the lower extremities. Symptoms include fever, chills, and general malaise. Cellulitis can cause warmth, swelling, redness, tenderness, and enlarged nodes in the affected area. Blood tests may show elevation of the white blood cell count and the presence of bacteria. Treatments include antibiotic therapy, ensuring adequate fluid intake, and local dressings if there is an open wound. Psychological complaints. Depression can be a normal, short-term reaction to a particular event. When sadness, restlessness, fatigue, and hopelessness persist for weeks, however, it becomes a larger concern. Depression in the geriatric population is a major health problem, with an incidence growing in tandem with the progressive aging of the population. This trend can be attributed to increases in polypathology, psychosocial stress, and age-related changes in the brain that collectively lead to greater cognitive impairment, increased medical illness, dependency on healthcare services, and more suicide attempts. Depression may also occur when a patient takes a variety of medications. Such polypharmacy is more likely when the person has multiple medical conditions that result in more vulnerability to toxic effects. When you are responding to psychological emergencies with geriatric patients, paramedics need to determine whether the situation is a true behavioral emergency or behavioral crisis. A behavioral emergency implies a significant risk of serious harm to self or others unless intervention is undertaken immediately. Examples include serious suicidal states, potential violence, and impaired judgment that could leave a person at risk of injury or death. In a behavioral crisis, the patient's ability to cope is insufficient and he or she becomes overwhelmed, sending the patient in search of alternative methods of coping. When the situation to which you are responding involves a patient with mental illness or a psychotic episode, always remember that a person who is psychotic is out of touch with reality. Many forms of psychotic behavior are possible, including schizophrenic and paranoid behaviors. All symptoms associated with psychotic conditions may not be present when a patient is having an episode, however. Clues to psychotic behavior might include the patient becoming excited or angry for no apparent reason, engaging in antisocial activity or being a loner, and sleeping during the day, and staying awake at night. You should consider underlying medical conditions as possible causes of altered behavior. Information about changes in the patient's normal routine may be obtained from family, friends, or caregivers. Management of medical emergencies in older adults. The assessment and management of medical emergencies in geriatric patients can be complex. If you are well prepared to deal with these complex situations, you'll not feel quite so overwhelmed and helpless. In every emergency, you should first complete a scene size up to confirm the scene safety, determine the nature of the call, identify the number of potential patients, and ascertain the need for additional resources. Next, you should perform an initial assessment, which consists of several quick, yet complex, observations. First, formulate a general impression based on the patient's mental status, and the status of his or her airway, breathing, and circulatory systems. Then, determine transportation priorities. With the exception of patients who require immediate interventions to maintain a patent airway, adequate and supportive breathing, or circulatory status, most pre-hospital care is supportive and focuses on pain relief and palliative interventions. Additional steps in the patient treatment plan will depend on the patient's specific medical emergency and chief complaint. Table 45-5 reviews common medical complications encountered with geriatric patients and their management strategies. Assessment and management of trauma in geriatric patients. Begin the assessment by looking at the mechanism of injury. Falls account for the largest number of injuries in the geriatric population, followed by injuries related to motor vehicles, including passenger and pedestrian trauma, and then burns and other injuries. Always look for signs or symptoms that the patient may have experienced a medical problem before the trauma. A syncopal event while driving, for example, may result in a collision. The initial management of an injured geriatric patient follows the basic ABC pattern of trauma care with some special concerns. When you are securing the airway, check for dentures. If they are intact and in place, leave them where they are. If the dentures are broken or loose in the mouth, remove them and place them in a safe container. Aggressive suctioning of blood or secretions is required because of the older patient's lessened airway and gag reflexes. When you are assessing breathing, check for rib fracture. If assisted ventilation is required, use a bag mask device gently, exerting just enough pressure to inflate the lungs so as to lessen the chance of creating a pneumothorax. Administer supplemental oxygen early to assist the patient's body in compensating for early states of trauma. When you are evaluating circulation, remember that what is a normal blood pressure in a younger person may mean hypotension in an older person. If possible, try to determine the patient's normal baseline blood pressure and circulatory status. The assessment of disability, neurologic status, should include an evaluation of the pupils and the level of consciousness, according to the AFPU scale. Finally, be sure to expose the entire injured area, even if it means peeling away many layers of clothing. Once the initial assessment is complete, try to obtain a complete history of the trauma event from the patient and from anyone who may have witnessed the event. If the patient fell, from what height? Did the patient have any symptoms beforehand, such as dizziness? If the patient was struck by a car, how fast was the car moving? If the patient was the driver of a car involved in a collision, did he or she feel dizzy or blackout beforehand? Did the patient have chest pain? Did witnesses notice the car moving erratically before it collided? Obtain a complete list of all medications the patient takes regularly. Inquire in particular about beta blockers, antihypertensives, and medications for diabetes because they may affect the patient's response to resuscitation measures and to anesthesia. Conduct the focused physical examination as usual, particularly attention to signs of injuries to the head, cervical spine, ribs, abdomen, and long bones. Pain from fractures or peripheral injury may be difficult to assess if the patient has decreased pain perception. Additional treatment will depend on the patient's specific injuries, although there are a few general principles to keep in mind. Use caution when inserting intravenous catheters and administering isotonic solutions. It is very easy to overload an older person with sodium, and you must balance that risk with the need to maintain adequate perfusion pressure. Use small boluses and reassess the patient frequently, especially for signs of pulmonary edema. Monitor cardiac rhythm throughout pre-hospital care of the patient, and be alert for changes. Previous or continuing cardiac disease predisposes a person to electrocardiogram changes. Take steps to preserve temperature in geriatric trauma patients. Regulation of temperature is slowed in older adults, and the blood in cold patients does not clot as well. Frail geriatric patients may not do well with a traction splint for a femoral fracture. If possible, place the patient on a well-padded backboard, and buttress him or her well with pillows secured firmly in place. Consider the use of pain medication. Remember that geriatric patients require a lower dosage of pain medications to reach therapeutic levels. Immobilize the cervical spine before transporting the patient. Pad the backboard generously, because the skin of an older person may be damaged by the direct trauma of the pressure and the decrease in blood flow. Target areas where the bone is near the surface, from top to bottom: occiput, scapula, spinous processes, elbows, sacrum, and heels. A pressure ulcer can develop in as little as 45 minutes, and can complicate the original injury. Elder maltreatment. One category of geriatric trauma that deserves special mention is elder maltreatment, that is, any form of mistreatment that results in harm or loss to an older person. 5 types of maltreatment are distinguished: physical, sexual, emotional, neglect, and financial. The first 4 are similar to the forms found in child maltreatment. Financial maltreatment involves improper use of an older person's funds, property, or assets, The average victim of elder maltreatment is 80 years old, is female, and has multiple chronic conditions. These conditions make patients unable to function on their own, leaving them dependent on others for at least part of their care. The abuser is almost always known to the victim, and is often a family member, such as adult children or a spouse. Although elder abuse does occur in long-term care facilities, it is more likely to occur at the patient's home or the home of a caregiver. One clue to elder maltreatment is unexplained injuries that do not fit the stated cause. Assessment of elder maltreatment must include not only the physical examination, but also the environmental and social clues. Look at the patient's overall hygiene, and review how he or she interacts with caregivers. Take adequate time to listen patiently to any concerns expressed by older patients about their care, or lack of it. If the patient's condition is stable but the situation is unsafe, see if the patient will accept transportation to the hospital. If the patient refuses transport, see if he or she will accept help from the local adult protective services. In some cases, patients may be hesitant to go with paramedics because of fear of caregiver retaliation. If the situation is immediately unsafe, notify law enforcement personnel, and remain with the patient only if the scene remains safe to do so. Across Canada, different laws apply in different types of maltreatment situations. 4 main types of laws help to protect older adults from maltreatment and neglect. Nevertheless, most elder maltreatment cases are never reported. In Canada, certain categories of maltreatment are crimes under the Criminal Code of Canada, and some types of maltreatment are also offences under provincial jurisdiction. You should become familiar with the legislation that applies to your area. However, regardless of the legislation, if you have any reason to suspect elder maltreatment in a given case of geriatric injury, for example, if you found evidence of gross patient neglect in the patient's residence, carefully document your observations and report your findings and suspicions to the receiving facility. For more information on this topic, see Chapter 46. End-of-life care. You'll inevitably be involved with end-of-life care for many patients. Do not resuscitate does not mean do not respond to the needs of a terminal patient. There is much you can do for patients at the end of life, such as demonstrating a caring and concerned attitude and approach. Many of your visits may result in a decision not to transport, but they are valuable to the patient. Many communities have a local hospice, an organization that provides terminal care for patients and support for their families. If one exists in your community, consider how you or your service might collaborate on providing quality care for a person at the end of life. Chapter 43. Neonatology. Introduction. The care of a newborn or neonate must be tailored to meet the unique needs of this population. A newborn refers to an infant within the first day after birth. A neonate refers to an infant within the first month after birth. Even a healthy neonate is completely dependent on others for nourishment, warmth, and protection from the environment. Most parents recognize this need, and instinctively wish to fulfill the role of nurturer and caregiver. When a neonate needs special support that necessitates intervention by trained healthcare providers, the parents may feel isolated and inadequate. It is important for you to support the needs of both the neonate and the parents or other caregivers by allowing them to be physically close as much as possible, explaining what is being done, and providing details of the plan for transport to the next level of care. This chapter reviews the physiologic changes that occur in a newborn during birth, the pre-hospital care that should be provided during and immediately after birth, and the special needs of premature births or births complicated by other factors. It also reviews the steps involved in neonatal resuscitation and outlines the process of transporting an infant to a hospital or between hospitals. General pathophysiology and assessment. Skilled care intervention is needed for approximately 6% to 10% of newborn deliveries, with the rate of complications increasing as the newborn's birth weight and gestational age decrease. An infant delivered at less than 37 completed weeks of gestation is considered preterm. An infant born at 37 to 42 weeks of gestation is described as term, and an infant born at more than 42 weeks of gestation is described as post-term, or post-dates. Infants are also described as small for gestational age when the birth weight is less than the 3rd percentile for gestational age, or large for gestational age if the birth weight is greater than the 97th percentile for the gestation. All others are appropriate for gestational age. Approximately 80% of babies born each year weighing less than 1,500 grams require resuscitation. Table 43-1 and Table 43-2 outline risk factors for complications before and during birth. Because both short and long-term outcomes in newborns have been linked to initial stabilization efforts, it is imperative that you anticipate problems with newborns, are knowledgeable about how to deal with them, have the appropriate resuscitation equipment readily available, and carefully consider the newborn's ultimate transport to the appropriate destination. Transition from fetus to newborn. In utero, that is, in the pregnant woman's womb, a fetus receives its oxygen from the placenta. The fetal lung is collapsed and filled with fluid, receiving only 10% of the total blood supply. As the fetus is delivered, a rapid series of events needs to occur to enable the newborn to breathe. This process is called fetal transition. During fetal transition, the umbilical cord is clamped, thereby removing the low-resistance placenta and increasing the systemic circulation pressure. As the newborn begins to breathe, the lungs expand with air, and pulmonary vascular resistance drops. Blood flows to the lungs for gas exchange, and the fetal circulation switches to a functional adult circulation. This is characterized by the functional, then permanent, closure of the ductus venosus, the ductus arteriosus, and the foramen ovale, the three shunts that have allowed blood to bypass the fetus's lungs and use the placenta as the organ of gas exchange. Anything that delays this decline in pulmonary pressure can lead to delayed transition, with hypoxia, possible brain damage, and potentially death. Arrival of the newborn. Use any time available before the infant arrives to take a patient history, and prepare the environment and equipment that may be necessary. Key questions you need to ask when you are at a scene involving a pregnant woman or a recent home birth include the woman's age, if she has had prenatal care, length of the pregnancy, preferably expressed in weeks, the time of onset and frequency of contractions, the presence or absence of fetal movement, whether membranes have ruptured, including the timing, and the makeup of the fluid, clear, meconium stained, or bloody, whether there have been any pregnancy complications, for example, diabetes, hypertension, ultrasonographically diagnosed fetal anomalies, if there are multiple fetuses, and any medications being taken. All of these questions will help you determine whether resuscitation is needed, and what equipment may be needed. Even if a piece of equipment is in a sealed sterile wrap, having it near at hand will expedite its use once the infant is delivered. At a minimum, you'll need warm, dry blankets, a bulb syringe, 2 small clamps or ties, and a pair of clean scissors to cut the umbilical cord. Table 43-4 lists additional equipment that may be needed if more extensive resuscitation becomes necessary. If the newborn is delivered in the ambulance, the foot of the mother's bed, covered with clean, warm blankets, can be used for the initial stabilization steps. The newborn can then be placed on mother's chest after you confirm adequate patency of the airway, breathing, and pulse rate. If more extensive resuscitation is needed, the foot of the mother's bed can be used, optimally transitioning to a second ambulance equipped with a neonatal transport incubator to allow maintenance of a thermoneutral environment and observation of the newborn's color, respirations, and muscle tone. If the umbilical cord comes out ahead of the newborn, which is more common with polyhydramnios, a condition characterized by extraamniotic fluid, or breech presentation, the blood supply through the umbilical cord to the fetus may be cut off. In this case, relieving pressure on the cord can be life-saving. This is done by having the woman assume a knee-to-chest, or Trendelenburg position. Then, using 2 gloved fingers inserted into the vagina, elevate the presenting part of the fetus off the cord, and maintain this position until obstetric help is available. Finally, cover the exposed cord with a moist sterile dressing. After delivery, keep the newborn at the level of the mother, with the head slightly lower than the body, to facilitate drainage of secretions. Clamp the umbilical cord in 2 places, and cut between the clamps. Suctioning of the oropharynx was once routine, but is now reserved for babies who have an obvious obstruction to spontaneous breathing or required positive pressure ventilation. Dry the infant well to limit body temperature loss through convection, then wrap the newborn in warm blankets or place the newborn directly on the mother's bare skin, and cover with blankets to maintain the newborn's temperature via conduction from the mother. For very preterm infants younger than 32 weeks gestational age, plastic wrap may be used to wrap the newborn's body prior to drying. A hat should always be applied as soon as possible due to large heat loss via the scalp. Thermal mattresses under and over the newborn may also help maintain temperature. To avoid hyperthermia and hypothermia, the newborn's core body temperature should be kept between 36 degrees Celsius and 38 degrees Celsius. Your initial rapid assessment of the newborn may be done simultaneously with any treatment interventions. Note the time of delivery, and monitor the airway, breathing, and circulation. In particular, assess respiratory rate, respiratory effort, pulse rate, and pulse oximetry measures on the right upper extremity. Oxygen saturations greater than 90% are typically not reached until 6 to 7 minutes after birth, and room air or 30% oxygen should be used to resuscitate the newborn if it is required. Nearly 90% of newborns are vigorous, full-term infants. All newborns are cyanotic immediately after birth, but quickly become centrally pink. The hands and feet will remain peripherally cyanosed with poor capillary refill typically for hours after delivery, so assessment of circulation should be done centrally, preferably over the sternum. If the newborn remains vigorous and begins to become pink in the first 5 minutes of life, ongoing observation and continued thermoregulation with direct skin-to-skin contact with the mother should be maintained while en route to a local hospital. Bonding with the mother should be encouraged in a stable newborn. The Apgar score. The Apgar score, named after Dr. Virginia Apgar, who developed this measure in 1953, helps determine the need for and the effectiveness of resuscitation. The Apgar score is determined on the basis of the newborn's condition at 1 and 5 minutes after birth. Normal newborns have Apgar scores ranging from 7 to 9 at 1 and 5 minutes, respectively. If the 5-minute Apgar score is less than 7, reassess the newborn's condition, and assign an additional score every 5 minutes until 20 minutes after birth. If resuscitation is necessary, complete the Apgar score by determining the result of the resuscitation. Need for resuscitation. If a problem arises, it is important for you to follow current neonatal resuscitation guidelines to optimize the outcome. Assess the newborn's respiratory rate, respiratory effort, pulse rate, and color. Count the respiratory rate and pulse rate for 6 seconds, and then multiply by 10 to quickly determine the rate per minute. The pulse rate can be determined preferably by auscultation or by feeling the base of the umbilical cord at the newborn's abdomen, as the umbilical artery should still have pulsatile flow. Be sure to communicate the heart rate to other members of your resuscitation team. Many newborns become centrally pink but have blue hands and feet, acrocyanosis. This is considered normal. If the newborn has a normal breathing pattern, and a pulse rate of greater than 100 beats per minute but maintains central cyanosis of the trunk or mucous membranes, provide supplemental free-flow oxygen as well as stimulation. If there is no other warming source available, keep the newborn on the mother's chest, and continue to manage the airway. If the newborn is apneic, that is, has a 20-second or longer respiratory pause, or has a pulse rate less than 100 beats per minute after 30 seconds of drying and stimulation, begin positive pressure ventilation by bag mask device, being sure to use a newborn-sized bag mask. Use caution when squeezing the bag to avoid inadvertently delivering too much volume, potentially resulting in a pneumothorax. The size of breath provided should result in a physiologic chest rise. It is preferable to have a manometer attached to the bagging circuit to reduce the risk of barotraumas. An inspiratory pressure of 25 to 33 centimeters of water is often needed to move the chest of a term newborn. After 30 seconds of adequate ventilation by positive pressure ventilation with 100% oxygen via a bag mask device, if the infant's pulse rate is less than 60 beats per minute, begin chest compressions. Effective chest compressions should result in palpable femoral and brachial pulses. Fewer than 1% of deliveries involve bradycardia that requires treatment with chest compressions. The most common etiology for bradycardia in a neonate is hypoxia, which is readily reversed by effective positive pressure ventilation. Profound hypoxia or shock is also the cause of cardiac arrest, which is almost always a secondary event in these small patients. If ventilation and chest compressions do not improve the bradycardia, administer epinephrine via the intravenous route, preferably an umbilical venous line. The drug may also be given via tracheal intubation, but requires tenfold dosing to be effective. Infants who have required active resuscitation for 20 minutes or longer rarely have positive long-term outcomes. If a spontaneous heartbeat has not been established after 10 minutes, you should consider stopping resuscitation. If spontaneous breathing has not been established after 20 minutes of resuscitation, the outcomes are likely very poor. You should seek further advice regarding discontinuation of life support. However, newborns are very resilient, and most respond readily to interventions. Specific intervention and resuscitation steps. Drying and stimulation. After you ensure the patency of the airway by bulb suctioning the newborn's mouth and nose, dry and stimulate the newborn. Position the newborn on his or her back or side, with the neck in the sniffing position. If the airway is not clear, suction using a bulb syringe or suction catheter, with the head turned to the side. Remember to suction the mouth before the nose to prevent aspiration. Finally, flick the soles of the newborn's feet, and gently rub the newborn's back. Avoid rubbing too roughly or slapping the newborn because these actions may lead to traumatic injury. Airway management. Free flow oxygen. If a newborn is cyanotic or pale, provide supplemental oxygen. Given that 50 grams per liter of deoxygenated hemoglobin is needed before clinical cyanosis becomes apparent, a severely anemic hypoxic infant will be pale, but not cyanotic. Therefore, provide oxygen to a pale newborn until an accurate oxygen saturation reading can be obtained using a pulse oximeter. Warm and humidify the oxygen if it will be provided for more than a few minutes. If positive pressure ventilation is not indicated, that is, the pulse rate is greater than 100 beats per minute, and the newborn has adequate respiratory effort, oxygen can initially be delivered through an oxygen mask or via oxygen tubing within a hand that is cupped and held close to the newborn's nose and mouth. For babies at term, the administration of oxygen should be regulated by blending oxygen and air, and the amount delivered guided by pulse oximetry monitored from the right upper arm. Hyperoxia can be toxic to newborns, particularly the preterm baby. Thus, oxygen saturation levels from 92% to 94% are considered optimal. The oxygen flow rate should be set at 5 liters per minute. Do not blow oxygen directly into the newborn's eyes. Some newborns will saturate 100% on room air, typically several hours after birth when all fetal shuts have closed. Oral airways. Oral airways are rarely used for neonates, but they can be life-saving if airway obstruction leads to respiratory failure. Bilateral choanal atresia, bony or membranous obstruction of the back of the nose preventing airflow, can be rapidly fatal, but usually responds to placement of an oral airway, or a gloved finger to maintain an open mouth until an adequate oral airway is located. The Pierre-Robin sequence is a series of developmental anomalies including a small chin, a cleft palate, and posteriorly positioned tongue that frequently leads to airway obstruction. Positioning the patient prone, chest down, may relieve the obstruction. If not, insert an oral airway. As with infants and small children, use a tongue blade to depress the tongue and insert the oral airway without rotating it. A nasopharyngeal airway may be an alternative to an oral airway for this latter group of infants with a small recessed chin, and may be more easily tolerated. Bag mask ventilation. Bag mask ventilation is indicated when a newborn is apneic, has inadequate respiratory effort, or has a pulse rate of less than 100 beats per minute, bradycardia. After you clear the airway of secretions, relieve obstruction from the tongue, and dry and stimulate the newborn. Signs of respiratory distress that suggest a need for ventilation support include periodic breathing, intercostal retractions, sucking in between the ribs, nasal flaring, and grunting on expiration. Respiratory distress occurs in approximately 8 of every 1,000 live births and accounts for approximately 15% of neonatal deaths. Table 43-6 summarizes the most common conditions leading to respiratory distress. 3 devices may be used to deliver bag mask ventilation to a neonate. 1. You may use a self-inflating bag with an oxygen reservoir. An oxygen source is not necessary to provide positive pressure ventilation, but is necessary to provide supplementary oxygen. 2. You may use a flow inflating bag, though it needs a gas source to provide positive pressure ventilation. This technique is therefore more common in the operating room. 3. You may apply a T-piece resuscitator, also needs a gas source, mostly found in neonatal intensive care units or delivery suites. In the pre-hospital setting, you'll most likely use a self-inflating bag for bag mask ventilation. If available, always use the infant size, 240 milliliters. Given that the breath size, tidal volume, of a neonate is only 5 to 8 milliliters per kilogram, less than 1/10 of the bag's volume will be used for each breath, which explains why a larger bag can easily create problems. If a neonatal bag is not available and the newborn is in severe respiratory distress, has apnea, or has bradycardia, you can use a bag designed for adults or older children, 750 milliliters or greater volume, as long as you carefully keep the delivered breath size appropriately small and monitor chest rise to avoid excessive volumes of delivered breaths. When available, a manometer connected in circuit will help to reduce the risk of barotraumas by keeping a close eye on inflating pressures. A disposable T-piece resuscitator is available for use in pre-hospital care, and may be preferable to the self-inflating bag due to having built-in pressure gauge. When you are administering bag mask ventilation, with or without oxygen, the face mask needs to provide an airtight seal, fitting over the newborn's mouth and nose, and extending down to the chin but not over the eyes. Pressure on the eyes, like deep suctioning, can lead to a vagal response and bradycardia. The newborn needs to have a patent airway, cleared of secretions, with his or her neck slightly extended in the sniffing position. Because of the large occiput in neonates, placing a folded towel under the infant's shoulders will help to create the position where the airway will be most patent. The first few breaths after birth will frequently require higher pressures, possibly around 30 centimeters of water, because the lungs are not yet expanded and are still full of fluid. To deliver these initial breaths, you may need to manually disable, cover with your finger, the spring-loaded pop-off valve. It is usually set by the manufacturer at 30 to 40 centimeters of water. Subsequent breaths should be delivered with sufficient pressure to result in visible but not excessive chest rise. Ensure that the positive and expiratory pressure valve is set to 5 to 6 centimeters to maintain lung recruitment between breaths. In a newborn, it is important to provide the correct timing for ventilation, which is 40 to 60 breaths per minute, because breaths delivered at a higher rate can lead to hypocapnia, air trapping, or pneumothorax. To help with the timing, count breath 2-3, breath 2-3 as you ventilate. Give a breath on breath, and release on 2-3. Continue positive pressure ventilation as long as the pulse rate remains less than 100 beats per minute or the newborn's respiratory effort is ineffective. If prolonged positive pressure ventilation is needed, greater than 1 minute, ensure the system is hooked to a pressure manometer to aid in monitoring and minimizing excessive pressures. Target peak inspiratory pressure less than 25 centimeters of water in full-term newborns, less than 20 centimeters of water in preterm infants. The most common reasons for ineffective bag mask ventilation are inadequate seal of the mask on the face and incorrect head position. Other causes, such as copious secretions, mucus plug, pneumothorax, or equipment malfunction, need to be considered as well. Intubation. Bag mask ventilation provides successful resuscitation of most newborns. Intubation, however, may be necessary if the newborn requires resuscitation beyond simple interventions. The shaded area within Figure 43-3 outlines the steps pertaining to management of the distressed newborn. Intubation is indicated in the following situations. Meconium-stained amniotic fluid is present and the newborn is not vigorous, indicating in utero hypoxia or stress, that is, poor muscle tone, bradycardia, inadequate ventilation, no respiratory effort, a condition for which tracheal suctioning is indicated. Note that routine tracheal suction is no longer recommended for a depressed newborn delivered through meconium-stained amniotic fluid. Congenital diaphragmatic hernia, a congenital defect in which abdominal organs herniate through an opening in the diaphragm into the chest cavity, is known or suspected, and respiratory support is indicated. The newborn does not respond to bag mask ventilation and chest compressions, necessitating tracheal administration of epinephrine, that is, No intraosseous site has been established. Prolonged positive pressure ventilation is needed, and hospital setting is more than 30 minutes away. Before you begin ventilation, make sure that you have the following equipment available. Suction equipment, 10F tubing, with 5F to 8F being available, suction set to 100 centimeters of water. Laryngoscope, check the light to ensure that the bulb is bright and screwed in tightly. Straight blades, usually size 1 for full-term newborns, size 0 for preterm newborns. Shoulder roll. Adhesive tape, to tape the tracheal tube. Tracheal tubes. 2.5 to 3.5 millimeters, 2.5 millimeters if the newborn is delivered before 28 weeks of gestation, 3.0 millimeters if delivered before 28 to 36 weeks of gestation, 3.5 millimeters if delivered at greater than 36 weeks of gestation. Some paramedics use a stylet to provide rigidity to the tracheal tube. In such a case, you must secure the stylet, bending it over at the top of the tracheal tube so it cannot advance, and make sure that it does not extend beyond the tracheal tube, or tracheal perforation may occur. Intubation of the neonate is discussed in Skill Drill 43-1. Skill Drill 43-1. Intubating a newborn. Step 1. Pre-oxygenate the newborn by bag mask ventilation with supplemental oxygen prior to making an intubation attempt, unless congenital diaphragmatic hernia is suspected, where bag mask ventilation is contraindicated, or the infant requires emergency intubation for bradycardia that is not responsive to bag mask ventilation. Oxygen saturation should be 90% to 95%. Step 2. Suction the oropharynx if there is an obvious obstruction to spontaneous breathing or requires positive pressure ventilation. This can be a vagal stimulus, so pay close attention to pulse rate, and avoid repeated or vigorous suctioning. Provide bag mask ventilation if bradycardia results. Step 3. Place the laryngoscope blade in the oropharynx. Visualize the vocal cords. Avoid applying torque to the blade because it increases the risk of trauma. Place the tracheal tube between the vocal cords until the black line on the tube is at the level of the cords. For full-term infants, the tracheal tube is usually advanced until it is at 9 centimeters at the lip. For a premature newborn, you may need to advance the tracheal tube to only 6.5 to 7 centimeters at the lip. Limit the intubation attempt to 20 seconds, and initiate bag mask ventilation if it is unsuccessful or if significant bradycardia, less than 80 beats per minute, develops. Step 4. Confirm tracheal tube placement. Observe chest rise, auscultate laterally in the epigastric region, and high on the chest. Note mist in the tracheal tube, seen when the patient exhales through the tube from condensation of humidified air leaving the lungs. Note equal breath sounds on both sides, and observe for clinical improvement. Note that an end-tidal carbon dioxide detector color change and capnograph waveform are the gold standards to confirm correct tracheal tube placement. Step 5. Secure the tracheal tube in place on the face to minimize the risk of the tube dislodging. Monitor the newborn closely for complications such as tube dislodgement, tube occlusion by mucus plug or meconium, or pneumothorax. This is the end of Skill Drill 43-1. Complications of tracheal tube placement include mucosal trauma causing bleeding, oropharyngeal or tracheal perforation, esophageal intubation with subsequent persistent hypoxia, and right main stem intubation that can lead to atelectasis, persistent hypoxia, and pneumothorax. You can minimize these risks by ensuring optimal placement of the laryngoscope blade, and carefully noting how far the tracheal tube is advanced. Once positive pressure ventilation or supplemental oxygen administration begins, you should reassess the patient by evaluating heart rate, respiratory rate, and oxygenation. Oxygenation is best determined by a pulse oximeter rather than simple assessment of color, because color is too subjective. Gastric decompression. Gastric decompression using an orgastric tube is indicated when you are providing prolonged bag mask ventilation, greater than 5 to 10 minutes, if abdominal distension is impeding ventilation, and in the presence of diaphragmatic hernia. Many diaphragmatic hernias are diagnosed prenatally by routine ultrasonography, postnatally, They are suspected clinically if there are decreased breath sounds. 80% to 90% of diaphragmatic hernias are on the left, a scaphoid or concave abdomen. Many of the abdominal contents are in the chest, and increased work of breathing. Skill drill 43-2 shows gastric decompression in neonate. Skill drill 43-2. Inserting an orgastric tube in the newborn. Step 1. Measure for correct depth. Use an HF feeding tube and measure the length from the bottom of the earlobe to the tip of the nose to halfway between the xiphoid process, lower tip of sternum, and the umbilicus. Step 2. Insert the tube through the mouth to the appropriate depth. Leave the nose open to allow for ventilation. Step 3. Attach a 20-gauge syringe and suction the stomach contents. Tape the tube to the newborn's cheek. Remove the syringe from the feeding tube, leaving open to free drainage, to allow venting of air from the stomach. Intermittently suction the feeding tube. This is the end of skill drill 43-2. Circulation. Chest compressions. Chest compressions are indicated if the pulse rate remains less than 60 beats per minute despite positioning, clearing the airway, drying and stimulation, and 30 seconds of effective positive pressure ventilation. 2 people are needed to deliver effective chest compressions while continuing ventilation. 2 different techniques are used. With the thumb, to rescuer technique, 2 thumbs are placed side by side between the xiphoid and an imaginary line drawn between the 2 nipples, and the hands encircle the torso. This is the preferred and recommended technique when possible. With the 2-finger, 1 rescuer technique, the tips of the index and middle fingers are placed over the lower third of the sternum, and the sternum is compressed by the fingers. The depth of compression is 1/3 of the anteroposterior diameter of the chest. Your thumbs or fingers should remain in contact with the chest at all times. In neonates, the chest compressions occur in synchrony with artificial ventilation, which you continue during chest compressions. There is no interruption in chest compressions at any time. The person delivering the chest compression counts out loud, with downward strokes of chest compressions delivered while saying 1 and 2 and 3. Release of the strokes should occur while saying and. The person ventilating delivers a breath during the sequence breath and. The goal is to deliver 100 to 120 compressions per minute, with a compression to ventilation ratio of 30 to 2 for single rescuer and 15 to 2 for multiple rescuers. Pulse rate is assessed at 60-second intervals, and once the pulse rate rises above 100 beats per minute, gradually slow the rate, and decrease the pressure of positive pressure ventilation. Liver laceration and rib fractures are possible risks of delivering chest compressions. Refer to Appendix A for details regarding infant cardiopulmonary resuscitation. Vascular access. Emergent access becomes necessary when fluid administration is needed to support circulation, and when resuscitation medications, for example, epinephrine, and therapeutic drugs, for example, intravenous dextrose, antibiotics, must be administered intravenously. However, establishing peripheral access in newborn can prove difficult. The umbilical vein can be catheterized using a low umbilical vein line in newborn using the following steps. 1. Clean the umbilical cord with alcohol or another antiseptic. Drape the area with sterile towels, keeping the umbilical stump exposed. Place a sterile tie firmly, but not too tightly, around the base of the cord to control bleeding. Although the line must be placed quickly in a code situation, maintain sterile technique as much as possible. 2. Attach a 3 ml syringe and a stopcock to a sterile 3.5F or 5F umbilical vein line catheter. A comparable size sterile feeding tube can be used in an emergency, and pre-fill the catheter with normal saline. 3. Cut the cord with a scalpel between the clamp placed on the cord and the cord tie, keeping the scalpel approximately 1 to 2 centimeters from the skin before cutting. 4. The umbilical vein is a large, thin-walled vessel usually found at the 12 o'clock position, as compared to the 2 thick-walled smaller umbilical arteries usually found at 4 and 8 o'clock. Insert the catheter into this vein for a distance of 4 centimeters, less in preterm infants, until blood can be aspirated. If the catheter is advanced into the liver, the infusion of hypertonic solutions may lead to irreversible damage. If the catheter is advanced into the heart, dysrhythmias may develop. 5. Flush the catheter with 2.0 milliliters of normal saline and tape it in place. In a newborn who weighs more than 3 kilograms, it may be preferable to place an intraosseous line. In a neonate more than a few days old, place a peripheral intravenous or intraosseous line. Placement of an intraosseous line is discussed in Chapter 8. While the technique for placing an intraosseous line is similar to that used with older children or adults, a smaller needle should be used in newborns to avoid exiting the far side of the bone. Pharmacologic interventions. Medications are rarely needed in neonatal resuscitation because most newborns can be resuscitated with effective ventilatory support. Medications in newborns are based on weight, so you may need to estimate the newborn's weight for dosing. A full-term newborn usually weighs 3 to 4 kilograms. A newborn born at 28 weeks of gestation, on average, weighs 1 kilogram. Epinephrine. Administration of epinephrine is indicated when the infant has a pulse rate of less than 60 beats per minute after 30 seconds of effective ventilation and 30 seconds of chest compressions. The recommended concentration for newborns is 1 to 10,000. The recommended dose is 0.1 to 0.3 milliliters per kilogram of 1 to 10,000 epinephrine intravenously, equal to 0.01 to 0.03 milligrams per kilogram, administered rapidly, followed by a 0.5 to 1 milliliter normal saline flush to clear the line. If intravenous access is not yet established, use the higher dose of 1 milliliter per kilogram of 1 to 10,000 epinephrine given via the tracheal tube. Dosing may be repeated every 3 to 5 minutes in case of persistent bradycardia. Volume replacement. If the infant has significant intravascular volume depletion owing to conditions such as antepartum hemorrhage due to placenta previa or placental abruption or septic shock, fluid resuscitation may be needed. In a newborn, place a low umbilical vein line or an intraosseous line, as outlined earlier. A fluid bolus in an infant consists of 10 milliliters per kilogram of normal saline intravenously given over 5 to 10 minutes. Multiple boluses may be administered if the newborn remains clinically hypovolemic. Signs of hypovolemia include pallor, delayed capillary refill, and weak pulses despite a good pulse rate or high-quality chest compressions. Pallor alone is not an indication for fluid boluses as it may be seen in fetal anemia and asphyxia. Family and transport considerations. Once the infant is stabilized as much as possible in the pre-hospital setting, transport the patient to the nearest facility that can provide the appropriate level of care. This facility will not necessarily be a tertiary hospital. A nearby community hospital, if it is located much closer, may be able to perform additional stabilization procedures for a very ill newborn, such as placing a chest tube for a clinically significant pneumothorax, or obtaining a definitive airway if required. Ideally, someone will contact this facility ahead of your arrival to discuss the situation and obtain advice regarding care and disposition. Sometimes the newborn will require immediate specialized attention, such as care of the extreme premature newborn or surgical intervention or diagnostic workup. Thus you may need to discuss transfer to the most appropriate facility with direct medical control. Throughout the process, ongoing communication with the family regarding what is being done for the newborn and what care is planned will help allay fears. Do not be specific about survival statistics. Many factors play into mortality and morbidity, and you do not want to be misleading. If family members have questions you cannot answer, be straightforward. Tell them that you do not have a definite answer, but you will help put them in touch with the people who do, that is, the center to which the newborn is being transferred. During transport, continuously observe the newborn and perform frequent reassessments to ensure timely intervention should the newborn's status change. Attention to thermoregulation, respiratory effort, patency of airway, skin color, and pulse rate is vital. A measurement of oxygen saturation and blood glucose level estimate are very helpful. If the infant is being transferred between facilities after the initial stabilization, continue to provide close observation and assessment of these factors to facilitate initiation of interventions should the newborn's condition change. The development of new and more sophisticated techniques for the care of newborns, especially premature newborns, together with round-the-clock care by expert medical personnel, has significantly reduced the mortality among high-risk newborns in hospitals where such capabilities are available. Because the average community hospital cannot provide the specially trained doctors and nurses or the expensive equipment needed for such care, it sometimes becomes necessary to transfer the critically ill infant to a regional center, where the newborn may benefit from highly skilled personnel and sophisticated equipment, and where a critical mass of complex patients maintains the necessary skills and competencies for optimal patient care and outcomes. In the well-organized regional referral system, transport of a high-risk newborn is carried out by specialized teams specially trained for this high-risk neonatal population. The process for transfer proceeds through the following several steps. 1. A physician at the referring hospital initiates a request for transport. A physician in the regional referral center mobilizes the transport team and decides which intensive care nursery can accommodate the patient, and gives the referring physician advice on management of the newborn until the specialized transport team arrives. 2. A mode of transportation is chosen: ground transportation, helicopter, or fixed-wing aircraft, depending on the distance, availability of services, and weather conditions. 3. The transport team is mobilized, and equipment is assembled. The ideal team consists of a nurse with special training in neonatal intensive care, a respiratory therapist with similar special training, and/or a paramedic who has spent a period of apprenticeship in a neonatal intensive care unit. For particularly critical patients, a physician may also attend. The equipment is highly specialized, requiring appropriately designed ventilation and oxygenation units and an incubator meeting stringent criteria. 4. On arrival at the referring hospital, the transport team continues to stabilize the newborn before embarking on transport. Conditions such as hypoxemia, acidosis, hypoglycemia, and hypovolemia must be treated before leaving the referring hospital. 5. While stabilizing the newborn, the team collects information and materials including a copy of the mother's and newborn's charts, including blood work results, and any radiographic studies taken of the newborn. A vial of the mother's blood, clotted for group and cross-match if needed, and the placenta for pathologic examination are helpful, if they can be retrieved. Specific conditions. Acidosis. If bradycardia persists after adequate ventilation, chest compressions, and volume expansion, you should suspect metabolic acidosis. While a bolus of normal saline and improved perfusion may help in milder cases of acidosis, sodium bicarbonate may be indicated for profound metabolic acidosis, pH less than 7.0. An initial dose of 2 ml equivalents per kilogram of 4.2% solution, 0.5 mg per milliliter, intravenously may be administered over 5 to 10 minutes. Avoid rapid administration, especially in premature infants, as a rapid change in pH may increase the risk of bleeding into the brain. If you are managing a newborn who is so profoundly ill that you suspect profound metabolic acidosis, and are considering sodium bicarbonate, you should contact direct medical control for further guidance and assistance. Respiratory distress and cyanosis. Prematurity is the single most common cause of respiratory distress and cyanosis in the neonate. These conditions occur more frequently in newborns younger than 30 weeks of gestation or weighing less than 2.5 pounds, 1,200 grams. Women with multiple gestations and pregnancy complications are at increased risk as well. There are many etiologies of respiratory distress and cyanosis in the neonate. Respiratory causes include airway obstruction, aspiration, meconium, amniotic fluid, maternal blood at delivery, gastroesophageal reflux, and foreign body, pneumonia, pneumothorax, tracheoesophageal fistula, congenital diaphragmatic hernia, or immature lungs. Any process that results in a delay in drop of pulmonary vascular resistance after birth, for example, acidosis, stress, and hypoxia, can lead to shunting of blood across the patent ductus arteriosus and patent foramen ovale, resulting in persistent pulmonary hypertension and cyanosis. Central nervous system depression can lead to ineffective respirations and subsequent cyanosis. Septic shock and severe metabolic acidosis often present with increased work of breathing and cyanosis. Cardiac anomalies typically result in cyanosis without increased work of breathing. Remember to address the airway, breathing, and circulation. Ensure the airway is patent, breathing is adequate, and a pulse is present. Assess respiratory rate, respiratory effort, including periodic breathing, intercostal retractions, nasal flaring, grunting, choking, or gagging, and breath sounds. Ask the parents if they have noted increased symptoms with feeding attempts. Is the newborn cyanotic or pale? Remember that a hypoxic newborn that is severely anemic will look pale, not cyanotic. Treatment focuses on establishing a patent airway, suction mouth, nose, and oropharynx as needed, ensuring adequate oxygen delivery by providing supplemental oxygen if needed, establishing effective ventilation, including providing positive pressure ventilation as needed, and ensuring adequate circulation, including chest compressions if bradycardia of less than 60 beats per minute persists once supplemental oxygen and adequate ventilation have been established. Keep in mind that occasionally resuscitative efforts do not result in improvement in cyanosis or bradycardia due to an underlying pneumothorax. In this situation, needle thoracentesis can be a life-saving intervention. Remember to keep the family updated regarding the newborn's condition and what is being done to help him or her, and maintain communication with the receiving hospital for advice, and to allow them to prepare for your arrival. Respiratory depression secondary to narcotic administration. If the mother was a chronic narcotic user, administration of naloxone to the newborn to reverse the narcotic effect may precipitate life-threatening seizures. Naloxone is no longer recommended as a first-line drug in resuscitation of a newborn with an altered level of consciousness. In the case of a newborn with respiratory suppression due to chronic maternal narcotic use, provide the newborn with ventilatory support, and transport immediately. If respiratory depression is the result of mother being treated acutely with narcotics, and there is no chronic maternal narcotic exposure, naloxone may be administered to the newborn via the intravenous, preferred, or intramuscular route at a dose of 0.1 mg per kilogram to reverse the narcotic effect. Pneumothorax decompression. A pneumothorax can occur if an infant inhales meconium at birth, if the lung is weakened by infection, or if positive pressure ventilation is needed. If a newborn has signs of a significant pneumothorax, severe respiratory distress unresponsive to positive pressure ventilation with unilateral decreased breath sounds and shift of heart sounds, a needle decompression of the pneumothorax may be necessary. On the side of the suspected pneumothorax, clean the area around the second intercostal space, mid-clavicular line, usually just above the nipple, with alcohol. Prepare the equipment needed: a 22-gauge butterfly needle attached to extension tubing, a 3-way stopcock, and a 20 ml syringe. Palpate the upper edge of the second rib and insert the needle above that rib as a second provider pulls back on the syringe, which is open to the patient. The nerves and blood vessels run below the ribs, so avoid piercing this area. Continue to slowly advance the needle until air is recovered. The butterfly needle is rigid, so be gentle to avoid further tearing the lung. If the 20 ml syringe becomes filled with air, turn the stopcock off to the newborn, push out the air from the syringe, open the stopcock to the newborn, and continue withdrawing air. Once no more air can be withdrawn, remove the needle. If there is a symptomatic ongoing air leak, you can insert a 22-gram angiocatheter in a similar location, remove the introducer needle, and attach the angiocatheter to the extension tubing. Note that the angiocatheter may further tear the lung during its initial placement, and that it is more likely to kink than the butterfly needle. Remove as much air as possible with the syringe. At this point, the tubing may be taped to the chest and briefly occluded while you place the end of the tubing that had been attached to the syringe in a small bottle of sterile water, and release the tubing occlusion. This can relieve the pressure buildup from the pneumothorax until the patient can be transferred to a facility for placement of a chest tube. During transport, closely monitor the infant for signs of a reaccumulation of the pneumothorax. While performing the pneumothorax decompression, continue your ongoing assessment, use proper positioning to maintain the airway, and avoid aspiration. Take steps to maintain thermoregulation, and ensure adequate communication with the family, and with the medical team receiving the newborn. Transport rapidly, but safely, and keep the infant warm. Meconium-stained amniotic fluid. Meconium-stained amniotic fluid, which is present in 10% to 15% of deliveries, carries a high risk of morbidity. A small percentage of babies delivered in the presence of meconium-stained amniotic fluid may go on to develop meconium aspiration syndrome, which carries a high risk of mortality and morbidity. Passage of meconium may occur either before or during delivery. It is more common in post-term newborns, and in those who are small for their gestational age, weighing less than 10th percentile for their age, and in newborns who are stressed before or during delivery. Newborns do not normally pass stool before birth, but if they do, and then inhale the meconium-stained amniotic fluid, either in utero or at delivery, their airways may become plugged, and hypoxia may ensue. This, in turn, can lead to atelectasis and/or persistent pulmonary hypertension, delayed transition from fetal to neonatal circulation, hypoxemia, pneumonitis, or pneumothorax, which may require needle aspiration. When a newborn is delivered through meconium-stained amniotic fluid, assess the newborn's activity level under a radiant warmer, if available. If the newborn is crying and vigorous, employ standard interventions. For newborns who are depressed, poor muscle tone, bradycardia of less than 100 beats per minute, inadequate ventilation, no respiratory effort, follow the usual guidelines for resuscitation, with positive pressure ventilation and/or chest compressions as required. Routine intubation of the depressed newborn with meconium for tracheal suctioning is no longer a recommended intervention. Follow the standard algorithm for resuscitation as per neonatal resuscitation program guidelines, including bag mask ventilation, recognizing that the newborn is at very high risk of meconium aspiration. If the newborn has prolonged hypoxia, the outcome will likely be poor. When transporting such an infant with respiratory and/or oxygenation failure, stay in communication with a facility skilled at managing high-risk newborns to help with management and identification of an appropriate transport destination. To help support the family, explain what is being done for the newborn but do not discuss chance of survival. Diaphragmatic hernia. Diaphragmatic hernia, that is, an abnormal opening in the diaphragm, most commonly on the left side, has an incidence of 1 in 2,200 live births. This diagnosis is often made on prenatal ultrasonography before birth. Postnatally, the diagnosis is suspected clinically in a newborn with respiratory distress, heart sounds shifted to the right, decreased breath sounds on the left, which can also be signs of a pneumothorax, bowel sounds heard in the chest, and scaphoid abdomen, that is, the abdomen, rather than being round, is sunken because the abdominal contents are in the chest cavity. Mortality may be as high as 50% for this condition, due to the hypoplastic lungs and associated pulmonary hypertension. While current neonatal resuscitation guidelines advocate using room air to initiate resuscitation in full-term newborns, those with suspected or known congenital diaphragmatic hernias should be resuscitated with 100% oxygen if hypoxic. If a newborn has a diaphragmatic hernia, bag mask ventilation will introduce air that distends the intestines in the chest cavity, further compromising the newborn's ability to ventilate. If positive pressure ventilation is needed in such a newborn, place a tracheal tube where possible and monitor peak ventilatory pressure carefully to minimize barotrauma. These newborns have poorly developed lungs and are at high risk of a pneumothorax even at fairly low peak inspiratory pressures. These newborns are also at increased risk of persistent pulmonary hypertension and lung hypoplasia, and may remain hypoxic in spite of supplemental oxygen. Immediately place an orgastric tube, and intermittently suction the newborn to minimize intestinal distension. Monitor the newborn's heart rate continuously throughout transport. Ultimately, a newborn with a diaphragmatic hernia will require surgical correction, so transport the newborn to a facility with a neonatal intensive care unit and a pediatric surgical team. Apnea. Apnea, respiratory pause greater than or equal to 20 seconds, is common in infants delivered before 32 weeks of gestation, but is rarely seen in the first 24 hours after delivery, even in premature newborns. If prolonged, greater than 20 seconds, it can lead to hypoxemia and bradycardia. Risk factors for apnea include prematurity, infection, prolonged or difficult labor and delivery, drug exposure, hypoglycemia, hypothermia, central nervous system abnormalities such as seizures, and metabolic disorders. The pathophysiology of apnea depends on the underlying etiology. Apnea of prematurity is due to an underdeveloped central nervous system, but is rarely seen in the first week of life. Drug-induced apnea frequently results from direct central nervous system depression. Regardless of the cause, a newborn with apnea needs respiratory support to minimize hypoxic brain damage and other organ damage. Attention to thermoregulation and glucose monitoring is important to avoid this side effect. Assessment of an apneic newborn includes a careful history to elicit possible etiologic risk factors, and a physical examination that focuses on neurologic signs and symptoms or signs of infection. At birth it is important to differentiate between primary apnea and secondary apnea. If the newborn has experienced a relatively short period of hypoxia, he or she will have a period of rapid breathing, followed by apnea and bradycardia. At this point, drying and stimulation may suffice to cause a resumption of breathing and improvement in pulse rate. If hypoxia continues during primary apnea, the newborn will gasp and enter secondary apnea. At this point, stimulation alone will not restart the newborn's breathing. Instead, positive pressure ventilation by bag mask device or tracheal intubation is required. Owing to the risk of gastroesophageal reflux or vomiting with aspiration, do not feed a newborn who required respiratory support and/or resuscitation. Additional conditions. Additional conditions that you may encounter, and your treatment response include the following. Choanal atresia. Place an oral airway. Pierre-Robin sequence. Position the infant prone to maintain the airway. Use an oral airway if needed. Cleft lip and/or cleft palate. When treating a newborn with cleft lip and/or cleft palate, airway resuscitation is not always needed, but if it is, you may need to apply cricoid pressure to facilitate intubation. Consider delivering positive pressure ventilation via a bag mask device. You may need to use a little extra positive pressure in the newborn with a cleft palate. Owing to the risk of aspiration and regurgitation, do not feed the newborn with a cleft lip and palate in the pre-hospital environment. Gastroschisis or omphalocele with exposed abdominal contents. These are developmental defects that lead to the intestines and/or other abdominal organs appearing outside the abdomen. In this situation, when providing standard resuscitation, place the newborn from the waist down into a sterile, clear plastic bag to keep the bowel clean and minimize heat or fluid loss. Nurse the infant on his or her side. Monitor the color of the intestines. Pink is good, blue or black is bad, and, if necessary, reposition the newborn so that the blood supply is not cut off due to kinking of the mesenteric blood vessels. Place a peripheral intravenous or intraosseous line in these newborns. Keep the intestines moist, using sterile saline as needed. Premature and low birth weight infants. Newborns delivered before 37 completed weeks of gestation are considered premature. Newborns born weighing less than 2,500 grams are considered low birth weight. The most common etiology for low birth weight is prematurity. While prematurity is often idiopathic, there are maternal conditions associated with preterm labor and delivery. They include genetic factors, infection, cervical incontinence, early opening of cervix, uterine abnormalities, bicornuate uterus, abruption, placenta separation from uterine wall, multiple gestations, for example, twins, triplets, drug use, and trauma. Other factors that may contribute to low birth weight include chronic maternal hypertension, smoking, placental anomalies, and chromosomal abnormalities. If a newborn is delivered prior to 24 weeks of gestation or weighs less than 500 grams, and is born outside a center equipped to manage such deliveries, the newborn is unlikely to survive. The degree of immaturity can be estimated by physical characteristics such as skin appearance, thinner and more translucent in more premature infants. If you observe signs of life, it is advisable to attempt resuscitation and maintain body heat until the newborn can be transported to an appropriate facility. A preterm newborn younger than 28 weeks may be placed directly, without drying, into a plastic bag, exposing only the head, following delivery to minimize heat loss. The head should dry and be covered as soon as possible with a hat, preferably made from wool to minimize heat loss. Resuscitation should continue in the usual way. Approximately 12% of births are preterm, less than 37 weeks of gestation. Morbidity and mortality in this population are, in large part, related to the degree of prematurity. Most preterm newborns delivered after 28 weeks of gestation who receive the necessary cardiorespiratory support after birth survive and do well over the long term. Newborns delivered at 23 to 26 weeks of gestation have a high mortality and morbidity. Approximately 1/3 die, and 1/3 experience significant long-term problems, typically respiratory issues, related to the need for long-term oxygen and ventilation, and neurologic issues, related to bleeding into the brain or insufficient blood supply to the brain parenchyma. Up to 1/2 will have long-term disabilities discovered at school age. If a newborn is delivered prematurely in the pre-hospital setting, providing cardiorespiratory support and a thermoneutral environment will optimize his or her survival and long-term outcome. Thermoregulation can be improved with careful environmental control, for example, warm blankets, plastic wrap, thermal mattresses. Premature newborns are at higher risk for respiratory distress due to surfactant deficiency. The lungs of a premature newborn are immature, so use only the minimum pressure necessary when you are providing positive pressure ventilation and positive end expiratory pressure, which helps to prevent the development of chronic lung disease also known as bronchopulmonary dysplasia. The lungs and other organs are susceptible to oxygen toxicity, so attempt to reduce the amount of inspired oxygen as quickly as possible using an oxygen saturation probe as a guide. Assuming adequate perfusion, and thus accuracy of the probe, maintain saturation levels at 90% to 95%. For very premature newborns, maintaining saturation levels in the region of 92% to 94% preferably throughout their neonatal intensive care unit course promotes a better outcome. Infants are also at risk of retinopathy of prematurity, abnormal vascular development of the retina, which may be worsened by high or long-term oxygen exposure. This may lead to severe visual deficits or blindness. Because hypoxia causes irreparable brain damage, however, do not withhold oxygen from a cyanotic premature newborn. Brain injury can result from hypoxemia, rapid changes in blood pressure, hyperosmolarity leading to intraventricular hemorrhage, or periventricular leukomalacia, with inadequate brain perfusion. These brain insults may cause permanent injury with associated long-term disabilities. Seizures in the neonate. Seizures are the most distinctive sign of neurologic disease in the newborn. A seizure is defined clinically as a paroxysmal alteration in neurologic function, that is, behavioral and/or autonomic function. Seizures are very common in premature newborns, and even term newborns, but are difficult to diagnose as they are most often subtle in nature. The incidence in this population can be as high as 57.5 per 1,000 newborns who weigh less than 1,500 grams at birth, compared with 2.8 per 1,000 newborns who weigh between 2,500 grams and 3,999 grams at birth. Newborns may exhibit normal motor activity that can sometimes be mistaken for seizures. These myoclonic movements, disconjugate eye deviations, or sucking movements are often seen when the newborn is drowsy or asleep. In addition, jitteriness is often confused with a seizure. Jitteriness is characteristically a disorder of newborns, and is rarely seen at a later age. Jitteriness is most commonly seen with hypoxic ischemic encephalopathy, hypocalcemia, hypoglycemia, and drug withdrawal. Careful monitoring and treatment of hypoglycemia may avoid permanent brain injury. Seizures represent a relative medical emergency. They are usually related to a significant underlying abnormality, one that often requires specific therapy. Seizures may also interfere with cardiopulmonary function, feeding, and metabolic function. Finally, prolonged seizures may even cause brain injury. Types of seizures. 4 major types of seizures are distinguished as follows. Subtle seizure. A seizure characterized by eye deviation, blinking, sucking, and pedaling movements of the legs and apnea. Tonic seizure. May be classified as focal or generalized. The persistent posturing of one limb, the neck, or the trunk with horizontal eye deviation is characteristic of a focal tonic seizure. Generalized tonic seizures are more common and typically involve a tonic flexion of the arms with tonic extension of the legs. This type of seizure is more common in premature infants, especially in those with intraventricular hemorrhage. Clonic seizure. May be classified as either a focal seizure if one body part is involved, or a multifocal seizure if multiple body parts are involved. The body parts involved may be contralateral to one another, that is, jerking of the left arm and kicking of the right, for example, due to the immaturity of the newborn's nervous system. Symmetric, bilateral generalized clonic seizures are not typically seen during the neonatal period as the neurons lack sufficient myelination to elicit this type of movement. This type of seizure can occur in both full-term and premature infants and may occur in neonatal stroke or aphasia. Myoclonic seizure. Categorized as focal, multifocal, and generalized. The jerks in myoclonic seizures are much more rapid, less than 50 milliseconds, and do not have a rhythm, in contrast to clonic seizure activity. Focal myoclonic seizure activity often involves flexion of the arms. Multifocal myoclonic seizure activity involves twitching of multiple body parts, asynchronously. Generalized myoclonic seizure activity involves bilateral jerking with flexion of the arms, and occasionally flexion of the legs. These are most commonly seen in the preterm infant. When describing seizures, multifocal refers to clinical activity that involves more than one site, is asynchronous, and is usually migratory. Generalized refers to activity that is bilateral, synchronous, and non-migratory. Causes of seizures. Table 43-8 lists the most common and important causes of neonatal seizures. The time of onset for hypoxic ischemic encephalopathy, birth trauma, neonatal stroke, arterial or venous infarctions, hypoglycemia, and other acute metabolic disturbances is usually within 24 hours of delivery. With all other causes listed including meningitis or encephalitis, seizures may begin within 3 days or longer after birth. Hypoxic ischemic encephalopathy, usually secondary to perinatal asphyxia, lack of oxygen to tissues around time of delivery, is the single most common cause of seizures in both term and preterm infants. Seizures characteristically occur in the first 24 hours, and may become severe progressing to status epilepticus over 2 to 3 days. Metabolic abnormalities include disturbances in the levels of glucose, calcium, magnesium, or electrolytes. Other metabolic disturbances include abnormalities of amino acids, organic acids, blood ammonia, and certain toxins. Hypoglycemia is most frequently seen in infants who are small for their gestational age, those who are large for their gestational age, and those whose mothers were diabetic during pregnancy. Neurologic symptoms consist of jitteriness, stupor, hypotonia, floppy, apnea, poor feeding, and seizures. A blood glucose level of 2.6 millimoles per liter or below is considered a medical emergency, and immediate intervention is required, even in the absence of symptoms, using glucose gel administered orally, nasogastric feeds, or intravenous fluid therapy depending on conditions. Bolus treatment with D10W, 10% dextrose in water, is the standard 2 milliliters per kilogram for rapid correction of the blood glucose level. Hypocalcemia has two major peaks of incidence. The first peak occurs at 2 to 3 days after delivery, and is most commonly seen in low birth weight infants, and in infants of diabetic mothers. Late-onset hypocalcemia is rare but may be seen in infants who consume cow's milk or synthetic formulas high in phosphorus. Other metabolic disturbances are uncommon in neonates, although hyponatremia, hyperammonemia, other amino acid, and organic acid abnormalities, or seizures from drug withdrawal, for example, narcotic analgesics, sedative hypnotics, tricyclic antidepressants, cocaine, or alcohol, may be seen. Rapid treatment of all neonatal seizures is essential in the pre-hospital setting. Assessment and management of seizures. When you evaluate a newborn with seizures, you must include a quick evaluation of prenatal and birth history and a careful physical examination. You may observe a quiet, often hypotonic infant. The newborn may be lethargic or apneic. Hypoglycemia must be recognized quickly and treated promptly. In these cases, blood glucose measurement and administration of dextrose may be life-saving in the pre-hospital environment. Obtain the newborn's baseline vital signs and oxygen saturation readings and provide additional oxygen, assisted ventilation, blood pressure evaluation, and intravenous access as necessary. A D10W solution may be given as an intravenous bolus, 2 milliliters per kilogram, if the newborn's blood glucose level is less than 2.6 millimoles per liter, with a recheck of the blood glucose level in about 30 minutes. Intravenous bolus administration of dextrose often needs to be followed by a D10W infusion at rates of 60 to 80 milliliters per kilogram per day. When an intravenous line cannot be readily established, an intramuscular injection of glucagon is recommended until vascular access is achieved. Glucose gel is an alternative especially for the term newborn. Consult with direct medical control if you are considering giving the newborn anticonvulsant medication. The first-line medication of choice for suspected neonatal seizures is a benzodiazepine, preferably lorazepam, 0.1 mg per kilogram, which may be repeated once. If seizures persist, phenobarbital, 20 mg per kilogram, followed by a repeat dose of phenobarbital, 20 mg per kilogram, if needed, should be given. If seizures persist, phenytoin, 20 mg per kilogram, is then given. Benzodiazepines, such as lorazepam, diazepam, or midazolam may also be administered as continuous intravenous therapy in conditions of status epilepticus. These medications require care and administration, and will likely impair respiratory and cardiac function. If you are managing a newborn who is experiencing a seizure, particularly after administration of a benzodiazepine, contact direct medical control for further guidance and assistance. Monitor the newborn's respiratory status and saturations carefully as apnea is often seen but can usually be managed by positive pressure ventilation. Maintain the newborn's normal body temperature, and keep the family informed about what you are doing for their infant as transport gets underway. Thermoregulation. Thermoregulation is the body's ability to balance heat production and heat loss to maintain normal body temperature. This ability is very limited in the newborn. The average normal temperature of a newborn is 37.5 degrees Celsius. For the neonate, the thermoneutral temperature range is 36.6 degrees Celsius to 37.2 degrees Celsius. Non-shivering thermogenesis, the production of heat by metabolism, is the primary source of heat production in the neonate. Brown fat, deposited in the fetus after 28 weeks of gestation, and principally stored around the scapula, kidneys, adrenal glands, neck, and axilla, is a thermogenic tissue unique to the newborn. Heat loss to the environment occurs through any of the following four mechanisms. In evaporation, heat loss occurs when water evaporates from the skin and respiratory tract. In convection, heat loss occurs to cooler surrounding air. The extent of heat loss depends on the air temperature and air movement. In conduction, heat loss occurs to cooler solid objects in direct contact with the body. In radiation, heat loss occurs to cooler surrounding objects not in direct contact with the body. These can be avoided by keeping environmental temperatures high, 23 degrees Celsius to 26 degrees Celsius, avoiding contact with cold surfaces, and minimizing air drafts or currents. Fever. Fever is defined as a rectal temperature greater than 38 degrees Celsius. Oral and axillary temperatures are, respectively, 0.6 degrees Celsius and 1.1 degrees Celsius lower on average than the rectal temperature. However, in infants younger than 2 years of age, the only reliable measurement is the rectal temperature. A newborn's temperature regulation system is relatively immature, so fever may not always be a presenting feature with infection or illness. In fact, neonates may become hypothermic with infection. No matter what the presenting symptoms are, it is important to identify newborns with serious bacterial infection, for example, bacteremia, urinary tract infection, meningitis, bacterial gastroenteritis, and pneumonia, or serious viral infection, for example, herpes simplex, for which treatment is available. Approximately 13% of infants younger than 28 days with a temperature of more than 38.1 degrees Celsius will have a serious bacterial infection. Fever may also be caused by overheating. Babies can easily become too hot when dressed in many layers of clothing, overbundled in a heated car, or placed in direct sunlight, even through a window, or near heating vents at home. Fever related to dehydration is an important consideration in breastfeeding babies, especially in the first week after birth. These infants have often lost more than 10% of their weight, and may have a history of difficulty in initiating breastfeeding. Newborns have limited ability to control their temperature. They do not sweat to allow cooling when they are hot, and they do not shiver to raise their temperature when they are cold. Term newborns may produce sweat over their brow but not the rest of their body. Premature newborns do not produce sweat. Moreover, many newborns with serious life-threatening infections may actually see their core temperature drop. These newborns are at a higher risk for hypoglycemia and metabolic acidosis. A careful examination will reveal irritability, somnolence, and decreased feeding. The newborn may feel warm to touch. Some newborns with fever, however, may be initially asymptomatic. When fever is suspected, observe the newborn for the presence of rashes, especially petechiae or pinpoint pink or red skin lesions, blisters, or vesicles. Obtain a careful history regarding general activity, feeding, voiding, and stooling. Obtain the newborn's vital signs, and ensure adequate oxygenation and ventilation, providing free-flow supplemental oxygen, if necessary. Perform chest compressions, if indicated. Administration of antipyretic agents such as acetaminophen or ibuprofen is controversial and not recommended in the pre-hospital setting. Never give ibuprofen to an infant. To cool the newborn, remove additional layers of clothing, and improve ventilation in the environment. Hypothermia. Hypothermia is a drop in body temperature to less than 36 degrees Celsius. Hypothermia in the newborn occurs in all climates, but is more common during the winter months. It has been linked to impaired growth, and may make the newborn vulnerable to infections and hypoglycemia. Moderate hypothermia is associated with an increased risk of death in low birth weight newborns. Sick or low birth weight infants admitted to the hospital with hypothermia are more likely to die than those admitted with normal temperature. Infants may die of cold exposure at temperatures adults find comfortable. Table 43-9 lists risk factors for hypothermia. Newborns have increased surface area to volume ratio, making the newborn extremely sensitive to environmental conditions, especially when wet after delivery. An increase in metabolic function in an attempt to overcome the heat loss can cause hypoglycemia, metabolic acidosis, pulmonary hypertension, and hypoxemia. Every hypothermic newborn should also be investigated for infection. Hypothermic neonates are cool to the touch, initially in the extremities. As their temperature drops, however, the skin becomes cool all over. The newborn may also be pale and have acrocyanosis. The hypothermic newborn may present with apnea, bradycardia, cyanosis, irritability, and a weak cry. As a newborn's temperature drops, he or she may become lethargic and obtunded. In severely hypothermic babies, the face and extremities may appear bright red. Sclerema, hardening of the skin associated with reddening and edema, may be seen on the back, limbs, or all over the body. Thermal shock, disseminated intravascular coagulopathy, and death may occur in more serious cases. Preventive measures include warming your hands before touching the newborn. Dry the newborn thoroughly after birth, and remove any wet blankets. Place a cap on the newborn's head, as the head is the largest source of heat loss. Place the newborn skin to skin with the mother, if possible. This keeps the newborn warm, and allows mother and infant to bond. Ensure adequate oxygenation and ventilation. If the infant is hypoglycemic, you may administer D10W. Warm intravenous fluids can assist in rewarming the newborn. Current recommendations for very preterm infants, less than 28 weeks, are to deliver them into a plastic bag or wrap in plastic wrap immediately to prevent heat loss, exposing only their heads, which are dried and covered with a hat. The critically ill newborn, once stabilized, should be placed in a pre-warmed incubator or, if none is available, covered with warm blankets and/or thermal mattress and kept on the mother's chest. At home, skin-to-skin contact is the best method to rewarm a newborn with mild hypothermia. Ideally, the room should be warm, 24 degrees Celsius to 26 degrees Celsius, and the newborn should be covered with a warm blanket, and wear a pre-warmed cap. Continue the rewarming process until the newborn's temperature reaches the normal range or his or her feet are no longer cold. Do not use hot water bottles. They may cause burns because blood circulation is poor in the cold skin of babies. Recent studies of neonates with hypoxic ischemic injury indicate improved outcomes when the infant is provided mild therapeutic hypothermia, 33 degrees Celsius to 34 degrees Celsius, within 6 hours of birth. This approach is not recommended in the pre-hospital setting, although it is prudent to prevent hyperthermia. Maintain the newborn at the lower margin of normal temperature, axillary temperature of no higher than 36.5 degrees Celsius. Hypoglycemia. In full-term or preterm newborns, hypoglycemia is a blood glucose level of less than 2.6 millimoles per liter. This condition represents an imbalance between glucose supply and utilization. Glucose levels may be low due to inadequate intake or storage or increased utilization of glucose. Most infants remain asymptomatic until the glucose falls below 2.2 millimoles per liter for a significant time. Because the brain relies on glucose as its primary fuel, hypoglycemia may result in seizures and severe, permanent brain damage. Table 43-10 lists risk factors for hypoglycemia in the newborn. The fetus receives glucose from the mother and deposits glycogen in the liver, lung, heart, and skeletal muscle in utero. The newborn then begins to utilize those glycogen stores to meet glucose needs after birth. Most full-term newborns will have sufficient glycogen stores to meet their glucose needs for 8 to 12 hours. Disorders related to decreased glycogen stores, small for gestational age, prematurity, post-maturity, or to increased utilization of glucose, infant of a diabetic mother, large for gestational age, hypoxia, hypothermia, sepsis, place the newborn at an increased risk for hypoglycemia. Metabolic adaptations to maintain normal glucose levels are regulated by counter-regulatory hormones such as glucagon, epinephrine, cortisol, and growth hormone. Frequently, stressed newborns will become hypoglycemic. Symptoms of hypoglycemia may include cyanosis, apnea, irritability, poor sucking or feeding, and hypothermia. These symptoms may also be associated with lethargy, tremors, twitching, or seizures, and coma. They may also have tachycardia, tachypnea, or vomiting. In these cases, blood glucose measurement and administration of dextrose may be life-saving in the field. Check the blood glucose level in all sick newborns by heel stick and evaluate the newborn's vital signs. After you establish good oxygenation, ventilation, and circulation, manage the hypoglycemia. Direct medical control personnel may order the administration of D10W as a bolus at 2 ml per kilogram via intravenous access if the newborn's blood glucose level is less than 2.6 millimoles per liter. This intervention may be followed by an intravenous infusion of D10W based on the newborn's gestational age, 60 ml per kilogram per day for a full-term newborn, 80 ml per kilogram per day for premature newborns. As always, maintain normal body temperature. Hypothermia places additional stress on glucose demand. Vomiting. Vomiting is common in newborns. Approximately 85% of infants vomit during the first week of life, and another 10% have vomited by 6 weeks of age. Vomiting ranges from spitting up to severe, bloody or bilious, projectile vomiting. Most episodes of vomiting are benign and do not result in weight loss, dehydration, or other ill effects. Bilious and/or bloody emesis, vomiting, indicates a pathologic condition that needs urgent medical attention. Persistent vomiting is a warning sign for underlying pathology, and can cause excessive loss of fluid, dehydration, and changes in electrolyte levels, that is, sodium, potassium, and glucose. Vomiting mucus, occasionally blood-streaked, in the first few hours of life is not uncommon. Persistent vomiting in the first 24 hours of life suggests obstruction in the upper digestive tract such as esophageal or small intestinal atresia. Vomitus containing blood is often a sign of a life-threatening illness. It indicates bleeding in the gut due to mucosal ulceration or ectopic gastric mucosa and intestinal duplication. Occasionally, swallowed maternal blood from an antepartum hemorrhage will cause blood-stained vomit or melena stools. Maternal blood can be easily recognized by carrying out an APT test, a test for adult hemoglobin. Sometimes bloody or tarry stools are associated with intestinal hemorrhage, and thus should be considered pathologic until proven otherwise. Aspiration of vomitus can cause respiratory insufficiency or obstruction of the airway. Bile-stained vomitus is an ominous sign, and midgut intestinal volvulus, which is an emergency, must be ruled out. Causes of vomiting. A newborn's presenting symptoms may give a clue to the site of obstruction or other problem that is causing the vomiting. One possible cause is esophageal atresia, a failure to develop the distal lumen, which may occur with or without a tracheoesophageal fistula. Its incidence is 1 case per 3,000 to 4,500 births. Newborns have excessive mucus soon after birth, and may choke when attempting to feed, because the swallowed milk is returned promptly. If accompanied by a fistula between the esophagus and trachea, air will rapidly fill the intestines when the infant cries, and this may lead to compromised ventilation due to abdominal distension. This necessitates urgent decompression of the stomach, typically by gastrostomy tube. The fistula also causes gastric contents to enter the lungs, which can cause severe aspiration pneumonitis. The fistula is ligated at the time of the definitive surgery for the esophageal atresia. Another possible cause of vomiting, pathogenic gastroesophageal reflux, is common in infants, with a reported prevalence of 2% to 10%. Gastroesophageal reflux is most commonly seen in infancy, with its incidence peaking in the 1 to 4 month age group. The newborn may vomit either immediately or a few hours after a feeding. The vomiting may not be forceful. In uncomplicated gastroesophageal reflux, the vomitus is not bile-stained or bloody. Gastroesophageal reflux in infants and young children can present as typical or atypical crying and/or irritability, apnea and/or bradycardia, poor appetite, an apparent life-threatening event, vomiting, wheezing, stridor, weight loss or poor growth, failure to thrive, hoarseness, and/or laryngitis. The condition is difficult to treat, and newborns should not be given anything to eat or drink by mouth in the pre-hospital setting. In infantile hypertrophic pyloric stenosis, marked hypertrophy and hyperplasia of the two, circular and longitudinal, muscular layers of the pylorus occur. As a consequence, the pylorus becomes thickened and obstructs the outlet of the stomach. The incidence of infantile hypertrophic pyloric stenosis is 2 to 4 cases per 1,000 live births, with a male-to-female predominance of 4 to 1. 30% of patients with infantile hypertrophic pyloric stenosis are firstborn males. The usual age of presentation is approximately 3 weeks of life, range 1 to 18 weeks. In infantile hypertrophic pyloric stenosis, the stomach muscles contract forcibly to overcome the obstruction. Affected newborns usually present with projectile vomiting, with dehydration, malnutrition, and electrolyte changes being late signs. The vomitus in this case is not bile-stained, but it can be brown or coffee in color due to blood, resulting from gastritis or to a Mallory-Weiss tear at the gastroesophageal junction. Malrotation is a congenital anomaly of rotation of the midgut. In this condition, the small bowel is found predominantly on the right side of the abdomen, the cecum is found in the epigastrium, right hypochondrium. In cases of malrotation, volvulus, or twisting of the gut around its mesentery, causes symptoms of bilious vomiting with or without abdominal distension. The bile-stained vomitus may be feculent, like feces or stool, if the obstruction is distal in the intestines. This is a surgical emergency because the blood supply in the mesenteric vessels may become interrupted and compromise circulation to the gut, leading to ischemia and loss of bowel integrity. Patients may die from perforation, peritonitis, or short gut syndrome when a large amount of the ischemic bowel has been surgically removed. Malrotation is estimated to occur in 1 of every 500 live births. Approximately 40% of patients are diagnosed within the first week of life. 75% are diagnosed by 1 year of age, and the remaining 25% are diagnosed later in life. With symptomatic malrotation, 75% to 90% of cases occur in infants younger than 1 year, 50% to 64% of cases occur in infants younger than 1 month, and 25% to 40% of cases occur in the first week of life. During the first week of life, the ratio of male to female presentation is 2 to 1. early mortality rates ranged from 23% to 33%. Since the advent of corrective surgical procedures, morbidity and mortality have decreased significantly. However, bile stain vomitus is always a red flag, and should be assumed to be due to volvulus with malrotation until proven otherwise. Abdominal ultrasonography and contrast studies must be carried out immediately to diagnose the condition, followed by immediate surgery. This is called a LAD procedure. Another cause of vomiting is meconium plug syndrome, whereby the passage of meconium is delayed. This is often seen in the infant with intrauterine growth restriction, but may also be seen in Hirschsprung disease. The last segment of colon fails to relax due to lack of innervation in the wall of the intestine, and this causes mechanical obstruction. The infant usually has a history of not passing meconium in the first 24 hours of life. Delayed passage of meconium is also associated with microcolons seen in infants of diabetic mothers or in true meconium ileus, a common presentation of cystic fibrosis in the newborn. Vomiting may also happen in conjunction with asphyxia, meningitis, infection of the membranes covering the brain and spine, and hydrocephalus. Large head size is a clue. It is often sudden, unexpected, and forceful in such cases, and it may be accompanied by persistent irritability. Meningitis and hydrocephalus may also be associated with increased intracranial pressure. Use of drugs during pregnancy can lead to several withdrawal symptoms in infants, including vomiting. The drugs that most commonly cause vomiting in newborns are barbiturates. Assessment and management of vomiting. On physical examination, you may note a distended stomach that has been associated with vomiting. Suspect an infection if the neonate has a fever or a history of contact with sick people, a mother who tested positive for group B strep or herpes, or prolonged rupture of membranes, greater than 12 hours, occurs. Initial management steps for a newborn with vomiting start with the airway, breathing, and circulation. Maintain a patent airway. A vomiting infant can aspirate the vomitus and compromise the airway. Keep the newborn's face turned to one side to prevent aspiration. Suction or clear the vomitus from the airway with the help of a suction catheter or suction bulb. Ensure adequate oxygenation, providing either free-flow supplemental oxygen, bag mask ventilation, tracheal intubation as necessary. Bradycardia may be caused by vagal stimulus, and is usually transient. It may resolve with stimulation and free-flow oxygen. Consider inserting a nasogastric or gastric tube to decompress the stomach and reduce emesis or vagal effects of distension. Antiemetics should not be administered in the pre-hospital environment. The newborn may be dehydrated, however, and need fluid resuscitation. Dry mucous membranes, tachycardia, heart rate greater than 160 beats per minute, or a sunken fontanelle are clues that the patient needs hydration. Normal saline, 10 ml per kilogram per bolus, may be required in that case, in addition to a dextrose or saline infusion. Use D10W 0.9 normal saline, or D5W 0.9 normal saline for newborns with obvious signs of shock for intravenous therapy depending on glucose levels. Some newborns may become hyperglycemic with sepsis. On transport, place the newborn on his or her side, identify a facility capable of managing a high-risk newborn, and explain to the family what is being done for the newborn. Diarrhea. A normal number of stools per day for an infant is 5 to 6, especially if the infant is breastfeeding, when infants often stool after every feeding. Diarrhea is an excessive loss of electrolytes and fluid in the stool. It is uncommon in newborns, and usually represents a viral etiology for infection. More serious conditions such as intussusception, malrotation, metabolic syndromes, and intestinal failure need to be ruled out. In neonates, other common causes of diarrhea include lactose or milk protein intolerance, neonatal abstinence syndrome, thyrotoxicosis, and cystic fibrosis. Severe cases of diarrhea can cause dehydration and subsequent electrolyte imbalance. Combinations of physical signs, such as ill general appearance, poor vital signs, capillary refill of greater than 2 seconds, dry mucous membranes, absent tears, weight loss, and low urine output, are good objective predictors of the degree of dehydration. Assessment and management of diarrhea. Assessment includes estimating the number and volume of loose stools, decreased urinary output, and degree of dehydration based on skin turgor, mucous membranes, presence of sunken eyes, and other signs. Patient management, as always, begins with the airway, breathing, and circulation. The newborn's airway and ventilation may be compromised if he or she is severely dehydrated and is obtunded, so ensure adequate oxygenation and ventilation. Perform chest compressions in addition to positive pressure ventilation in newborn if the pulse rate is less than 60 beats per minute. Fluid therapy may be indicated when a newborn has diarrhea. Normal saline, 10 milliliters per kilogram boluses, may be needed immediately to fluid resuscitate the infant, along with maintenance. Common birth injuries in the newborn. Birth trauma includes both avoidable and unavoidable injuries to the infant resulting from mechanical forces, that is, compression, traction, during the delivery process. Such trauma is estimated to occur in 2 to 7 of every 1,000 live births. Most birth injuries are self-limiting and have a favorable outcome. Nearly one-half are potentially avoidable with recognition and anticipation of obstetric risk factors. Birth injuries account for 2% to 3% of all infant deaths, with 5 to 8 of every 100,000 newborns dying of birth trauma and 25 of every 100,000 newborns dying of anoxic injury. Separating the effects of a hypoxic ischemic insult from the effects of a traumatic birth injury may prove difficult. A difficult birth or injury to the infant can occur because of the infant's size or position during labor and delivery. Conditions associated with the difficult birth include premigravida, first pregnancy, cephalopelvic disproportion. The size and shape of the maternal pelvis are not adequate for the vaginal delivery of the infant, or the infant's head is relatively large, prolonged or rapid labor, abnormal presentation, for example, breech or brow, face, large size, birth weight greater than 4,000 grams, prematurity, or low birth weight. Birth trauma includes a variety of injuries. For example, abrasions, lacerations, bruises, and subcutaneous fat necrosis can occur with deliveries that involve instruments, for example, a vacuum or forceps. Molding of the head and overriding parietal bones are part of the normal process of labor, but occasionally excessive molding may be seen. Caput succedaneum is swelling of the soft tissue of the infant's scalp as it presses against the dilating cervix. This type of cutaneous cranial injury is very common. The swelling usually disappears in the first day or two after birth. It is important to distinguish this from a subepineuritic or subgallal hemorrhage, where bleeding occurs under the scalp as a result of shearing forces, especially common in vacuum delivery. The newborn may have a great deal of blood loss into this tissue space, and go into shock. These newborns require neonatal intensive care unit admission, and careful hourly monitoring of head circumference, vital signs, and hemoglobin checks because blood transfusion is often required. A cephalohematoma is an area of bleeding between the parietal bone and its covering periosteum. It often appears several hours after birth as a raised lump on the newborn's head, is limited by the boundaries of the bone, and may take 2 weeks to 3 months to resolve. Babies born by instrumental vaginal delivery are more likely to have a cephalohematoma. Do not try to drain a rapidly expanding scalp hematoma, as this may worsen or prolong the bleeding. When a large amount of blood collects, jaundice may ensue in the week after delivery as the red blood cells break down. Linear skull fractures are occasionally seen with difficult births, spontaneous vaginal deliveries, or deliveries using instruments. Non-displaced fractures can be managed conservatively. Care should be observed to avoid pressure to the involved area. Displaced fractures warrant neurosurgical evaluation. The clavicle is the most frequently fractured bone in the newborn. Such a bone injury is most often unpredictable, unavoidable complication of normal birth. Risk factors may include large size, mid-forceps delivery, and shoulder dystocia, that is, the infant's shoulders get stuck in the birth canal. The infant may present with pseudoparalysis as he or she tries not to move the affected extremity to minimize pain. Examination will show crepitus and palpable bony irregularity. Loss of spontaneous arm or leg movement is an early sign of long bone fracture. The femur and humerus are the most commonly affected long bones. The fractures are treated by splinting. Look for signs of radial nerve injury with a humerus fracture. Brachial plexus injuries typically occur in large babies and have an incidence of 0.5 to 2.0 cases per 1,000 live births. The most common brachial plexus injuries are palsy, involvement of C5, C6, clump paralysis, C7-C8, T1, is rare and results in the weakness of the intrinsic muscles of the hand. Some of these brachial plexus injuries predate birth and are due to problems in utero. Although branches of the facial nerve may be injured in forceps delivery, most facial nerve palsy is unrelated to trauma. Physical findings include asymmetric facies with crying. Lack of movement on the affected side makes the face appear to be pulled to the opposite side. Full resolution of cranial nerve injuries may take several weeks. Diaphragmatic paralysis may occur as an isolated finding when the cervical roots supplying the phrenic nerve are injured or in association with brachial plexus injury. The newborn may experience respiratory distress with hypoxemia, hypercapnia, and acidosis. Approximately 80% of the lesions are on the right side, and 10% are bilateral. Laryngeal nerve injury appears to result from an intrauterine posture in which the head is rotated and flexed laterally. The infant presents with stridor or a hoarse cry. Bilateral injury may be associated with severe respiratory distress needing respiratory support. The paralysis often resolves in 4 to 6 weeks, but may occasionally take as long as 6 to 12 months to clear up. Spinal cord injury may result from excessive traction, in a breech delivery, or rotation and torsion, in a vertex delivery. The clinical presentation is stillbirth or rapid neonatal death with failure to establish an adequate airway. In these cases, the only available treatment will be tracheostomy with home ventilation. Intra-abdominal injury is uncommon and may be overlooked as a cause of death in newborn. Hemorrhage is the most serious complication, and the liver is the organ most commonly injured. The bleeding may be catastrophic or insidious, and the patient presents with circulatory collapse. Consider intra-abdominal bleeding in every newborn presenting with shock or unexplained pallor, plus abdominal distension, especially those who are large for gestational age, and macrosomic.
Chapter 44. Pediatrics. Introduction. Children differ anatomically, physiologically, and emotionally from adults. In addition, the types of illnesses and injuries they sustain and their responses to them vary across the pediatric age span. Sick or injured children present unique challenges in evaluation and management. Their perception of their illness or injury, their surroundings, and those involved in their care often differs from the perception of an adult. They may not be able to report what is bothering them, and fear or pain may make them difficult to assess. Also, most pediatric calls involve at least one caregiver who is also stressed or frightened. In the midst of this potential chaos, you are expected to be calm, carry out your job systematically, carefully, and with confidence. The manner in which you approach a sick or injured child will depend on the child's age and developmental level. Childhood extends from the neonatal period, just after birth, until age 18 years. An enormous amount of physical and psychological development occurs in these 18 years. A child's anatomy, physiology, and psychosocial development will all influence your assessment and treatment. For these reasons, you must tailor your approach to accommodate for the developmental and social issues unique to pediatrics. This chapter addresses some of the special considerations that will enhance your effectiveness in caring for an ill or injured child. It begins by discussing the approach to pediatric patients, with a focus on their developmental level, and the anatomic or physiologic differences unique to the age group. This information is used to outline an approach to pediatric assessment, review specific pediatric emergencies, and address their pre-hospital management. Finally, the chapter details the skills needed to care efficiently and effectively for pediatric patients, regardless of the diagnosis. Developmental stages. Neonate and infant. As discussed in Chapter 9, Human Development, the first month of life is called the neonatal period, whereas infancy refers to the first 12 months of life. Over time, a baby will have longer awake periods, and interact more with the environment. Infants between 2 and 6 months of age begin to hold their heads up and seek attention. At 6 to 12 months, infants begin to crawl and babble. A great deal of development occurs during this interval. Because infants cannot communicate their feelings or needs verbally, it is especially important to respect a caregiver's perception that something is wrong. Non-specific concerns about a young infant's behavior, feeding, or sleep pattern may be tip-offs to a serious underlying illness or injury. Consider the best location for performing your initial assessment. Although separating a 2-week-old from a parent will not cause distress, an older infant in stable condition will be calmest in a parent's arms. Make sure that your hands and stethoscope are warm. A startled, crying infant will be difficult to examine. Be opportunistic with your examination. If the child is quiet, listen to the heart and lungs first, perhaps listening over the clothes before you expose the chest, and disturb the infant. If a young infant starts crying, letting the baby suck on a pacifier or gloved finger may quiet the child enough to allow you to complete your assessment. Jingling keys or shining a penlight may distract an older infant long enough for you to finish an examination. Toddler. The toddler period extends from ages 1 to 2 years. It includes the terrible twos, a behavioral manifestation of the child's struggle between continued dependence on caregivers for food, shelter, and love and the emerging drive for independence. Children in this age group have limited reasoning, and a poorly developed sense of cause and effect. Language development is occurring rapidly, as is the ability to explore the world by crawling, walking, running, and climbing. Many toddlers will begin to have associations, possibly negative, with health care providers. Your assessment of a toddler begins with observation of the child's interactions with the caregiver, vocalizations, and mobility, measured through the pediatric assessment triangle, which is described in detail later. Examine a toddler in stable condition on the parent's lap. Get down to the child's level, sitting or squatting for the examination. You may need to be creative to get a good examination of a toddler with stranger anxiety. Ask the parent to lift the shirt so that you can count respiratory rate, or have the parent press on the abdomen to see if that appears painful. Use play and distraction techniques whenever possible. Listening to a doll's chest first may buy you a few minutes of cooperation. Offer toddlers limited choices when possible because they like to be in control. If you ask yes or no questions, the answer is likely to be no. Consider doing the more upsetting parts of the examination, such as palpating a tender abdomen or examining an injured extremity, last. Be flexible in your approach. Some toddlers will not let you complete an orderly head-to-toe examination. Preschool-aged child. During the preschool years, 3 to 5 years, the child is becoming much more verbal and interactive. He or she can understand directions, and be engaged with an activity or set of goals. Generally, a preschooler will be able to tell you what hurts and may have a story to share about the illness or injury. Preschoolers will understand as you explain what you are going to do, but choose your words carefully because preschoolers are very literal. Saying "I'm going to take your pulse" may lead preschoolers to believe that you are taking something from them and wonder if you plan to give it back. Speak to them in very plain language about what you are going to do and provide lots of reassurance. This is the stage of monsters under the bed, and many other fears. As you perform your assessment, take advantage of the child's curiosity and desire to cooperate. If the patient is in medically stable condition, offer to take turns with the child in listening to the heart and lungs. Let the preschooler play with or hold equipment that is safe. To help give the child some sense of control, offer simple choices. Avoid yes or no questions. Set limits on behavior if the child acts out. For the most part, you should be able to talk a preschooler through an orderly head-to-toe examination. School-aged child. As a child enters the school-age period, 6 to 12 years, he or she becomes much more analytic and capable of abstract thought. At this age, the child can understand cause and effect. School-aged children will have their own stories to tell about the illness or injury, and may have their own ideas about the care to be given. By 8 years, the child's anatomy and physiology are similar to those of adults. Ask the child about the history leading to calling 911 and let the child describe the symptoms, rather than focusing on the caregiver. Explain what you plan to do in simple language, and answer the child's questions. Give the child appropriate choices and control whenever possible, and provide ongoing reassurance and encouragement. Adolescent. The adolescent years, from 13 to 18 years, can be difficult. Adolescents are struggling with issues of independence, body image, sexuality, and peer pressure. Friends are key support figures, and this is a time of experimentation and risk-taking behaviors. With respect to cardiopulmonary resuscitation and foreign body airway obstruction procedures, once secondary sexual characteristics have developed, breasts or facial or axillary hair, the child should be treated as an adult. During the assessment, you must address the patient. Failure to do so can result in the adolescent feeling left out of his or her own care, which can alienate the patient, making it difficult to get an accurate assessment or give appropriate treatment. Encourage the patient's questions and involvement. Also, provide accurate information. A teen may become alienated and uncooperative if you are suspected of being misleading. When you perform the physical examination, respect the patient's privacy. If possible, address the adolescent without a caregiver present, especially about sensitive topics such as sexuality or drug use. If the adolescent's friends are on the scene, he or she may want them to remain during the assessment. Let the patient have as much control over the situation as appropriate. Of course, do not let down your guard regarding scene safety. In a gang situation, members may have weapons and a reputation to earn. Pediatric anatomy, physiology, and pathophysiology. Head. When you are looking at infants or young children, you will note that children have heads that are large relative to the rest of their bodies. An infant's head is already 2/3 the size it will be in adulthood. The large head means more surface area for heat loss. During the school-age years, the head and body develop adult proportions. The head's larger size and weight also make it more susceptible to injury. A young child falling from a height, for example, is more likely to fall on his or her head. Traumatic brain injury is the leading cause of death and significant disability in pediatric trauma patients. Neck and airway. Children have short, stubby necks, which can make it difficult to feel a carotid pulse or see jugular veins. Not surprisingly, the airway of a young child is also much smaller than an adult airway. That smaller diameter makes the airway more prone to obstruction, either by foreign body inhalation, inflammation with infection, or the child's disproportionately large tongue. During the first 4 to 6 months of life, infants are obligate nose breathers, and nasal obstruction with mucus can result in significant respiratory distress. Their epiglottis is floppy and U-shaped, which can make it difficult to visualize the cords during intubation. Finally, the narrowest part of a young child's airway occurs at the level of the cricoid cartilage, rather than at the vocal cords as in adults. These differences must influence your choice of tracheal tubes. Chest and lungs. A child's chest wall is quite thin, with less musculature and less subcutaneous fat than in an adult. The thin chest wall makes it easy to hear heart and lungs sounds, but also means that sounds are readily transmitted throughout the chest. Sounds originating from the nose or throat can be heard quite clearly on auscultation. The ribcage is more compliant, making retractions easy to see. Use of the diaphragm as a muscle of respiration is pronounced in infants, leading to belly breathing at baseline. Chest trauma is the third leading cause of serious injury in pediatric trauma. Because a child's chest wall is more pliable and flexible than that of an adult, children have fewer rib fractures and flail chest events. However, injuries to the thoracic organs may be more severe because the pliable ribcage is more easily compressed during blunt trauma. As a consequence, children are more vulnerable than adults to pulmonary contusions, cardiac tamponade, and diaphragmatic rupture. Be sure to look for signs of these injuries in a child with suspected chest trauma, but note that the signs of pneumothorax or hemothorax in children are often subtle. You may not see signs such as neck vein distension, and it may be difficult to determine tracheal deviation when a pneumothorax has progressed to a tension pneumothorax. Heart. Circulation in the fetus is much different from that in the newborn, and large right side forces on the electrocardiogram are normal in young infants. During the first year of life, the electrocardiogram axis and voltages shift to reflect left ventricular dominance. Cardiac output is rate-dependent in infants and young children. They have relatively poor ability to increase stroke volume, which is reflected in their normal heart rates, higher in newborns than in older children and adults, and in rate response to physiologic stress and hypovolemia. Abdomen and pelvis. The appearance of abdominal distension in a healthy infant is due to two factors: the weak abdominal wall muscles and the size of the solid organs. The liver extends below the rib cage in infants. As the child grows, the liver becomes smaller proportionately and is better protected by the bony rib cage. Abdominal injuries are the second leading cause of serious trauma in children, after head injuries. In pediatric patients, the intra-abdominal organs are relatively large, making them vulnerable to blunt trauma. The liver and the spleen extend below the rib cage in young children and, therefore, do not have as much bony protection as they do in an adult. These organs have a rich blood supply, so injuries to them can result in large blood losses. The kidneys are also more vulnerable to injury in children because they are more mobile and less supported than in adults. Finally, the duodenum and pancreas can be damaged in handlebar injuries. Pelvic fractures are relatively rare in young children, and are generally seen only with high-energy mechanisms of injury. The risk for pelvic fracture increases in adolescence, when the skeleton and mechanisms of injury become more like those of adults. The musculoskeletal system. Reaching adult height requires active bone growth. The growth plates, ossification centers, of a child's bones are made of cartilage, are relatively weak, and are easily fractured. Overall, the bones of growing children are weaker than their ligaments, making fractures more common than sprains. This susceptibility to fractures is a function of bone density and the presence of cartilaginous growth plates. Growth plate fractures can be seen with low-energy mechanisms of injury, and they may not present with the degree of tenderness, swelling, and bruising usually associated with a broken bone. Because a young child's ligaments are sturdier than the long bones, sprains are relatively uncommon, and joint dislocations without associated fractures are not often encountered. Bones finish growing at differing times, but most growth plates will be closed by late adolescence. The nervous system. As the brain and nervous system matures, the infant's responses to the environment, outside stimuli, and even pain become more organized and purposeful. The rapidity of brain development can be appreciated by comparing the abilities and interactions of a 4-day-old baby, whose repertoire is mainly limited to eating and sleeping, with those of a 4-month-old, who smiles socially, rolls over, and plays with a rattle, and with those of a 12-month-old, who walks, is beginning to talk, and expresses preferences for people and activities. Spinal column. The vertebral column continues to develop along with the child. When the child is younger, the cervical spine fulcrum, or bending point, is higher because the head is heavier. As the child grows, the fulcrum descends to adult level, around C5 through C7. An infant who sustains blunt head trauma involving acceleration-deceleration forces is at high risk for a fatal, high cervical spinal injury. By comparison, a school-aged child who experiences the same injury will likely sustain a lower cervical spinal injury and be paralyzed. Fortunately, vertebral fractures and spinal cord injuries in young children are uncommon. Spinal ligaments are more flexible in children than in adults, leading to increased mobility and the phenomenon of cord injury in the absence of identifiable vertebral bony fracture or dislocation. Thoracic and lumbar spinal injuries are also encountered relatively infrequently until a child is pursuing adult activities, such as driving and diving. Nevertheless, these injuries are seen in children in association with specific mechanisms, for example, seat belt-associated lumbar spine injuries, often associated with abdominal injury, and compression fracture due to axial loading in a fall. When confronted with a significant mechanism of injury, the safest course is to assume that the child has a bony injury, and transport with spinal motion restriction precautions. Caregivers of ill or injured children. The majority of children you will treat will come with at least one parent or caregiver. Thus, in many pediatric calls, you will be dealing with more than one patient, even if it is only the child who is ill or injured. Serious illness or injury to a child is one of the most stressful situations caregivers can face. Some may react to this stress by becoming angry at the fact that their child is sick, at the person or situation that caused the injury, or at you simply because they need someone to blame. Other caregivers will be frightened or guilty about the circumstances that led to the illness or injury. Establishing rapport with caregivers is vital because they will be a source of important information and assistance. Children look to their caregivers when they are frightened and often mimic their response, so helping calm a caregiver may also help the patient cope. Approach stressed caregivers in a calm and professional manner. Enlist their help in caring for the child. Along the way, explain what you are doing and provide honest reassurance and support. Above all, do not blame the caregiver for what has happened. Finally, transport at least one caregiver with the child. If the parent or caregiver is extremely emotional, provide support, but remember that your first priority is the child. Do not let a distraught or aggressive caregiver interfere with your care. If necessary, enlist the help of other family members or law enforcement personnel. Pediatric assessment. Just as your general approach to a pediatric patient differs somewhat from your approach to an adult patient, so, too, will your assessment. In particular, you may need to adapt your assessment skills. Using the pediatric assessment triangle to form a general impression. After ensuring scene safety, the first step in an initial assessment of any patient begins with your general assessment of how the patient looks, the sick or not sick classification. An assessment tool called the Pediatric Assessment Triangle has been developed to help paramedics form a from-the-doorway general impression of pediatric patients. Paramedics with experience in treating ill and injured children intuitively use some version of the Pediatric Assessment Triangle to make the important distinction between sick and not sick patients. The Pediatric Assessment Triangle standardizes this approach by including three elements: the child's appearance, work of breathing, and circulation, that collectively paint an accurate clinical picture of the patient's cardiopulmonary status and level of consciousness. This quick assessment applies a rapid, hands-off, systematic approach to observing an ill or injured child, and helps establish urgency for treatment or transport. Appearance. The first element of the pediatric assessment triangle is the child's appearance. In many cases, this is the most important factor in determining the severity of illness, the need for treatment, and the response to therapy. Appearance reflects the adequacy of ventilation, oxygenation, brain perfusion, body homeostasis, and central nervous system function. The tickles, pronounced tickles, mnemonic highlights the most important features of a child's appearance. Tone, interactiveness, consolability, look, or gaze, and speech or cry. To assess appearance, observe the child from a distance, allowing the child to interact with the caregiver as he or she chooses. Walk through the characteristics of the tickles mnemonic while observing the child from the doorway. Delay touching the patient until you have developed your general impression because the child may become agitated by your touch. Unless a child is unresponsive or critically ill, take your time in assessing his or her general appearance by observation before you begin the hands-on assessment, and take vital signs. Figure 44-2 and Figure 44-3 demonstrate examples of an infant with a normal appearance, and one with a worrisome appearance. An abnormal appearance may result from numerous underlying physiologic abnormalities. A child may show evidence of inadequate oxygenation or ventilation, as in respiratory emergencies, inadequate brain perfusion, as from cardiovascular emergencies, systemic abnormalities or metabolic derangements, such as with poisoning, infection, or hypoglycemia, or acute or chronic brain injury. In any event, a child with a grossly abnormal appearance is seriously ill and requires immediate life support interventions and transportation. The remainder of the pediatric assessment triangle, work of breathing and circulation, plus the initial assessment may help identify the cause of the abnormal appearance, and determine the severity of a child's illness, and the need for treatment and transportation. Work of breathing. A child's work of breathing is often a better assessment of his or her oxygenation and ventilation status than the auscultation or respiratory rate. The work of breathing reflects the child's attempt to compensate for abnormalities in oxygenation and ventilation and, therefore, it is a proxy for effectiveness of gas exchange. The hands-off assessment of work of breathing includes listening for abnormal airway sounds and looking for signs of increased breathing effort. Some abnormal airway sounds can be heard without a stethoscope, and can indicate the likely physiology and anatomic location of the breathing problem. For example, snoring, muffled, or hoarse voice, or stridor can indicate obstruction at the level of the oropharynx, glottis or supraglottic structures, or glottis or subglottic structures, respectively. Such an upper airway obstruction may result from croup, bacterial upper airway infections, bleeding or swelling. Lower airway obstruction is suggested by grunting or wheezing. Grunting is a form of autokeep, positive and expiratory pressure, a way to distend the lower respiratory air sacs, that is, alveoli, to promote maximum gas exchange that can be heard in infants in respiratory distress. Grunting involves exhaling against a partially closed glottis. This short, low-pitched sound is best heard at the end of exhalation, and is often mistaken for whimpering. Grunting suggests moderate to severe hypoxia, and is seen with lower airway conditions such as pneumonia, bronchiolitis, and pulmonary edema. It reflects poor gas exchange because of fluid in the lower airways and air sacs. Wheezing is a musical tone caused by air being forced through constricted or partially blocked small airways. It often occurs during exhalation only but can occur during inspiration and expiration during severe asthma attacks. Although this sound is often heard only by auscultation, severe obstruction may result in wheezing that is audible even without a stethoscope. Abnormal positioning and retractions are physical signs of increased work of breathing that can easily be assessed without touching the patient. A child who is in the sniffing position is trying to align the axes of the airways to improve patency and increase airflow. Such a position often reflects a severe upper airway obstruction. The child who refuses to lie down or who leans forward on outstretched arms, tripod position, is creating the optimal mechanical advantage to use accessory muscles of respiration. Retractions represent the recruitment of accessory muscles of respiration to provide more muscle power to move air into and out of the lungs in the face of airway or lung disease or injury. To optimally observe retractions, expose the child's chest. Retractions are a more useful measure of work of breathing in children than in adults because a child's chest wall is less muscular, so the inward excursion of skin and soft tissue between the ribs is more apparent. Retractions may be evident in the supraclavicular area, above the clavicle, the intercostal area, between the ribs, or the substernal area, under the sternum. Another form of retractions is head bobbing, the use of neck muscles to help breathing during severe hypoxia. The patient extends the neck, then allows the head to fall forward during exhalation. Nasal flaring is the exaggerated opening of the nostrils during labored inspiration, and indicates moderate to severe hypoxia. Combine the characteristics of work of breathing, abnormal airway sounds, abnormal positioning, retractions, and nasal flaring, to make your general assessment of the child's oxygenation and ventilation status. Together with the child's appearance, the child's work of breathing suggests the severity of the illness, and the likelihood that the cause is in the airway or is respiratory. Circulation to skin. The goal of rapid circulatory assessment is to determine the adequacy of cardiac output and core perfusion. When cardiac output diminishes, the body responds by shunting circulation from non-essential areas, for example, skin, toward vital organs. Therefore, circulation to the skin reflects the overall status of core circulation. The three characteristics considered when assessing the circulation are pallor, mottling, and cyanosis. Pallor may be the initial sign of poor circulation or even the only visual sign in a child with compensated shock. It indicates reflex peripheral vasoconstriction that is shunting blood toward the core. Pallor may also indicate anemia or hypoxia. Modeling reflects vasomotor instability in the capillary beds, as demonstrated by a lacy pattern in areas of vasoconstriction and vasodilation. It may also be a child's normal physiologic response to a cold environment. Cyanosis, a blue or purple discoloration of the skin and mucous membranes, is the most extreme visual indicator of poor perfusion or poor oxygenation. Acrocyanosis, blue hands or feet in an infant younger than 2 months, is distinct from cyanosis. It is a normal finding when a young infant is cold. True cyanosis is seen in the skin and mucous membranes and is a late finding of cardiorespiratory failure. Combine the 3 pieces of the pediatric assessment triangle to estimate the severity of illness and the likely underlying pathologic cause. If you have determined that the child has a life-threatening condition by your pediatric assessment triangle, you must intervene, that is, provide high-flow oxygen or begin cardiopulmonary resuscitation. The latter should be initiated if the child is lifeless, unresponsive to his or her environment, shows no signs of breathing or only occasional gasping, and is pale or cyanotic. Primary assessment. After using the pediatric assessment triangle to form a general impression of the patient, you will need to complete the rest of the primary assessment. That is, you must assess the child's airway, breathing, and circulation and mental status, and prioritize the care and need for transport. Prior to entering the room, determine which personal protective equipment you will do in. Threats to the airway, breathing, and circulation are managed as they are found, providing a prioritized sequence of life support interventions to reverse critical physiologic abnormalities. The steps are the same as with adults, but with differences related to the child's anatomy, physiology, and signs of distress. Early in your assessment of a young child, you will need to estimate the child's weight, because much of your care will depend on the child's size. Ask a caregiver how much the child weighs or make your own estimate, using a tool such as a length-based resuscitation tape. 1. Measure the child's length, from head to heel, with the tape, with the red portion at the head. 2. Note the weight in kilograms that corresponds to the child's measured length at the heel. 3. If the child is longer than the tape, use adult equipment and medication doses. 4. From the tape, identify appropriate equipment sizes. 5. From the tape, identify appropriate medication doses. Airway. The pediatric assessment triangle may suggest the presence of an airway obstruction based on abnormal airway sounds and increased work of breathing. As with adults, determine if the airway is open and the patient has adequate chest rise with breathing. Check for mucus, blood, or a foreign body in the mouth or airway. If there is potential obstruction from the tongue or soft tissues, position the airway and suction as necessary. Determine whether the airway is open and patent, partially obstructed, or totally obstructed. Do not keep the suction tip or catheter in the back of a child's throat too long because young patients are extremely sensitive to vagal stimuli and the heart rate may plummet. Breathing. The breathing component of the primary assessment involves calculating the respiratory rate, auscultating breath sounds, and checking pulse oximetry for oxygen saturation. Verify the respiratory rate per minute by counting the number of chest rises in 30 seconds, and then doubling that number. Healthy infants may show periodic breathing, or variable respiratory rates with short periods of apnea for less than 20 seconds. As a consequence, counting for only 10 to 15 seconds may give a falsely low respiratory rate. Interpreting the respiratory rate requires knowing the normal values for the child's age, and putting the respiratory rate in context with the rest of the pediatric assessment triangle, and primary assessment. Rapid respiratory rates may simply reflect fever, anxiety, pain, or excitement. Normal rates, by contrast, may occur in a child who has been breathing rapidly with increased work of breathing, and is becoming fatigued. Serial assessment of respiratory rates may be especially useful because the trend may be more accurate than any single value. Auscultate the breath sounds with a stethoscope over the mid-axillary line to hear abnormal lung sounds during inhalation and exhalation. Listen for extra breath sounds such as inspiratory crackles, wheezes, or rhonchi. Rhonchi often indicate harsh breath sounds or sounds that may be transmitted from the upper airways. If you cannot determine whether the sounds are being generated in the lungs or the upper airway, hold the stethoscope over the nose or trachea, and listen. Also, listen to the breath sounds for adequacy of air movement. Diminished breath sounds may signal severe respiratory distress. Auscultation over the trachea may also help distinguish stridor from other sounds. Check the pulse oximetry reading to determine the oxygen saturation while the child breathes ambient air. You can place the pulse oximetry probe on a young child's finger just as you would with an adult. In infants or young children who try to remove the probe, it may be helpful to place the probe on a toe, possibly with a sock covering it. A pulse oximetry reading of greater than 94% saturation while breathing room air indicates good oxygenation. As with the respiratory rate, evaluate the pulse oximetry reading in the context of the pediatric assessment triangle and remainder of the primary assessment. A child with a normal pulse oximetry reading, for example, may be expending increasing amounts of energy, and increasing the work of breathing to maintain his or her oxygen saturation. The pediatric assessment triangle and primary assessment would identify the respiratory distress and point to the need for immediate intervention despite the normal oxygen saturation. Circulation. The information obtained from the pediatric assessment triangle about circulation to the skin directs the next step of the primary assessment. Integrate this assessment of circulation with the pulse rate and quality, skin color, temperature, and condition plus capillary refill time, and blood pressure to obtain an overall assessment of the child's circulatory status. Obtain the child's pulse rate by listening to the heart or feeling the pulse for 30 seconds, and doubling the number. As with respiratory rates in pediatric patients, it is important to know normal pulse rates based on age. Interpret the pulse rate within the context of the overall history, pediatric assessment triangle, and primary assessment. Tachycardia may indicate early hypoxia or shock or a less serious condition such as fever, anxiety, pain, or excitement. Feel for the pulse to ascertain the rate and quality of pulsations. If you cannot find a peripheral, distal, pulse, that is, radial or brachial, feel for a central pulse, that is, femoral or carotid. Check the femoral pulse in infants and young children and the carotid pulse in older children and adolescents. As with adults, if there is no pulse, start cardiopulmonary resuscitation. After checking the pulse rate, do a hands-on evaluation of skin color, temperature, and condition. Check whether the hands and feet are warm or cool to the touch. Check capillary refill time in the fingertip, toe, heel, or pads of the fingertips. A normal refill time is less than 3 seconds. Vasoconstriction can also be due to reduced cardiac output from various causes. One can be somewhat reassured if the central capillary refill time, that is, on the chest, is normal. These two pieces of information need to be placed in context with the pediatric assessment triangle and remainder of primary assessment because cool extremities and delayed capillary refill are commonly seen in a child in a cool environment. The last step in the circulation assessment is to measure the blood pressure. It may be difficult to obtain an accurate measurement in a young child or infant because of a lack of cooperation and need for proper cuff size. Nevertheless, you should attempt to measure the blood pressure on the upper arm, calf, or thigh, making sure the cuff has a width 2/3 the length of the upper arm or thigh. One formula for determining the lower limit of acceptable blood pressure in children ages 1 to 10 years is this: minimum systolic blood pressure equals 70 plus, 2 times age in years. For example, a 2-year-old toddler should have a minimum systolic blood pressure of 74. A lower reading indicates decompensated shock. Table 44-6 shows normal minimal systolic blood pressure values for different ages. Given the technical difficulty of trying to measure a child's blood pressure, make one attempt in the pre-hospital setting. If unsuccessful, move on to the rest of the assessment. Mental status. Your general impression of the patient should provide the first clues about the child's neurologic status. As you begin the primary assessment, use the AVPU scale to evaluate the cerebral cortex. The ADPU scale is a conventional way of assessing any patient's level of consciousness or mental status. It categorizes motor response based on simple response to stimuli, classifying the patient as alert, responsive to verbal stimuli, responsive to painful stimuli, or unresponsive. After evaluating the patient's response with the ADPU scale, assess the pupillary response to a beam of light to assess brainstem response. Next, evaluate motor activity, looking for symmetric movement of the extremities, seizures, posturing, or flaccidity. Combine this information with the pediatric assessment triangle results to determine the child's neurologic status. Exposure considerations. Proper exposure of the child is necessary to complete the primary assessment. During the pediatric assessment triangle, the child will have been at least partially undressed to assess the work of breathing and circulation. It is also important to evaluate the child from head to toe, and to look at the child's back during the primary assessment. Be careful to avoid heat loss, especially in infants, by covering the child up as soon as possible. Keep the temperature in the ambulance high, and use blankets when necessary. Assessment of pain. Numerous studies have found that children are much less likely than adults to receive effective pain medications. Inadequate treatment of pain has many adverse effects on the child and family. Pain causes morbidity and misery for the child and caregivers, and it interferes with your ability to accurately assess physiologic abnormalities. Children of all ages who do not receive appropriate analgesia may be more likely to have exaggerated pain responses to subsequent painful procedures. Also, post-traumatic stress may be more common among children who experience pain during an illness or injury. Assessment of pain must consider developmental age. The ability to identify pain improves with the age of the child. In infants and preverbal children, it may be difficult to distinguish crying and agitation due to hypoxia, hunger, or pain. Further assessment and discussion with caregivers about their perceptions of the child's pain are essential to identify pain in this age group. For verbal children, pain scales using pictures of facial expressions, such as the Wong-Baker Faces Scale, may prove helpful. Remaining calm and providing quiet, professional reassurance to caregivers and the child is critical for managing pediatric pain and anxiety. A calm parent will help keep the child calm and more at ease. Distraction techniques with toys or stories may prove helpful in reducing pain, as may visual imagery techniques and music. Sucrose pacifiers may reduce pain in neonates. Pharmacologic methods for reducing pain and anxiety, such as acetaminophen, opiates, benzodiazepines, and nitrous oxide, are available to paramedics in a number of EMS systems. The benefit of such analgesic or anxiolytic medication must be weighed against the risks of its administration. Respiratory depression, bradycardia, hypoxemia, and hypotension are potential side effects of sedatives, including the potential route of administration. Medications that are given intravenously are often most effective at reducing pain, but they require establishing intravenous access, which itself is a painful procedure. Today, assessment of pain is recognized as part of vital sign assessment, and management of pediatric pain and anxiety should be a routine part of pre-hospital care. This effort requires a thorough understanding of non-pharmacologic techniques, drugs, potential drug contraindications and complications, and management of the complications. Transport decision. After completing the primary assessment and beginning resuscitation when necessary, you must make a crucial decision, whether to immediately transport the child to the emergency department or continue the additional assessment and treatment on the scene. Immediate transport is imperative if the emergency call is for trauma, and the child has a serious mechanism of injury, a physiologic abnormality, a potentially significant anatomic abnormality, or if the scene is unsafe. In these cases, stabilize the spine, manage the airway and breathing, stop external bleeding, and begin transport. Attempt vascular access on the way to the emergency department. If the emergency call is for an illness, the decision to stay or go is less clear-cut and depends on the following factors: expected benefits of treatment, local or regional EMS protocols, comfort level, and transport time. Additional assessment. Focused history and physical examination. The focused history and physical examination, which is performed on medical and trauma patients, has 4 objectives. To obtain a complete description of the chief complaint, for example, OPQRST and sample. To determine the mechanism of injury or nature of an illness. To perform a rapid trauma or medical assessment or a focused or vectored physical examination of a specific body part or body system. To obtain baseline and subsequent vital signs. If the child seems to be in physiologically unstable condition based on the initial assessment, you may decide to begin transport immediately and conduct the focused history and physical examination in the ambulance. If the child is in stable condition and the scene is safe, perform the focused history and physical examination on the scene before transport. The detailed physical examination is conducted en route to the hospital for trauma patients with a significant mechanism of injury. It can be done on the scene if you are waiting for the ambulance to arrive or if patient removal is delayed because of entrapment. As opposed to the primary assessment, which addresses immediately life-threatening pathologic problems, the focused history and physical examination narrows the focus to assessing the body part or body system specifically involved, obtaining a complete set of baseline vital signs, elaborating on the chief complaint, that is, OPQRST, and obtaining a patient history, that is, sample. To obtain the focused history, use the sample mnemonic. Tailor the physical examination to the child's age and developmental stage. In trauma patients, after the detailed physical examination is complete, reconsider the need for immediate transport. Ongoing assessment. The elements in the ongoing assessment include the pediatric assessment triangle, reassessment of patient priority, vital signs, every 5 minutes if in unstable condition, and every 15 minutes if stable, assessment of the effectiveness of interventions, for example, medications administered, splints applied, bleeding controlled, and reassessment of the focused examination areas. Perform this kind of ongoing assessment on all patients to observe their response to treatment, to guide ongoing treatments, and to track the progression of identified pathologic and anatomic problems. New problems may also be identified on reassessment. The elements in the ongoing assessment also guide the choice of an appropriate transport destination, and your radio or telephone communications with direct medical control. Respiratory emergencies. Respiratory problems are among the medical emergencies that you will most frequently encounter in children. Pediatric patients with a respiratory chief complaint will span the spectrum from mildly ill to near death. In pediatrics, respiratory failure and arrest precede the majority of cardiopulmonary arrests. By contrast, a primary cardiac event is the usual cause of sudden death in adults. Early identification and intervention can stop the progression from respiratory distress to cardiopulmonary failure, and help to avert much pediatric morbidity and mortality. General assessment and management. When faced with a respiratory emergency, the first step is to determine the severity of the disease. Is the patient in respiratory distress, respiratory failure, or respiratory arrest? Respiratory distress entails increased work of breathing to maintain oxygenation and/or ventilation, that is, it is a compensated state in which increased work of breathing results in adequate pulmonary gas exchange. The hallmarks of respiratory distress, which is classified as mild, moderate, or severe, are retractions, suprasternal, intercostal, subcostal, abdominal breathing, nasal flaring, and grunting. A patient in respiratory failure can no longer compensate for the underlying pathologic or anatomic problem by increased work of breathing, so hypoxia and/or carbon dioxide retention occur. Signs of respiratory failure may include decreased or absent retractions owing to fatigue of the chest wall muscles, altered mental status owing to inadequate oxygenation and ventilation of the brain, and an abnormally low respiratory rate. Respiratory failure is a decompensated state, requiring urgent intervention to ensure adequate oxygenation and ventilation and to prevent respiratory arrest. Do not be afraid to assist ventilations at this point if you judge the tidal volume or respiratory effort to be inadequate. Respiratory arrest implies that the patient is not breathing spontaneously. Administer immediate bag mask ventilation with supplemental oxygen to prevent progression to cardiopulmonary arrest. Resuscitation of a child from respiratory arrest is often successful, whereas resuscitation of a child in cardiopulmonary arrest may or may not be. By combining the three components of the pediatric assessment triangle, you can determine the severity of disease before you even touch the patient. The child's appearance will give you clues about the adequacy of central nervous system oxygenation and ventilation. If a child with trouble breathing is sleepy, assume the child is hypoxic. Assess the work of breathing by noting the patient's position of comfort, presence or absence of retractions, and grunting or flaring. A patient who prefers to sit upright, use the sniffing position, or use his or her arms for support is trying to optimize breathing mechanics. Deep retractions herald the use of accessory muscles of respiration to move air. Assessment of circulation for the presence of pallor or cyanosis will give further information on the adequacy of oxygenation. After forming a general impression using the pediatric assessment triangle, move on to the hands-on primary assessment. For respiratory emergencies, focus on the child's airway and breathing. Assess the airway by listening for stridor in awake patients or checking for obstruction in obtunded patients. Assess breathing by determining the child's respiratory rate, listening to the lungs for adequacy of air entry and abnormal breath sounds, and checking pulse oximetry readings. A rate that is too low may be more worrisome than a rate that is too high for the child's age. The presence of abnormal breath sounds may identify the anatomic or pathologic abnormality and suggest a likely diagnosis. For example, symmetric, diffuse wheezing implies bronchospasm and possibly asthma, whereas diffuse rhonchi, crackles, and wheezing in an infant or toddler are typical signs of lower airway inflammation associated with bronchiolitis or pneumonia. The presence of stridor in the context of clear lung fields is consistent with upper airway obstruction, often due to croup. Poor air entry with decreased breath sounds is an ominous sign that must be addressed immediately. Determine oxygen saturation by assessing pulse oximetry via a finger or toe or, in a small infant, around the foot and palm of the hand. Your determination of whether the patient is in respiratory distress, respiratory failure, or respiratory arrest will drive your next steps by indicating the urgency for treatment and transport. You can obtain the sample history at the scene or during transport, depending on the patient's stability. Table 44-10 lists key questions to ask during a respiratory emergency. Most pediatric patients with a primary respiratory complaint will have respiratory distress and require only generic treatment. Allow the child to assume a position of comfort and provide supplemental oxygen. The choice of oxygen delivery method will depend on the severity of illness and the child's developmental level. Young children may become agitated by a nasal cannula or face mask. Because crying and thrashing increase metabolic demands and oxygen consumption, you must weigh the benefits of this therapy against the potential cost. Allowing a caregiver to deliver blow-by oxygen to a calm toddler may be your best choice if the child does not show signs of respiratory failure. As a child becomes fatigued, respiratory distress may progress to respiratory failure. As part of your ongoing assessment, electronically monitor the patient's pulse rate, respiratory rate, and oxygen saturation. A significant change or trend in any of these variables requires prompt patient reassessment. You should also perform frequent reassessment to evaluate the effects of your treatment. Upper airway emergencies. Foreign body aspiration or obstruction. Infants and toddlers explore their environment by putting everything and anything into their mouths, resulting in a high risk of foreign body aspiration. Any small object or food item has the potential to obstruct a young child's narrow trachea. Peanuts, hot dogs, grapes, balloons, and small toys or pieces of toys are frequent offenders. Swallowed foreign bodies can also cause respiratory distress in infants and young children because a rigid esophageal foreign body can compress the relative pliable trachea. In addition, the tongue, owing to its large size relative to the upper airway, frequently causes upper airway obstruction in a child with a decreased level of consciousness and diminished muscle tone. In the absence of fever, cough, or respiratory congestion, suspect foreign body aspiration when a child has a sudden onset of respiratory distress accompanied by coughing, gagging, stridor, or wheezing. An awake patient with stridor, increased work of breathing, and good color on the pediatric assessment triangle has mild upper airway obstruction. Auscultation may reveal fair to good air entry, and the presence of unilateral wheezing may tip you off to a foreign body lodged in a mainstem bronchus. In contrast, a patient with severe airway obstruction is likely to be cyanotic and unresponsive when you arrive, owing to profound hypoxia. If the child is spontaneous respiratory effort, you will hear poor air entry. You may not hear stridor owing to minimal airflow through the trachea. A typical sample history for foreign body aspiration reveals a previously healthy child with sudden onset of coughing, choking, or gagging while eating or playing. Initial management of mild airway obstruction involves allowing the patient to assume a position of comfort, providing supplemental oxygen as tolerated, and transporting the child to an appropriate treating facility. Avoid agitating the child as this stimulus could worsen the situation. Continuous monitoring and frequent reassessments are needed to ensure that the problem does not progress to severe airway obstruction. In cases of severe airway obstruction, the patient is unable to cough or make any sound. Rapid intervention is needed to clear the obstruction. For a responsive infant, deliver 5 back slaps and 5 chest thrusts. 1. Hold the infant face down, with the body resting on your forearm. Support the infant's head and face with your hand, and keep the head lower than the rest of the body. 2. Deliver 5 back slaps between the shoulder blades using the heel of your hand. 3. Place your free hand behind the infant's head and back, and bring the infant upright on your thigh, sandwiching the infant's body between your 2 hands and arms. The infant's head should remain below the level of the body. 4. Give 5 quick chest thrusts in the same location and manner as for chest compressions, using 2 fingers placed on the lower half of the sternum. For larger infants, or if you have small hands, you can place the infant in your lap, and turn the infant's whole body as a unit between back slaps and chest thrusts. 5. Check the airway. If you can see the foreign body now, remove it. If you cannot, repeat the cycle as often as necessary. Do not stick your fingers in the infant's mouth to remove a foreign body unless you can actually visualize the object. 6. If the infant becomes unresponsive, begin cardiopulmonary resuscitation with compressions, remembering to look in the airway before ventilations each time. If the infant regains consciousness, place him or her in the recovery position, administer 100% supplemental oxygen, and transport immediately. If you are unable to relieve the obstruction after several attempts, begin immediate transport. Performing abdominal thrusts, also called the Heimlich maneuver, is the most effective method of dislodging and forcing an object out of the airway of a responsive child, older than 1 year. This method aims to increase the pressure in the chest, creating an artificial cough that may force a foreign body from the airway. Use this maneuver until the obstructing object is expelled or the child becomes unresponsive. If the child becomes unresponsive, carefully position him or her supine and perform 30 chest compressions, 15 compressions if 2 rescuers are present. After 30 compressions, look inside the mouth. If you see the object, remove it. If not, attempt to give 2 breaths. If the first breath does not produce visible chest rise, reopen the airway, and reattempt to ventilate. If both breaths fail to produce visible chest rise, continue chest compressions. If you are unable to relieve a severe airway obstruction in an unresponsive patient with the basic techniques previously discussed, you should proceed with direct laryngoscopy, visualization of the airway with a laryngoscope, for the removal of the foreign body. Insert the laryngoscope blade into the patient's mouth. If you see the foreign body, carefully remove it from the upper airway with McGill forceps, a special type of curved forceps. This list summarizes the steps for using McGill forceps on a pediatric patient. 1. Hold the laryngoscope handle with your left hand. 2. Open the mouth by exerting thumb pressure on the chin. 3. Insert a pediatric straight blade into the mouth, and lift the tongue with the blade. 4. Exert gentle traction upward along the axis of the laryngoscope handle at a 45 degrees angle, and advance the blade. Do not use the teeth or gums for leverage. 5. Watch the tip until the foreign body is visible. Do not go past the vocal cords. 6. Use suction to improve visibility if secretions are present. 7. Insert the McGill forceps into the mouth with the tips closed. 8. Grasp the foreign object, and remove while looking directly at it. 9. Look at the airway to ensure that it is clear of debris. Remove the laryngoscope blade. If you manage to remove the object, recheck the patient's breathing and circulation. Begin rescue breathing and cardiopulmonary resuscitation as needed and arrange for immediate transport. If direct laryngoscopy does not reveal the foreign body, use bag mask ventilation. If bag mask ventilation does not provide adequate ventilatory support, attempt to insert an advanced airway, such as a tracheal tube or laryngeal mask airway. Immediate transportation to an appropriate facility is required. Anaphylaxis. Anaphylaxis is a potentially life-threatening allergic reaction, triggered by exposure to an antigen, foreign protein. Food, especially nuts, shellfish, eggs, and milk, and bee stings are among the most common causes, although anaphylaxis to antibiotics and other medications can occur as well. Exposure to the antigen stimulates the release of histamine and other vasoactive chemical mediators from white blood cells, leading to multiple organ system involvement. Onset of symptoms generally occurs immediately after the exposure, and may include hives, respiratory distress, circulatory compromise, and gastrointestinal symptoms, vomiting, diarrhea, abdominal pain. Although a child with mild anaphylaxis may experience only hives and some wheezing, a child with severe anaphylaxis may be in respiratory failure and shock when you arrive. The pediatric assessment triangle may reveal an anxious child. With severe anaphylaxis, the child may be unresponsive due to respiratory failure and shock. He or she may have increased work of breathing due to upper airway edema or bronchospasm, and poor circulation. The initial assessment will usually reveal hives, with other findings potentially including swelling of the lips and oral mucosa, stridor and/or wheezing, and bounding or diminished pulses. If the child has a known allergy, the sample history may reveal recent contact with or ingestion of the potentially offending agent, including consumption of prepared foods containing traces of eggs, nuts, and milk at daycare or school. The gold standard treatment for anaphylaxis is epinephrine. Epinephrine's alpha agonist effect decreases airway edema by vasoconstriction and improves circulation by increasing peripheral vascular resistance. Its beta agonist effect causes bronchodilation, resulting in improved oxygenation and ventilation. Epinephrine should be given by the intramuscular route. The dose may be repeated as necessary every 5 to 15 minutes. If several doses are needed, the child may require a continuous intravenous epinephrine drip. In addition to epinephrine, treatment of anaphylaxis should include supplemental oxygen, fluid resuscitation for shock, and bronchodilators for wheezing. Many children with a history of anaphylaxis will have been treated with intramuscular epinephrine by a caregiver before EMS activation. Given the short half-life of this drug, the child should be transported, even if asymptomatic on your arrival. Other treatment options include diphenhydramine and other antihistamine medications, and steroids to prevent rebound anaphylaxis. Croup. Croup, laryngotracheal bronchitis, is a viral infection of the upper airway, and the most common cause of upper airway emergencies in young children. The parainfluenza virus is the pathogen most commonly responsible for croup, but respiratory syncytial virus, influenza, and adenovirus have also been implicated. The virus is transmitted by respiratory secretions. Croup most commonly affects children between 6 months and 6 years of age, with most cases occurring in the fall and winter months. The virus has an affinity for the subglottic space, the narrowest part of the pediatric airway, and causes edema and progressive airway obstruction. Turbulent airflow through the narrowed subglottic airway causes the hallmark sign of croup, stridor. The severity of croup may range from mild to severe. Emergency medical services may be called when the symptoms come on abruptly or cause moderate to severe respiratory distress. The pediatric assessment triangle for a child with croup will typically reveal an alert infant or toddler who has audible stridor with activity or agitation, a barky cough, some increased work of breathing, and normal skin color. If a child with a history compatible with croup is sleepy or obtunded or has significant respiratory distress or cyanosis, be concerned about critical airway obstruction. On your initial assessment, breath sounds will likely be clear over the lung fields, although you may hear stridor, originating at the level of the subglottic space. Because the pathophysiology of croup largely involves the upper airway, hypoxia is uncommon, and its presence should alert you to critical obstruction and the need for immediate treatment. The sample history usually reveals several days of cold symptoms and low-grade fever, followed by onset of a barky cough, stridor, and trouble breathing. The cough and respiratory distress are often worse at night. The initial management of croup is the same as for most respiratory emergencies. Allow the child to assume a position of comfort, and avoid agitating him or her. The use of cool mist or nebulized saline is controversial. For patients with stridor at rest, moderate to severe respiratory distress, poor air exchange, hypoxia, or altered appearance, nebulized epinephrine is the treatment of choice. The alpha-adrenergic effect results in vasoconstriction and decreased upper airway edema. Nebulized epinephrine is available as L-epinephrine. The dose for L-epinephrine is 0.25 to 0.5 mg per kilogram of the 1 to 1000 solution, maximum 5 mg per dose. This form can be diluted with normal saline to bring the volume to 3 milliliters. Although only a small amount of epinephrine is absorbed via the nebulized route, side effects may include tachycardia, agitation, tremor, and vomiting. In the case of croup and respiratory failure, nebulized epinephrine alone may not be adequate and assisted ventilation may be necessary. Assisted ventilation with bag mask ventilation will often succeed in overcoming the upper airway obstruction. Advanced airway placement is rarely needed in croup. If performed, choose a tracheal tube 1/2 to 1 full size smaller than normal for age or size to accommodate the subglottic edema. Children requiring nebulized epinephrine or assisted ventilation need to be transported immediately to an appropriate treatment facility. Epiglottitis and bacterial infections. Epiglottitis, the severe inflammation of the supraglottic structures, usually due to bacterial infection, is now rare in children. Since the introduction of a childhood vaccine against Haemophilus influenzae type B, the incidence of this life-threatening condition has decreased dramatically. Nevertheless, sporadic cases have been reported among adolescents, adults, and unimmunized children. The classic presentation of epiglottitis is easily distinguishable using the pediatric assessment triangle and the initial assessment. A child with epiglottitis looks sick and will be anxious, will sit upright in the sniffing position with the chin thrust forward to allow for maximal air entry, and may be drooling because of an inability to swallow secretions. The work of breathing is increased, and pallor or cyanosis may be evident. The primary assessment may reveal stridor, a muffled voice, decreased or absent breath sounds, and hypoxia, all signs of a significant airway obstruction. The sample history will reveal a sudden onset of high fever and sore throat in preschool or school-age children. Because symptoms progress rapidly, children with epiglottitis are generally sick for only a few hours before they come to medical attention. Remember to ask about immunizations as part of the pertinent medical history for patients suspected of having epiglottitis. Your goal is to get the child with epiglottitis to an appropriate hospital with a maintainable airway. Because rapidly progressive disease carries a risk for acute airway obstruction, and respiratory arrest, you should minimize your scene time, and not attempt procedures that might agitate the child. Allow the patient to assume a position of comfort, and give supplemental oxygen only if tolerated by the patient. Do not attempt to look in the mouth because this can precipitate complete airway obstruction, and do not insert an intravenous line. Be prepared with a bag mask device, and a tracheal tube 1 to 2 sizes smaller than anticipated for the child's age and length in case of complete obstruction during transport, and the need for assisted ventilation. Tracheal intubation of a child with epiglottitis is notoriously difficult owing to the extreme distortion of the airway anatomy. Alert personnel at the receiving facility to the suspected diagnosis and patient's condition because they will need to mobilize a team for the management of this difficult airway. Some uncommon conditions can also cause upper airway obstruction, including retropharyngeal abscess, paratonsillar abscess, tracheitis, and diphtheria. Presentation may include fever, stridor, difficulty handling secretions, and respiratory distress. Regardless of the underlying diagnosis, initial assessment and management will be the same as for croup. Lower airway emergencies. The underlying pathophysiology in upper airway emergencies involves restriction of airflow into the lungs, inhalation. By contrast, the pathophysiology of lower airway respiratory emergencies involves restriction of airflow out of the lungs, exhalation. Asthma. Asthma is the most common chronic illness of childhood, and the most common respiratory complaint encountered by paramedics. An estimated 5% to 10% of children are affected by asthma, many of whom will be treated in the emergency department. Recent studies indicate that the incidence of this disease is increasing. There are 3 main components that lead to obstruction and poor gas exchange: bronchospasm, mucus production, and airway inflammation. Lower airway inflammation in asthma results in hypoxia because of ventilation-perfusion mismatch, a situation in which blood flowing to parts of the lung is poorly oxygenated. Triggers for asthma attacks include upper respiratory infections, environmental allergies, exposure to cold, changes in the weather, physical activity, and secondhand smoke. Clinical signs include frequent cough, wheezing, and more general signs of respiratory distress. The initial assessment of a child with an acute exacerbation of asthma will vary based on the degree of obstruction and the presence or absence of respiratory fatigue. A child with mild to moderate respiratory distress will be awake and alert, sometimes preferring a seated posture. Although increased work of breathing may be evident by retractions and nasal flaring, circulation will seem normal. Expiratory wheezing alone may be heard in patients with mild to moderate asthma attacks. Decreasing alertness, assumption of the tripod position, deep retractions, and cyanosis are signs of respiratory failure. The initial assessment will reveal shortness of breath as evidenced by inability to speak in full sentences, increased respiratory rate, prolonged expiration phase, and wheezes noted on auscultation. The wheezing may be heard on inspiration and expiration. Decreased air movement, and the absence of wheezes in a person with asthma who has activated the EMS system suggests severe lower airway obstruction and respiratory fatigue and signal the need for immediate treatment to prevent respiratory arrest. The sample history for a patient suspected of having asthma should reveal the frequency and severity of previous asthma attacks, as reflected by emergency department visits and hospitalizations. A patient who has previously been admitted to an intensive care unit or intubated for asthma is at increased risk for severe, possibly fatal, attacks. The medication history should identify any preventive treatment, controller medications, and any rescue medications administered by the caregiver before your arrival. Inhaled corticosteroids are the most common controller medications used in pediatrics, whereas inhaled salbutamol is the most common beta-2 agonist drug used as a rescue medication. The initial management of an asthma exacerbation remains basic respiratory care. Allow the patient to remain in a position of comfort, and start supplemental oxygen. The gold standard treatment consists of bronchodilators, beta agonists that relax smooth muscles in the bronchioles, thereby decreasing bronchospasm, and improving air movement and oxygenation. Bronchodilators may be delivered by nebulizer or meter-dose inhaler with a spacer mask device. Unit doses of 2.5 mg of salbutamol premixed with 3 ml of normal saline are often used for nebulization, and represent an acceptable starting dose for most young children. For a larger child or a child of any age who is in severe distress, consider administering 5 mg of salbutamol as the initial dose. If nebulized salbutamol is used, 4 puffs is equivalent to 2.5 mg administered by nebulizer. Children with moderate to severe respiratory distress can be given treatments every 10 to 20 minutes during transport, including back-to-back nebulizer treatments. Although salbutamol is a relatively safe medication, its potential early side effects include tachycardia, tremor, and mild hyperactivity. Children with moderate to severe respiratory distress may also benefit from treatment with inhaled ipratropium, Atrovent, an anticholinergic bronchodilator. Studies have shown that the combination of salbutamol and ipratropium, which may be mixed and delivered together by nebulizer, is more effective than salbutamol given alone. The dose of ipratropium given is based on the patient's weight, a 0.25 mg unit dose nebulized or 1 puff by meter dose inhaler for children weighing less than 10 kg or a 0.5 mg unit dose nebulized or 2 puffs by meter dose inhaler for children weighing more than 10 kg. If a child is in respiratory failure, is obtunded, or has markedly diminished air movement on auscultation, a dose of intramuscular epinephrine may be given. Epinephrine will cause immediate relaxation of bronchial smooth muscles, opening the airways to allow bronchodilators to work. The dose is 0.01 mg per kilogram of 1 to 1,000 epinephrine injected intramuscularly. Single doses should not exceed 0.3 mg. Initiate bronchodilator therapy immediately after administering the epinephrine. Although epinephrine can be used, it is falling out of favor due to lack of evidence for the practice. Consult your local and regional protocols to guide its use in this situation. Assisted ventilation is problematic for patients with an asthma exacerbation. High inspiratory pressures force air into the lungs, but exhalation is compromised by bronchospasm, mucus production, and inflammation, leading to air trapping, and a high risk of pneumothorax and pneumomediastinum. Assisted ventilation should be undertaken only if the patient has respiratory failure, and has failed to respond to intramuscular epinephrine and high-dose bronchodilators. If this therapy is performed, use very slow rates to allow time for adequate exhalation. Your goal is adequate oxygenation. Bronchiolitis. Bronchiolitis is an inflammation of the small airways, bronchioles, in the lower respiratory tract due to viral infection. The most common source of this disease is respiratory syncytial virus. Other viruses such as metapneumovirus, adenovirus, parainfluenza, and influenza have also been found to cause bronchiolitis. These viruses occur with highest frequency during the late fall and winter months, and they primarily affect infants and children younger than 2 years. Severity ranges from mild respiratory distress to respiratory failure. Younger infants are at particularly high risk for episodes of apnea associated with respiratory syncytial virus infection, which may not be associated with severe respiratory distress. The signs and symptoms of bronchiolitis can be difficult to distinguish from those of asthma. One clue is the child's age. Asthma is rare in children younger than 1 year. An infant with a first-time wheezing episode occurring in late fall or winter likely has bronchiolitis. Mild to moderate retractions, tachypnea, diffuse wheezing, diffuse crackles, and mild hypoxia are characteristic findings on the pediatric assessment triangle and primary assessment. As with asthma, a sleepy patient or one with severe retractions, diminished breath sounds, or moderate to severe hypoxia, oxygen saturation less than 90%, is in danger of respiratory arrest and requires immediate transport. Infants in the first months of life or who have a history of prematurity, underlying lung disease, congenital heart disease, or immunodeficiency are at greatest risk for respiratory failure and arrest. The management of infants and young children with bronchiolitis is entirely supportive. Leave the patient in a position of comfort, for example, in the caregiver's arms. If the child does not seem to be in respiratory failure, provide supplemental oxygen, and remove excessive secretions from the nose and mouth by gentle suctioning. Although bronchodilator therapy has not proved effective in the majority of cases, inhaled salbutamol or nebulized epinephrine, 0.25 to 0.5 mg per kilogram of the 1 to 1000 solution, maximum 5 mg per dose, alone or in combination with an inhaled or oral steroid may be given as a therapeutic trial in children with moderate to severe respiratory distress. Be prepared to assist ventilation with bag mask ventilation or tracheal intubation if needed. Management of respiratory emergencies. Infants and young children with severe tachypnea and retractions, in association with hypoxia, bradycardia, or altered mental status, are in respiratory failure, and need immediate intervention to prevent respiratory arrest. A respiratory rate too slow for age in a child with a history of respiratory distress should also raise concerns for fatigue and respiratory failure. Airway management. Managing any respiratory emergency starts with the airway. Check for obstruction, and position the airway using the head tilt chin lift or jaw thrust maneuver. In a child younger than 2 years, place a thin layer of padding under the shoulders or upper torso to align the airway. An airway adjunct may be helpful if the patient is unresponsive and cannot maintain a patent airway. The use of a nasal or oral airway will help to maintain an open airway, improve bag mask ventilation, and may avert the need for an advanced airway, such as a tracheal tube, laryngeal mask airway, King LT airway, or comba tube. When placing the adjunct, make sure to start by choosing the appropriate size equipment. Oropharyngeal airway. An oropharyngeal, oral, airway is designed to keep the tongue from blocking the airway, and it makes suctioning the airway easier. This kind of airway should be used for pediatric patients who are unresponsive and cannot maintain their own airway spontaneously. It should not be used for responsive patients or patients with a gag reflex. An oropharyngeal airway may stimulate vomiting, thereby increasing the risk of aspiration. In addition, this adjunct should not be used for children who have ingested a caustic, corrosive, or petroleum-based product. Skill Drill 44-1 shows the preferred technique for inserting an oropharyngeal airway in a child. Skill Drill 44-1. Inserting an oropharyngeal airway in a pediatric patient. Step 1. Determine the appropriate size airway by measuring from the corner of the mouth to the angle of the jaw, mandible, or by using the length-based resuscitation tape to measure the patient. Place the airway next to the face, with the flange at the level of the central incisors, and the bite block segment parallel to the hard palate. The tip of the airway should reach the angle of the jaw. The key is to not push the tongue back as the airway is slid into the correct position. Step 2. Position the patient's airway. For medical patients, use the head tilt chin lift maneuver to avoid hyperextension. If the patient has a traumatic injury, use the jaw thrust maneuver and provide inline spinal stabilization. Step 3. Open the mouth by applying pressure on the chin with your thumb. Insert the airway by depressing the tongue with a tongue blade on the base of the tongue, and inserting the airway directly over the tongue blade. If a tongue blade is not available, point the airway tip toward the roof of the mouth to depress the tongue. Gently rotate the airway into position as it passes through the mouth toward the curve of the tongue. Insert the airway until the flange rests against the lips. Reassess the airway after insertion. This is the end of Skill Drill 44-1. Take care to avoid injuring the hard palate as you insert the airway. Rough insertion can cause bleeding, which may aggravate airway problems and cause vomiting. If the oropharyngeal airway is too small, the tongue may be pushed back into the pharynx, obstructing the airway. If it is too large, it may obstruct the larynx. Nasopharyngeal airway. An nasopharyngeal, nasal, airway is usually well tolerated and is not as likely as the oropharyngeal airway to cause vomiting. The nasopharyngeal airway is used for responsive patients and patients with altered levels of consciousness. In pediatric patients, it is typically used in association with respiratory failure. It is also a good choice for patients having a seizure or in a postictal state as a way of maintaining an airway. This type of airway is rarely used for children younger than 1 year because of the small diameter of their nares, which tend to become easily obstructed by secretions. Follow the steps in skill drill 44-2 to insert a nasopharyngeal airway in a child. Skill drill 44-2. Inserting a nasopharyngeal airway in a pediatric patient. Step 1. Determine the appropriate size airway. The external diameter of the airway should not be larger than the diameter of one of the external openings of the nose, nares, and there should be no blanching, turning white, of the nares after insertion. Place the airway next to the patient's face to make sure the length is correct. The airway should extend from the tip of the nose to the tragus of the ear, the small cartilaginous projection in front of the opening of the ear. Position the patient's airway, using the techniques described for the oropharyngeal airway. Step 2. Lubricate the airway with a water-soluble lubricant. Insert the tip into the right nares with the bevel pointing toward the nasal septum. Step 3. Carefully move the tip forward, perpendicular to the face, following the curvature of the nose, until the flange rests against the outside of the nostril. If you are inserting the airway on the left side, insert the tip into the left nares upside down, with the bevel pointing toward the septum. Move the airway forward slowly until you feel a slight resistance, and then rotate the airway 180 degrees. Reassess the airway after insertion. This is the end of skill drill 44-2. Several problems are possible with the nasopharyngeal airway. A diameter that is too small may become obstructed by mucus, blood, vomitus, or the soft tissues of the pharynx. If the airway is too long, it may stimulate the vagus nerve and slow the heart rate. It may also enter the esophagus, causing gastric distension. Inserting the airway in responsive patients may cause spasm of the larynx and result in vomiting. A nasopharyngeal airway should not be used when the patient has facial trauma because the airway may tear soft tissues and cause bleeding into the airway. Similarly, a nasopharyngeal airway should not be used for a patient with moderate to severe head trauma because it could increase intracranial pressure. Oxygenation. As part of your breathing assessment, you will assess the patient's ventilatory and oxygenation status. All patients with respiratory emergencies should receive supplemental oxygen. The two most common ways to deliver oxygen to pediatric patients are the blow-by technique and the non-rebreathing mask. The blow-by technique does not deliver high concentrations of oxygen to the patient, so it is best used when only a small amount of supplemental oxygen is needed or when the patient cannot tolerate wearing the mask needed for higher oxygen delivery. You can use oxygen tubing, a mask, a styrofoam cup, or a similar device to deliver blow-by oxygen. The child or caregiver can hold the device near the patient's face. The idea is to increase the oxygen concentration immediately around the patient's mouth and nose. For children in significant respiratory distress or respiratory failure or for older children, a non-rebreathing mask is the preferred method of oxygen delivery. At a flow rate of 10 to 15 liters per minute, a non-rebreathing mask can deliver up to 95% oxygen to the patient. Bag mask ventilation. If the patient's respiratory effort is not improved with airway positioning or insertion of an airway adjunct, start assisted ventilation with a bag mask device. Bag mask ventilation is always the first step in assisted ventilation, and it represents definitive airway management for many patients. Proficiency in bag mask ventilation is a critical skill for all paramedics, and may avert the need for tracheal intubation, a procedure with a much higher complication rate. You may need to try a variety of mask sizes to find the one that gives the optimal seal. Do not hesitate to change providers, hand position, or technique if difficulty with ventilation continues. Avoid excessive tidal volumes and rates to minimize gastric distension, vomiting, and aspiration. Deliver breaths at a rate of 12 to 20 breaths per minute for infants and children, squeezing the bag only until you see chest rise. Do not overdistend the chest. Assist the ventilation of an infant or child using a bag mask device in the following way. 1. Ensure that you have the appropriate equipment in the right size. The mask should extend from the bridge of the nose to the cleft of the chin, avoiding compression of the eyes. The mask is transparent, so you can observe for cyanosis and vomiting. The mask volume should be small to decrease dead space, and avoid rebreathing. However, the bag should contain at least 450 milliliters of air. Older children and adolescents may need an adult-size bag. Make sure that there is no pop-off valve on the bag or, if there is one, make sure that you can hold it shut as necessary to achieve adequate chest rise. 2. Maintain a good seal with the mask on the face. An inadequate mask-to-face seal will result in inadequate tidal volume delivery, and a decreased concentration of delivered oxygen. Consider the use of airway adjuncts, nasal and oropharyngeal airways, in tandem with bag mask ventilation. 3. Ventilate at the appropriate rate and volume over approximately 1 second until the chest visibly rises. Do not hyperventilate. Errors in technique, including providing too much volume with each breath, squeezing the bag too forcefully, and ventilating at too fast a rate, can result in gastric distension or an pneumothorax. An inadequate mask-to-face seal or improper head position can lead to inadequately delivered tidal volume and hypoxia. Even with the best technique, however, the patient may regurgitate and aspirate the stomach contents. Perform one rescuer bag mask ventilation for an infant or child by following the steps in skill drill 44-3. By comparison, two-person bag mask ventilation requires 2 rescuers, one to maintain an adequate mask-to-face seal, and maintain the patient's head position, and one to ventilate the patient. Although this technique is more effective at delivering adequate tidal volume, you may not always be able to dedicate 2 providers to the patient's airway. Skill drill 44-3. 1 rescuer bag mask ventilation for a pediatric patient. Step 1. Open the airway and insert the appropriate airway adjunct. Step 2. Hold the mask on the patient's face by using the EC clamp method. Form a C with the thumb and index finger along the mask, while the other 3 fingers form an E along the mandible. With infants and toddlers, support the jaw with only your 3rd finger. Do not compress the area under the chin because you may push the tongue into the back of the mouth and block the airway. Bring the child's face up into the mask instead of pushing the mask down on the child's face. The soft cartilage in a young child's nose can become compressed with excessive pressure, making your bagging less effective. Ensure the mask forms an airtight seal on the face. Maintain the seal while checking that the airway is open. Step 3. Squeeze the bag, using the correct ventilation rate. 12 to 20 breaths per minute for infants and children, 1 breath every 3 to 5 seconds, synchronized with the child's spontaneous effort when possible. Allow 1 second per ventilation, providing adequate time for exhalation. Step 4. Assess the effectiveness of ventilation by watching for adequate bilateral rise and fall of the chest. This is the end of skill drill 44-3. Tracheal intubation. Consider tracheal intubation if adequate oxygenation and ventilation cannot be achieved with good bag mask technique or if transport times are long. Intubation has the advantage of providing a definitive airway and carrying a decreased risk of aspiration. However, studies have shown significant failure and complication rates when using this technique in the pre-hospital setting. Potential complications include damage to teeth and oral structures, aspiration of gastric contents, bradycardia due to a vagal response, bradycardia due to hypoxemia from prolonged attempts, increased intracranial pressure, and incorrect placement. Incorrect placement of the tracheal tube into the right mainstem bronchus may result in hypoxia and inadequate ventilation. A catastrophic complication is an unrecognized esophageal intubation. Paramedics should exercise caution when considering intubating a pediatric patient, do so only when necessary, and consider aborting attempts, and using basic airway maneuvers after 1, or at most 2, intubation attempt or attempts. When preparing to intubate an infant or a young child, remember the differences between the adult and pediatric airways. Children have a relatively large tongue, an airway that is positioned more anteriorly, a relatively large and floppy epiglottis, and a flexible trachea that can be easily compressed. Young infants also have a large occiput. Equipment for tracheal intubation. Access to pediatric-specific equipment is mandatory, including a range of laryngoscope blades in sizes 0 to 3 and tracheal tubes in sizes 2.5, for pre-hospital deliveries of premature infants, to 6.0. Any size of laryngoscope handle can be used, although many paramedics prefer the thinner pediatric handles. Straight, Miller or Wisshipple blades make it easy to lift the floppy epiglottis. If a curved, Macintosh blade is used, the tip of the blade is positioned in the vallecula to lift the jaw and epiglottis to visualize the vocal cords. The appropriate size blade extends from the patient's mouth to the tragus of the ear. Acceptable means of measuring include using the length-based resuscitation tape, and following these general guidelines. Premature newborn, size 0 straight blade. Full-term newborn to 1 year, size 1 straight blade. 2 years to adolescent, size 2 straight blade. Adolescent or older, size 3 straight or curved blade. Use a length-based tape to choose the appropriate tracheal tube size or, for children older than 1 year, use this formula. Age divided by 4, plus 4 equals size of tube, in millimeters. For example, a 4-year-old child would need a 5 mm tracheal tube, 4 divided by 4, plus 4 equals 5.0. Always have a tube that is one size smaller and one that is one size larger than expected available for situations in which there is variability in upper airway diameter. Guidelines for selecting pediatric tracheal tubes are shown in Table 44-12. Uncuffed tracheal tubes were long considered necessary until the child reached 8 to 10 years of age because the narrowest part of the airway was below the cords, and would provide a suitable seal against a proper-sized tracheal tube. Uncuffed tubes were also considered necessary to prevent ischemia and damage to the tracheal mucosa. With newer tube and cuff designs, it is no longer necessary to use an uncuffed tube in patients age 1 year or older. Use of a cuffed tube is now encouraged in these children. The advantage of using a cuffed tube is prevention of a large air leak and prevention of aspiration of stomach contents. You must always be cautious to avoid excessive cuff inflation, and to prevent ischemia and damage to the tracheal mucosa at the level of the cricoid ring. The appropriate depth of insertion of the tracheal tube is 2 to 3 centimeters beyond the vocal cords. After the tube has been inserted, the depth at the corner of the child's mouth should be recorded and monitored. For uncuffed tubes, a black band, the vocal cord guide, often encircles the tube at its distal end. When you see this band at the level of the vocal cords, stop. Cuff tubes should be inserted until the cuff is just below the level of the vocal cords. Another guideline is to insert the tube to a depth equal to 3 times the inside diameter, millimeters, of the tube. For example, a 4 mm tube should be inserted to a depth of 12 centimeters, 12 equals 3 times 4 millimeters. Pediatric stylets will fit into tubes sized 3 to 6 millimeters, whereas adult stylets are used for tubes 6 millimeters or larger. The use of a stylet is based on personal preference. If you use a stylet, insert it into the tracheal tube, stopping at least 1 centimeter from the end of the tube. A stylet that protrudes beyond the end of the tube can damage the oral mucosa and vocal cords. With the stylet in place, bend the tracheal tube into a gentle upward curve. In some cases, bending the tube into the shape of a hockey stick is beneficial. Preparing for and performing tracheal intubation. Pediatric patients should be pre-oxygenated, but not hyperventilated, with a bag mask device and 100% supplemental oxygen for at least 30 seconds before you attempt intubation using the squeeze, release technique. Adequate pre-oxygenation cannot be overemphasized because respiratory failure or arrest is the most common cause of cardiopulmonary arrest in the pediatric population. During this time, you must also ensure that the child's head is in the proper position, the neutral position for patients with suspected spinal trauma or the sniffing position for patients without trauma. Insert an airway adjunct if one is needed to ensure adequate ventilation. Stimulation of the parasympathetic nervous system with resultant bradycardia can occur during intubation in children, therefore, you should apply a cardiac monitor. A pulse oximeter should be used throughout the intubation attempt to monitor the child's oxygen saturation. In addition, suction should be readily available to clear oral secretions from the child's airway. Atropine sulfate was once routinely advocated as a pre-treatment prior to pediatric intubation. While this is no longer the case, a dose of 0.02 mg per kilogram, minimum dose of 0.1 mg, may be considered administered to prevent vagal-induced bradycardia secondary to parasympathetic stimulation. Consult your local or regional protocols to determine if and when atropine pretreatment is indicated. To perform tracheal intubation in an infant or a child, follow the steps listed in Skill Drill 44-4. Skill Drill 44-4. Performing pediatric tracheal intubation. Step 1. Wear personal protective equipment, gloves and face shield at a minimum. Step 2. Check, prepare, and assemble your equipment. Step 3. Measure the length of the child using a length-based resuscitation tape to aid in determining needed equipment sizes. Step 4. Manually open the patient's airway. Step 5. Measure the proper size, and then insert an oropharyngeal or nasopharyngeal airway. Step 6. Ventilate the patient with a bag mask device at a rate of 12 to 20 breaths per minute with sufficient volume to produce visible chest rise. Attach the pulse oximeter and note the child's oxygen saturation level. Pre-oxygenate the child for at least 2 to 3 minutes with 100% oxygen. Step 7. Place the patient's head in a neutral or sniffing position, add padding as needed to achieve proper positioning. Remove the airway adjunct, then insert the laryngoscope blade in the right side of the mouth and sweep the tongue to the left. Lift the tongue with firm, gentle pressure. Avoid using the teeth or gums as a fulcrum. Step 8. Identify the vocal cords. If the cords are not yet visible, instruct your partner to perform the backward, upward, rightward pressure maneuver, if possible. Step 9. Introduce the tracheal tube in the right corner of the patient's mouth. Step 10. Pass the tracheal tube through the vocal cords to 2 to 3 cm, less in a neonate, below the vocal cords. Remove the laryngoscope from the patient's mouth. Inflate the cuff to the proper pressure, and immediately remove the syringe if a cuff tube is used. Step 11. Attach an end-tidal carbon dioxide detector, waveform capnography preferred. Attach the bag mask device, ventilate, and auscultate for equal breath sounds over each lateral chest wall high in the axilla. Ensure absence of breath sounds over the epigastrium. Assess for hypoxia during the intubation attempt. Step 12. Secure the tracheal tube with a commercial device or tape, noting the placement of the distance marker at the patient's teeth or gums. Ventilate the patient at the proper rate and volume while monitoring capnography and pulse oximetry. This is the end of Skill Drill 44-4. Although tape may be applied in several ways to secure tracheal tubes, no single method is fail-safe. One person should always hold the tube in place while another secures the device. Consider the use of a commercially manufactured tube securing device for adults and children, when possible. A critical step in tracheal intubation is confirmation of correct placement of the tube. Watch the tracheal tube pass through the vocal cords, listen for breath sounds, and document the presence of end-tidal carbon dioxide. The end-tidal carbon dioxide can be detected by using a colorimetric monitor or can be measured by capnometry. Most paramedic units use capnometry, whereas colorimetric end-tidal carbon dioxide detectors are used most commonly in the hospital setting. The colorimetric devices, which should be selected based on the weight of the child, are very accurate, even in infants and small children. The exception is in cardiac arrest, a situation in which poor perfusion may result in levels of exhaled carbon dioxide too low to be detected by these devices. If an intubated patient deteriorates, use the DOPE mnemonic, displacement, obstruction, pneumothorax, equipment failure, to identify the potential problem and institute an appropriate intervention. Complications of tracheal intubation. Frequent monitoring of proper tube placement, especially during any move of the patient, such as from the ground to the stretcher, is essential. The following clinical findings indicate immediate removal of the tracheal tube. No chest rise with ventilation. Absence of breath sounds during auscultation. Presence of epigastric gurgling sounds or vomitus in the tracheal tube. Failure to confirm proper tube position with detection devices. In a patient with spontaneous circulation, lack of color on a colorimetric device indicates esophageal intubation. In such a case, the tracheal tube should be removed, bag mask ventilation resumed for 2 minutes, and tracheal intubation reattempted. Orogastric and nasogastric tube insertion. During positive pressure ventilation, it is common to inflate the stomach, as well as the lungs, with air. Gastric distension impairs downward movement of the diaphragm, and decreases tidal volume, making ventilation more difficult and necessitating higher inspiratory pressures. It also increases the risk that the patient will vomit and aspirate stomach contents into the lungs. Placement of a nasogastric tube or an orogastric tube decompresses the stomach, and makes assisted ventilation easier. Gastric decompression with a nasogastric or orogastric tube is contraindicated in unresponsive children with a poor or absent gag reflex and an unsecured airway. Instead, you should perform tracheal intubation first to decrease the risk of vomiting and aspiration. Preparation of equipment. To perform nasogastric or orogastric tube insertion, you will need an appropriate size nasogastric or orogastric tube, a 30 to 60 milliliter syringe with a funnel-tipped adapter for manual removal of stomach contents through the tube, mechanical suction, adhesive tape, and a water-soluble lubricant. To prepare the patient and the equipment for nasogastric or orogastric tube placement, follow these steps. 1. Select the proper size tube. Use a length-based resuscitation tape to determine the proper size, or use a tube size twice the tracheal tube size that the child would need. For example, a child who needs a 5.0 mm tracheal tube requires a 10 French orogastric or nasogastric tube. 2. Measure the tube on the patient. The length of the tube should be the same as the distance from the lips or tip of the nose, depending on whether the orogastric or nasogastric route is used, to the earlobe plus the distance from the earlobe to the xiphoid process. 3. Mark this length on the tube with a piece of tape. When the tip of the tube is in the stomach, the tape should be at the lips or nostril. 4. Place the patient in a supine position. 5. Assess the gag reflex. If the patient is unresponsive and has a poor or absent gag reflex, perform tracheal intubation before gastric tube placement. 6. In a trauma patient, maintain in-line stabilization of the cervical spine if a neck injury is possible. Choose the orogastric route of insertion if the patient has a severe head or midfacial injury. 7. Lubricate the end of the tube. Nasogastric tube insertion. Follow these steps to insert a nasogastric tube in an infant or child. 1. Insert the tube gently through the nostril, directing the tube straight back. Do not angle the tube superiorly. 2. If the tube does not pass easily, try the opposite nostril or a smaller tube. Never force the tube. 3. Advance the tube into the stomach. 4. If nasogastric passage is unsuccessful, use the orogastric approach. Orogastric tube insertion. Follow these steps to insert an orogastric tube in an infant or child. 1. Insert the tube over the tongue, using a tongue blade, if necessary, to facilitate insertion. 2. Advance the tube into the hypopharynx, then insert it rapidly into the stomach. 3. If the child begins coughing or choking or has a change in voice, immediately remove the tube, it may be in the trachea. Assessing placement of orogastric and nasogastric tubes. Follow these steps to confirm successful placement of a nasogastric or orogastric tube. 1. Check tube placement by aspirating stomach contents. Use a syringe with an appropriate adapter to quickly instill 10 to 20 milliliters of air through the tube while auscultating over the left upper quadrant. If you hear a rush of air, or gurgling, over the stomach, the placement is correct. 2. If correct placement cannot be confirmed, remove the tube. 3. Secure the tube to the bridge of the nose or to the cheek, using adhesive tape. 4. Aspirate air from the stomach, using a 30 to 60 milliliter cannula-tipped syringe, or connect the tube to mechanical suction at a low, continuous suction of 20 to 40 millimeters of mercury or to the intermittent setting. Complications of orogastric or nasogastric tube insertion. As with tracheal intubation, you must be aware of the potential complications associated with the placement of a nasogastric or orogastric tube, placement of the tube into the trachea, resulting in hypoxia, vomiting and aspiration of stomach contents, airway bleeding or obstruction, and passage of the tube into the cranium. The last complication can occur if you insert a nasogastric tube into a patient with severe head or midfacial trauma because the tube may be passed through the fracture and into the brain. Cardiovascular emergencies. Cardiovascular emergencies are relatively rare in children. When such problems arise, they are often related to volume or infection rather than a primary cardiac cause. Through the pediatric assessment triangle and primary assessment, you can quickly identify a cardiovascular emergency, understand the likely cause, and institute potentially life-saving treatment. General assessment and management. As with all pediatric emergencies, when called to a scene for a suspected cardiac complaint, begin the hands-off assessment by using the pediatric assessment triangle, and then move on to the initial assessment using the airway, breathing, and circulation. The child's appearance gives an overview of perfusion, oxygenation, ventilation, and neurologic status. For a suspected cardiovascular problem, an abnormal appearance may indicate inadequate brain perfusion, and the need for rapid intervention. Tachypnea, without retractions or abnormal airway sounds, is common in an infant or child with a primary cardiac problem. It is a mechanism for blowing off carbon dioxide to compensate for metabolic acidosis related to poor perfusion. In contrast, when cardiac compromise progresses to heart failure, pulmonary edema leads to increased work of breathing and a fast respiratory rate. The presence of pallor, cyanosis, or mottling may tip you off to this problem. For suspected cardiovascular compromise, start with airway and breathing, and provide supportive care as needed. Ensure adequate oxygenation and ventilation, and then assess the circulation by checking heart rate, pulse quality, skin color, temperature, and condition, and blood pressure when possible. Combine information from the pediatric assessment triangle and primary assessment to make an initial decision about the likely underlying cause, the patient's priority, and the need for immediate treatment or transport. If you're determined that the patient's condition is stable enough for you to continue the assessment on site, continue with the sample history and the focused physical examination. Table 44-14 reviews key elements of a cardiovascular sample history. Repeat the pediatric assessment triangle and airway, breathing, and circulation after each intervention, and monitor trends over time. Shock. Shock is defined as inadequate delivery of oxygen and nutrients to tissues to meet metabolic demand. The types of shock that you may encounter are the same in adults and children: hypovolemic, distributive, obstructive, and cardiogenic. Besides determining the cause of shock, you must quickly determine whether the child is in a compensated or decompensated state. In compensated shock, although the child has critical abnormalities of perfusion, his or her body is, for the moment, able to mount a physiologic response to maintain adequate perfusion to vital organs by shunting blood from the periphery, increasing the heart rate, and increasing the vascular tone. A child in compensated shock will have a normal appearance, tachycardia, and signs of decreased peripheral perfusion, such as cool extremities with prolonged capillary refill. Timely intervention is needed to prevent a child in compensated shock from decompensating. Decompensated shock is a state of inadequate perfusion in which the body's own mechanisms to improve perfusion are no longer sufficient to maintain a normal blood pressure. By definition, a child in decompensated shock will be hypotensive for his or her age, see Table 44-6. In addition to being profoundly tachycardic and showing signs of poor peripheral perfusion, a child in decompensated shock may have an altered appearance, reflecting inadequate perfusion of the brain. Because children typically have strong cardiovascular systems, they are able to compensate for inadequate perfusion by increasing heart rate and peripheral vascular resistance more efficiently than adults. Hypotension is, therefore, a late and ominous sign in an infant or a young child, and urgent intervention is needed to prevent cardiac arrest. Initial management involves allowing the child to assume a position of comfort and starting supplemental oxygen. After completing the primary assessment, make a transport decision based on the severity of the problem. Start resuscitation on scene for any child who shows signs of decompensated shock. Although rapid transport is imperative, the risk of deterioration to cardiac arrest is too high to permit a load-and-go approach. Hypovolemic shock. Hypovolemia is the most common cause of shock in infants and young children, with loss of volume occurring due to illness or trauma. Because of their relatively small blood volume, 70 milliliters per kilogram body weight, a combination of excessive fluid losses and poor intake in an infant or a young child with gastroenteritis, stomach flu, can result in shock relatively quickly. The same vulnerability exists with hemorrhage from trauma. A patient with hypovolemic shock will often appear listless or lethargic and may have compensatory tachypnea. The child may appear pale, mottled, or cyanotic. In medical shock, further assessment may identify signs of dehydration such as sunken eyes, dry mucous membranes, poor skin turgor, or delayed capillary refill with cool extremities. In an injured child, the site of bleeding may be identified on the primary assessment or detailed physical examination. Allow the child to remain in a position of comfort, administer supplemental oxygen, and keep the child warm. Apply direct pressure to stop any external bleeding. Volume replacement is the mainstay of treatment for hypovolemic shock, whether medical or traumatic in origin. If the child is in compensated shock, you can attempt to establish intravenous or intraosseous access en route to the hospital. As with all procedures, gather all the equipment necessary before beginning this step. Catheters, preferably an over-the-needle catheter, are available in pediatric sizes of 20, 22, and 24 gauge. A butterfly needle is a temporary alternative if an over-the-needle catheter is unavailable. This stainless steel needle stays in the vein, predisposing it to infiltration. Many of the sites used for intravenous access in adults are the same for children. The most commonly used sites are the dorsum of the hand and the antecubital fossa. In children, veins in the foot may also be used. Scalp veins and the external jugular veins are used less commonly. The procedure for establishing intravenous access is as follows. 1. Check the intravenous fluid for proper fluid, clarity, and expiry date. Look for any discoloration or particles floating in the fluid. If any are found, discard and choose another bag of fluid. 2. Select the appropriate equipment, including a needle, syringe, saline, and extension set. A 3-way stopcock may also be used to facilitate easier fluid administration. 3. Select the proper administration set. Connect the administration set to the bag. Prepare the administration set. Fill the drip chamber, and flush the tubing. Make sure no air bubbles remain in the tubing. 4. Prepare the syringe and extension tubing. 5. Tear the tape before venipuncture, or have a commercial device available. 6. Use appropriate personal protective equipment. This must be done before the intravenous puncture. 7. Select the vein that you will use. 8. Secure the appropriate limb to minimize movement during the procedure. 9. Apply a constricting band proximal to the selected site. 10. Clean the site with alcohol using aseptic technique. 11. Insert the catheter through the skin at an angle of approximately 45 degrees with the bevel facing upward. 12. Advance the needle with the catheter until you see blood return into the hub. 13. Continue to gently advance the catheter over the needle into the vein until the hub of the catheter is flush with the skin. 14. Completely remove the needle and attach intravenous tubing. 15. Flush the catheter with saline. Note if the line is easily flushed or if there is resistance. Resistance may mean that the catheter has infiltrated the vein. Carefully look at the surrounding skin for infiltration of fluids. If the line is infiltrated, remove it. 16. Dispose the needle in the proper container. Once intravenous access is established, any fluid resuscitation should begin with isotonic fluids only, such as normal saline or lactated Ringer solution. Begin with 20 milliliters per kilogram of isotonic fluid, and then reassess the patient's status. The use of warm intravenous fluids, when possible, can counteract the effects of systemic hypothermia from environmental exposure, blood loss, or open wounds. Multiple fluid boluses may be necessary during transport. Volume resuscitation should be addressed separately from treatment of hypoglycemia. In a child with shock due to medical illness, perform a bedside glucose check. Treat with dextrose-containing fluid only for a documented low blood glucose level. Hypoglycemia is unlikely in shock due to acute injury. If a child is in decompensated shock with hypotension, begin initial fluid resuscitation at the scene. Make one attempt at intravenous access. If it is unsuccessful, begin intraosseous infusion. When an intraosseous needle is placed correctly, it will rest in the medullary canal, the space within the bone that contains bone marrow. An intraosseous infusion is contraindicated if a secure intravenous line is available or if a fracture, or possible fracture, exists in the same bone in which you plan to insert the intraosseous needle. Anything that can be administered intravenous can be administered through an intraosseous line, such as isotonic fluids and medications. The intraosseous needles are usually double needles, consisting of a solid bore needle inside a sharpened hollow needle. This double needle is pushed into the bone, usually the proximal tibia, with a screwing, twisting action. Once the needle pops through the bone, the solid needle is removed, leaving the hollow steel needle in place. Standard intravenous tubing is attached to this catheter. The intraosseous lines require full and careful immobilization because they rest at a 90 degrees angle to the bone, and are easily dislodged. If the needle is wobbly, it has been dislodged and can no longer be used. Stabilize the intraosseous needle, thereby ensuring adequate flow, in the same manner that you would any impaled object. As with any invasive procedure, several complications may be associated with intraosseous infusion: compartment syndrome, failed infusion, growth plate injury, bone inflammation caused by infection, osteomyelitis, skin infection, and bony fracture. Proper technique will help to minimize these complications. Follow the steps in Skill Drill 44-5 to establish an intraosseous infusion in pediatric patients. Skill Drill 44-5. Pediatric intraosseous infusion with standard needle. Step 1. Check that the selected intravenous bag is the proper fluid. Check for clarity and expiry date. Look for any discoloration or particles floating in the fluid. If any are found, discard and choose another bag of fluid. Select the appropriate equipment, including an intraosseous needle, syringe, saline, and extension set. A three-way stopcock may also be used to facilitate easier fluid administration. Step 2. Select the proper administration set. Connect the administration set to the bag. Prepare the administration set. Fill the drip chamber, and flush the tubing. Ensure no air bubbles remain in the tubing. Prepare the syringe and extension tubing. Step 3. At any time before the intraosseous puncture, cut or tear the tape, and prepare bulky dressings. Before the intraosseous puncture, take standard precautions. Identify the proper anatomic site for intraosseous puncture. To miss the epiphyseal growth plate, you should measure 2 finger breadths below the tibial plateau on the medial side of the leg. Step 4. Cleanse the site using aseptic technique, that is, in a circular manner from the inside out. Stabilize the tibia. Place a folded towel under the knee, and hold it so that you keep your fingers away from the puncture site. Insert the needle at a 90 degrees angle to the leg. Advance the needle with a twisting motion until you feel a pop. Step 5. Unscrew the cap, and remove the stylet from the needle. Step 6. Remove the stylet from the catheter. Attach the syringe and extension set to the intraosseous needle. Pull back on the syringe to aspirate blood and particles of bone marrow to ensure placement. If you are not able to aspirate marrow but the intraosseous flushes easily with no signs of infiltration, swelling around insertion site, and the needle is not wobbly, then continue to flush. Slowly inject saline to ensure proper placement of the needle. Watch for infiltration, and stop the infusion immediately if any is noted. It is possible to fracture the bone during insertion of the intraosseous. If this happens, you should remove the intraosseous needle and switch to the other leg. Connect the administration set and adjust the flow rate. Fluid does not flow well through an intraosseous needle, and boluses are given by administering the fluid using the syringe and a 3-way stopcock. Step 7. Secure the needle with tape, and support it with a bulky dressing. Be careful not to tape around the entire circumference of the leg, which could impair circulation and create compartment syndrome. Dispose of the needle in the proper container. If using an EZ-IO or similar device, follow the manufacturer's instructions to ensure correct insertion. This is the end of skill drill 44-5. As with intravenous administration, administer 20 ml per kilogram boluses of isotonic fluid via intraosseous infusion to treat hypovolemia, reassessing after each bolus, and repeating as needed based on physiologic response. As much as 60 ml per kilogram may be needed during transport to improve the child's blood pressure, pulse rate, mental status, and peripheral perfusion. Rapidly transport the patient to an appropriate treatment facility. Distributive shock. In distributive shock, decreased vascular tone develops, resulting in vasodilation and third spacing of fluids due to increased vascular permeability, leakage of plasma out of the blood vessels, and into the surrounding tissues. This results in a drop in effective blood volume, and functional hypovolemia. Distributive shock may be due to sepsis, anaphylaxis, and spinal cord injury. Sepsis accounts for the bulk of pediatric cases. Early in distributive shock, the child may have warm, flushed skin and bounding pulses as a result of peripheral vasodilation. In contrast, the symptoms and signs of late distributive shock will look much like hypovolemic shock on initial assessment. Fever is a key finding in septic shock, whereas urticarial rash and wheezing may be noted in anaphylaxis, and neurologic deficits, and a relatively low heart rate are apparent in shock due to spinal cord injury. First-line treatment of distributive shock is volume resuscitation because the child is in a state of relative hypovolemia. In a child with apparent sepsis who remains persistently hypotensive despite a total of 60 ml per kilogram of isotonic fluid, vasopressor support to improve vascular tone may be considered. Anaphylactic shock should be treated immediately with intramuscular epinephrine, 0.01 mg per kilogram of 1 to 1000 solution, maximum dose, 0.3 mg. This dose should be repeated as necessary every 5 minutes. If several doses are needed, the child may require a low-dose, continuous epinephrine intravenous drip. The decision about timing of intravenous access and transport for distributive shock considers the same factors as for hypovolemic shock. Obstructive shock. In obstructive shock, there is impaired filling of the heart, thus reduced cardiac output. This can be due to an extrinsic pressure on the heart, for example, cardiac tamponade or tension pneumothorax, or from downstream pressure on the right ventricle, for example, pulmonary embolism. A child with obstructive shock usually has a history of abrupt onset of symptoms of shock and/or a history of trauma to the chest. The child will exhibit signs of shock, with maximal vasoconstriction to maintain blood pressure. They will also have signs specific to the underlying cause, such as asymmetric chest rise, and absent breath sides on the side of a tension pneumothorax, or muffled heart sounds, and an elevated jugular venous pressure in cardiac tamponade. As with hypovolemic shock, initial therapy is fluid resuscitation. However, definitive therapy is aimed at treating the cause as soon as possible, that is, needle decompression of the chest for a tension pneumothorax, or pericardiocentesis for tamponade if paramedic scope and local or regional protocols permit. Cardiogenic shock. Cardiogenic shock is the result of pump failure. Intravascular volume is normal, but myocardial function is poor. This type of shock is uncommon in the pediatric population but may be present in children with underlying congenital heart disease, myocarditis, or rhythm disturbances. It is important to recognize cardiogenic shock by the child's history and from the initial assessment because the treatment for this type of shock is very different from that for hypovolemic or distributive shock. A child in cardiogenic shock will appear listless or lethargic, like children in hypovolemic or distributive shock, but is likely to show signs of increased work of breathing owing to heart failure and pulmonary edema. Circulation will be impaired, and skin will look pale, mottled, or cyanotic. Your initial assessment may reveal an abnormal heart rate or rhythm, or a murmur or gallop. The child's skin may feel clammy, and you may palpate an enlarged liver. The caregiver may describe the infant sweating with feeding and, in many cases, will recount a history of congenital heart disease. If you suspect cardiogenic shock, allow the child to remain in a position of comfort, often sitting upright, administer supplemental oxygen, and transport. The transport destination is a critical decision because the ultimate management requires pediatric critical care capability. Supplemental oxygen may not increase the pulse oximetry in children with particular types of congenital heart disease, and parents or caregivers will often alert you to this fact. Consider establishing intravenous access en route to the receiving facility. Unless you are sure of the diagnosis of cardiogenic shock, the child has a history of congenital heart disease, is afebrile, and has no history of volume loss, err on the side of fluid resuscitation. If you suspect cardiac dysfunction, administer a single isotonic fluid bolus slowly, and monitor carefully to assess its effect. Increased work of breathing, a drop in oxygen saturation, or worsening perfusion after fluid administration will confirm your suspicion of cardiogenic shock, and will persuade you not to give more fluid. Although inotropic agents may be needed to improve cardiac contractility and improve perfusion, they are rarely administered in the pre-hospital environment. Dysrhythmias. Rhythm disturbances can be classified based on whether the heart rate is too slow, bradydysrhythmias, too fast, tachydysrhythmias, or absent, pulseless. The signs and symptoms associated with a rhythm disturbance are often nonspecific. For example, the patient or caregiver may report fatigue, irritability, vomiting, chest or abdominal pain, palpitations, and shortness of breath. If you suspect a rhythm disturbance, quickly move through the pediatric assessment triangle and primary assessment, supporting the airway and breathing as necessary. An electrocardiogram or rhythm strip will help to identify the underlying rhythm and suggest which specific management steps should be initiated. Address reversible causes of dysrhythmias such as hypoxemia. The decision to stay on the scene to obtain additional history and perform a focused physical examination will be dictated by the child's overall physiologic status. Bradydysrhythmias. Bradydysrhythmias in children most often occur secondary to hypoxia, rather than as a result of a primary cardiac problem, such as heart block. Airway management, supplemental oxygen, and assisted ventilation as needed are always first-line treatment. Also, treat any underlying respiratory problem. Less common causes of bradycardia include congenital or acquired heart block, and toxic ingestion of beta blockers, calcium channel blockers, or digoxin. Elevated intracranial pressure can also cause bradycardia, and should be considered in children with ventricular shunts, a history of head injury, or suspected child maltreatment without a consistent injury history. Initiate electronic cardiac monitoring as part of your initial assessment. If the child is asymptomatic, no further treatment is indicated in the pre-hospital setting. Healthy, athletic adolescents may have bradycardia as an incidental finding and should be transported to a hospital for further evaluation. If the child's pulse rate is lower than normal for age, but perfusion is poor despite providing adequate oxygenation and ventilation, begin chest compressions and ventilations, and attempt intraosseous access. The intraosseous route is preferred, ideally with a device or a method that provides rapid, reliable access to the intraosseous space. For chest compressions to be effective, the patient should be placed on a firm, flat surface with the head at the same level as the body. If you need to carry an infant while providing cardiopulmonary resuscitation, your forearm and hand can serve as the flat surface. Recommended treatment guidelines for pediatric bradycardia accompanied by poor perfusion appear in See Appendix A, Cardiac Life Support Fundamentals, for more information about infant and child cardiopulmonary resuscitation. Tachydysrhythmias. Sinus tachycardia, a pulse rate higher than normal for age, is common in children. Although it may be a sign of serious underlying illness or injury, it may also be due to fever, pain, or anxiety. Interpret the presence of tachycardia in the context of the remainder of the pediatric assessment triangle and initial assessment. For example, if a child appears well but has a fever, sinus tachycardia is likely and treatment with antipyretics is all that is necessary. If a tachycardic child has a history of copious vomiting or diarrhea, fluid resuscitation is the appropriate treatment. If a tachycardic child appears ill and has poor perfusion with no history of fever, trauma, or excessive volume loss, continue your assessment for a primary cardiac cause while initiating resuscitation. Your assessment should include determination of pulse rate along with interpretation of an electrocardiogram or rhythm strip. Recommended treatment guidelines for pediatric tachycardia accompanied by poor perfusion appear in Figure 44-21. Tachydysrhythmias are subdivided into two types based on the width of the QRS complex. A narrow complex tachycardia exists when the QRS complex is 0.09 second or less. A wide complex tachycardia exists when the QRS complex is greater than 0.09 second. Narrow complex tachycardia. Although sinus tachycardia is the most common dysrhythmia in children, supraventricular tachycardia is the most frequent tachydysrhythmia requiring antidysrhythmic treatment. Table 44-15 compares sinus tachycardia, supraventricular tachycardia, and ventricular tachycardia. You may identify sinus tachycardia based on normal P waves, heart rate variability, and history of preceding illness or injury. Its treatment is geared toward the underlying cause, and may include oxygen, fluids, splinting, and analgesia. Supraventricular tachycardia, which involves abnormal conduction pathways, can be identified by a narrow QRS complex, absent or abnormal P waves, and an unvarying pulse rate of more than 220 beats per minute in an infant or more than 180 beats per minute in a child. The child may have a history of supraventricular tachycardia or exhibit nonspecific signs and symptoms, including irritability, vomiting, and chest or abdominal pain. Parents of young infants may report poor feeding for several days. The treatment of supraventricular tachycardia depends on the patient's perfusion and overall stability. If the child is in stable condition, consider attempting vagal maneuvers while obtaining intravenous access. Have an older child hold his or her breath, blow into a straw with the end crimped over, or bear down as if having a bowel movement. In a younger child, take a large examination glove or bag filled with ice and some water and place firmly over the whole face, and hold for no more than 15 seconds. Warn caregivers before performing this maneuver, as it can appear that you are hurting the infant or young child. You can try keeping the mouth uncovered, but there is less chance of success. Attempt these techniques only once, while continually monitoring the child's rhythm. If the child has adequate perfusion, and vagal maneuvers do not succeed in converting supraventricular tachycardia to a sinus rhythm, consider administering adenosine, 0.1 mg per kilogram. Adenosine has a short half-life and must be injected quickly into a vein near the heart, usually an antecubital vein. The best way to achieve rapid infusion is by connecting the adenosine to one port of a three-way stopcock, and a saline flush to another port. The saline flush can be pushed instantly following the adenosine. Its administration will be followed by a brief run of bradycardia, ventricular tachycardia, ventricular fibrillation, or asystole, which will convert spontaneously to sinus rhythm. Persistence of any of these rhythms is rare, but be prepared to switch dysrhythmia algorithms if necessary. For a child with supraventricular tachycardia who has poor perfusion, synchronized cardioversion is recommended. Synchronized cardioversion is the timed administration of electrical energy to the heart to correct a dysrhythmia. If the child is generating a regular but ineffective rhythm, it is important to time the jolt of electricity with the appropriate phase of the electrical activity, corresponds with the R wave on an electrocardiogram. A burst of electricity to the myocardium during the relative refractory period, the downward slope of the T wave, can precipitate ventricular fibrillation, a potentially lethal effect. Follow the same steps with synchronized cardioversion as with defibrillation, except that you must press the sync button on the defibrillator to alert the machine to time the electrical jolt. The dose of the initial synchronized cardioversion attempt is 0.5 to 1.0 joule per kilogram of body weight. If the first dose is unsuccessful, a repeated dose of 2 joules per kilogram can be given. In the hospital setting, sedation is provided before cardioversion, but its administration must not delay the procedure in a child in unstable condition. The survival rate for children in ventricular fibrillation or ventricular tachycardia arrest is slightly better than in adults, and, as in adults, depends on early defibrillation. An alternative approach to treating the child in supraventricular tachycardia with poor perfusion is to give a dose of intravenous adenosine if vascular access is readily available. Do not delay synchronized cardioversion if vascular access is not already established, however. If the child remains in supraventricular tachycardia, and is in unstable condition or shock or is unresponsive, you may give additional antidysrhythmic medications in conjunction with cardiology consultation. Wide complex tachycardia. A child with a wide QRS complex tachycardia with a palpable pulse is likely in ventricular tachycardia, a rare, but potentially life-threatening rhythm in children. Its presence may reflect underlying cardiac pathology. Supraventricular tachycardia may sometimes manifest as a wide complex rhythm, and distinguishing between the two can be challenging. A trial dose of adenosine, 0.1 mg per kilogram, is appropriate in case the rhythm is supraventricular tachycardia. If a child with suspected ventricular tachycardia is in hemodynamically stable condition, and intravenous access is available, consider giving antidysrhythmic medication. Amiodarone is the drug of choice for ventricular tachycardia with a pulse, although procainamide is an acceptable alternative. Do not give amiodarone and procainamide because both prolong the QT interval. If a child with ventricular tachycardia is in unstable condition or shock or is unresponsive but has a pulse, the treatment is synchronized cardioversion. Prior sedation is ideal, but do not delay cardioversion for this reason. The same dose of synchronized cardioversion is used for supraventricular tachycardia and ventricular tachycardia. If a child with a tachydysrhythmia is or becomes pulseless, begin cardiopulmonary resuscitation, and follow the pulseless arrest treatment guidelines. Prepare to immediately transport any child with a dysrhythmia to an appropriate receiving facility. Copies of rhythm strips or electrocardiogram tracings will be helpful to hospital personnel for diagnostic and therapeutic purposes. Pulseless arrest. Cardiopulmonary arrest exists when the child is unresponsive, apneic, and pulseless. In children, this type of dysrhythmia is usually a secondary event, that is, the end result of profound hypoxemia and acidosis owing to respiratory failure. Asystole is the most common arrest rhythm. Pulseless electrical activity, ventricular tachycardia, and ventricular fibrillation are seen with lower frequency in children than in adults. The survival rate for children with asystolic arrest in the pre-hospital setting is poor, and few survivors have good neurologic outcomes. When confronted with a pediatric patient in cardiopulmonary arrest, the most important consideration is to provide high-quality cardiopulmonary resuscitation. Attach a monitor or defibrillator to determine the underlying cardiac rhythm. If the rhythm is pulseless ventricular tachycardia or ventricular fibrillation, defibrillation is indicated. Additional interventions include establishing vascular access, administering epinephrine, and considering the administration of an antidysrhythmic, such as amiodarone. If the cardiac rhythm is asystole or pulseless electrical activity, defibrillation is not indicated, and additional treatment is limited to establishing vascular access and administering epinephrine. After administering the medication, perform 5 cycles of cardiopulmonary resuscitation, approximately 2 minutes, before rechecking the rhythm. If asystole or pulseless electrical activity persists, continue with cardiopulmonary resuscitation and epinephrine. The steps for managing the pediatric patient in cardiac arrest follow the pediatric cardiac arrest algorithm. Appendix A, Cardiac Life Support Fundamentals, covers providing cardiopulmonary resuscitation to pediatric patients in detail. Medical emergencies. Approximately 1/2 of all pre-hospital calls for pediatric patients are trauma-related, the other half are medical. Medical calls may include respiratory complaints, as previously discussed in this chapter, fever, seizures, and altered level of consciousness. Fever. Fever is a common pediatric complaint, but often not a true medical emergency. A symptom of an underlying infectious or inflammatory process, fever can have multiple causes. Most pediatric fevers are caused by viral infections, which are often mild and self-limiting. In other cases, fever is a symptom of a more serious bacterial infection. Your general impression and initial assessment will help you determine the severity of illness. Remember that young children with a fever can look quite ill, even if they only have a bug, because increased body temperature causes increased metabolism, tachycardia, and tachypnea. Record temperature as part of the vital signs, but recognize that the height of the fever does not reflect the severity of the illness. If the patient is a young infant, a rectal temperature is most accurate, but recognition that fever is present is more important than the exact temperature. As you move through the initial assessment, look for signs of respiratory distress, shock, seizures, stiff neck, petechial or purpuric rash, or a bulging fontanelle in an infant. These signs may tip you off to the presence of pneumonia, sepsis, or meningitis, all of which can be life-threatening and require prompt transport to an appropriate facility. Young infants, younger than 2 months, should always be considered at risk for serious infection. Young infants have few ways of interacting with the world, and a fever, defined as body temperature greater than 38 degrees Celsius, may be the only sign of a potentially life-threatening illness. Regardless of how well a young infant looks, he or she should be assessed and transported quickly to a hospital. Febrile infants who are less than 1 month old will receive a full sepsis workup, including blood, urine, and cerebral spinal fluid analysis. Newborns and young infants can also present in hypothermia when they have infection. The focused history and physical examination will help to determine the underlying cause of the fever and the severity of illness. Perform this assessment on the scene if the child is in stable condition or en route to the hospital if the child appears seriously ill. Ask about the presence of vomiting, diarrhea, poor feeding, headache, neck pain or stiffness, and rash. A history of infectious exposure may provide clues to the likely cause of the child's current illness. The focused medical history may also identify a child at high risk for serious bacterial illness. For example, sickle cell disease, autoimmune conditions, and childhood cancers may all lead to an immunocompromised state. A child with a fever may require little intervention in the pre-hospital environment. Simply support the airway, breathing, and circulation as needed. Although fever by itself is not dangerous, temperature control will make the child with a minor acute illness look and feel better. Consider treating with acetaminophen or ibuprofen, but avoid aspirin in children. Use of aspirin in children has been linked with a rare illness called Reye syndrome, which can result in cerebral edema and liver failure. Other cooling measures should be limited to undressing the child. Transport the patient to an appropriate medical facility with ongoing reassessment for clinical deterioration. Meningitis. Meningitis entails inflammation or infection of the meninges, the covering of the brain, and spinal cord. It is most often caused by a viral or bacterial infection. Although children may look and feel quite ill, viral meningitis is rarely a life-threatening infection. By contrast, bacterial meningitis is potentially fatal. Children with bacterial meningitis can progress rapidly from mildly ill-appearing to coma, and even death. In the early stages of illness, it is difficult to tell which type of infection is present, so take the safe route. Always proceed as if the child may have bacterial meningitis. The symptoms of meningitis vary depending on the age of the child, and the agent causing the infection. In general, the younger the child, the vaguer the symptoms. A newborn with early bacterial meningitis may have fever as the only symptom. Young infants will often have fever, and perhaps localizing signs such as lethargy, irritability, poor feeding, and a bulging fontanelle. Young children rarely show typical meningeal signs such as nuchal rigidity, neck stiffness with movement of the neck. Verbal children will often report headaches, photophobia, light sensitivity, and neck pain. An altered level of consciousness and seizures are ominous symptoms at any age. Neonates most often contract meningitis-causing bacteria during the birthing process. The bacteria that may be present in the mother's vaginal tract, Escherichia coli, group B Streptococcus, and Listeria monocytogenes, can produce serious infections in newborns. Older infants and young children are at risk for contracting viral meningitis from enteroviruses, which are widespread during the summer and fall. Bacterial meningitis in older age groups most often involves Streptococcus pneumoniae, also known as pneumococcus, and Neisseria meningitidis, also known as meningococcus. Pneumococcus infection is becoming less frequent as more young children are vaccinated against this bacterium. Meningitis from H. influenzae is also rare because a vaccine against a strain of this pathogen was introduced in the 1990s. Neisseria meningitidis may also cause sepsis, an overwhelming bacterial infection in the bloodstream, called meningococcemia. Meningococcal meningitis with sepsis is typically characterized by a petechial, small, purple, non-blanching spots on the skin, or purpuric, larger purple or black spots, rash in addition to the other symptoms of meningitis. Infection control is an important part of managing a child who may have meningitis. Meningococcus, in particular, is quite contagious. Protect yourself and others from contracting this illness by being vigilant about using standard and respiratory precautions. Wear a gown, gloves, and a mask with an eye shield if meningitis is a possibility, and remember to place a mask on the patient. Children with meningococcal sepsis and meningitis get very sick, very fast, so move quickly through your assessment. Form your general impression, and perform the primary assessment as usual, while recognizing that the initial presentation of a child with meningitis can be highly varied. Look for fever, altered mental status, bulging fontanelle, photophobia, nuchal rigidity, irritability, petechiae, purpura, and signs of shock. Perform a bedside glucose check because hypoglycemia may result from the hypermetabolic state. Helpful components of a sample history are shown in Table 44-16. For children in physiologically unstable condition, provide life-saving interventions as needed and transport them quickly, ideally to a facility with a pediatric intensive care unit. En route, perform frequent reassessments. One of the hallmarks of this disease is rapid deterioration. Monitor vital signs and changes in physical examination findings closely to anticipate a child's needs, and intervene early. Patients with meningococcemia often require a significant amount of fluid to maintain an adequate blood pressure. Altered level of consciousness and mental status. An altered level of consciousness or mental status is an abnormal neurologic state in which a child is less alert and interactive with the environment than normal. Recall from Chapter 31, Neurologic Emergencies, that the mnemonic AEIOU tips, alcohol or acidosis, epilepsy, insulin, overdose, uremia, trauma, infection, psychosis, and stroke, can be used to highlight some common causes of altered level of consciousness. Without a good history, it may be difficult to determine the underlying cause, and you may find yourself simply identifying and treating concerning symptoms. Run through the pediatric assessment triangle and airway, breathing, and circulation quickly to determine possible points of intervention. Pay special attention to possible disability and dextrose issues. Use of POO to identify the level of disability. In addition, check the patient's glucose level because hypoglycemia, defined as a serum glucose concentration less than 2.2 millimoles per liter in a newborn and less than 3.3 millimoles per liter in all other infants and children, is easily treatable. The focused history and physical examination, whether performed at the scene or en route to the hospital, may also provide clues about the underlying cause. For example, a child with a history of epilepsy may be in a postictal state after an unwitnessed seizure. A child with diabetes may be hypoglycemic or in diabetic ketoacidosis. A history of toxic ingestion, recent illness, or injury may also reveal the cause of the altered mental status. Regardless of the cause, the initial management of altered mental status is the same. Support the airway, breathing, and circulation by carefully assessing the patient's airway and breathing. Provide assisted ventilation or airway support as needed. If the child is hypoglycemic, give glucose using 2 ml per kilogram intravenously of a 25% dextrose solution for infants and young children. Use 5 ml per kilogram of a 10% dextrose solution for neonates. Neonates do not tolerate hypertonic solutions and should not receive a dextrose solution greater than 10%. Always recheck the blood glucose level after giving intravenous glucose. The goal is to maintain a normal glucose level. Hyperglycemia is associated with worse neurologic outcomes in patients with cerebral ischemia. For children with altered mental status and signs or symptoms suggestive of an opiate toxidrome, consider giving naloxone. Toxidromes are discussed in Chapter 36. All patients with altered mental status should be transported expeditiously to an appropriate medical facility. Seizures. Seizures result from abnormal electrical discharges in the brain. Although many types of seizures exist, generalized seizures manifest as abnormal motor activity and an altered level of consciousness. Some children are predisposed to seizures because of underlying brain abnormalities, whereas others experience seizures as a result of trauma, metabolic disturbances, ingestion, or infection. Seizures associated with fever, febrile seizures, are unique to young children, and are typically benign. The physical manifestation of a seizure will depend on the area of the brain firing the electrical discharges, and the age of the child. Infants have immature brains, so seizures in this age group may be subtle. Repetitive movements such as lip smacking, chewing, and bicycling suggest seizure activity. Apnea and cyanosis can result from underlying seizure activity. The prognosis following a seizure is closely linked to the underlying cause and duration. For example, a child with a febrile seizure will not have brain damage as a consequence of the event unless significantly prolonged. That is, brain damage is possible after a 30-minute seizure, whereas a child who has a seizure as a complication of a head injury or meningitis may have long-term neurologic abnormalities. All types of seizures, but especially first-time seizures, are frightening to caregivers, and they often result in 911 calls. Types of seizures. The classification system for seizures is the same for children and adults. See Chapter 31 for an in-depth discussion of seizures. Briefly, seizures that involve the entire brain are considered generalized seizures, and involve loss of awareness, whereas those that involve only one part of the brain are called focal seizures. The most common type of seizures is generalized tonic-clonic seizures, grand mal, which involve jerking of arms and/or legs. Absent seizures are generalized seizures that involve brief loss of attention without abnormal body movements. Focal seizures can be further subclassified into focal aware seizures, which involve focal motor jerking without loss of consciousness, and focal impaired awareness seizures, which feature focal motor jerking with loss of consciousness. Febrile seizures. Febrile seizures occur in about 2% to 5% of young children. To make this diagnosis, the child must be between 3 months and 6 years old, have a fever, and have no identifiable precipitating cause, such as head injury, ingestion, or meningitis. Most febrile seizures occur in children between the ages of 6 months and 3 years. The strongest predictor for having a febrile seizure is a history of this diagnosis in a first-degree relative. Simple febrile seizures are brief, generalized tonic-clonic seizures, lasting less than 15 minutes, that occur in a child without underlying neurologic abnormalities. Atypical febrile seizures are longer, lasting greater than 15 minutes, are focal, or occur in a child with baseline developmental or neurologic abnormality. They may also be associated with serious illness. The majority of your calls for fever and seizures will involve simple febrile seizures. The postictal phase after a brief seizure tends to be short, so the child will often be waking up or back to baseline by the time you arrive at the scene. Depending on your agency's policy, a well-appearing child who has a history consistent with a simple febrile seizure may be transported by EMS or by parents or caregivers, but always needs urgent physician evaluation. The prognosis for children with simple febrile seizures is excellent. Although 1/3 of children who have one simple febrile seizure will have another such seizure, their prognosis does not change. There is little to suggest a relationship between simple febrile seizures and brain damage or future developmental or learning disabilities, and children with this diagnosis have only a slightly increased risk for subsequent development of epilepsy. Assessment of seizures. The general impression and primary assessment of a child with a history of seizures should give special attention to compromised oxygenation and ventilation and signs of ongoing seizure activity. Seizures place a child at risk for respiratory distress or failure because of airway obstruction, often from the tongue, aspiration, or depressed respiratory drive. Given the typical EMS response time, any child who is still having a seizure when you arrive has likely been having seizure activity for at least 10 minutes, and should be considered to be in status epilepticus. Initiate treatment to stop the seizure in such cases. Status epilepticus is defined as a condition in which seizures recur every few minutes, or last more than 20 to 30 minutes. Refer to your regional protocols for guidelines related to how long a seizure can continue before you should intervene. As part of your sample history, ask about prior seizures, anticonvulsant medications, recent illness, injury, or suspected ingestion, duration of the seizure activity, and the character of the seizure. Treatment of seizures. Treatment at the scene will be limited to supportive care if the seizure has stopped by your arrival, but status epilepticus requires more extensive intervention. For a child with ongoing seizure activity, open the airway using the head tilt chin lift or jaw thrust maneuver. Proximal airway obstruction is common during a seizure or postictal state because the tongue and jaw fall backward owing to the decreased muscle tone associated with altered mental status. If the airway is not maintainable with positioning, consider inserting a nasopharyngeal airway. Suction for secretions or vomitus, and consider the lateral decubitus position in case of ongoing vomiting. Do not attempt to intubate during an active seizure because tracheal intubation in this setting is associated with serious complications, and is rarely successful. More appropriate care includes using basic life support airway management, stopping the seizure, and then considering the child's need for advanced life support airway support. Provide 100% supplemental oxygen to the patient, and start bag mask ventilation as indicated for hypoventilation. Consider placing a nasogastric tube to decompress the stomach if the patient requires assisted ventilation. Assess the child for intravenous sites. Measure the serum glucose level, and treat any documented hypoglycemia. Consider your options for anticonvulsant administration. Insertion of an intravenous line can be difficult in a child having a seizure, and alternative routes for medication delivery may be needed. The goal of medical therapy is to stop the seizure while minimizing anticonvulsant side effects. First-line anticonvulsant treatment consists of a benzodiazepine, lorazepam, diazepam, or midazolam. All benzodiazepines can cause respiratory depression, so monitor oxygenation and ventilation carefully, especially when you give repeated doses or combinations of anticonvulsants. Lorazepam is an excellent choice for seizure management because of its rapid onset, lower risk of respiratory depression, and relatively long half-life. Its usefulness in the pre-hospital environment is limited because it must be refrigerated. Diazepam is sometimes used in the pre-hospital setting, given by the intravenous or rectal route. The advantages of rectal administration include ease of access, and a lower rate of respiratory depression, although onset of action is longer, approximately 5 minutes. Midazolam may be administered by the intravenous, intraosseous, intramuscular, and intranasal, using an atomizer, routes. Although it has excellent anticonvulsant effects, it has the shortest duration of action of the 3 benzodiazepines mentioned. Be prepared to repeat dosing for recurrent seizures. If the seizures do not stop after 2 or 3 doses of a benzodiazepine, 5 minutes apart, a second-line agent is necessary. Phenobarbital is the second-line agent of choice for neonates. Phenobarbital, phenytoin, and fosphenytoin are acceptable second-line agents for infants and children outside of the neonatal age group. Phenobarbital has sedative effects and causes respiratory depression, so be vigilant if you give it after a benzodiazepine. Although phenytoin has the advantage of not compromising the respiratory system or causing sedation, it is difficult to administer and can cause hypotension and bradycardia. Fosphenytoin, a drug that is metabolized to phenytoin, allows for more rapid infusion with fewer side effects. It may be administered by the intravenous or intramuscular route. Any child with a history suggestive of seizures requires physician evaluation to look for the cause. Although treatment at the scene is appropriate for a child in status epilepticus, detailed assessment should be performed during transport. Monitor cardiorespiratory status in any postictal child, and reassess frequently for recurrent seizure activity. Toxicology emergencies. Toxic exposures account for a significant number of pediatric emergencies. More than one-half of these toxic exposures occurred in children younger than 6 years, and 65%, greater than 1.5 million cases, occurred in patients younger than 20 years. Toxic exposures can take the form of ingestion, inhalation, injection, or application of a substance. See Chapter 36 for more on specific exposures. A toddler or preschool-aged child is most likely to have an unintentional exposure, the result of developmentally normal exploration. In this age group, ingestion tends to involve small quantities of a single cleaning product, cosmetic, plant, or a few pills. In contrast, toxic exposures in adolescents are typically the result of recreational drug use or suicide attempts, and often involve multiple agents. Although intentional exposures among adolescents lead to greater morbidity and mortality, in small children, the toxic effects of some medications are such that one pill can kill. Assessment. The evaluation of a child who has experienced a potentially toxic exposure follows the standard assessment sequence. Take a focused history to identify the agents to which the child was exposed, the quantity, and the route and time of exposure. Findings of your physical assessment will vary widely based on these factors. Make special note of vital signs, pupillary changes, skin temperature and moisture, and any unusual odors. Putting together these pieces of the puzzle may allow you to identify a toxidrome, a pattern of symptoms and signs typical of a particular poisoning. When performing the initial assessment, attend to airway, breathing, and circulatory support as indicated. A glucose check is an important test because ingestion of some common substances can lead to hypoglycemia, namely, ethanol, and other alcohols, insulin, oral hypoglycemic agents, and beta blockers. Treat documented hypoglycemia as part of your resuscitation. If the child is in stable condition without physiologic abnormalities, and without a serious toxic exposure, stay on scene to obtain additional history, and perform an expanded physical examination. See Table 44-18 for the sample history for a pediatric patient with a potential toxic exposure. During the expanded physical examination, look for toxidromes by assessing the patient's mental status, pupillary changes, skin color, temperature, and condition, gastrointestinal activity, bowel sounds, emesis, or diarrhea, and abnormal odors. Perform frequent reassessments because the child's condition may change. Children with potentially life-threatening toxic exposures may be asymptomatic on your arrival, and the dose of drug in an accidental toddler ingestion may be high. Always attempt to collect any pill containers or bottles, and transport them with the patient to the hospital to assist the emergency department staff in making treatment decisions. Management. The management of any potential toxic exposure begins with supportive care and attention to the airway, breathing, and circulation. Other management options include reducing the absorption of the substance by decontamination, enhancing elimination of the substance, and/or providing an antidote. Give special attention to the risks of environmental exposures for you and your crew, who may also require decontamination measures. Decontamination. If the substance has been applied to the skin, reducing absorption involves removal of all clothing, and a thorough washing of the skin. With ocular exposure, immediately wash out the eyes. For ingested toxins, options to reduce gastric absorption include dilution, gastric lavage, and activated charcoal. Depending on the substance ingested, it may be useful to dilute the substance by having the child drink a glass of milk or water. This decision should be made in conjunction with a poison center consultant or your direct medical control physician or nurse. If the child has any airway or breathing concerns, do not to allow the child to drink. Although parents were once encouraged to keep syrup of ipecac available to induce vomiting in young children, this treatment is no longer recommended. Ipecac does not remove significant amounts of ingested toxins, and can cause prolonged emesis, and it should not be used in the pre-hospital management of pediatric toxic ingestion. The most common method currently used for gastrointestinal decontamination in the emergency department setting is the administration of activated charcoal. Activated charcoal absorbs many ingested toxins in the gut, making less drug available for systemic absorption. Even if it is administered within the first hour after exposure, however, some common toxins do not bind to charcoal, for example, heavy metals, alcohols, hydrocarbons, acids, and alkalis. Activated charcoal is messy to administer and is rarely readily accepted by pediatric patients. For these reasons, as well as the risk of severe chemical pneumonia if a child with altered mental status or vomiting aspirates the charcoal, this treatment may be best given in the hospital setting. If activated charcoal is given in the pre-hospital environment, the ideal dose is 10 times the mass of the ingested substance. The amount of drug ingested is often not known, so the typical dose is 1 to 2 grams per kilogram. Enhanced elimination. Cathartics such as sorbitol are sometimes combined with activated charcoal. They work by speeding up elimination. In general, cathartics are not recommended for young children because they have been known to cause significant diarrhea with serious, sometimes life-threatening, electrolyte abnormalities. Hospital providers have additional options for enhancing elimination, such as whole bowel irrigation, urinary alkalinization for salicylate overdoses, dialysis, and hemoperfusion. Antidotes. Antidotes can be life-saving but are available for only a few poisonings. They work by reversing or blocking the effects of the ingested toxin. Table 44-19 lists some of the more commonly available antidotes. Indications for their use are the same for young children as for adults. The dose depends on the weight of the child. Sudden unexpected infant death. Sudden unexpected infant death is the death of an infant younger than 1 year that occurs suddenly and unexpectedly, the cause of which is not immediately obvious before investigation. Most sudden and unexpected infant deaths are reported as one of three types. 1. Sudden infant death syndrome, formerly known as crib death, is the sudden death of an infant younger than 1 year that cannot be explained after a thorough investigation is conducted, including a complete autopsy, examination of the death scene, and a review of the clinical history. 2. Unknown cause. The sudden death of an infant younger than 1 year may remain undetermined because one or more parts of the investigation was not completed. 3. Accidental suffocation and strangulation in bed. The sudden death of an infant younger than 1 year can happen because of suffocation by soft bedding, for example, when a pillow or waterbed covers an infant's nose and mouth, overlay, when another person rolls on top of or against the infant while sleeping, wedging or entrapment, when an infant is wedged between two objects, such as a mattress, and the wall, or strangulation, for example, when an infant's head and neck become caught between crib railings. Whatever the cause, the sudden death of an apparently healthy baby is devastating to families, and to the paramedics who respond to the call. Risk factors include male gender, prematurity, low birth weight, young maternal age, sleeping in the prone position, sleeping with soft, bulky blankets or soft objects, sleeping on soft surfaces, and exposure to tobacco smoke. Sudden infant death syndrome is the leading cause of death in infants aged 1 month to 1 year, with a peak incidence between 2 and 4 months. Each week, 3 babies in Canada die of sudden infant death syndrome. Assessment and management. The typical scenario for a sudden infant death syndrome call is that of a healthy infant who was put down for a nap, and later found dead in bed. On arrival of EMS, the baby will be lifeless and, depending on discovery time, may have rigor mortis, and dependent lividity, pooling of blood on the underside of the body. The presence of frothy or blood-tinged fluid in the mouth or nose or on the bedding is typical of sudden infant death syndrome. Be alert for clues to other potential causes of death, such as trauma, suffocation, or maltreatment. Your decision to start resuscitative efforts, or to stop cardiopulmonary resuscitation that was started by first responders or family members, can be difficult in cases of suspected sudden infant death syndrome. Your actions will be guided by local protocols on declaring death in the pre-hospital environment, and by your assessment of the patient and the needs of the family. Although a victim of sudden infant death syndrome cannot be resuscitated, failure to initiate care may not be acceptable to the shocked family. Likewise, emergency department care will not change the outcome for the infant, but hospital-based social services for the family may be an important resource. In cases that meet the criteria for declaring death at the scene, and non-transport, notify the coroner, medical examiner, or law enforcement personnel, as dictated by local protocol, so that appropriate scene investigation can be undertaken. You also have an important role in mobilizing support for the survivors, for example, a chaplain or minister, sudden infant death syndrome team, social worker, or other family members. Despite the emotionally charged atmosphere, doing a thorough scene assessment, and obtaining the pertinent history is important. A history of recent illnesses, chronic conditions, medications, or trauma may decrease the likelihood of sudden infant death syndrome as the cause of death. The presence of pillows, stuffed toys, window blind cords, or sheepskin in the baby's crib may make suffocation a possibility. Brief resolved unexplained event. A brief resolved unexplained event, formerly known as an apparent life-threatening event, is an episode during which an infant becomes pale or cyanotic, chokes, gags, or has an apneic spell, or loses muscle tone. These changes are sufficiently dramatic that the caregiver becomes frightened and may think that the baby is dying. Brief resolved unexplained events frequently prompt 911 calls. Their causes may include benign diagnoses, such as a brief episode of laryngospasm during feedings or gastroesophageal reflux, and serious diagnoses, such as sepsis, congenital heart disease, and seizures. Brief resolved unexplained events were once thought of as existing along a spectrum with sudden infant death syndrome. As such, they were called near-miss or aborted sudden infant death syndrome. More recent evidence demonstrates that although both events occur in early infancy, the two are not related. It is common to find a distraught caregiver and a well-appearing baby on arrival at the scene of a brief resolved unexplained event call. Provide life support if the infant shows signs of cardiorespiratory compromise or altered mental status, and transport all infants with a history of a brief resolved unexplained event to an appropriate medical facility for evaluation. This is a challenging age group to assess, and over-triage is the safest path. Child abuse and neglect. In 2008, there were an estimated 235,842 investigations related to child maltreatment. 36% of those cases were confirmed cases of maltreatment, or approximately 85,000 children. Child abuse or maltreatment comes in many forms: physical abuse, sexual abuse, emotional abuse, and child neglect. Physical abuse involves the infliction of injury to a child. Sexual abuse occurs when an adult engages in sexual activity with a child. It can range from inappropriate touching to intercourse. Emotional abuse and child neglect are often difficult to identify and may go unreported. Neglect is refusal or failure on the part of the caregiver to provide life necessities. Keep the possibility of child abuse in mind when you are called to assist with an injured child. The information you gather from the initial scene assessment and interviews may prove invaluable. If you suspect child abuse, you should act on your suspicions because child abuse involves a pattern of behavior. A child who is abused once is likely to be abused again, and next time, it may be more serious or even fatal. Risk factors for abuse. No child asks to be abused, but certain risk factors make maltreatment more likely. Younger children are more often abused than older children, perhaps a function of their helplessness and limited ability to communicate their needs. Children who require a lot of extra attention, such as children with physical or mental challenges, chronic illnesses, or other developmental problems, are also more likely to be abused. Child abuse occurs across all socioeconomic levels, although it is more prevalent in families at lower socioeconomic levels. Divorce, financial problems, illness, and lack of social support systems can contribute to the overall stress level of parents, placing them at higher risk to abuse their children. Drug and alcohol abuse can also interfere with a caregiver's ability to parent, and both are associated with higher rates of abusive behavior. Domestic violence in the home places a child at a much higher risk for child abuse. Suspecting abuse or neglect. When you are called to the home of an injured child, and suspect maltreatment or neglect, trust your instincts. Use your scene assessment, focused history, and physical examination to gather additional information. Look for red flags that could suggest child maltreatment, summarized in the mnemonic child abuse. A history inconsistent with the type of injury sustained, for example, a child who fell from a tree but whose bruises are only on the buttocks. An account of the injury that is inconsistent with the developmental abilities of the child, for example, a 2-month-old child rolling off a bed. An old injury that went unreported. Inappropriate actions or language from the caregiver. Assessment and management. Scene assessment. To recognize abuse, you first have to suspect it. Once you begin to question whether abuse or neglect is involved, it becomes important to carefully document what you see. Although it may be difficult to remain impartial when child abuse or neglect is suspected, it is an important part of professionalism. Record what you see and hear, but do not editorialize. Be detailed in your incident report about the child's environment, noting the condition of the home, and the interactions among the caregivers, the child, and your crew. Record concerning comments verbatim in quotes, as well as the name of the person who made the comments, and when. Do not approach the caregiver with your concerns, but make sure that you pass them on to staff at the receiving hospital. In many provinces, paramedics are mandatory reporters of suspected child maltreatment. Be aware of local regulations. You may have a legal, and an ethical, obligation to ensure that a report is made to the local child protection services. General and initial assessments. Although child abuse can generate a big emotional response from the EMS crew, remember that your primary focus should be on trauma assessment and management and on ensuring the safety of the child. Base your general impression on the pediatric assessment triangle, which may range from normal in a child with minor inflicted injuries to grossly abnormal in a child with severe internal or central nervous system injuries. In shaken baby syndrome, you may encounter a child with a very abnormal appearance but no external signs of injury. In such a case, the child receives a severe brain injury when a caregiver violently shakes the infant or young child, often when the child is crying inconsolably. Given that few caregivers will admit to having hurt the child, be alert for a history that is inconsistent with the clinical picture. Pay special attention to the child's skin while looking for bruises, especially of different ages or in concerning locations. Active toddlers often have bruises on their shins from falls and active playing, but rarely on their backs or buttocks. Bruises in identifiable patterns, such as belt buckles, looped cords, or straight lines, are rarely incurred accidentally. Figure 44-24 and Figure 44-25 are examples of bruises that are suggestive of physical abuse. Use the child abuse mnemonic when you obtain additional history. Ask yourself, does the caregiver's explanation make sense? Could this child produce this bruise or injury through his or her normal activities? Mimics of abuse. It can be difficult to distinguish some normal skin findings from inflicted injuries. For example, Mongolian spots can mimic bruises. These birthmarks are generally found on the lower back and buttocks of children of Asian or African descent. They may be mistaken for bruises because of their unique bluish coloring. Certain cultural customs also produce skin markings that can mimic child abuse. Coining and cupping are traditional Asian healing practices, often used in the treatment of fever. Although the skin markings can be impressive, the practice is not harmful and does not represent abuse. Trauma. Pediatric trauma is the leading cause of death among children older than 1 year. Motor vehicle collisions cause the most deaths in this age group, followed by falls and submersions. Among adolescents, homicide and suicide are major causes of death. Children's age-related anatomy and physiology make their injury patterns and responses to trauma different from those seen in adults. In addition, a child's developmental stage will affect his or her response to injury. For a young child, being strapped to a backboard may be as traumatic as the injury leading to the EMS call. Injury patterns. Blunt trauma is the mechanism of injury in more than 90% of pediatric injury cases. Because they have less muscle and fat mass than adults, children have less protection against the forces transmitted in blunt trauma. Falls are common in pediatric patients, and the injuries sustained will reflect the anatomy of the child and the height of the fall. For example, a 6-year-old playing on the monkey bars is most likely to sustain an upper extremity fracture when falling onto an outstretched arm. Internal or head injuries would be uncommon with this mechanism. Conversely, an infant, with a big head, and no protective reflexes, who pitches out of a backpack or shopping cart will commonly have a skull fracture, and could have an intracranial hemorrhage. Falls from a standing position usually result in isolated long bone injuries, whereas high-energy falls, such as from a window, ejection from a motor vehicle, or car versus pedestrian collision, may result in multiple trauma. Injuries from bicycle handlebars typically produce compression injuries to the intra-abdominal organs. Duodenal hematomas, pancreatic injuries, and vertebral fractures can occur with this mechanism of injury, as can upper extremity injuries. You must also consider a head injury if the patient went over the handlebars, especially if the child was not wearing a helmet. Motor vehicle collisions can result in a variety of injury patterns depending on whether the child was properly restrained and where the child was seated in the car. For unrestrained passengers, assume multiple trauma. Restrained passengers may sustain chest and abdominal injuries associated with seat belt use. If you see chest or abdominal bruising in a seat belt pattern, have a high suspicion for spinal fractures. Airbags pose a particular threat for head and neck injuries in young children. A child who is the victim of a car versus pedestrian collision is likely to sustain multi-system trauma. Depending on the child's height and the height of the vehicle's bumper, a child may receive chest, abdominal, and lower extremity injuries at impact. Head and neck injuries may result from the fall when the child is thrown. Assessment and management. The first steps in managing pediatric trauma are the same as for medical emergencies. Use your hands-off assessment to establish a general impression. If the pediatric assessment triangle findings are grossly abnormal, quickly move to the primary assessment and management to prevent death or disability. Abnormal appearance should make you think immediately of a head injury. With an isolated closed head injury, the child's breathing and circulation may be normal. Of course, abnormal appearance may also reflect inadequate oxygenation of the brain owing to shock or respiratory failure. Abnormalities in work of breathing will tip you off to chest or airway injury, and abnormal circulation to a hemorrhage problem. If multi-system injuries are present, all three sides of the pediatric assessment triangle may be abnormal. Begin the primary assessment, initiating life support interventions as you identify problems. Assess the airway for obstruction with teeth, blood, vomit, or edema. Suction as needed. For cervical spinal injury, open the airway using the jaw thrust maneuver. If the child cannot maintain the airway, consider placement of a nasopharyngeal or oropharyngeal airway. If you attempt tracheal intubation, maintain cervical spinal precautions. Establishment of an emergency surgical airway in a child is fraught with complications, and the failure rate is high. For these reasons, tracheotomy should be reserved for expert surgeons in a controlled setting. The chances of needing to perform a needle cricothyrotomy in a child are remote. In younger children, identification of the cricothyroid membrane is difficult. Appropriate needle cricothyrotomy is described in Chapter 13. Breathing assessment includes evaluation for symmetric chest rise and equal breath sounds. Provide 100% supplemental oxygen, give bag mask ventilation as needed, and place a nasogastric or orogastric tube for stomach decompression. Avoid a nasogastric tube in suspected head injury. Pneumothorax is not common in pediatric blunt chest injury, but it may be present with penetrating trauma of the chest or upper abdomen. Remember that you are less likely to see jugular venous distension and tracheal deviation in a child. If the mechanism suggests a possible tension pneumothorax, and the patient is in significant respiratory distress with asymmetric chest rise, reduced air entry on one side, and hemodynamic instability, hypotension, weak pulses, prolonged capillary refill time, perform needle decompression. Needle decompression is discussed in detail in Chapter 26. When performing this skill in a pediatric patient, you should first assess the child to ensure the presentation is due to a tension pneumothorax. Notably, tracheal deviation, hyperresonance, pulsus paradoxus, and even decreased breath sounds can be difficult to assess in a young child. Remember, tracheal deviation is a late finding, and tension pneumothorax can be present without it. Use a large bore intravenous catheter for these patients. Locate the second or third intercostal space in the mid-clavicular line on the affected side, and insert the needle at a 90-degree angle, just superior to the third rib. Any trauma patient should be considered to be at risk for developing shock from visible external bleeding or internal bleeding. Assess the child's circulation by checking the heart rate and quality, capillary refill, skin temperature, and blood pressure. In pediatric patients, the only sign of compensated shock might be an elevated heart rate. Children have a remarkable capacity for peripheral vasoconstriction and can maintain their blood pressure despite significant blood loss. If the mechanism of injury is concerning, and the child is tachycardic, assume the presence of compensated shock, and initiate volume resuscitation with 20 ml per kilogram of isotonic fluid, normal saline or lactated ringer solution. Ideally, you will insert 2 peripheral intravenous lines, but an intraosseous line may be best in a child with hemorrhagic shock. Control external bleeding as you would in any trauma patient. Once the airway, breathing, and circulation are stabilized, Continue your assessment of disability with the AVPU scale. Your assessment of appearance in the pediatric assessment triangle will already have identified an altered level of consciousness. Check the child's pupils and motor function. Consider spinal motion restriction precautions if indicated. If increased intracranial pressure is a concern, keep the head midline to facilitate jugular venous return to the heart. If the patient is not in shock, elevate the backboard or head of the stretcher to 30 degrees. Perform shock resuscitation with intravenous fluids. Brain hypoperfusion will make matters worse. If the child has acute signs of herniation, such as a blown pupil or the Cushing triad, elevated blood pressure, bradycardia, and abnormal respiratory pattern, consider mild hyperventilation guided to an end-tidal carbon dioxide of 30 to 35 millimeters of mercury, and giving mannitol or 3% saline. Assess exposure, that is, a head-to-toe examination to identify all injuries. Log roll the child, and examine the back and buttocks. Once you have completed this examination, cover the child in blankets. Do not forget to cover the head, especially in infants and young children, and avoid drafts from heating or air conditioning units. Children have a relatively large skin surface area body mass ratio, increasing their risk for heat loss and hypothermia. Consider the use of warm intravenous fluids, warm oxygen, a warm patient transport environment, and keeping the patient covered. Also be sure to remove any wet clothing that could conduct heat away from the patient. Treat any fractures, open or closed, as you would in an adult. Check out your equipment ahead of time to ensure that you have splints appropriate for smaller children. Transport considerations. After initial assessment and stabilization, you are faced with the transport decision. Some traumas are load-and-go situations because of the severity of injuries and the patient's unstable condition. Examples include trauma involving an ominous mechanism of injury regardless of how the patient looks on scene, a child with an unstable or compromised airway, a child in shock, a child with difficulty breathing, and a child with a severe neurologic disability. For these patients, perform life-saving procedures on scene or en route, and quickly transfer them to an appropriate trauma center according to local trauma triage protocols. All trauma victims for whom spinal injury is suspected require appropriate spinal stabilization. The indications are the same for children and adults. You may have difficulty finding an appropriate size cervical collar for infants or very young children. Do not attempt to place a collar that is too big on a small child. Use towel rolls and tape to immobilize the head. Apply the tape across the temples and forehead, but avoid tape over the chin or throat because it may impair ventilation. Choose a pediatric immobilizer with a recess for the child's large occiput, or place a towel or small blanket under the shoulders and back to prevent neck flexion in infants and toddlers. Perform spinal motion restriction of a child by following steps in skill drill 44-6. Follow the steps in skill drill 44-7 to perform spinal motion restriction of an infant. Secure the child firmly onto the backboard but leave room for adequate chest expansion. Being immobilized is a frightening experience, especially for a young child who cannot understand your intent. Use developmentally appropriate language to explain what you are doing, and why, and keep a parent or caregiver close by when possible. Skill drill 44-6. Performing spinal motion restriction of a child. Step 1. Use a towel under the neck and shoulder area of a child to maintain the head in a neutral position. Step 2. Apply an appropriate size cervical collar. Step 3. Carefully log roll the child onto the immobilization device. Step 4. Secure the patient's torso to the immobilization device first. Step 5. Secure the child's head to the immobilization device. Step 6. Complete immobilization by ensuring that the child is strapped in properly. This is the end of skill drill 44-6. Skill drill 44-7. Performing spinal motion restriction of an infant. Step 1. Carefully stabilize the infant's head in a neutral position, and lay the infant's seat down into a reclined position on a hard surface. Step 2. Position a pediatric backboard or other similar device between the patient and the surface on which the infant is resting. Step 3. Carefully slide the infant into position on the backboard. Step 4. Make sure the infant's head is in a neutral position by placing a towel under the infant's shoulders. Step 5. Secure the torso first, and place padding to fill any voids. Step 6. Secure the infant's head to the backboard. This is the end of skill drill 44-7. The identification of the nearest appropriate facility depends on local protocols and the capabilities of local hospitals. In some areas of the country, you may be directed to take the patient directly to a pediatric trauma center or to arrange for air transport to a pediatric trauma center. In other areas of the country, children are evaluated primarily at local hospitals, and then transferred to a pediatric trauma center. Expanded history and examination. If the patient is in stable condition, and does not meet the load and go criteria, obtain additional history as outlined in Table 44-21 and perform a more thorough physical examination. A head-to-toe, back-to-front, detailed physical examination should be performed on all trauma patients with significant mechanism of injury en route to the emergency department. For infants, this will include checking the anterior fontanelle for bulging, a sign of increased intracranial pressure. Look for bruises, abrasions, or other subtle signs of injury that may have been missed during the primary assessment. Be sure to revisit the primary assessment during your ongoing assessment on the way to the hospital because the patient's condition can change quickly. Pain management. Pain is often undertreated in young children. Regardless of whether a child can communicate with you verbally, do not overlook signs of pain in pediatric trauma patients. Consider pain assessment as important as the vital signs, and use one of the many tools available to elicit the child's self-report of pain level. Tachycardia and inconsolability may be the only way a child has to express pain, and findings may be similar to those of early shock or fear. Pain treatment includes use of a calm, reassuring voice, distraction techniques, and, when appropriate, medications. Commonly used pain medications include morphine and fentanyl. Patients who are intubated should receive pain medication and sedation, such as morphine, if they are in hemodynamically stable condition. These medications, which may need to be repeated depending on transport time, can also be used in conjunction with benzodiazepines for patients in stable condition. Side effects of narcotics and benzodiazepines include respiratory depression, hypoxemia, bradycardia, and hypotension. You must weigh the risks and benefits when deciding to administer these medications. Children who are in shock and hemodynamically unstable condition are not good candidates for narcotics or sedatives. These medications may worsen their already precarious status. All children receiving such medications should be carefully monitored in terms of their pulse rate, respiratory rate, pulse oximetry, and blood pressure. Burns. The initial assessment and management of pediatric burn victims is similar to that of adults, with a few key differences. The larger skin surface to body mass ratio of children makes them more susceptible to heat and fluid loss. Worrisome patterns of injury or suspicious circumstances should also raise concerns of child abuse. Assessment. The assessment of scene safety is an important element in a burn call. Check for ongoing dangers such as fire, chemicals, or other hazardous materials. Your from-the-doorway assessment may identify signs of smoke inhalation, such as abnormal airway sounds, and respiratory distress, or soot around the nose. Quickly move the patient and crew to a well-ventilated area. An estimation of the percentage of body surface area burned may affect your decision to start fluid resuscitation in the pre-hospital environment and influence the transport destination. For adolescents, use the same rule of nines that you use for adult burn victims. See Chapter 23. For younger children, this rule of nines is modified to account for a child's disproportionately larger head size. For infants, the head and trunk each account for 18% of body surface area, the arms each count as 9%, and the legs each count as 13.5%. The size of a child's palm, not including fingers, represents about 1% total body surface area. You can also use this rule of palms to assess the extent of the burn. Burns suggestive of maltreatment include those in which the mechanism or pattern observed does not match the history or the child's developmental capabilities. For example, a child who cannot stand independently is unlikely to pull a hot cup of coffee off a table. Splash burns, as from tipping over a pot of boiling water, should have an irregular configuration because the hot liquid runs down the child's body. Be suspicious if a burn has clear demarcation lines or is on the buttocks. Management. Initial management begins with removal of burning clothing and support of the airway, breathing, and circulation. If you observe signs of smoke inhalation, consider early intubation. Make sure that you have a range of tubes available because airway edema and sloughing may mandate use of a smaller tube than originally estimated. All burn victims should be provided 100% supplemental oxygen, regardless of the presence or absence of signs of respiratory distress. Smoke inhalation may cause bronchospasm resulting in wheezing and mild respiratory distress. Consider using a bronchodilator such as intramuscular salbutamol or epinephrine. If possible, insert an intravenous line and initiate fluid resuscitation in transport for patients with more than 5% of burned body surface area. Start with 20 milliliters per kilogram of isotonic fluid and reassess the need for additional boluses, as large burns can lead to huge fluid shifts. Clean burned areas minimally to avoid hypothermia, and cover them with clean, dry cloth. Avoid putting lotions or ointments on burned skin because they can trap heat and bacteria. Avoid heat loss by covering the burn and the patient as needed. Analgesia is a critical part of the early management of burns. These injuries can be incredibly painful. Assess and treat pain and anxiety as discussed previously. Carefully monitor any child given narcotics or benzodiazepines for signs of respiratory or hemodynamic compromise. Once the patient's condition is stabilized, begin transport to an appropriate medical facility. Larger burns, full-thickness burns, and burns involving the face and neck are best treated at a regional burn center. Children with special health care needs. Children with special health care needs include those with physical, developmental, and learning disabilities. The disabilities have a broad range of causes, including premature birth, traumatic brain injury, congenital anatomic anomalies, and acquired illnesses. Advances in technology and drugs have enabled an increasing number of children with disabilities to receive care in the community, leading to a corresponding increase in the number of EMS calls for this medically complex population. Technology-assisted children. Technology-assisted children constitute a subset of children with special health care needs that may require your assistance. It is important to familiarize yourself with the various types of medical technology that you may encounter and have to troubleshoot. Tracheostomy tubes and artificial ventilators. Tracheostomy is a surgical procedure involving creation of a stoma, in this case, a permanent connection between the skin of the throat and trachea, through which a tracheostomy tube can be placed for long-term ventilatory needs. A child might need a tracheostomy for a variety of reasons, including long-term ventilator support for chronic lung disease, inability to protect the airway because of neurologic impairment, and a congenital airway anomaly leading to airway obstruction. Caregivers have been trained in the use and care of their child's tracheostomy, and are a source of valuable information. In general, they will have a spare tracheostomy tube available. A child with a tracheostomy tube may breathe spontaneously with room air if the function of the tube is simply to bypass mechanical upper airway obstruction. Alternatively, the child may be dependent on a home ventilator and supplemental oxygen if he or she has severe lung disease or problems with respiratory drive. Although a tracheostomy tube is intended to provide a secure, permanent airway, problems can arise, as with any mechanical device. The most common problem is obstruction of the tracheostomy tube with secretions, resulting in respiratory distress or respiratory failure. Displacement of the tube is another potential problem. If you are faced with a child with a tracheostomy tube and respiratory distress, Start by assessing tube position and suctioning the tube. If the child is using a home ventilator, disconnect the circuit and provide bag mask ventilation. If these measures fail to lead to improvement, or if the child is cyanotic or in severe distress, you may need to remove and replace the tracheostomy tube, preferably using a tube of the same diameter and length. Confirmation of tube position is done in the same manner as for a tracheal tube. Gastrostomy tubes. Gastrostomy tubes, G-tubes, are surgically placed directly into the patient's stomach through the skin. They provide nutrition or medications directly into the stomach, bypassing the oropharynx and esophagus. Some children are unable to take food or medication by mouth, and depend on a G-tube for all of their nutrition. For other patients, the tube is used to supplement intake and ensure adequate nutrition. Problems such as obstruction, dislodgement, or leakage of a G-tube are not uncommon, but rarely represent an emergency. Most such calls can be managed by supportive care and transport. Urgent physician evaluation is needed if a G-tube has been pulled out because the opening on the abdominal wall tends to constrict quickly, making replacement difficult. Central venous catheters. A central venous catheter may be inserted when a child needs long-term intravenous access for medications or nutrition. Such a device is placed surgically or by interventional radiologists into large central veins, such as the subclavian. Completely implanted central lines, with a port or reservoir accessible under the skin, may be left in place for months to years. For example, they are commonly placed in children with cancer who are undergoing long courses of chemotherapy. Partially implanted central lines have tubing external to the skin. Complications associated with central venous catheters include infections, obstruction, and dislodged or broken catheters. Children with an infection of the central line may have redness, swelling, tenderness, or pus at the skin site of insertion. They may also have systemic signs of infection, such as fever, or signs of septic shock. Central line obstruction may be a medical emergency, depending on what is infusing through the line. If the child is not in urgent need of the infusion, simply assess the patient and transport to a hospital. Dislodged or broken catheters may result in leakage of fluid or blood. In such a case, use sterile technique to clamp off the broken line to minimize risk of infection or air embolus. On rare occasions, you will be confronted with a child who has a functioning central line but requires emergency intravenous access for pre-hospital treatment. Because these permanent lines carry a high risk for infection, look for peripheral access, and avoid using the central line whenever possible. Cerebral spinal fluid shunts. Hydrocephalus is a condition resulting from impaired circulation and absorption of cerebral spinal fluid, leading to increased size of the ventricles, fluid-filled spaces in the brain, and increased intracranial pressure. Hydrocephalus may be congenital or acquired. It is most commonly seen in children born with brain malformations as a complication of prematurity or following surgery for a brain tumor. Cerebral spinal fluid shunts are inserted to drain excessive fluid from the brain, thereby normalizing intracranial pressure. A neurosurgeon places the tube and connects it to a one-way, pressure-sensitive valve that runs from the enlarged ventricle subcutaneously into the abdominal peritoneal space, rarely placed in other spaces, such as pleural space. When pressure builds up in the ventricle, the one-way valve opens, and cerebral spinal fluid drains into the peritoneum, where it is reabsorbed. A cerebral spinal fluid shunt obstruction occurs when the drainage of fluid from the brain through the shunt tubing becomes blocked, perhaps due to a break in the tubing, problems with the valve, or buildup of debris in the tubing. Without adequate fluid drainage, the cerebral spinal fluid continues to accumulate, resulting in hydrocephalus. A child with a shunt obstruction will show signs of increased intracranial pressure, which may range from subtle changes in behavior to impending brain herniation. Typical symptoms include headache, fatigue, vomiting, and even coma. Late signs include the Cushing triad, hypertension, bradycardia, and an abnormal respiratory pattern. A cerebral spinal fluid shunt infection results from bacterial contamination during the surgery to place the shunt or from bacteria in the blood adhering to and infecting the hardware. Infections are encountered most frequently within months of shunt surgery. Children with shunt infections are generally very sick and have fever and signs of shunt obstruction. Shunt obstructions and shunt infections are true medical emergencies. The patient should be transported to appropriate treatment facilities where neurosurgical evaluation is available. The child's condition can deteriorate rapidly, so maintain continuous cardiopulmonary monitoring during transport. Assessment and management. Follow the standard pediatric assessment sequence when approaching children with special health care needs. Ask questions of the parent or caregiver to establish the child's baseline level of neurologic function and baseline physiologic status. Meet every child at his or her unique developmental level. An otherwise healthy 10-year-old with a perinatal brain injury may have the developmental skills of a toddler. Conversely, a 6-year-old with severe cardiopulmonary compromise may be ventilator dependent and have oxygen saturation in the 80s but be cognitively intact. Your treatment goal is to restore a child to his or her own physiologic baseline, which will require collaboration with caregivers to determine what is normal for the child and management strategies that have been successful in the past. Transport. Most children with special health care needs will have a medical home, that is, a hospital, clinic, or private practice where they receive their care. Transporting to a facility where the clinical team is familiar with the patient's history and needs will streamline his or her care. If this is not possible, take along any medical records available to assist the team at the receiving facility to sort out the potentially complex issues faced by the patient. Take any assistive devices as well, including home ventilators and feeding pumps. Most important, take the parent or caregiver of the child. Children with special health care needs rely on their caregivers for much, if not all, of their needs, so it can be emotionally difficult for the child to be separated from the caregiver. Pediatric mental health. As a paramedic, you will encounter children with behavioral and psychiatric problems. The call may be for out-of-control behavior or for a suicide attempt. Unfortunately, EMS calls for behavioral emergencies are increasing, reflecting in part the limited community resources available for children with mental health problems. A recent study of one pediatric emergency department found that 5% of all pediatric emergency department visits were for mental health concerns. Safety. When you are called to a home for a behavioral or psychiatric emergency, safety should be your first priority. Assess the scene for your own safety, and for the safety of your patient. If weapons are involved or you cannot determine the degree of risk, call for law enforcement backup. Approach the child calmly, letting him or her know you are there to help. Address the patient directly when obtaining the history, and explain clearly what you are doing, and why. Some children are flight risks, so determine how best to deploy your squad so that they do not leave the scene. As always, answer questions as honestly as possible. A small percentage of children cannot be safely talked down for transport and must be mechanically restrained for their own protection, and the protection of the paramedics. Applying these restraints may be a task for paramedics or for law enforcement personnel. If you decide to apply restraints, carefully document the reason, and keep the restraints in place until arrival at the emergency department. An out-of-control, 27-kilogram 8-year-old can make transport dangerous. Try to avoid using chemical restraint, that is, tranquilizing drugs, in the pre-hospital setting. Assessment and management. The pediatric assessment triangle will give you a general impression of the child's mental status and cardiovascular stability. A child who has attempted suicide by ingestion may have life-threatening medical complications that trump his or her psychiatric concerns. In the absence of acute medical issues, the bulk of your assessment will be based on observation and history. In cases involving a very agitated child, your hands-on examination may be limited. Table 44-22 lists specific sample questions for behavioral emergencies. As always, treat any existing medical problems or injuries by using standard protocols. An ounce of prevention. Emergency care for children involves a team approach by health care professionals in the community and in the hospital. Paramedics are a critical part of the community responsible for caring for sick and injured children, but your role in prevention is not always highlighted, even though this is an area where you can have a greater public health impact than possible by running a code or controlling an airway. To be an effective child safety advocate, you must be knowledgeable about local and national prevention programs. Prevention of injuries. Most injuries are not accidents, but rather are predictable and preventable events. Knowledge of injury patterns helps target potential areas for intervention and prevention. For example, childhood poisonings can be prevented by effective storage of medications and chemicals. Toddler drowning and submersion can be virtually eliminated by installation of four-sided pool fencing. The risk of serious injury from a bike collision is lessened by use of a helmet. The morbidity and mortality from motor vehicle collisions is dramatically decreased by the appropriate use of child restraint devices. As you care for children, you may be frustrated by the illnesses and injuries that you encounter, especially when they're preventable. Take this frustration as a call to action. Get involved in your community. Participate in existing prevention programs or start your own program. Numerous types of pediatric injury can be targeted. Choose something that interests you, and take a leadership role.